Hello, everybody. My name is Gerasimos Philippatos. I'm from Attikon University Hospital from the University of Athens. And it's a great pleasure and honor to coordinate this session with Professor Economidis and Dr. Chrysochou. It's a very interesting session, and I think we can start immediately. Professor Economidis, Ignatie.
Good morning. From my side, it's a pleasure for me to participate in this venue, and I would like to invite Professor Manolis Vavouranakis, the chairman of the Third University Cardiology Department, to present us the current evidence-based practices and clinical trials landscape on mitral regurgitation. Professor Vavouranakis, please.
Good morning to everyone. First of all, I would like to congratulate Dr. Sparias, Dr. Patakos and Hygeia Hospital for organizing this excellent course and meeting. And hopefully in the future we'll be in a better situation. We'll be able to attend this meeting live in Athens. I would like to start with the knowledge that mitral regurgitation is not a single disease entity. It has to do with the abnormalities in the anatomy of the mitral valve, of the left ventricle. So it is separated in the degenerative mitral regurgitation and to the functional mitral regurgitation. What have been the options for treating this abnormality on the mitral valve? Traditionally has been the leaflet resection by surgeons, the Alfieri technique, annuloplasty, or chordal repair. What about when we try to correct these problems with transcatheter options? What we have to deal with is basically potentially replicate the results of the surgical approach. However, in the surgical field, obviously, the surgeon can correct different entities, like the annular, chordae, leaflet resection can be done. In the transcatheter approach, unfortunately, no approach can be ideal and correct all the problems at the same time. On my presentation, I will focus mostly on the leaflet repair, the edge-to-edge repair, which is my topic, which would be focused on the mitral clip and the Pascal device. These are the two tools that have been used in clinical practice, the mitral clip and the Pascal system. I would say they're similar in their actions with some differences, but obviously all started with the mitral clip. And we know that there have been several publications that supported the use of the mitral clip as a device to cure mitral regurgitation. We have to remember that all started to be influential in the clinical practice as soon as we have the results from the Everest 2 trial. Now we have the 5 years, they have been published, the New England Journal of Medicine. And as we see here, it looks like 5 years, there was very promising results between the surgical and the blue line, which is the mitral clip. Of course, we know, and it has been published, that at the first year, we have about 25% failure of the mitral clip, the generation of the mitral clip that was used in Everest. This is an old version. It's not anymore used in clinical practice. However, if we pass the 1 year, then we see that the lines remain close to each other. That means that there is no deterioration after the initial year. And of course, there were certain criteria that were used at that time in order to be able to perform the procedure safely and effectively with the devices that were available. These criteria were changed and actually were made more wider in the use with the German Society of Cardiology. And bottom line is, by having the selection criteria very specific and the results with Everest 2 trials, now today we have the edge-to-edge therapy as a 2A indication for primary mitral regurgitation. Like I said on the beginning, we have also the secondary MR, the functional MR, mostly ischemic and non-ischemic remodeling of the left ventricle that creates this problem. And this etiology of the MR seems to be very important and unfortunately has severe adverse outcome, which is worse actually than the degenerative. Degenerative is the white lines, functional is the red lines, and you see here death, the one that is interrupted, that is completely, and the interrupted lines, death and heart failure, hospitalization as a combined endpoint. And unfortunately, the functional MR, which has the worst prognosis, has also is the most of the patients involved. It's 4 times higher in number than the degenerative mitral valve. And regardless if it's an ischemic cardiomyopathy, patients with the red dots are with severe MR, or non-ischemic cardiomyopathy, it does affect their survival, the presence of the severe MR. Overall on the top and separated in ischemic and non-ischemic cardiomyopathy. There have been some data from previous studies that recognize some anatomical characteristics of the left ventricle that are associated with severe MR, functional MR. And the question comes, if there are some markers by the left ventricle anatomy, well, is the MR related to the degeneration of the left ventricle, or could this MR itself affect prognosis and survival in this patient? This was a big question, and we know that regardless of the question, no surgical therapy was very effective, obviously, in the previous year. This is from old studies that were done a database, and we see here that if patient has a functional MR and no coronary disease and a low EF, basically they were not treated with surgery. Then we had the attempts with the annuloplasty ring by the surgeons. But no, the results were not the best, and we see here like follow-up patients who were on medical therapy versus annuloplasty. They are similar, the outcomes, I would say. And then we have for ischemic MR, replacement versus repair, and this is a study that showed, published in New England Journal of Medicine, it showed actually that there was no significant difference. Actually, the replacement had less MR. So what I'm pointing out is that unfortunately the surgery is not an option, an adequate option in patients with functional MR, and we know the surgeons don't like to operate on those patients. On the other hand, on the contrary, if we look at the result from the Everest, we had a message that the mitral clip, because there were some patients with functional MR, could be beneficial in this group of patients. And as a result, the 2 randomized trials came out, the COAPT trial and the mitral FR. The COAPT trial, which was the bigger trial, showed actually that the primary endpoint had significant improvement as far as heart failure hospitalization, but also it was a surprise, which we do not expect, that also showed significant benefits on mortality in these patients at 24 months. And death or heart failure hospitalizations were also better in the patients that received mitral clip versus optimal medical therapy, not surgery comparison here, optimal medical therapy. It's interesting that these results at 3 years were maintained, as we see here, and the green line is lower. It shows lower events for heart failure hospitalizations. And also the benefits for mortality remain at 3 years in the follow-up of the patients. And basically, if we look at the benefits, it looks like there are significant benefits by the mitral clip, which is actually overwhelming and is more than what you expect with a sacubitril valsartan. These are current therapies that are given for heart failure. Why the co-opt showed such good results and the mitral FR, which we see on the left, failed? Well, there are several attempts to explain this, because in that trial, we did not find significant benefits over medical therapy or optimal medical therapy. Well, first of all, there were, I would say, the numbers were less in the mitral FR, excluded patients with less severe MR, and this, I think I would point out in the next slide, how it could have affected the results. Here's the mitral FR patients with volumes about 250 ml. So you expect that the dilated ventricle would have some kind of MR because of the dilatation, which would be associated with the concept that degenerative function of the left ventricle is associated with MR as a consequence, I would say. While on the co-op trial, we have less volumes, more effective regurgitation orifice area, and this regurgitation of the mitral is so considered to be disproportional for the degree of the LV dysfunction. So that could be an explanation, theoretical explanation, why the difference occurred, as patients with the co-opt, involved in co-opt, had a truly significant mitral regurgitation regardless of the dysfunction of the left ventricle, which probably contributed to the outcomes. So at this point, for the functional MR, H2H therapy is now 2A. These are the consensus. This is the consensus document that actually supports this from the European Society. And of course, there are challenges. Challenges: leaflet morphology, calcium, small vessel area, leaflet tethering, broad jet, residual MR, and durability. Here you can see there are clips, the clips that have been used in the past, the NT and the XT, the wide types. So we needed longer clips, we needed wider clips to have better grasping of the leaflets. And also a characteristic which was obvious in the Pascal device, and now it's also in the new generation of the mitral clip, the independent functionality of the grippers, which can sometimes is very helpful. And another characteristic is that you have a continuous now LA pressure monitoring, which is useful to evaluate your results. Here we see the evolution of the mitral clip, and I think the generation 4 would probably help a lot. Now, since the mitral clip, the study of the mitral clip and the application of the device in the clinical practice, there were not been any evaluation with the XTR, the newer devices, and this actually study, the ECL assessment study with the core lab, evaluated whether now what we're doing in clinical practice is actually reflected with the newer generation of the devices. We see here the methodology that with the core lab evaluation of the degree of the MR and the results that we were able to succeed, that you have a single leaflet device attachment very low. This is practice, daily practice. So it remains very good, the outcome of the procedure with very low leaflet injury. We see that there is improvement with the newer devices in MR, a significant improvement. And also now patients with complex anatomy on the mitral regurgitation are treated. And as you see here, the proportion is almost 30%. And complex anatomy or non-complex anatomy, you still have a very good reduction by choosing the appropriate size of the newer devices. And regardless of the prolapse gap and the flail gap, if you have a bigger prolapse, then XTR is obviously preferred, or the same with the flail gap. So the conclusion is actually with the newer devices, you have maintained the good results of the Everest. Reshape is coming again, and repair MR will be the trial that will confirm the low-risk patients with the surgical patients with primary MR actually and some secondary. Pascal, I must say, you can congratulate Kostas Parias, who was the first one to introduce the Pascal device as a therapy, alternative therapy to the mitral clip for mitral regurgitation. We see here the Pascal device. The CLASP study has been published. It's a single-arm, multi-center prospective study. Relatively smaller percentage of patients regarding to the data of with the mitral clip. We're almost done. And the procedure characteristics, very good success. As you see here, 6 months follow-up. Patients is about 76 years old. And what is important is that the intervention and complications are very low. So excellent results, 1 year follow-up, sustained. And as we see here, the transmitral greater remains. And at 2 years, the PCR results that were presented, again, very good results with the Pascal. So the Pascal is a very good alternative option for patients who have, and we'll wait for the GLASP 2 or D2F for the trials. And this is my last slide, which indicates that all these procedures are done and all this success is also attributed to the echocardiographyst who has been a very valuable help during the procedure. Thank you very much.
That was an excellent presentation by Professor Vavouranakis. We can have our discussion now. Actually, from my point of view, I can see that we need some new criteria according to the type of valve and to the problem we have for each valve. For example, if there is calcification, maybe Pascal is better. If there is a large gap, flail gap, for example, a G4 mitral clip is more indicated. So we need, I suppose, a new consensus defining the criteria to the various types of valves. What is your opinion, Professor Vavouranakis?
I would speak generally as far as using different devices for the treatment of valvular disease, which includes the mitral, but also and the aortic. I would say one important thing is that the experience of the operator. I think if you have a lot of cases, obviously you can use the G4 and the Pascal are excellent devices. And I think the experience of the operator would influence which device to use. Now, if you have a lot of cases in your lab, then that would be also one consideration. But I think the most important is the experience that you have built with each device that will determine which one will have the best results. Now we are approaching more difficult cases, but I think that they are not related only to the device, they're related mostly to the experience of the operator.
Yeah, I think, Manol, is that still it's not clear to most of us who is the patient who would not benefit from mitral clip. And usually, sometimes I think that we send to you, Kostas, to the teams who perform the procedure, patients too late or too early. What is my opinion, could be wrong, is that one of the reasons for success, for the failure of MITRA-F and for the success of COAPT, it was the heart team, the selection of patients for the procedure, which is, I think, is what do you think? I mean, are we here outside the trial? Are we at the same level to evaluate the heart team, to evaluate the patients and select the best patients?
Dr. Professor Philippatos, thank you very much for the question. I will take the opportunity to answer this, but I also would like to express my thinking on how we should think about treating patients with with severe MR. I think we have to separate those patients that we are treating because we have data that we're improving long-term outcome. And then we have patients that we are treating because as a palliative care, because there's nothing else to do. For example, if you have, the guidelines state that, if you use it for a functional and you have an end diastolic diameter 70 or more, which is basically, then you are trying to do something which is not proven as far as long-term survival. On the other hand, this patient obviously is not going to be undertaken by any surgeon because so you might do a procedure which would be worthless because they will die anyhow with severe decompensated left ventricular function. You might have a transient improve for a few 1-2 months because you close something, but then it will deteriorate. So in that case, it's a palliative procedure without knowing actually, except some case reports that you're doing something good. Now, this is a concept which I don't know if the state of the financial situation would be willing to support as a health system in a country. On the other hand, you have the patient, which you should do everything you can. So this is a very controversial issue. So if we stick with the guidelines, patients, we do know data and they should get the best care. But if we go to the case reports or the feasibility of something, this is different. You have to consider.
Thank you very much. We'll continue. Thank you very much, Professor Vavouranakis. And we continue with the second presentation, but by one of the really world experts in this area in imaging of valvular heart disease, Dr. Chrysocheris, who is going to present the latest data on echocardiographic screening for edge-to-edge therapy.
Dear Chairman, dear colleagues, thank you very much for the kind introduction. We'll present the echocardiographic screening for edge-to-edge therapies in the next 10 minutes. Can you see my slides?
Yes.
Okay. So this is the heart team from Hygeia Hospital, from which we've done several cases of transcatheter mitral valve repair. Mitral valve repair relies heavily on echocardiographic imaging and screening. We see here the MitraClip device, with the prototype device for transcatheter repair, which has now reached generation 4 with multiple iterations of the system that allow for different devices and different sizes, which we can tailor to each individual patient. And that's very important. Along the way, also, we have Pascal, the Pascal device, which also has 2 iterations, the Pascal and the Pascal Ace, which also have some differences in terms of their characteristics and allow for tailoring to the individual patient. Now, the basics for selecting patients is a good screening examination with echocardiography, which should identify the mechanism, whether it's degenerative, functional, or mixed. This confirm the severity of mitral regurgitation, moderate, severe, or severe. Evaluate the morphology of the mitral valve, identify clefts, indentations, calcium thickening. Evaluate for leaflet mobility length, which is very important, and we need to have over 7 millimeters of mobile length to grasp with edge-to-edge. Also evaluate mitral valve area by 2D and by preferably 3-dimensional echocardiography. Evaluate the peak and mean mitral valve gradients for stenosis. Evaluate the intra-atrial septum, the left ventricular size and systolic function, especially now in the era of co-op study, RV size and function, and concurrent tricuspid valve disease, and systolic pulmonary pressure. Here are some examples of mitral degenerative, organic, or primary MR, where the defect is on one or more structures comprising the mitral apparatus. And conversely, we have functional or secondary MR, in which the problem lies with the underlying ischemic or dilated cardiomyopathy. And also, we have a third element of atrial functional MR, where we have dilatation of the annulus in patients with dilated atria and secondary functional mitral regurgitation. The screening transthoracic echocardiogram already gives us a lot of information about the origin of the jet of mitral regurgitation, as well as the anatomy of the mitral valve. And here in our long axis, we can see the A2 and P2 segments. If we tilt more lateral or more medial, we can interrogate the valve at different planes. And if we do an apical 2-chamber view, we can also see a nice commissural view of the mitral valve and evaluate the origin and the extent of the mitral regurgitant jet. In addition, we should also have an understanding of the severity of mitral regurgitation based on the calculation of the ERO and the regurgitant volumes. Moving on to the screening transesophageal echocardiogram, the initial images are at 0 degrees mid-esophageal, where we scan the valve at various planes and we assess different parts of the valve. But the more critical view for the mitral valve is the commissural view, which is a view somewhere around 60 degrees mid-esophageal, where we scan the valve from one commissure to the other commissure. This is the most important, in my mind, view for the mitral valve. The second more important is the long axis view, which is the grasping view for all transcatheter leaflet repair interventions. And here we have this view, but the possibility of doing biplane imaging is the most important and the useful tool that we have in everyday assessment of these patients. And if we use a basic image from a commissural view and scan the valve along the line of the commissure, like we can see in this particular example, up here we have a commissural view on the right upper hand side, commissural view starting from a commissural view, and we explain the image to a long axis view, and we see right at the center of the valve how the valve looks like, how the leaflets look like, and if we tilt the cursor to more medial, we get a sense how the valve looks in the A3, P3 region, and if we tilt the probe, the cursor to the lateral area, we get a screening of the lateral aspect of the valve, the A3, the A1, P1, which is very, very important. Real-time 3D imaging obviously has revolutionized the understanding of mitral valve, and we can now understand complex anatomies like this very wide flail A2, this very complex posterior flail. This is a more simple P2 flail, and this is a P3 flail in a degenerative MR patient. In addition, with patients with ischemic or functional dilated cardiomyopathy, we can assess the degree and extent of regurgitation, the degree of tenting of the valve leaflets into the ventricle, and understand better the anatomy and morphology of the mitral valve. In addition, 3D allows the identification of deep indentations, like in this area between P1 and P2, which may pose an issue with edge-to-edge repair. And we can also clearly understand the degree of and extent of calcification around the annulus and the mitral valve structures. Moving on to a couple of case examples that will highlight all these and put together all these things. This is a patient referred for a screening of degenerative mitral regurgitation. And we can see here mid-esophageal 0 degrees view. We don't clearly see where the piece of vena contracta is coming, so it's not coming from this area, but we move a bit more deep in the esophagus. We see clearly the P2 flail in this patient with a ruptured cord. And we can also highlight that with color Doppler. Moving on to the commissural views, which, as I said before, are critical in understanding the pathology of the mitral valve. Here we see the P2 flail, and we can easily measure the flail width in this view, and we can understand the significance of the mitral pathology. Moving on to the long axis views, we see here the flail gap that is created by this flail segment and the corresponding color that comes along from this area. This also view highlights that we should be able to grasp this valve nicely with a edge-to-edge technology. Moving on to the transeptal views, which are also very important to understand because this is a transeptal procedure. We see here that in this particular patient, we have a PFO with a shunt. It's important to understand that so we don't go through it with our devices. Furthermore, we can do some measurements and understand what's the flail width and the flail gap, as well as understand the width of the vena contracta area in these patients. With 3D and FOSS view, we can understand the complexity of the regurgitant flail segment. We can easily measure the mitral valve orifice area, which is a critical aspect of edge-to-edge. Here we have measurements of the vena contracta at 7 by 17 millimeters. We have to measure also the flail width, the flail gap of this pathology. And we can easily measure also the length of the leaflets, which are more than adequate for leaflet repair. In addition, we assess the left atrial appendage for lack of any thrombus. A more complex degenerative MR patient is highlighted in this section here. We see a patient who has a calcification on the mitral valve, severe degenerative mitral regurgitation from the central A2P2 area. And we put the X-plane probe on the valve, biplane imaging. We can see clearly the degree of calcification that also involves the base of the anterior leaflet, as well as the subvalvular apparatus, which is critical information to understand when we discuss about edge-to-edge repair. We measure the length of the leaflet, the mobile length, which is about 8 millimeters, sufficient for edge-to-edge repair. 3D imaging also allows us to understand better the pathology. And when we gain down the image, we can clearly see the extent of the calcifications on the valve leaflets. Adding color to 3D helps us understand the extent and the severity of the regurgitation. This is live 3D color from looking from the valve from a different perspective. Estimation of the valve gradient is also very important to preclude any valvular stenosis, but we go ahead and measure the valve area directly with 3D planimetry and assess that the valve area has an adequate 4 square centimeter size. And finally, I will close with a patient with functional mitral regurgitation and their screening evaluation here. We go at 0 degrees as before, and we see that the origin of the regurgitant jet is in the central area, the A2P2 segment of the valve, a jet of severe regurgitation. Moving on to the commissural images, which are again the most important image of the screening process. We see a wide jet from the central A2P2 area. Moving on to the long axis images, which are important also to understand how the leaflets can be grasped with edge-to-edge technology. We see here tethering the posterior leaflet and tethering both leaflets actually towards the ventricle, but more so of the posterior leaflet, so we have an eccentrically posteriorly directed jet. The transeptal views as well here showed that the septum was a bit thicker than what we'd like to see, but if we moved on to a different view lower, we found that it was acceptable. We also have to assess the height of the transeptal puncture. We need at least 3.5 to 4 centimeters above the annulus plane, and we can assess that in this view. And furthermore, we can do more measurements, including the vena contracta, width of the regurgitant jet. If we go transgastric, which we don't always do, but it's also a very useful projection to understand the location of the regurgitant jet, especially if you don't have 3D capability. We can see here the extent of the regurgitant jet along the commissure line. But 3D is the key modality to understand the pathology of the valve, as well as the extent of the regurgitation. And here we see the vena contracta of the valve of the jet at 13 by 6 millimeters with a piece of severe regurgitation. And definitely we have the leaflet lengths with the posterior leaflet at 11 and anterior leaflet at 25, more than adequate for a leaflet repair. In summary, echocardiographic screening for edge-to-edge repair is critical first step in the success of the intervention. A detailed study to identify the mitral valve pathology and origin of mitral regurgitation is mandatory. And the screening allows selection of appropriate device type and size. We don't have one device for everybody these days. We've moved on to multiple devices, so we have to select wisely what would benefit the patient most. And with that, I would like to thank you for your attention.
Thank you very much, Dr. Chrysoheris, for the excellent presentation. And it's clear, I think, from your presentation, but also from all the information that we receive, that this echocardiographic screening for mitral clip, for the mitral valve, but also for all this structural heart disease, probably is a separate unit within the imaging department. Maybe Professor Economidis, would you like to comment on this?
Thank you, Dr. Chrysoheris. It was an excellent presentation of the need and implementation of the echo techniques to choose the best device, actually, because as I gather today, the only technical, at least, exclusion criteria would be extensive calcification of the mitral annulus extending to the leaflet, and of course the length of the posterior leaflet. It appears that at least from the latest registry on mitral regurgitation, where Professor Philippatos and myself from our department contributed in about 15,000 patients screened, there is a large number, about 30% of patients that have functional MR and about 14% patients that they have a mixed MR, which is functional and a lot of degenerative tissue. And all these patients would be candidates for mitral clip. Now with the G4, we don't really care about the flail gap, for example, or how large is the flail part of the valve. However, and with the Pascal, we may also deal with patients with more calcification than we used to before with the simple mitral clips. Would you like to comment on that?
Well, I agree with you that the screening of the patients essentially we used to have the Everest criteria to screen patients anatomically for eligibility, but nowadays essentially it's making sure that the valve has an adequate orifice so we don't cause stenosis, that we have enough leaflet length to grasp, and that we have adequate imaging to see what we're doing, and that's why the interventionalists have expanded the application of edge-to-edge technologies in even more complex anatomies. But definitely the technology has a limitation in terms of how much it can deal with, and definitely calcification extensive calcification is the enemy of this technology.
So thank you very much, Dr. Chrysochou. Any comments?
As a matter of fact, I would like to ask you, but maybe we will initially for the next topic and the next speaker. How can we deal about can we interpret the discrepancy we see in the guidelines between the American Heart Association and the European Heart Association according to the definition of severity of mitral regurgitation, the functional one? I mean, if we will follow the American guidelines, then there are more strict borders for the definition of for a ROA definition for severe functional mitral regurgitation, and in this issue we may have to deal with large volumes of left ventricle. And according to the studies, we see that the large volumes of the left ventricle do not have a very good follow-up after the put of the mitral clip. So how can we interpret this in the
so I mean, just to make it easy, Christine, I think I don't know if there is an answer. I think both actually you could also answer this, but also Dr. Chrysochou.
No, I don't think I can answer it.
Why we have this difference?
Yes, in the definition of severe functional MR between American Heart Association and European Heart Association.
Do you have any interpretations?
Yeah.
Yes, please.
I think if I may say, I think functional mitral regurgitation is an entity that's been a bit, how can I say it? It's an entity that many people equate to something benign, something that's it's okay to have in a sense. But it's clear from the especially from the CLAP study is that it's in certain patients it's actually the mitral regurgitation which becomes even more severe than the underlying cardiomyopathy. So I think the American guidelines, what they do highlight and they identify patients who really have severe mitral regurgitation, in which essentially have a destroyed valve. You know, and we have an ERO of 40 and a posterior leaflet that is not moving. Essentially, it's a destroyed valve. But we do call it functional, but it's not really functional in my mind. So I think the importance here is to understand in these patients that functional mitral regurgitation is not a benign entity. And I think the European guidelines being at 20 for the ERO, assuming that it's an underestimate of the true regurgitant orifice, because it's usually not semicircular, but it's semi-elliptical. They try to sort of increase the sensitivity of the method. But I think we should try to identify really those who have a truly severe functional mitral regurgitation, because those are the ones who are going to benefit the most.
If I may,
yes, please.
Comment on that. I totally agree with Dr. Chrysochou. What the European guidelines, they use this cutoff of 0.2 because this was associated with the prognosis of these patients. The American part uses the 0.4 because they had some studies, not only from mitral clip, but from surgery, that they linked that number with improvement in prognosis and effects of treatment on prognosis on these patients. So there's going to be a benefit if you have a 0.4. However, the Europeans say that if you have also 0.2, you have an adverse prognosis. I suppose the Americans are more practical and they say if we want to intervene, you have to have a 0.4 to have a positive outcome. Otherwise, things are debatable.
Yes, thank you very much. And of course, we see the same, let's say, small discrepancy, different interpretation in many other guidelines, because the data is here, but the team that evaluates the data sometimes have different opinions. Thank you very much, Dr. Chrysoheris. Dr. Chrysofou.
Yes, thank you. It's my great pleasure to introduce the next speaker, who combines advanced training and lifelong experience in this field. So Dr. Kospargias will speak about technical planning and strategies for age and functional or degenerative mitral regurgitation, central versus commissural, single versus multiple devices. Dr. Spargias. Dr. Spargias, if you can switch on your microphone.
Christina, thank you for the introduction. Can you hear me now?
Yes.
And you can see my slides?
Yes, yes.
Perfect. So I'd like to thank this party that we gathered this morning, this scientific party, to discuss about Edwards-in mitral valve. And after Michael's presentation on the screening, which is extremely important and somehow defines how we go ahead, what device we choose, and what strategy we develop for the procedure, I will talk about the technical side of the procedure, the planning, the strategies, if there's any difference between FMR and DMR, central versus commissural position of the regurgitance jet, and when to use multiple devices or a single device will be enough. Disclosures and the heart team were doing these procedures. And going to the nitty-gritty of the procedure, I'd like to tell you that it's very important and essential to remember the basics. So the basics say we should keep coaxial, we should keep symmetrical with our device, otherwise we're not going to have any effect on the MR reduction. And we have the anterior-posterior coaxiality from the LVOT view in the transesophageal, we see this. So we should have a device that is coming coaxially and not with an anterior tilt or with a posterior tilt. Also is the height. We should grasp enough of the leaflet edges and not just very little. And then we should grasp enough, but not go above the annular plane, because we may cause an injury. So this is the X-plane view that we use to check both the anterior-posterior trajectory of our device, but also the medial-lateral trajectory of our device. And as you can see here, this is our anterior-posterior trajectory, and this is perpendicular to the leaflet we want to grasp, the leaflet that has the pathology, which is the posterior in this case. But if you note here, when the prolapse is large and we have a drop of the leaflet back into the atrium, then probably this is the best position to grasp the leaflet. And in this case, if we keep this trajectory, this will be unfavorable in succeeding the grasping. So we have to move more posterior trajectory like this to be successful. And then, of course, we have the case of tethered valve, like in FMR, that the posterior leaflet remains like this at systole. And in this case, if we keep this trajectory, we're not it's not the optimal trajectory to get this posterior leaflet. So we may actually have to move a bit aortic anterior to get more of this leaflet. The same holds when we have a difficulty to grasp one of the two leaflets, like the anterior leaflet. Sometimes when we're coming with an aortic trajectory like this, it's obvious if we lose the anterior leaflet with this trajectory, we have to move more with a more posterior trajectory, so we'll be better suited to succeed with the leaflet we failed. And this is the medial-lateral coaxiality, as we've seen in the X-plane. We have to come perpendicular to the area we want to put our device. And we should keep in mind that we should try to stay central, because this is where the space is free of cordi. So if we keep in this area, we'll have an easier job to do. And that's why we should always have this trajectory like a Vendalia, as you can see here, no matter where we plan to go. And finally, we have the perpendicularity of the device that we see here on the coaptation line. And this is also extremely important, and we should follow always the coaptation line and be perpendicular to the area we want to implant our device, the area where the regurgitation is coming from. And this is how we rotate the device to achieve the perpendicularity from being completely out of coaxiality, and then we correct gradually to go perpendicular to the area we want to grasp. And then this is the result if we are not perpendicular. If we're not perpendicular, we have this distortion of the valve when we close the device, and you see the tension, the anterior leaflet is pulled in this direction because our device is like this and it's not like this. And that's why we have residual regurgitation. And then if we rotate our device in the correct perpendicularity, you see immediately that this distortion of the valve goes away, and also the residual MR is close to zero. So this symmetricity on the tethering of the anterior and posterior leaflet when we close the device is very important if we want to have a good result. And here is the commissural areas with the cordi that we want to avoid, as we discussed earlier. And if we have to go there, we have to consider the way out. So the withdrawal configuration of the devices we have now is this configuration for the Pascal, which is like a straight line, and this configuration for MitraClip, which has these wings like a plane, and this certainly is a wider span than this. So if we're entangled into cordi, we may have some difficulty. It's more likely to have some difficulty with the MitraClip. And then let's see the anatomies that are out of the common anatomies, or the standard anatomies we can easily treat with clip. This is prolapse in the P3 region of the posterior leaflet. So when we go in this area, we have to use a device that is probably shorter, so like an NT instead of an XT. And also because this is an area full of cordi, we have to use a device that is thinner rather than the wider. So we will go for not the wide clip Gen 4, but the simple one, and also for the Pascal Ace, which is the thin Pascal that is 6 millimeters, as we're going to see. This is the same anatomy, but in the P1 scallop, you see, and everything that I said about the P3 is also valid for this area. We'll try to use a shorter device and a thinner device, and you see here a Pascal going into this area and grasping the posterior and the anterior leaflet, and giving us this very good result. And what happens with DMR? Here you see a flail width that is really huge. It's everywhere, from commissure to commissure. This is a case that you want to use multiple device, or if you want to avoid multiple devices, which is always a good thing to do, you should go for a wide device. So it's then for a wide device, and also because it's central, you have a large anatomy, so you'll go for an XTR. And if you use the Pascal, you'll go for the wide Pascal, the Pascal 10 millimeter, that could probably give you a very good result with one device. Here you see a combination of an XT and an NT mitral clip. In this case, put one next to another with a very good result. And here you see and also DMR, but with a big flail gap, as you can appreciate here. And this is also a case that the coaxialities, as I described earlier, are very important to grasp the flail part of the leaflet at its best. And here is what we did with just one MitraClip device. So what we have today is the MitraClip Gen 4 that comes in the regular width, which is 4 millimeters, and the W or wide configuration that is 6 millimeters. So not a lot of big difference, 2 millimeters wider, but still wider. And if we want to see the other dimensions of the device when it's fully open, the NT, the small device, is 20 millimeters, and the large device is 25 millimeters. Why are these dimensions important? Because the wider a device, the easier is to grasp your leaflets, because you have a bigger reach. You go deeper behind the leaflet, so it's easier to grasp a larger part of the leaflet, a larger length of the leaflet. And immediately we can see that the Gen 4, what it brought very good results from this study. And as you can see, the usage of the wide clips tends to become universal. So I suspect the huge majority of the clips we're going to use from now on, the MitraClip Gen 4, will be the wide, the W, as you can see in this study. And this is the Pascal that has two sizes regarding the width. The Pascal A's, which is 6 millimeters, and it's similar width with the MitraClip, the wide MitraClip. And then the really wide Pascal, which is the Pascal 10, that has a width of 10 millimeters. So this means the larger the width, the bigger the area, the longer the area on the cooptation line that you can grasp with one device. So you can have a better reduction with just one device. And then the span of the device when it's fully open is 26 millimeters, irrespective of whether it's A's or the Pascal 10, which means that you have the larger span with this device. So the easier is to go deeper and grasp a larger part of the anatomy. And of course, the elongated configuration, as you saw there, that makes withdrawal back really easy. And here is a study, the registry, the expand global expand registry that used the NTR and the XTR. And what they did is they took the patients, they used any XTR device, and the patients that they used NTR only, large numbers, more than 1,000 patients, and they saw that they used the XTR when they had more MR, when they had larger anatomies, and also they used XTR more often when they had primary DMR than FMR. And the way they did the selection was very successful because, as you can see, irrespective of whether they used XTR or NTR only, they had similar reductions of the mitral regurgitation. The results all-cause death at 30 days, very low, so it's a very benign operation for this kind of patients, 2%, stroke, extremely rare, and a need for urgent surgery because of the procedure, extremely rare. And here are the anatomical features that made the XTR more successful in reducing the MR more consistently and more significantly, more than 2 grades. You see more MR, so the higher the MR, the more successful the XTR. More complex anatomy of the mitral valve, more successful. Larger prolapse gap, when we have higher gradient, which is probably a surrogate of the degree of the MR. And finally, when you have smaller dimensions, 1 XTR is more successful in reducing the MR. The leaflet adverse events in this registry, important to know, there were about 2% of the cases. They had a leaflet adverse event. And the single leaflet device attachment, the SLDA, was in 18 cases, as you can see. And leaflet injury, mostly perforation or tear, were in 4 cases, mostly in XTR cases. And when you see the procedural and echo characteristics, the SLDA, the single leaflet device attachment, was in more complex mitral valve anatomies. And when you had to have more grasping attempts, that was a characteristic of both the cases that they had detachment of the clip and in cases that they had leaflet injury, more difficult procedures. And then the residual MR severity was more than 3, more often, of course, when you had a SLDA, and 100% when you had leaflet injury, and only 2% in the general population. And they came back with some suggestions when to use XTR and NTR, basically from the results we've just described. And then we have the suggestion when to use the W that we foresee or anticipate that is going to be the dominant device from now on. When you have a broader jet, you will use the W, and when you have a larger valve, a larger annulus, a larger anatomy. This is a case of extreme PO1 prolapse, and you see with an 1 XTR XTW device how we were able to go there and grasp and have a very good results. And then the feature of independent grasping or clasping that was there in the Pascal from the beginning now is available with MitraClip Gen 4. And here is how we use it. When we have difficulty to grasp or clasp together the leaflets, like in this case, you see the anterior leaflet, the posterior leaflet, it goes out, and this was after multiple attempts. So what we do is we usually first get the anterior. You saw how the clasp went down, so the anterior is in, and then we move, we rotate the device, we tilt the device to go to the posterior, and then as you saw, the posterior clasp coming down to grasp it, and then we close the device, close the paddles, and we get this excellent result with one device. So this is a feature, the independent grasping, that is used in about 20 to 30% of the cases. And this is how we use it with MitraClip Gen 4. This is the optimization. It's not only the independent grasping, but it's also the optimization. So you see the device is positioned here. This is an NTW device, but you still have a lot of MR. So what we do here is you see the posterior leaflet is loose. So there is some part that still can come in. So we open the device, as you're going to see here, but the gripper stayed down. And then we open the posterior gripper, we rotate the device completely, we tilt the device to the posterior leaflet, as you can see here, and then we just drop the posterior gripper here, and you can see now all that loose part of the posterior leaflet came into the device, and that's why this grasping is better, and you get this excellent result without having to put a second device. So optimization with independent grasping is very important. And then we have also what we had in Pascal from the beginning, the hemodynamic monitoring that was continuous. We also have it with MitraClip Gen 4, and this is how we use it, the V-wave before and after the procedure. The difference in the Pascal is this nitinol design. Yes, thank you. I'm going to close soon. The nitinol design, that what it offers, and also the spacer, what it offers the spacer is a larger orifice area by approximately 20% in comparison to a device without spacer. And also the elements, the retention elements are all at the top of the clasp, as you can see. So once the leaflet is inside, then it's caught by all the retention elements. And this is a difference to MitraClip, that the retention elements are aligned, configured in this direction. So depending how leaflet you get inside, then you have a number of elements keeping the leaflet. And I think I will stop here. I had some more examples to show you. The only one I want to show you is this is a case that Mihaly showed earlier with calcium, is that it seems that with the new devices, the number of clips per case are going down. So here you see the number of devices per Pascal case is below 1.3. And here you see the numbers of the new Gen 4 clips per case, mitral clips per case, are also coming down between Gen 3 and Gen 4. And this also brings an improvement in the device time. These procedures become shorter. And I will stop here, and I'd like to thank you for the attention.
Thank you. Thank you very much for this excellent and illustrative talk. We understand there are many technical challenges when you have to deal with large volumes of left ventricle, and maybe the use of XTR is one of your tools. If there are any comments from the
I just want one brief question for one brief comment. You are one of the pioneers, Costa, of the technique and in general structural heart disease. I just want you to tell us your opinion, since you are one of the top recruiters for ReShape 2. What do you think will bring us? What extra information will give us?
I think I completely agree with what you said earlier about the way and the protocol was implemented in the COAPT, the way that all the patients were screened by a screening committee. The criteria were very stringent, and probably this was the difference between MITRA-France and COAPT. In ReShape 2, I think the protocol was somewhere in the middle. So it was certainly stricter than MITRA-France, but probably not as strict. It was giving some degree of liberty to us in the recruitment of the patients. And then it's also a small study compared to COAPT. So I believe that the extension of the study with addition of more than 200 patients will make it more conclusive. That's my belief about ReShape.
Thank you. Ignatius.
Thank you. It was an excellent presentation. I think Dr. Sparia showed us that there is always a solution for every kind of valve. And now we have new devices that can deal with all the problems that Dr. Chrysoheris has shown very elegantly from the echo guidance. And of course, I have to comment on Professor Vavouranakis. He showed us the large studies and showed us the need of new studies that will incorporate new criteria, new devices, and find probably new cutoff points and define the patients that will be the ones to benefit from these procedures. And I'm sure that the criteria will be extended, and ReShape 2, as Professor Filippato said, may shed some light on it. And I would like to conclude and finish this very interesting session and carry on through the rest of the day. Thank you all.
Thank you.
Thank you.
Good morning. So we welcome you in this second part of the edge-to-edge mitral regurgitation repair session. So we have a very interesting table. We will commence with Dr. Fabian Prats from Bern University Hospital. He will elaborate on the issue of which device to use, Pascal and or mitral clip, which are the indications, followed by two didactic cases by the best people, as we say in Greece, on the issue, Dr. Spargias and Dr. Nignos. So, Dr. Pras, the virtual podium is yours.
So thank you very much. Thank you for having me. It's a great pleasure, and I received this title, which is a bit a provocative one. And you know, I think we don't know everything about the device selection between mitral clip and Pascal, but I like this idea and to introduce, to follow on this idea and the comparison with TAVI. I think we have to look a little bit into the anatomy of the mitral valve as well, and to make comparison with the aortic valve. And if you look at this, you see immediately, actually only on these images, without going into too much details, that the mitral valve, but the atrioventricular valve in general are much more complex than the aortic valve. The mitral valve has a subvalvular apparatus, it has two leaflets, it is a mobile structure much more than the stenotic aortic valve, and has also a three-dimensional saddle shape structure, which make it much more complex. But if you think about it, during years, actually, the only device for repair that has been used for transcatheter therapy was only one size, and only the anti-mitral clip. While on the aortic side, you have several different devices to address more calcified patient, less calcified patient, and all different bicuspid, tricuspid anatomy. So probably a domain of structural hearts that where a lot of improvement was needed. And now we are so far, I think this development has taken place. So we had from 2003, the first mitral clip implantation, actually 15 years without so much change into the technique and into the device. And then since 2018, with the XTR device development, and 2016, of course, the introduction of the first compassionate case of the Pascal device. Costa and Michael were involved in that and were instrumental in developing this program as well. And now, you know, this competition as well has introduced rapid development in this device, with now 4 sizes with the mitral clip G4, 2 sizes for the Pascal device. And this introduced a lot of complexity as well in the selection and in the decision about this device. You have this before from Costas. You know, there are now 2 different devices for Pascal, for the Pascal platform. One large device, which is larger, the largest device actually on the market, with 10 millimeter width, and the ACE device that is more actually like NTV, or XTV, I would say. It's a bit broader than the anti-clip. And then you know about the particular feature of the Pascal device, with a large width, a large clasping width, and also the ability to elongate the device in entangle, to avoid entanglement and in difficult situation. The delivery catheter has a difference to the mitral clip. It has 3 catheters that are embedded with the opportunity from the very beginning to measure continuous left atrial pressure, which is now also the case with the mitral clip Gen 4. And these 3 catheters give a lot of flexibility. I think that's a bit the difference to the mitral clip system, that is more stable, but also a bit more stiff, and has now these 4 different devices that you can see here. A new feature with the Gen 4 is the control gripper actuation, is the ability to control one gripper independently from the other, which is, I think, also something that is used. We have seen some example before that is used now, I would not say on a daily basis, but in a significant proportion of patients treated with this device. So if I summarize a little bit, what are the main differences? So for the size of the devices, you have 2 different sizes for the Pascal, 4 different sizes for the mitral clip J4. There is no central spacer in the mitral clip, while you have this for Pascal and ACE. Both devices are now the option of independent grasping or clasping. And one of the important differences is also the closure mechanism. If you look at Pascal and ACE, it's a nitinol device, and the closure is a passive one, just based on the memory of shape of the device. While for the Gen 4, you have an active closing mechanism. And this makes a little bit of difference. I think I will come back on this in a minute. Number of catheter, 2 versus 2, and this 3 versus 2, and this influence a little bit the stability or flexibility of the system, and then the continuous left atrial pressure, which is possible with both devices now. If we look at what parameters play a role when we decide which patient will receive which device, I think leaflet tension is probably something we have to take into account. We start to understand this. There is not so much data, but we understand that putting a device in the mitral valve will create tension on the leaflet. This depends on how the leaflet are grasped, but also on the correct orientation of the device. And this play a role, I think, and has some difference in that device. There have been some work done on the fourth generation with a larger device that has a better repartition of the tension that it was the case with the XTR. But there is still some differences between the tension, and the tension is higher with the mitral clip than with the Pascal. You have seen this as well, also differences in the way the clasp or the arm of the clip grasps the leaflet, and also due to the spacer, differences in the way the mitral valve area is reduced with this device. And the higher tension will reduce probably the mitral valve area more with the mitral clip than it is the case with the Pascal. That's my next point. So if you see there are some differences in that device, and the important point with the Pascal is probably that due to less tension and maybe also the spacer, the reduction in mitral valve area is less than you would expect for this big device, and you are able to use a large device of 10 millimeter without having too much risk of an increased gradient. And we have also learned, we will probably publish this soon, we have learned from this data that there are also differences between XTR and NT in the reduction of mitral valve area. So differences in devices, and maybe also in the way you will apply it to avoid gradient. Mitral regurgitation reduction, is that a difference, or is that a criteria for the decision? There are some small differences if you look at this. So overall, we have an impressive increase and improvement in the reduction we are able to achieve with this new device. That's also a bit more operator experience. And you see here, if you look at EXPAND, you have 90% of patients achieving grade 1 or 2, whereas for Pascal, it's only 80%. But you have to keep in mind for EXPAND that about 1/3 of the patient did not have severe MR by core lab. So 1/3 of the patient had grade 1 or 2 MR already at baseline. So this data need to be a little bit look at it critically, but certainly small differences that are probably also due to the learning curve. If you look here, you are able with your 525 cases, if you are previous mitral clip experience, to improve your result with the Pascal. So a short learning curve that will be compensated very soon. So no big differences, I would say, but of course a head-to-head comparison of the device would be important. And if you look at anatomical complexity, we know that we are a little bit less good when the anatomy is complex, but still in the EXPAND study, excellent result with XT and XTR for patients with complex anatomy. The XTR has been used a little bit more, in particular in patients with large prolapse gap and large flail. So that gives a little bit the way also for the use of the XTV. I don't think many people will use the XTR anymore because of this issue of leaflet tension and the risk of leaflet damage, but the XTV is probably a good option. Pascal has been developed actually in patients with difficult anatomy, and already at the beginning, quite good result. As a conclusion, I would just show you a case where we, for example, in our center would take a Pascal. That's a patient with a short posterior leaflet, a very damaged leaflet, I would say, with calcification inside of the leaflet. That's typically an example of a case where we are a bit concerned about leaflet tension, about the risk of tearing this posterior leaflet. And that's a patient where we have used 2 Pascal device. You see the lateral one is a P10, a normal size device, and the medial one is an ACE. with a very good result in a patient that we consider at risk for leaflet tear, for leaflet damage, and in that situation would prefer to use the Pascal device. So that's a bit a summary that we are proposing in an editorial. So you look at mitral valve area, you look at the localization of the jet, and you look also at concern about leaflet tension or risk of leaflet tear due to the higher tension of the device, and decide finally what to use. The answer finally to my talk will be brought by the randomized trial from Edwards that is ongoing, and will give some differences, maybe or not, between this device. So I think, as a conclusion, both systems can be used indifferently in most of the patients. There are some patients where there is differences between concerning stability and flexibility and leaflet tension or mitral valve area, and a randomized head-to-head comparison is needed and will come soon to show differences in terms of safety and efficacy. Thank you very much for your attention.
So thank you, Dr. Prazet. It was very informative. So if you don't mind, maybe you could stick around, and at the end of following the didactic cases, maybe it would be nice to do the discussion. Thank you so much.
Of course.
Yanis, I think we could have a small discussion now if there are some questions for Fabien, because his talk was very interesting and very relevant to our practice.
May I have a question, please?
Yes,
Dr. Praz, yes. I'm Kostas Papadopoulos. I'm a clinical echocardiologist, not interventional cardiologist. I would like to ask you a general question. Do you think that is Pascal device only just a newly introduced device with some additional characteristics, such as the spacer or paddle design, that bring only better optimization of the leaflet capsule, or there are some specific or any specific indications that you prefer to use only Pascal and not mitral clip?
Yeah, so they are, I cannot base this statement on data because we don't have this data now. But there are some differences in practice that where you want to use a Pascal more than a mitral clip, I would say. And that's typically a situation where you have an anatomy that you see as a complex anatomy, where you have an anatomy where you expect actually to needing several grasps to adjust maybe your positioning, and an anatomy where you are concerned about leaflet tension and about damaging the leaflet. And this has several situations actually, a very short posterior leaflet, a very tethered secondary MR in patient with dilated left ventricle where the leaflet are under tension, where you could, by applying too much tension on the leaflet, have damage of the leaflet, or a situation where you have calcification, as I showed before, of the leaflet, or even a Barlow disease. In this situation, you cannot predict completely your result. You will expect to regrasp sometimes, and you don't want to be afraid, of having any tear of the leaflet. And in that situation, I think the Pascal is an excellent device.
Fabien, can I ask a question? Were there any case that you wished your Pascal was stronger in closing forces?
Sorry, say it again, Costa, I did not get.
Yeah, I wonder if you've ever had a case that you wished the Pascal closing forces were higher. You want a tighter grasp of the leaflets.
I don't think so. That's a very good question, actually. What you see typically when you implant the device, and you have seen it as well, you see it moving. So it's open with the leaflet of the mitral valve. But I don't think that this will will change anything in the result. What we see most of the time is rather than when you release the device, actually, that the result is getting better, because you have not this tension effect that you see sometimes with the mitral clip. And the other thing is that you have less tension on the whole system. So I think the result that you get before detaching the Pascal is actually more close to the reality than the one you will get after releasing the mitral clip. But there is probably some issue, some situation where you need more annuloplasty effect or something like this that we don't know yet. But actually not. I don't have this situation.
I'm glad to hear that we are coming to the same conclusions. I completely agree with your comments without having discussed about it before.
Another point, maybe relating to that, I don't know if you had this, but we never had a single leaflet attachment with the Pascal device. When I say that, I'm always a bit afraid because it will probably come tomorrow. But so that's a situation we never had so far. And I think the data, we have some data on that, and the leaflet, the single leaflet device attachment is clearly less. It's low with both device now. It decreased a lot with both device, but it's clearly less in the Pascal experience so far. And this relates also maybe to this tension issue.
Can I ask something? Just a short comment on this. Yanis Yakov, can I?
Yes, go ahead, Dimitri.
Yeah, good morning, Professor Pratt. It's Dimitris Nikas from Ioannis University Hospital. Before I offer my condolences to your last bit from Italy in the European consent song, Eurovision, I just want to comment on this because, as far as I understand, Pascal offers, let's say, less tension to the mitral area because it's obvious because it grasps a larger area of the mitral leaflet, therefore creates less tension. However, I'm just wondering, instead of looking which is more tension to what is less tension to the mitral valve, is there a point to use a combination, both of the devices or the devices of them? I mean, we did a couple of cases with Vlasis where we used an XTR and NTR device, or is there a possibility? I don't think this is make any sense, but I'm just asking to use both devices together.
You mean a mitral clip and a Pascal?
Why not?
Yeah, I've never done this, but that's very interesting. That you could imagine. Of course, if you do it in the same procedure, that would be something quite expensive because you will have to, to change your delivery system and everything. Right. But sometimes I could imagine a situation when you redo a patient having a mitral clip, for example, and you will use a Pascal. Why not? I'm not aware of that kind of cases, but that's interesting. One point maybe, because you may think that I'm only for the Pascal device in that situation, but that's not the case. So there's some elements that need to be mentioned as well. The stability of the device is something that needed to be improved, and that if you are not a very experienced operator, you will have some issue with that from the beginning. And also something I noticed, and Costas maybe did the same, saw the same in his practice, is that the matching of, for example, two Pascal to a P10, because of the spacer in the middle, is not so harmonic, I would say, as a matching of two mitral clip. And sometimes you may have small jets between the device. So that's all a little bit the consideration you have to take. But of course, also the size of the device is important, because the Pascal is actually the largest one on the market. And that's something, if you see a very broad jet, or if you see in a secondary patient a jet that you think you could maybe address with a broad Pascal device, that's an indication. I don't know if you have changed once from an ACE to a Pascal. We have done this 2 times, I think, because we are not happy about the reduction, and the difference is tremendous. You have a very big difference in terms of mitral regurgitation reduction when you change from one device to the other because of the larger paddles.
Fabian, good morning. I wanted to, you made an inference before about annuloplasty effect from edge-to-edge therapy. What can you elaborate?
Yeah, I think exactly that. I think that could be also a disadvantage of the Pascal device. We don't know this in details. I'm not aware of data showing this, but probably what you see, you know, the Pascal device, the normal one, is a very big one, and you can implant it actually only while it's not tensioning so much the leaflet, because you know, for this size, you would expect a high gradient in many patients, or a high reduction of mitral valve area, which is not the case, and that's probably because this device, you know, has a physiological way to grasp the leaflet and less tension. But if you think of annuloplasty effect in secondary MR, maybe this device is less effective than, for example, an XTV, a large mitral clip. So that's will be something that we will need to get experience on, and data as well.
Thank you.
Good. So, Dimitri Nikas, will you?
Yes, thank you very much.
Yes.
And it's my pleasure to present my good friend and long-time partner and long-time proctor to our center, Vlasta Dinios, who is going to present an interesting case with mitral clip. I hope to be one of our cases we did together, because every case we did together, it's a really interesting case. Please, Vlasis, go ahead.
Good morning, Dimitris. Good morning, everybody. It's not one of our cases, but yeah, I can definitely confirm that we had some very exciting moments in your cath lab. So the question is to show an interesting mitral clip case. And this is the case I'm going to share with you. Some of you might have seen it in some of my latest talks. This is an 87-year-old female patient with previous TAVI for severe aortic stenosis, and she had an initial improvement. The TAVI was performed about 2 years before, but then she went into heart failure, and obviously this is the reason she has severe mitral regurgitation. I have to say that when you look in this images, it doesn't look a very exciting valve to repair with edge-to-edge therapy. You can see that the leaflets are thickened. There's some calcification at the base of the posterior leaflet. You can certainly see a posteriorly directed jet arising from some part of the valve. And when we change into the commissural and X-plane view, so this is the commissural view, you can see that there's something flail going in the medial area. This is where the appendage is. This is where the septum is. This is the X-plane view that shows that there is a ruptured cord there. But if we put our axis exactly where the flail part is, you can see that there is a prolapse of the anterior leaflet just at the medial commissure. You can see that there's a ruptured cord. Of course, there's a short posterior leaflet. There's some thickening, and relatively the anterior leaflet is not very mobile there. This is the TAVI, and there's some fibrosis of the subvalvular apparatus, the posterior papillary muscle, you can see there. So we try to take some more views to understand the anatomy. This is a closer look at the medial commissure. And this is another look at the medial commissure. It is pretty obvious that there's a ruptured cord there. And the features of the anterior leaflet are as you see. So certainly not an easy case, certainly not a beginner's case. Maybe some would have rejected this case, but this patient had no options because of the age and the previous comorbidities, and we had to try and give a solution. These are some more views of the valve, as you can see, just to try to understand the anatomy. Here you can clearly see the fibrosis of both papillary muscles. The ejection fraction is very good though, and there's a dilated left atrium. Now we can definitely see that the jet is coming from the medial commissure. You can see it's an eccentric jet swirling around the left atrium, going into the left atrial appendage. And this is another view of that A3P3 area. So this is the 3D that shows that there's a commissural prolapse with a ruptured cord coming exactly from the commissure, and it's from the anterior part of the leaflet at the commissural level. And this is the color on the 3D picture that shows that exactly the jet is arising from this area. So the plan was to put an NTR clip. We didn't have Gen 4 at the time. It was just before the NTW came to us, to our region. So the plan is to put the smallest clip, the NTR, which is similar to the NT, as you know. And because we're going to attack the medial commissure, we wanted to have a transeptal puncture as posterior and as high as possible. So this is exactly the area, posterior mid-fossa, going in to the left atrium, and then trying to bend the system down so that we can get on top of the commissure. Now you can see here, we're trying to get to this area, but we're coming a little bit shallow on the aorta. So this is where we need to put a plus on the guide. And now you can see our trajectory is very, very much improved. We're coming really not shallow, hugging the aorta, but perpendicular to the level of the valve, which is what we want. And also we're above the commissure. I think we're just about right there. We're above the collar jet, and we're trying to hit the valve. So we're now below the leaflets. We've already turned counterclockwise our mitral clip. We had the clip closed just above the mitral valve. We went in with the clip closed just below the leaflets because we want to avoid the cords. You remember that there were some cords and fibrotic papillary muscle. We now open the arms and we just grasped exactly to the sweet spot. Here is the medial commissure. In fact, this was our first attempt. We have been quite lucky to grasp the exact area. And you can see now how we have enough tissue from the posterior leaflet, enough tissue from the anterior leaflet. We still have some mobile part of the posterior leaflet out, but you can see how immobile the anterior leaflet is, exactly where the fibrotic part towards the base of the leaflet is. We're very, very satisfied to see that the collar had disappeared. And that was very nice. And then this is our 3D. So you can still see, despite the fact that the clip is closed, the counterclockwise direction. So this is the aortic valve. So instead of having this configuration to the A2-PTU area, we have this configuration respecting the line of coaptation to the medial part of the valve. And you can see that this huge jet that was coming from the commissure disappeared. And this is the final result after releasing the clip. We're very happy that there was no MR, and also that both leaflets were still attached to it. And here is the final result. And this is our final fluoroscopic image, something that we see more and more these days, a TAVI and a mitral clip. This is the 3D before and after. You can appreciate that we don't have a medial commissure left. It's a true commissural clipping. The ruptured cord has disappeared, has been swallowed by the NTR. And the valve orifice is a little bit smaller, but of course there was no stenosis and no residual MR. So this is the case. I'm open to discussion and thoughts, perhaps coming after Dr. Price's talk about Pascal and mitral clip. It would be interesting to see if Pascal would have been a selection for this case, or if, for example, I mean, these are my questions, if we had the Gen 4 available, whether we would have gone for an NTW, or we just would have still used the narrow NT. Maybe this is a case for just a narrow NT clip. So
thank you very much, Vlasis. It was really an educational case. As you said, not from the Gibbons, I wouldn't dare to do this one because I think it was accuracy and particularity, I think, was the key in this case. Am I right? I mean, putting the right size, the right device to the right spot at the right particularity, I think was the key to have this great success with one clip. Am I right?
the key with commissural clipping is to be absolutely spot on the area where the ruptured cord is, and to make sure that when you go in, you don't rotate, you don't have open arms, you don't go very deep, because if you go too deep and you get caught on the chorda, it might be a problem because your cords of the medial commissure are just below the leaflets, fanning around. So, you know, it's very, very absolutely sure to have your trajectory right, your perpendicularity right, and then go in very slowly, open the arms below the leaflets and go for the grasping. And you remember that we have done some of these cases together, Dimitris, and you've been very good with it. So I'm pretty sure you could have attended it yourself.
And so if it is, this is a session between a fight between one device to another. So as far as I can see one advantage of the mitral clip, because it's a smaller device, so you can easily do, as you said, the spot-on clipping. On the other hand, it's a device that cannot enter easily to the left ventricle and that can be more easily to be attached to the cornea. Do you think a Pascal device, which is larger, and on the other hand, it's more safe to put it and rotating inside the left ventricle and make, let's say, better particularity, would be an advantage in this case?
I don't have any experience with the Pascal device, so maybe Kostas and Professor Praz can comment on that. And of course, it's also an issue to discuss because there was a lot of fibrosis and some degree of immobility at the base of the anterior leaflet. So maybe the clip tension would have been a disadvantage. On the other hand, this is a really narrow area. You saw where the cord is. I mean, it was definitely a few millimeters, 2-3 millimeters width of this scallop there. And you didn't really want to go more wide than that. You didn't need, and perhaps you didn't want to. So it's a question, and I saw from Dr. Spraz's slides before that there was a big question mark on commissural disease, whether Pascal would have been an option. So please, can you comment on that, Dr. Praz and Kostas?
Dr. Praz.
So yes, excellent case. I mean, that's always a challenging case to go into a commissural lesion. The advantage of this case is, of course, you have a clear lesion. You know exactly where the problem is, but you know, just to catch, it was your first grasp. The exact area is quite challenging. For commissural lesion, you know, you saw the question on my slide, and actually that was before the ACE. So clearly, if you want to use Pascal in that situation, I don't know if Kostas does it differently, but we will not go, or not anymore, with a big one, so with a normal Pascal, and we will rather use an ACE. And I think, you know, as you mentioned absolutely correctly, the tension on the leaflet is less a problem in commissural lesion. The maximum tension is rather in the middle or slightly off of the middle of the valve. And in that situation, I think the NT, as I would have gone from AT as well. The NT is an excellent device. You don't even need the wider one. So excellent choice. Huh? And you know, the stability in that situation of the mitral clip is an advantage. If you are very medial, then you will go in very stably, and it will do the job.
I completely agree with both of you. So we coincide on the decision. Commissural, very small vena contracta, very small area, and I would definitely go with mitral clip NT. Now with the NTW, I think the difference is very little, just 2 millimeters. So I'd probably go with NTW. The only disadvantage of mitral clip here would be that in case you had to retract it back into the left atrium, and the configuration of the Pascal is more safe, I believe. But then again, you want to get the best result to tuck down the flail there, and I think a smaller device like the MP would also be my choice. I wouldn't worry about calcification because that part of the posterior leaflet is fully mobile, and that part of the anterior leaflet is fully mobile. There's no calcification there.
I don't know
well
if any ever come to
and usually the cases you're afraid of, like this one, are the cases that go very well. With just one attempt, you finish the case with an excellent results. And this is a low, and when you have a case that you think it's easy and you don't give a lot of thought about it, it turns out to be very difficult. So And that's why the pre-procedural planning should be done in all cases, irrespective of whether you believe they're easy or difficult.
I think that's a very wise tip of an experienced mitral operator. It's exactly the case. You don't expect the difficulty most of the time.
I don't know if any other of our co-moderators have any comments or questions. Yannis, Dr. Papadopoulos.
I'm all set. It was really an excellent case, and philosophical as well. The conclusion.
So I think it's time to go on, and I will ask Dr. Papadopoulos to present the next prestigious speaker.
First of all, I would like to thank the organizing committee for the kind invitation. So let's proceed to the next speaker, Dr. Sparias, an expert, a pioneer in the field of transcatheter heart valve interventions, and for sure the right person to present us an interesting case about the Pascal device and its use in edge-to-edge procedure in patients with mitral regurgitation. Dr. Sparias.
Thank you, Kostas, for the introduction. And after Vlas's very nice case, I'll show you another interesting, I believe, case, this time using the Pascal device, with some similarities and some differences compared to the previous case. So this is an 86-year-old male that has severe mitral regurgitation from a flail A2, a coronary artery disease with previous multiple stenting, previous surgical aortic valve replacement with a bioprosthetic valve, and a rich history of other medical problems, as you can read on this slide. Chronic atrial fibrillation, and his ECG here. This was his chest X-ray. You can appreciate some pleural abnormalities there on the right side. This was his treatment, typical treatment for coronary artery disease and heart failure. These were his coronaries. You can appreciate the old stents in the right coronary and LAD, but there was no, this burning significant disease that needs to be treated. And also a stress echo only showed mild inferior ischemia. And so the decision was to proceed with conservative treatment. And this was his mitral regurgitation. You can appreciate the prolapse, the small prolapse in the center. And here you can start to appreciate the problems. You can see this part of the anterior leaflet that is calcified and immobile. And you can see this chordae that is also calcified. And just below or above the chordae, you can see the last part of the anterior leaflet that is mobile and prolapsing. There is also some calcification in the base of the posterior leaflet. And you have an eccentric jet that is swirling around the left atrium. And some more imaging here are the mobile lengths of the leaflets. They are both short, both the posterior and the anterior, the moving anterior. They are only 8 millimeters on this measurement. And here you can appreciate the immobile part of the anterior leaflet, the mobile and prolapsing part at the tip, and the heavily calcified chordae and secondary chordae in the anterior leaflet. And here is the tricuspid valve that has moderate regurgitation, as you can appreciate here. And these are the 3D images of this regurgitation. And here you start to get a grasp about the anatomy. And what you see is some annular calcification, but then a nodule of calcium on the anterior leaflet that extends down to the tip, almost the tip of this leaflet. And you can see that this is exactly the area that the vena contracta originates. And so this is exactly the area you want to position a device. Certainly severe mitral regurgitation. You see various views here. You can appreciate the calcium problem in the anterior leaflet, again, in these views, and another measurement of the posterior and the anterior leaflet. And to add on the problem, you have already a baseline mean gradient on this valve of 4. So, and this is the additional problem. And the third additional concern is that you have a small annulus area on this gentleman with only 3.5 square centimeters. So we discussed a lot about this, so no need to discuss again. I go ahead with the procedure. We decided to go ahead with the Pascal device for all the obvious reasons. You see the measurements, you see our transeptal. We always use a safe set for our transeptals. And you see the V wave at the beginning of the procedure was 42 millimeters, and the mean left atrial pressure was 25. Keep these numbers in mind to compare with what we had at the end of the procedure. And these are some photorealistic images of the beginning of the procedure, crossing the septum with a guide catheter. The guide catheter here, this is what we had on the day of the operation, and the patient under general anesthesia. So if anything, it's more, more marked regurgitation from what we had at the baseline, the screening echo. This is our device coming out from the guide catheter in the left atrium, and then it's rotated down towards the mitral valve. In the center, you see we have a good coaxiality in both the medial lateral and the anterior posterior. And then we check the perpendicularity and we correct the perpendicularity, and we do a precise targeting to the area of the regurgitation. And here, what we're gonna see is how the device looks on fluoroscopy. And here we're taking the clasps. First, both of them are going up. You can appreciate them here, the posterior clasp and the anterior clasp. And this is to recognize, to acknowledge which is which at the beginning of the procedure in case we need to do independent grasping or optimization. Here you can see the posterior clasp coming down, and here you can see the anterior coming down. And this is the suture that holds the clasp up and down, pulls the clasp up and down. And now we are below the valve with the device almost closed. We check and correct perpendicularity again below the valve. Oh, that was quick. And this is the, we're very lucky in brackets, again, like Vlas's before. So our first opening of the device, and we have both leaflets on our paddles. And as you can see, no need to use the independent grasping. Both clasps are falling down, and they get here, both leaflets very nicely and all the way in. So this is the device half closed. And just to appreciate its positioning in the leaflet insertion before we close it more here. So the residual regurgitation is becoming lower the more we close the device. And here, just before release, and it's interesting what Fabien noticed earlier, that with Pascal, consistently what we get with a device released is usually better than what we have with the device on. So this is our final result in this difficult anatomy with just one device. And here you'll see the release of the device and the shape of the device, how it moves. This is the ACE, the Pascal ACE, the small Pascal. And this is the hemodynamics at the end of the procedure. So the V wave went down to half, 22 from 40 something, and the mean to 21. And this is our final result on the table. And you can appreciate there is a mild grade 1, probably residual regurgitation in this difficult anatomy with one device. And you will see there is no interaction with the calcium, no injury on the valve. This is the 3D, and the device is exactly where we want it to be. And photorealistic imaging, live 3D color, and various imaging of this valve after the positioning. And here we're going to see that the gradient didn't really change, despite putting a device with a width of 6 millimeters there. The mean gradient remained 4, and the area measurements, as you can see, the 2 orifices there were just above 2 square centimeters. And with that, I would like to thank you for the attention.
Thank you, Dr. Sparias. Excellent presentation and very interesting case. I have just 1 or 2 questions. First one is, considering the design and mainly the size of the Pascal device, you have also mentioned, but how does you think it's impacting mitral valve gradient? Have you experienced cases with increased mitral valve gradient, in particular when you need more than 1 Pascal devices?
That's a great question. I think this is one of the advantages or of the features of the Pascal that made it desirable for many cases. Like this one, that you had already a high gradient at the beginning and a small mitral annulus area at the beginning. Because of the central spacer and because of the device design, the nitinol mesh, the way it closes and the forces it exerts of the leaflets, we don't really see significant increases in the gradients with this device, despite its large size, because consider that the ACE, the small Pascal, has the width of the wide mitral clip, exactly the same, 6 millimeters. So there is like a range. You start from the small mitral clip, the width of 4, then you go to the middle, which is the W, the wide mitral clip, same in width with the ACE, the Pascal ACE, and then you go to the wider device, which is the Pascal 10. So for the reasons we discussed, we don't really see a funny and marked increases in gradients, even in small anatomies and in calcified leaflets or fibrous leaflets that move and block together with this device.
Thank you very much. I see also Michalis Sersocheris here, and I would like to ask him if there are any particular changes regarding the imaging procedure, the TOE procedure, in Pascal comparing to mitral clip, or you follow the same steps during the TOE procedure. And also I see the Pascal device a little bit larger, a little bit bigger. Maybe what about the artifacts of this valve, the sounding artifacts or blooming or other artifacts? Do you have difficulties to see the grasping very well of the device in the leaflets, or no, or you don't have any?
This is a very interesting question indeed. The procedural steps are similar between the two edge-to-edge leaflet repair technologies. So essentially, we go through the same imaging views and the imaging sequences. And in terms of whether there's difference in acoustic properties, in overall for the mitral space, I don't think there is any significant difference between the mitral clip and the Pascal device. And in general, we haven't had the issues with imaging. Indeed, the Pascal device is a bit bulkier. It has the central spacer, and that's a difference from the mitral clip device, which is narrower. But overall, we haven't seen in the mitral space much difference in terms of the acoustic properties and imaging that we need to have. Now, definitely, we don't have device-specific imaging yet, imaging that's tailored to the particular device. It's sort of a generic imaging, but maybe in the future we'll see device-specific imaging, something that's going to be more specific for the mitral clip or the Pascal device.
Thank you very much, Michael. So are there any questions or comments from the panel? Dr. Iakovou or Dr. Nikas? Yes?
I
have a question.
Yeah, Costa, so if you were limited, so if you could not use a Pascal device in this case, what would you do? What would you be, the option with the mitral clip? What would you choose? An NT device or an XT?
Yeah, I would definitely attempt this with mitral clip as well. Just have the luxury of the selection of the two devices. So I selected Pascal for the reasons I've explained. I would go for an NT, I think. Okay. The risk going with NTW would be to have a gradient and have to remove it and go with NT. I think the choice will be between NT and NTW. But I want to ask all of you, speakers and panel, after these presentations, these three presentations, are you convinced somehow that there is a selection process now when you have two devices available doing edge-to-edge repair, similar to the selection process between SAPIEN and Evolut, let's say? Is it going there?
I can answer that because I had the belief that maybe these devices can be interchangeable. But of course, there are a lot more data with the mitral clip, and the interventional cardiologist or the cardiographer can feel more safe to place the mitral clip. But after these two cases and the discussion, I think I reached the conclusion that maybe they're interchangeable in a way, but in expert hands. So of course there are special, let's say, advantages and disadvantages, but the main thing is to plan the procedure. And if the procedure is difficult, as we said before, Kostas, it will end up smoothly. Okay.
I think we are quite fortunate that we have 4 different sizes for the mitral clip and 2 different sizes for the Pascal. It's like the coach on the football, Pete, that you have all the players available and then you don't know who to put in to play the game. So I think refining this process and getting the data from the trials will help us to refine the selection, really. If you compare this to the romantic years about, 10 years ago when you had only one clip and that was it, it's really fortunate that we have these options.
If I may make my comment on this, to my mind, I put some notes here. To my mind, I think Pascal device, it's a bigger, safer, more easy to use device, but much more bulkier. So I think you grasp a lot, but you don't know what you grasp with all. On the other hand, the mitral clip device is smaller. You need to be more accurate. So it's more than like a craft-handed made job. This is how I can understand the two difference between the two devices. I don't know, Professor Prats agrees with me.
Yes, I think that there is something there, but I'm convinced there are differences. So, for example, the case Kostas saw is a case that I would be also very reluctant to attempt with a mitral clip, because you have this transition between a mobile part of the leaflet and calcification, and in that situation you are really concerned to if you have to regrasp to just tear this part of the leaflet. So I think we will move to defining some anatomies that at the end everybody will agree for one or the other device. That's a process taking part now, and also for the TAVI world, some people will rather do a SAPIEN. Some people are doing only SAPIEN, and some people are doing only Evolut, and some people are doing it more in a more differentiated way. So it's not completely different. It's exactly the same process. and we will start to understand this more and more. But I think the case that has been shown are really two very nice cases. I would have done the same. The case with the commissioner, I would have go for a mitral clip because of the stability of the device and the size of the device. And the case Costa, I would have gone for a Pascal because of the concern of having and the mitral valve area as well. So I think really very nice demonstration actually.
Excellent. So Kostas, do you have any closing argument?
I don't have anything else to say. I think it was a very interesting and very formative session. So we have no time, and we proceed to a break, a 30-minute break, and then to the next session about the mitral, also mitral clip is the part 3, I think.
Okay.
So I would like to thank everyone. Dr. Yakov, if you want to say something at the end.
Oh, it was okay. It was a learningful session as we expected. We learned a lot, and thank you to the organizers for letting us be part of this insightful experience. Thank you very much, and we will continue, of course, to follow this very interesting virtual conference. Thank you.
Thank you very much. Bye-bye.
Thank you.
Good afternoon to everyone. I think we're coming to the third part on the edge-to-edge repair for mitral valve regurgitation. We have excellent panel and excellent also crew chairman for this session. I think I will call first Professor Akeli, who is an expert on echo, and discuss with us the metrics of success or failure in edge-to-edge repair, echo and hemodynamics. Professor Akeli.
Good morning, ladies and gentlemen. I would like to thank the organizing committee for this kind invitation. We know that transcatheter edge-to-edge mitral valve repair has revolutionized the treatment of primary and secondary mitral regurgitation. The landmark Everest and COAPT trials included only clinically stable patients with favorable mitral valve anatomy for edge-to-edge repair. Lately, the growing operator experience, device iteration, and improvements in interprocedural imaging have led to an expansion in the utilization of transcatheter edge-to-edge repair to more complex mitral valve pathologies and clinical scenarios, even in acute clinical scenarios. We know that there are two available different devices, MitraClip with two arms in order to grasp the leaflets, and the Pascal device with two paddles in order to clasp the leaflets. Lately, we have discussed more frequently for unfavorable futures for edge-to-edge mitral valve repair. Besides rheumatic etiology, none of these anatomical criteria is viewed to be an absolute contraindication. And we know that there are different types of clips with different arm lengths and different arm widths. And we also know that XTW has wider clip arms with independent leaflet capture, and it has improved leaflet engagement, enhanced steering control, and has designed for challenging cases. And so it's a more powerful device and is more feasible and suitable in Barlow's disease. Concerning anatomical considerations for the use of NTR and XTR, we know that XTR is suitable and it favors more for A2 to P2 target, whereas the NT clip is more suitable for commissural target. And you see one of our cases with a long redundant leaflets. You see how difficult is the grasping using NT device. On the other hand, Edwards Pascal transcatheter valve is another repair system, more newer. As you see, it has a central spacer intended to fill the regurgitant orifice area and two paddles in order to reduce stress on leaflets. And another characteristic of Pascal system is the implant elongation for safe subvalvular maneuver. And this is the result. These are the results of 1 year follow-up. You see how favorable are the results. So let's focus on top pearls for success of clip. The A to Z is the case selection. Another important points are the proper interceptor puncture, real-time left atrial pressure monitoring, orientation of clip, holding the respirator during grasping, confirming leaflet insertion, and the final evaluation of the result combined echo and hemodynamics. First of all, the case selection is very crucial. We have selected high risk or sick but not futile patients with adequate mitral valve orifice, adequate leaflets to grasp, and furthermore, location of pathology does not matter. This is the pre-procedural checklist. After anesthesia and tracheal tube placement, we have to confirm MR severity again, mechanism, and origin. We have to evaluate for pulmonary vein flow reversible, measure MV gradient. We have to rule out left atrial appendage thrombus and to evaluate for pericardial effusion. It's very important to demonstrate to study the anatomy, the morphological data of mitral valve pathology, and of course to evaluate the regurgitation, the mitral valve regurgitation. You see, this is a patient with A2P2 prolapse, and you see using Doppler, color Doppler, multiple jets across the coaptation line. Another 3D demonstration of mitral valve from LA perspective. It's like a real senile smile with severe mitral regurgitation. Different anatomy in this patient with a redundant A1 to A2 segments from LA perspective and LV perspective. And you see, using the 3D color Doppler, you see the origin of the mitral valve regurgitation. Another anatomy with prolapse of anterior and posterior leaflet and clefts between P1, P2, and P2 and P3. It's very important to measure the mitral valve leaflet length. You see that this case has a very short and restricted posterior leaflet, and this mitral valve is unsuitable for XTR. We have to consider the mitral valve dimensions of. Lately, it has been recommended to use more and more CT to accurate demonstration of anatomical data of mitral valve apparatus. First step is the proper transeptal puncture at the mid-fossa posterior 4 to 4.5 centimeters from the mitral orifice for function, and more than 4.5 centimeters for primary mitral valve regurgitation. An optimal puncture will facilitate maneuvering, device alignment, and trajectory. In most of our cases, we evaluate the whole procedure using 3D depiction. This is a case with lipomatous hypertrophy, and you see how the atrial septal puncture is challenging to proceed to the mitral valve mitral clip implantation. Second step, continuous LA pressure measurement. And you see the high V wave, which is consistent with severe mitral valve regurgitation. Orientation of the clip is very important. You see from the LA perspective, the open device, which has to be perpendicular to the coaptation line, and the second or the third device should be parallel to the first one. Another case with device perpendicular to A3 to P3 area, and we have to check the perpendicularity when the device is in the left ventricle, lowering the gain. Another case, you see the oriented device to the mitral valve regurgitant orifice. Fourth step, it's safe to hold ventilator for up to 3 to 4 minutes on 100% of AiO2 to help. It's very helpful to accurate position of the clip and to grasp of the leaflets. And we have to check also the leaflet insertion and to evaluate the residual MR. Less leaflet motion means good insertion. Excessive leaflet motion means inadequate insertion. And of course, the deterioration of mitral valve regurgitation means a distortion of the leaflets. You see an example of the grasping of the leaflet, and you see that there is a more than moderate residual MR due to distortion of the leaflets. We have to evaluate using 3D Doppler before and after the procedure, and you see how lower is the mitral valve regurgitation using 3D. Spectral Doppler recording is essential before the procedure and after the procedure, and you see the reverse or blunt systolic pattern of pulmonary vein before and the normalization of the velocities after the procedure. And of course, we have to measure the mean gradient. Ideally, the gradient should be less than 4 millimeters of mercury. And we have record again the LA pressure. You see a severe reduction from 68 to 22 millimeters of mercury. Finally, we have to depict, to demonstrate the iatrogenic heteroseptal defect. You see that in this case, we have left to right shunt, but in this case, we have right to left shunt. It's a challenging case. Recently, we have published, which is the significance of shunt directionality of iatrogenic heteroseptal defect. There are conflicted findings in the literature. We know that most of the majority of iatrogenic heteroseptal defects spontaneously close within 12 months. And that rate of systemic embolism and stroke did not differ from rates in patients without iatrogenic heteroseptal defects. And finally, we have using transthoracic echo, we have to demonstrate the mitral valve using Doppler. And ladies and gentlemen, dear chairman, we have to combine echo or cardiovascular imaging data and hemodynamics data in order to confirm the successful procedure. Horoscope in the future is addressing unmet needs in interventional cardiology, and it were to point out that the magnitude of benefit of edge-to-edge procedure is less in proportionate MR patients. The proportionality is the only reason for disagreement between COAPT and mitral FAR trials. Maybe it's not. There are many other factors such as severe TR or severe PASP that predicts outcomes. And the final conclusion, the case selection is important, is a heart team decision. The experience and attention to detail at each step is essential. Use of echocardiography and invasive hemodynamics are essential in final assessment of results. Thank you for your attention.
You are muted, Professor Vavrounakis.
Ευχαριστούμε πολύ την κυρία Αγγέλη για την εξαιρετική ομιλία της. Μπορούμε να κάνουμε, αν έχουμε κάποια ερώτηση, βλέπω στο chat δεν υπάρχουν. Αν κάποιος από τους πρόεδρους θα ήθελε να κάνει κάποιο σχόλιο, δεδομένου δεν έχουμε την κυρία Αγγέλη μαζί αυτή τη στιγμή.
It was, so good morning from me as well. I'm Christoph here from Nicosia General Hospital. It's a great honor to be among esteemed colleagues to co-chair this session. A very interesting and excellent actually talk from Ms. Ageli, which showed very clearly how important are the technical details of this procedure. And in these cases, I am wondering sometimes, and maybe Kostas, who has the experience of following up these patients, what do you think is the most important aspect? The clinical background, the LV dilatation, the RV dysfunction, the pulmonary hypertension, or how adequately and precisely we have managed to minimize the MR and without having any mitral valve gradient in any residual stenosis? Or this is not a valid question at all and everything is important?
Christos, this question is for me. If I may, make a comment.
If you can make a comment.
Well, there are several publications that show that it depends on the base LV size, the size of the right ventricle and the contractility, the pulmonary artery pressure. All of these are very important for the outcome of the patients that are going to implant an edge-to-edge repair device, especially in functional mitral regurgitation cases. And I would also like to comment that for the success of these patients with FMR, we need to see the reverse remodeling of the left ventricle, how the left ventricle reduces its volumes. And I think that's why in ACC guidelines 1 year ago, they used the COAPT criteria for FMR cases, for LV size, for pass spent ejection fraction.
Okay, let me make a point here. I think it's important to realize that, and I think that was the topic also the Professor Gale tried to clear up, that we have to have certain parameters that we should use and evaluate during the procedure to make sure we adequately evaluate the results. For example, a very important issue is that as far as hemodynamics, you have to know the blood pressure when you evaluate the residual of the MR by the echo. You have to be sure that you have adequate pressure. Otherwise, a good result in the lab on the next day might be much worse. So this needs to be definitely addressed. I saw very nicely that she addressed the issue of pulmonary vein velocities, which is very important. I think we should also measure that before and after the procedure. And also to make sure we don't create a new mitral disease, mitral stenosis. And I know that when you start putting, we had a case, we had to put 3 clips, and on the 3rd clip, this was a case, and we have to actually disengage the clip. We know that when you develop mitral stenosis above 6 gradient, the prognosis is definitely worse from long-term follow-up. So I think these are parameters that we need to follow appropriately on every patient. Anesthesia does affect hemodynamics, so you have to consider that also. And I think that would be my message of how to appropriately evaluate the results that you have immediately after procedure.
And Professor, you are absolutely correct. With the team of Dr. Sparias, we used to increase a little bit the blood pressure at the end of the procedure in order to not to be affected from the sedation. And it's very important for the stenosis effect, we need to have a normal heart rate, because if the patient is in tachycardia, then we know, and Dr. Soheris knows very well, that the mean gradient increases along with the heart rate. So all these are important to be evaluated at the end of the procedure.
Great. I don't know if you're ready to proceed to Dr. Papadopoulos with your next presenter. Yeah,
yes, if we don't have any other comments, just one last comment, Professor, if I may, for the limits of regurgitant orifice area that we may have at baseline for edge-to-edge repair. There has been a publication showing that if the ERO is more than 70 millimeters square, then we might have failure of, we might not be able to reduce all this MR. Do you have any comment on that?
I think the more complex the anatomy is, the more severe the MR, the wider the MR, and I think we're still learning that. We probably need to use wider devices, but I think with the availability of this device, probably we can avoid putting 2 clips, and the more complex the disease, the more possibilities that you will have some residual. Ideally, if you have A2P2, obviously the results would be much easier to be obtained. So yeah, but we have several tools now, but depending which size we are targeting. If you are targeting P2, P3 is different than P2. P1 is different again. Smaller devices need to be inserted. You see the anatomy, how fragile is the tissue that you will grasp. Several things, you know, that. But I agree, the larger the regardless of an orifice, chances are that you're probably not going to get the good results, or at least an ideal result.
Just a comment on this question from Konstantinos regarding the severity of the regurgitant ERO. Obviously, the MitraClip and Pascal is what we have at this point, so we would attempt to fix these valves even if they had severe torrential mitral regurgitation. Obviously, we will require multiple devices, but in the future, and as transcatheter valves are coming out, this would be the area of competition between multiple edge-to-edge leaflet repair therapies and valves, because we know that with MitraClip or Pascal, we may have some residual MR in these very sick patients. However, with the valve, we can eliminate mitral regurgitation at all.
Okay, yes, great. This is a great comment. Hopefully the valves will be improved and will be able to fit different anatomies. You know very well, Michael, that you need to have a good angulation, space, but I think this is the future for the difficult anatomies, and I think that's why I believe MitraClip will still have a place, and excellent actually results will be obtained, but then we will have the different anatomies when MitraClip and Pascal, of course, both devices, and then you have the difficult anatomies where the valve will probably be your best option. Dr. Papadopoulos, we're ready to go
on. After this very interesting discussion, we can move on to the next speaker. Is Dr. Kurkovelli from Hygia Hospital. We will see a MitraClip, a Pascal case for a functional mitral regurgitation in a pre-recorded video. If we can play the video.
Dear colleagues, hello. Thank you all for your attendance here today. I have nothing to declare, and this is the THV team at Hygia Hospital. The patient I'm going to present to you is a 63 years old male in New York Heart Association classification 4 with multiple admissions for heart failure decompensation last year and increasing need of inotropes. Patient has a history of ischemic cardiomyopathy and coronary artery bypass grafting in May 2019 and an LV aneurysm repair at the same time. Has a chronic kidney disease, with a creatinine clearance of 37 and has already CRT device implanted. The echocardiogram showed dilated left ventricle and left ventricle with a diameter of 72 millimeters, ejection fraction of 20%, severe FMR, severe pulmonary hypertension, and severe dilated left atrium. Patient was on optimal medical treatment at that point. So there was several discussion about what to do next with this patient. Hemodialysis was an option for volume optimization, or a 24-hour inotrope infusion with through a catheter, a Hickman catheter, LVAD implantation, or to target the mitral valve disease per se with transcatheter treatment. So this is the baseline echo views of the mitral valve. See the huge vena contracta and the severe mitral regurgitation. The hemodynamics with huge V waves of the atrial, of left atrial. And this is the echo images of the during the Pascal P10 implantation, which is the device was planned to be positioned at the A to B2 segment of the mitral valve. And this is the final views, and you can see only a mild residual regurgitation in the lateral segment. Again, the Pascal device well and stable at the A2P2 segment. There was no residual stenosis, and the mean gradient was 3 mm of mercury. And the final normal hemodynamics, you can see the difference with pre and post hemodynamics here. The patient was discharged 4 days post-implantation, and he was clinically improved. And these are the medication at discharge. And an impressive thing was that his renal function was also improved with a creatinine clearance of almost 59 ml per minute. 1 year later, patient remains stable, New York Heart Association classification 2. He had no hospitalizations for heart failure decompensation, and his medication were up-titrated to the maximum tolerated dose. This is the echo 1 year post the implantation. You can see the Pascal device, which is stable, the residual mild regurgitation, and the mild increase in the left ventricular ejection fraction. So just to conclude, we need all to remember that functional or secondary MR is not a benign disease, and sometimes the underlying cardiomyopathy is not the cause of the patient's decompensation, and we should target the mitral valve pathology. Optimal medical treatment and cardiac resynchronization therapy, of course, the hallmarks, but we should not forget transcatheter mitral valve treatments when applicable. And to conclude, this is a slide of the COAPT trial showing very clearly the positive effect of good medical treatment and the device implantation in patients compared to good medical treatment alone. Thank you all for your attention.
That was an interesting case and a nice Pascal case for FMR. As you can see, this was a really diseased left ventricle, and how important is the concomitant mitral regurgitation in these patients that reduce the prognosis and make the compensation. So Michael, at first, after this Pascal implantation, the remaining MR was considered to be mild, a bit more.
Well, both with echocardiography as well as hemodynamics, we considered it to be mild residual regurgitation on the table, that means, with one Pascal device. It's interesting, the reduction in MR was tremendous. It was a very wide jet. Pascal has a width of 10 millimeters. It's a wider device compared to the mitral clip. We probably would need 2 or more mitral clip devices to deal with this anatomy. One Pascal device was sufficient. And again, the whole case highlights that in many patients with functional mitral regurgitation, it's not the cardiomyopathy, it's the valve that is in trouble, and the valve is the one that's really impacting the prognosis of these patients and their quality of life. And fixing it will make truly a big difference.
From these two randomized trials, COAPT and MITRA-FR, do we really screen and select the patients according to the left ventricle? I mean, have you ever rejected the patient because he had a really big left ventricle and disproportionate LV disease over the MR?
Well, you may not always help the patient if they have advanced cardiomyopathy, but for instance, I can recall a patient that was on a transplant list in whom the mitral regurgitation was corrected with a mitral clip, and that delayed eventual cardiac transplant for another year. So you may help patients in different ways by these procedures. You may not always have the tremendous benefit, but you may help them in different ways. And definitely there's a quality of life improvement.
Professor Vouranakis?
Actually,
well, I think we have discussed this previously in other session and our personal discussions with all the whole team, I think we should be very careful when you select those patients, having in mind two different approaches. The one is to improve, reduce hospitalizations, improve survival. And when you are looking at that aim, you have to follow the data from the clinical trials. So a bad ventricle, less than 20%, dilated ventricle, probably this patient might feel well for a while, maybe 1 month, 2 months, but then will deteriorate and they will not improve survival. So you have at least at this point, still an expensive therapy for a health system, which has not been proven in the extreme outside of the trials that it does benefit. So this is one case where the case that was presented was an excellent case. Obviously, the patient met all the criteria of the co-op trial. I don't know if the surgical risk for redoing probably was high. Anyhow, the patient had already bypassed. So this is under optimal medical therapy, had a device. So I think you should give the opportunity to do the best you can on this patient. But if you have a patient with a dilated cardiomyopathy, 50%, at the end of his lifespan, I think it's futile to inform the patient that this will prolong his life. You can say that you might try and see if it improves some symptoms for a while, but we have to be very clear what we expect with this, with the edge-to-edge repair. Mortality benefits have been shown only the population that we had, and remember that these mortality benefits were not shown with regardless of the etiology that we expect, proportional, disproportional with the France MR. So we have, because we should not give to the patients messages and expectations that might not be a reality. And it's our responsibility. If we explain them what we expect, it's perfect, but we have to be clear on that.
Dr. Eftichiou, do you have any comment?
Yeah, it actually was a really interesting case, and it came exactly after your comments when you have regurgitant volumes over 70, and the ROA the ROA of the patient was 80 square millimeters, and despite that, Professor Vavouranakis is right. We don't know whether this patient will have a survival benefit, but the patient actually felt better. It was clinically improved, and it's probably as equally important to survival benefit to a young patient who he was less than 70 with a lima and a rima, no option of surgical reintervention, I believe. And we shouldn't forget that the clinical benefit in symptoms is also equally important in some cases. If you don't have any other comments, I think it would be nice to move on to the next speaker.
Let me clarify. This was an excellent case, good selection. That's why I mentioned, because the patient had a bypass, had a lima. So obviously, but I'm talking about the extreme that, the question was brought with. So it's a different patient. This was an excellent patient. He was helped and he improved clinically because it was good and appropriate selected after optimal medical therapy, plus had a resynchronization therapy, I think.
And no
I would
other
also
options.
point out, I would like to point out on this particular patient that the mitral clip device, the option for edge-to-edge repair was offered as a last resort. People thought highly of hemodialysis sessions. They thought about inotropic support for this patient with a central line and so on. But with the edge-to-edge therapy being the last on the list, which I think is a disservice not only to this patient but also many other patients who are being treated in ICUs and they don't have access to this therapy. Now I understand that they talk about survival and patients who are very ill and so on. I think Dr. Shuvi later on will show us some amazing data on patients with the cardiogenic shock and patients who are post-MI with significant functional mitral regurgitation. And again, you will see that functional mitral regurgitation is a problem of its own. And it's many patients, it is a valve that is destroyed. And we treat it as, we say functional, we imply benign, but it's not benign. That's what I'm getting to.
We can go on.
If there are no other comments, then we should move on to our next speaker, Dr. Shavi from Israel. who will talk us about transcatheter mitral valve repair for post-myocardial infarction patients and for patients with cardiogenic shock.
Good afternoon. I'm very happy to be in the transcatheter heart valve in Greece, and I will present TMVR for post-MI patients and for patients with cardiogenic shock. So let's start first with a case. This is a 74-year-old woman that presented with shortness of breath. Her past medical history include recent ST elevation MI. She presented with late arrival infraposterior wall MI 1 month prior her current admission. During the hospitalization, she underwent reperfusion to her left circumflex artery. Other comorbidities include dyslipidemia and hypertension. Since the episode of the ST elevation, she was hospitalized several times due to heart failure and pulmonary congestion. The recent episode involved respiratory failure due to pulmonary edema that required insertion of intra-aortic balloon pump and mechanical ventilation. She was treated with aspirin, clopidogrel, bisoprolol, spironolactone, high dose of Lasix, and Entresto. Her chest X-ray at admission shows pulmonary edema. And we can see here the echocardiogram, the TEE, that showed moderately reduced LV function with akinesis of the infraposterior wall MI. The infraposterior wall MI akinesis causes tethering of the leaflets, and but without papillary muscle rupture or any caudal rupture. And the tethering of the leaflets causes severe functional mitral regurgitation after a recent myocardial infarction. Patients that develop acute mitral regurgitation, if after myocardial infarction or in other causes like papillary, such as a cord rupture in patients with degenerative valve disease, often became very symptomatic. The reason for this is the low compliance of the left atrium. Therefore, the regurgitant volume causes very high pressure in the LA, which translates to pulmonary edema and even to cardiogenic shock. The MR in this condition is also part of the vicious cycle of the LV dilatation, more severe MR, more LV dilatation, and deterioration to severe heart failure. So what are the treatment options for patients that develop subacute functional MR after acute MI? So we can treat them, of course, medically, and many of them are managed medically. However, in many patients, the medical therapy is not enough, and those patients need intervention. Mitral valve replacement is a valid option in this condition. However, those patients are often very symptomatic after recent myocardial infarction and therefore are high risk for surgery. And MitraClip is another option in order to decrease the MR and improve the patient's hemodynamic. And that was what we chose for this woman. We performed an acute MitraClip. We reduced the MR, improved the hemodynamic, and allowed recovery of this patient. So following this case and additional cases that we did an acute MitraClip, both for patients after acute MI and both for patients that develop acute rupture cord in degenerative valve disease, and even in patients with severe heart failure that deteriorated and required urgent intervention for recovery. And we showed here our experience for acute MitraClip in this population, showing that the procedure is safe and allows recovery of these patients. Next, we establish a multi-center international registry of MitraClip in acute MR after MI. The registry included several hospitals from Europe, the United States, And from Greece, as you can see here, our friend Michael Christo-Harris and Dr. Spargias were all part of this registry. And in this registry, we described a salvage mitral clip in severe secondary MR complicating acute myocardial infarction. And we showed that early intervention in these patients improve the MR grade, reduces significantly the atrial V wave and the pulmonary artery pressure, and allows recovery. Most patients recover from their very severe condition and improve significantly. Following this data, we developed the primary mitral clip concept, which suggests that patients that develop acute MR after MR are usually at very high risk. They have high Euroscore. All of them are treated with dual antiplatelet and maybe with also anticoagulation. They're very symptomatic because of the acute nature of the MR. And we showed that early mitral clip is safe and effective in selected patients. It allows us to avoid cardiopulmonary bypass in this condition. Usually the valve is favorable because the condition is often due to the LV remodeling without the involvement of the valve apparatus. And of course, it preserves the surgical alternative in patients when the clip is not very successful. Next, we thought to look and compare the intervention with mitral clip with surgical treatment and with a conservative therapy. And this data was presented a few days ago in a late-breaking trial in the EuroPCR, and I am happy to show the data also here. So the data included a retrospective analysis of patients who had at least +3 MR and heart failure symptoms within 90 days after the acute MI. The data was obtained from 21 centers in Europe, North America, and the Middle East. All patients were managed or by surgical intervention, repair or replacement, the SMVR group, PMVR with a mitral clip system, or without mitral intervention, just medical therapy. And let's go for the results. Here is a comparison between patients that were treated conservatively and patients that were treated by intervention, PMVR or SMVR. We can see here that patients that were treated conservatively were significantly older, but patients that were treated with intervention had higher Euroscore. Most of them had at least KLIP 3 class at admission. Almost 50% of them were in cardiogenic shock, which is significantly higher compared to the patients that were treated conservatively. Almost 40% of them were required mechanical ventilation, and almost 45% of them required intra-aortic balloon pump. And although patients that were treated by mitral valve intervention had more comorbidities and were sicker during their hospitalization, their outcome was significantly improved compared to patients that were treated conservatively. In fact, patients that were treated conservatively had very high mortality rate, reaching to almost 40% mortality within 30 days after the MR. The predictors for mortality included age, KLIP 3, mechanical ventilation, and of course, cardiogenic shock. Next, we went and compared patients that were treated by SMVR compared to the PMVR, which means we focused on the interventional group. We can see here that patients that were treated with PMVR were older, had more comorbidities, they had more prior stroke, they were more likely to have chronic kidney disease, the Euroscore was higher, the ejection fraction was lower, more than 50% of them presented in cardiogenic shock, and almost 45% of them required mechanical ventilation. and 40% were required intra-aortic balloon pump. Now let's go for the outcomes. We can see here that SMVR and PMVR were both successful in reducing the MR. However, major complication was significantly higher among patients that were treated with the SMVR. Almost 1/3 of them developed major complication. This major complication was translated to high in-hospital mortality. Almost 1/4 of them died during hospitalization compared to less than 10% of patients that were treated with PMVR. These results were also translated to increased 1-year mortality among patients that were treated with SMVR compared to PMVR, and you can see here the Kaplan-Meier curves. So for conclusion, we showed that post-MI severe MR is associated with poor outcomes. PMVR is successful in decreasing MR. It improves hemodynamic parameters and was associated with lower mortality rates when compared to surgical intervention. Therefore, PMVR might be considered as an alternative for patients that are deemed high risk for surgical intervention after acute MI. And of course, the data is a retrospective data, and future randomized trials are required to validate our findings. Thank you very much for your participation.
Good morning, Moni. How are you doing?
Are you with us? Professor Savi, can you hear us?
Yes, I can hear you. There's some problem with the connection. I can hear you. It's great to be with you also online, but maybe next year in person.
Yes, we hope to. All of us hope to. I think you succeed a lot in Israel, although where you are walking out without masks and everything.
Yeah, yes, it's a big change now with the vaccinations. It's really new life now. Hope it will also be first in other countries again.
You can also tell that it's really old life.
Right. It's old life, definitely.
Old life.
Professor Savi, let me first of all, I congratulate you on your attempt to establish the mitral clip in a very high risk population. I saw the Euroscore 2, it was 17, the average. So we're talking about really high risk patients. And those registry data support that it can be a bridge, at least a bridge, until maybe later you have, of course, you mentioned that it has to, before it comes to real daily practice, it has to be proven by comparison with surgery. And the question is actually kind of going to this, because a lot of these patients might have also concomitant coronary artery disease, which will influence the decision. So it would be very difficult to match, according only to the mitral insufficiency when you compare those groups with surgery. Is that right? I mean,
I have some issue with the connections, but I can tell that it's really difficult to compare those patients with surgery, because often surgery is not even an option for those patients. We know from previous studies that most of those patients are treated medically. They don't have any, the physicians that treated don't even think that any intervention to the valve is really an option for them.
Do you think?
And then for the first thing,
I'm going to stop because I think. Go ahead, Professor Savi.
Can you hear me now?
Yes.
Yes.
I must say that most of those patients are not even candidates for anything. We know from previous studies that patients that develop cardiogenic shock after MI and severe MR are often treated medically. And we know that those patients face a very poor prognosis. So the first finding of those patients in our trial is that intervention is good for them. Though they're at very high risk, intervention sometimes is the only option for recovery. And then when you compare to the SMVR and the PMVR, we can see that PMVR is sufficient to allow some recovery and allow stabilization and allow stabilization of the LA pressure, especially, which often leads to recovery for those patients. And then they can be, of course, treated medically and even, if needed, require surgery. But the clip is the bridge to recovery of the acute event.
Do you foresee, I know it's against the guidelines, but I am asking for your experience in the future, that the mitral clip might have a position in lower risk patients as a bridge?
I think so. Yes, I think so. That sometimes you see some patients that you say, okay, I can, if I'll just decrease the MR, I may prevent surgery in the near future and maybe delay the surgery in few years. I had a recent patient that they had moderate AS and moderate to severe MR, a young guy that didn't want to go now for two surgeries, for two valve surgery. And we thought that we can buy time for surgery by fixing the mitral valve and allowing him medical therapy until the aortic valve will require intervention. So it's possible, although it's not the most common scenario. I must say that the most common scenario that I see it is the patients that are extremely sick, patients that are severe symptomatic, and that mitral clip in this scenario allows stabilization of the patient and even allows that more effective medical therapy. I must say that in my experience, many of patients extreme conditions cannot tolerate medications. They often have low blood pressure, they have a chronic kidney disease, and medical therapy is often limited to those comorbidities. And sometimes intervention to the valve can allow better medical therapy in this high-risk, very sick population.
Professor Shabi, thank you very much. Very interesting topic and excellent data. I have a question. How long would you wait after revascularization before proceeding to a transcatheter edge-to-edge repair?
That's a great question that I don't have an answer. I must say that many of the patients that develop acute MR are often patients that are late arrival for their revascularization, often get non-sufficient revascularization, a lot of thrombus, no reflow, and many times the revascularization is not optimal in those patients. I must say that in patients that have great revascularization, the need for intervention to the mitral valve is often low. So many of those patients have limited revascularization, and therefore waiting is not a good solution for them. In fact, I think that if you have a non-reperfused artery and the patient in cardiogenic shock, don't wait. Just try and stabilize those patients with a clip. And I must say that the hemodynamic effect of this intervention is tremendous. Patients getting to the cath lab with a V wave of 60 and blood pressure of 80, systolic blood pressure of 80, and a few minutes after clipping them, the LA pressure, the V wave reduces to 15, and the blood pressure immediately goes up and helps those patients that are in critical shape to recover the hospitalization.
Moni, can I ask you a question? What do you think will be required for this therapy in this subset of patients to gain traction and become essentially a class 1 indication?
Well, I must say that waiting to a randomized trial will be difficult. Most of those patients are really in extreme condition, and I'm not sure that randomized trial will ever occur. I think that the most data that we'll get, it will come from retrospective data. I think that the availability of the clip and the confidence of the team to perform mitral clip in patients who are in severe conditions are the key for allowing this therapy for those populations. Sometimes you hear, oh, he's too sick for this. I don't think so. I think that we should treat those patients like in a STEMI. If they are sick, you go and open the artery. If they are sick and have acute MR, it won't be resolved by itself. You should go, have the ability and have the confidence to take patient in cardiogenic shock to the cath lab and do an acute clip. And I think this is a way to establish this therapy.
Even in mechanical complications of MI. With Dr. Sekeris and Dr. Spargas, we've done a case with papillary muscle rupture with great results. You know that, I think.
Definitely. The data that we include also patients with papillary muscle rupture, although most of the patients had functional MR, and therefore I'm not, we cannot really say that, okay, if you have a rupture papillary muscle, the treatment of choice is a mitral clip. It's too early to say this, but it's definitely an option. And I'm sure that if you are looking for those patients in cardiogenic shock after MI, you will find the severe MR, and this is one option for those patients for stabilization.
And I totally agree that it's going to be really difficult to do a randomized trial, especially if half of these patients are on ventilation. It's not going to be easy to recruit these patients.
Yeah.
Okay. Well, can I ask a question before you close?
Yes, Kostas. Yes.
Hi, Dr. Savi. I think we completely agree that these are the patients you need to act upon. If you have anything to offer to them, you have to stop the acute MR. And the thing that these patients used to be well up until a few hours or days before the MI event, I think it's an advantage to them. If you correct the acute problem, they have more higher likelihood to become well as they were a few days ago. But what's your opinion about the much larger population that develop subacute MR after a successfully revascularized or less successfully revascularized MI? So they don't develop the MR acutely in the hospital, but they develop it subacutely over the next few weeks to months. So have we identified the sweet spot when it's the best time to intervene in them? Because they have like severe MR like 2 months after, moderate 2 months after, severe 4 months after, but with good dimensions still. And then we see them after 6 months with severe MR and now dilated LV. So a lot of us think that something like a miracle may happen and may get a good remodeling. So wait. But then again, waiting, you see a negative remodeling and a most difficult case. What's your opinion about the ideal timing of intervening with clipping in these patients with subacute MR after an MI?
I think it's a great question. It's a great question. The data that I showed is just patients that need an urgent intervention for recovery. However, patients that develop subacute MR and then develop adverse remodeling, and then you meet them after a few months with dilated LV, more severe MR, and heart failure, are patient populations that should be addressed in a randomized trial. I definitely tried to do this. I tried to establish a randomized trial of patients that have symptomatic moderate to severe MR after MI and see if early intervention to the mitral valve can stop the adverse remodeling and allow them better medical therapy because many of those patients, in order to be stabilized, are getting very high dose of medications. They're on high dose of Lasix, after load reductions. Many times they develop symptoms, although they are with a very high dose of several medications. And I think that mitral clip in this population should be offered to delay or avoid the adverse remodeling of the left ventricle. However, the data is still lacking in those populations, and I really hope that I can establish a randomized trial of medical therapy versus early intervention in these patients and show that early intervention to the valve can prevent the adverse remodeling. We have this data from animal studies that fixing the MR early prevent the adverse remodeling. However, no data on humans in this condition.
Well, we have to stop this session. We already start joining us, the other speakers. So thank you very much, all of you, for your presentations. And we're ready to proceed with the next session. Thank you very much.
Thank you all.
Thank you.
Have
Thank you very much.
Bye-bye. Have a nice day. Hello, welcome to this session that is one of the most interesting sessions of this two-day course on transcatheter heart valves, and it's focusing on tricuspid valve that seems to be like the focus of transcatheter interventions lately, surpassing even the field of aortic and mitral valve. And it's our pleasure to have some of the top cardiologists in the field from all around the world. First, the imager, the leading imager in the world, Rebecca Hahn, that will be with us with a pre-recorded presentation because of the time difference. And then we're very lucky to have live with us probably the top users of edge-to-edge repair in TR, from Germany, Professor Stefan Verdeleben and Professor Hausleiter. So we feel very lucky. The first will tell us about the technicalities of these procedures, and the second, same again, the technicalities of this procedure, but especially when we have to do simultaneously both the mitral and the tricuspid valve. And with that, I would like to let the video of Rebecca Hahn to begin. And I would like, first of all, to welcome you. And we're going to moderate this session with my colleague, Dr. Christopher Harris and Professor Toutoukas from Athens University. So let's start with Rebecca's presentation.
I'd like to thank the conference organizers for inviting me to speak today on when to intervene in TR, clinical factors, TR grading, RV function, PA pressures, and pulmonary vascular resistance. These are my disclosures. What do the guidelines currently say about the treatment of tricuspid regurgitation? Well, in order to manage TR, one needs to determine the etiology as well as the tricuspid urge severity, quantify right ventricular size and function, determine the etiology and severity of pulmonary hypertension, and then determine symptoms. By doing so, one can go through this algorithm and appropriately determine those patients who should undergo surgery or medical therapy. How about the assessment of symptoms and the role of medical therapy? Well, in the US guidelines, the clinical symptoms and presentation of severe symptomatic TR include elevated venous pressure, dyspnea on exertion, fatigue, ascites, and edema. All of these are signs and symptoms of decreased cardiac output. But the problem with tricuspid regurgitation is that volume overload is tolerated well until late. Early presentation is very nonspecific: peripheral edema, fatigue, reduced functional capacity. When late symptoms occur, they are associated with right heart failure, bloating and early satiety, ascites and hepatomegaly, pleural effusions, chronic kidney and liver disease, coagulopathy and cachexia, very poor cardiac output with relative or absolute hypotension. The guidelines state that there's a class 2A indication for treatment of this disease with a diuretic. In addition, in those patients with signs and symptoms of right heart failure, therapies to treat the primary cause of the disease, including pulmonary vasodilators to reduce pulmonary pressures, or guideline-directed medical therapy for heart failure with reduced ejection fraction, could be very useful. The European guidelines are not that sure. Indeed, there is a lack of evidence-based data to guide therapy. But we know that right heart size, and therefore tricuspid regurgitation, is very sensitive to a diuretic. And although we lack evidence-based medicine, we know that clinically our patients will respond initially to a diuretic. Indeed, we should be trying to determine an aggressive diuretic algorithm for these patients. And yet we still lack ongoing research necessary to design these algorithms for treatment. What about the treatment for left heart failure? Well, we know that there are a number of different medical therapies or CRT that decrease mortality in association with heart failure with reduced ejection fraction. And many of these have actually been shown to reduce mitral regurgitation. We know from the mitral clip COAPT trial that indeed treatment of mitral regurgitation could result in the reduction in tricuspid regurgitation, and in doing so, reduce mortality. How do we assess tricuspid regurgitation severity? Well, the guidelines suggest that we use multiple parameters that seem more appropriate for mitral regurgitation. It turns out, in fact, that we do have a number of different parameters by which we can grade mild, moderate, or severe disease. However, these parameters are limited. We know they're limited in the setting of tricuspid regurgitation because of the irregular, eccentric, or elliptical orifice that is often seen with this tri-leaflet or even multi-leaflet valve. In this instance, the vena contracta, which is usually measured from the septolateral dimension, will grossly underestimate the anteroposterior dimension, and therefore more complex ways of assessing regurgitation are needed, and nearly all measures of TR in the guidelines will underestimate TR severity. We've shown in the core lab that when you look at proximal ice velocity surface area as your method for calculating regurgitant orifice area, and compared that to 3D vena contracta areas or Doppler volumetric regurgitant orifice areas, that PISA EROA significantly underestimates the severity of the disease by the other two methods. That indeed, when using a multiparametric method to determine which patients have severe, the cutoff associated with those patients is an EROA of 34 millimeters squared versus 60 millimeters squared for 3D vena contracta area and 65 millimeters squared for Doppler EROA. Indeed, we also looked at the average vena contracta area from 2 orthogonal views and found the cutoff to be 9 millimeters instead of 7. All of these numbers have been confirmed by other studies, but importantly, even using these numbers, we know that patients come to us with much greater than severe disease. In fact, massive and torrential have been suggested as additional severity grades in the setting of patients coming with right heart failure symptoms. We now know from, again, multiple studies, this is one of the first, that there is an increased mortality associated with grades higher than severe. The study by Perry used PISA EROA to show that in those patients with greater than 40 millimeters squared EROA, so greater than severe, there was indeed excess mortality associated with an EROA of 70 millimeters squared, which would be the equivalent of massive to torrential disease in the proposed new cutoffs. Finally, this study by Fortuny looked at vena contracta width and EROA by PISA, finding that there was an increase in hazard associated with vena contracta up to a certain point. And at that point, at the plateau, there was no further increase in mortality, whereas with PISA EROA, there was a continuous mortality with higher values, therefore also proving that there are grades beyond severe that have increased mortality associated with it. Eventually, we will be able to use multimodality imaging for TR severity. However, further validation is required. What about quantifying RV size and function? Well, the guideline suggests that we need to do that because the right ventricular and right atrial dilatation is a consequence of the severe tricuspid regurgitation. We have normal values for RV systolic function, as well as normal values for right ventricular size. But most of the normative data does not distinguish between mild, moderate, and severe dilatation or mild, moderate, and severe dysfunction. And therefore, there remains an unanswered question of how to actually accurately grade RV function for the trials of transcatheter devices. We do know, however, that using the simplest measures that we have, so just a tricuspid annular dimension or a TAPSE, that we can divide patients with severe secondary disease into 4 different RV remodeling groups. And in those groups, the ones that have either dysfunction or dilatation, patterns 3 or 4, are indeed associated with worse 5-year survival rates. But it's the RV dysfunction that had significantly worse survival than patients with normal RV function. And therefore, RV function becomes one of the main things we need to determine in order to understand the outcomes of our patients with severe TR. And whether or not we can use 3-dimensional imaging or more refined measures of RV function remains to be determined. This happens to be a 3-dimensional strain imaging assessment where you can look at both global, longitudinal, radial, and anteroposterior strain, showing again that the strain is significantly altered in those patients with pulmonary arterial hypertension. So multimodality imaging may also be of use here in looking at RV size and function. We know that we can look at volumes by CMR, but we could also look at RV strain and 4D flow. These may help us determine the severity of regurgitation, as well as the recoverability of RV function when looking at RV fibrosis. But it is indeed the response of the RV to the pulmonary afterload that may also help determine outcomes in our patients with TR. We know that the RV is extraordinarily sensitive to pressure overload, and you can see here in patients with even change in the septal location. So this is a patient with LV disease, that you will alter flow and the mechanics of the RV. And so it is indeed this response of the RV to the pulmonary arterial and pulmonary vasculature that may determine outcomes. We know that we can measure the pulmonary artery systolic pressure by echo, but indeed in patients with severe tricuspid regurgitation, we know that there can also be an underestimation of the pulmonary artery pressures, and that's proven by this study by Philip Lurtz, who looked at those 3 different categories of patients, ones that had concordant echo and invasive measures but no pulmonary hypertension, and the concordant patients with pulmonary hypertension, and then another set of patients that had discordant measures of pulmonary arterial pressure. And it's those patients with discordant measures, very low echocardiographic measures of pulmonary artery pressure, but with pulmonary hypertension by invasive means, that had the worst outcomes. And that when Lurtz looked at the afterload corrected RV function using invasive measures, and so this is RV-PA coupling using invasive pulmonary artery systolic pressure, that measure also determined the combined endpoints of mortality and heart failure hospitalization. So what is RV-PA coupling? Well, ventricular arterial coupling specifically refers to the relationship between the ventricular contractility and afterload. It is the most objective metric of RV function, and therefore can be measured not only invasively, but also non-invasively. There are a number of different studies that have used these non-invasive measures of function, TAPSE, 3-dimensional RV ejection fraction, or RV strain, and coupled it to estimates of pulmonary vasculature, so either pulmonary systolic pressures or pulmonary vascular resistance. In our study, we looked at the tri-valve registry. This is a registry of patients who have had transcatheter tricuspid valve intervention, and looking at the baseline measures of TAPSE, which is tricuspid annual plane systolic excursion, divided by pulmonary estimates of pulmonary artery systolic pressure, all done non-invasively. We see that high TAPSE is associated with much better all-cause mortality compared to those patients with low TAPSE, and therefore a TAPSE may become one of the measures that we look at to gauge outcomes in our patients. So in sum, the European guidelines look at a variety of different parameters in order to decide the appropriate therapy for the patient with tricuspid regurgitation, including determining the etiology and severity of the disease, RV size and function, pulmonary hypertension, and RV-PA coupling, as well as determining the symptoms. And what we need to do in the future is to continue to increase the awareness of the prognosis associated with TR in order to make clinicians aware of the need to move those patients into level 1 valve centers, and then improve the quantitation tools for quantifying TR severity, RV size and function, as well as RV-PA coupling. In that way, we can determine the most appropriate management strategies, which should include aggressive medical treatment algorithms, and then determine the appropriate intervention and the timing of intervention based on patient-specific anatomy. Thanks for your attention.
Great. That was an excellent talk about the echocardiographic assessment and imaging of tricuspid regurgitation today, with a view to timing of intervention and time of intervention. And I'm happy to say that we've started to have a better understanding of what echocardiographic parameters we need to develop and to assess, to understand, to evaluate these patients before making a decision to intervene either with something that will offer partial reduction of the tricuspid regurgitation, like edge-to-edge repair, or something that will offer complete sealing with a transcatheter tricuspid valves. and I'm very happy about it. Comments from the panel?
This was a very comprehensive analysis by Dr. Khan, and I really appreciated it. I appreciated multiple levels. Number one, the emphasis on RV function and how much we really don't know how to assess mild, moderate, or severe RV dilatation or RV dysfunction. And the emphasis on trying to get a better handle on that was great, actually. Also, the coupling between the RV function and the pulmonary artery, and those metrics are very interesting, and I think it's going to have tremendous clinical impact. And also the severity of the tricuspid regurgitation, which definitely cannot be mild, moderate, severe, but extended to torrential and massive, because it has a survival difference in these patients. I found it fascinating.
I fully agree with Dr. Harris, and it was a wonderful presentation regarding the optimal time and the tools that we have, the diagnostic tools. I also emphasize the 0.7 ERA, that it's a threshold that we should keep in mind, and also the underestimation of the pulmonary artery pressure by the echo. We should keep this also in mind.
Right. It's one thing to intervene in every patient with TR just to reduce symptoms irrespective of the RV function or RV pulmonary resistance coupling interplay. And it's another thing to intervene in a patient that you know from before and you have approved from before on echocardiographic parameters that this patient will have a prognostic benefit from this intervention.
Yeah, I agree, Kostas. I think it's very important to see that we have low mortalities now at 1 year and 2 years in these single-arm trials, and we're getting more data on this. And I think it's also important to learn from pediatric and congenital cardiology that we have to respect the precapillary pulmonary hypertension as a dismal progression here. And this may not be the right candidate. So I would highly support to do more right heart caths in these patients before treating them.
Great. Kostas, you want to proceed with?
Okay, that's wonderful. Let's proceed to the second lecture regarding the tricuspid regurgitation. I'm really happy to introduce you from Professor Stefan von Bardeleben from University of Mainz, and he will talk about the Pascal in tricuspid regurgitation, some pearls, do's and don'ts. Please.
Yeah. Dear panel, thank you very much for the very kind introduction, and it's my pleasure to move on to one of the two major tiers possibilities in the toolbox of treating actually tricuspid regurgitation. These are my disclosures. Tricuspid regurgitation anatomy has already been shown by Becky Hahn, but I would like to highlight that in most cases, we have an interaction between right ventricular and right atrial dilatation that adds to disease progression with a flattening of the virtual tricuspid annulus. And this produces actually predominantly between the large anterior and the septal leaflet, as well as between the septal and the posterior leaflet, a progressive gap that will be treated by a leaflet therapy like the Pascal system. The prevalence and etiology of TR has already been highlighted. It's approximately 4 million. So it's the second place after mitral regurgitation. And on the right-hand side, we see again the etiology, which is in 60% of the cases, left ventricular or left valvular disease. Isolated TR is rare with about 8 to 10%, and even more rare is organic disease or congenital disease, which accounts for approximately 7%. In those isolated and organic disease patients, very often also pacemaker plays or ICDs play an important role, and this is more and more recognized as we do more tricuspid valve echoes in patients, and this should also be highlighted in the etiology evaluation. On the other hand, there may be at least a recommendation class 3 for primary pulmonary hypertension, as given here with about 20 to 23%. And those patients with typically a wedge pressure below 15, with a transpulmonary gradient and with Woods units between or above 3.5 or above 5 have actually a more dismal progression of the disease. And we know from pediatric cardiology that those patients treating those with shunts, with valve disease, actually may accelerate their disease progression and their fatal outcome. So we already saw by the extremely nice talk of Becky, the situation that we typically underestimate, especially with PISA methods, the regurgitation. And if we are used to ROAs between 0.2 to 0.6 in the mitral, we have to learn that vena contracta area in the tricuspid space can be anywhere between 0.2 and 4 centimeters in carcinoid syndrome, for instance. We also know from the latest publication by Shireen that actually also tricuspid regurgitation as mitral regurgitation is a severity-dependent predictor, marker, and component to negative outcome and mortality in those patients. We already saw these images about the invasive PA measurement, and it's important to highlight that on every patient with a severe, massive, or torrential TR, echo fails in predicting really the right ventricular pressure and PA pressure, as the RA will become more and more ventricularized. So as soon as you have a 3rd, 4th, or 5th grade regurgitation, you should always add an invasive right heart catheterization, as highlighted in this very nice publication, the European Heart Journal. There are also predictors of success, and they also influence actually what we do, whether we do annuloplasty or, as in this talk, tricuspid tear, transcatheter edge-to-edge repair. And we've seen in the TriValve registry by Maurizio Taramasso very nicely here in 2019 that patients with a procedural success fare much better and have a long-term outcome here of 1.5 years that is superior to those who stay in a situation of severe, massive, or torrential regurgitation. The main univariate and multivariate analysis parameters here are annular diameter, and transcatheter methods begin to fail at an annulus diameter of approximately 5 centimeters. This means that there is no replacement system, and that also TEER has more and more problems to overcome gaps of more than 1 centimeter. The early studies were done with gaps of about 4 millimeters to 5 millimeters in the Trilumnet trial. Later, with the upcoming new devices with independent clasp control or independent grasping, we know that we can also safely treat between 5 and 10 millimeters, but above 10 millimeters, the effect is less pronounced. Building up a systolic PA pressure was actually in the multivariate analysis a positive factor, and this may be that there is still a differentiation of the pressures between the ventricle and the atrium, because this was an echo parameter and not done by invasive measurements. This explains the paradoxical situation you see at the bottom, and this also highlights again the importance of the paper by Philip Lourdes, as we've seen it already with Becky Hahn. Tricuspid valve is a very complex situation, and we always say that TAVR versus mitral valve is an upgrade in complexity, but tricuspid valve imaging and tricuspid valve regurgitation treatment is still another upgrade in complexity to mitral valve treatment. There are multiple reasons for this. For once, we have very dense cords, so the cords are not as predictive with 2 papillary muscles on the mitral, but we have moderator bands, we have septal integration of the cords, and we have a huge impact of volume or pressure dilatation of the right ventricle on the performance of the cords and of the tethering. On the other hand, both the leaflets and the cords are thin and more fragile. So typically the power that can be taken up to pull on these leaflets is less than about 60% of that of the mitral valve, as the right heart is not used to high pressures as is the systemic ventricle. And these thin variable leaflets, on the other hand, have less calcification. So the annulus is more compliant actually to pulling with the TEER system or with the replacement system. So we have also benefits on this valve. And on the right-hand side, you see that we have the largest valve and the largest annulus of the human body. So typically, a tricuspid valve has an effective valve or opening of 5 to 7.5 centimeters square, which is much larger than the mitral and, of course, especially pulmonary and aortic valves. If we look into the concepts to use the Pascal system, the beginning was actually, and there is also a very high experience in Greece with Spargas, of course, Kostas, of the initial mitral, but also tricuspid treatment with the Pascal system. You can see that the Pascal system is quite wide with approximately 10 millimeters in the central part, but it has a unique feature, and that is the material. It is not stainless steel, but nitinol, which allows the system to open under pressure and to close again. And this can happen per heartbeat, but this will also happen on different volume status of the patient. So if the patient gets filled up with 2 liters of fluid, the Pascal implant will open slightly, and thus giving way to the pressure and causing less stress on the leaflets. And I think this is a very important feature of this device that you can nicely see in the cartoon on the right-hand side and caused by the super elastic nitinol components of this device. On the other hand, there is, of course, the need to overcome the gap. And you see this is a typical 3-dimensional image. You see that there is a small gap between the anterior leaflet, which is between 3 o'clock and 7 o'clock. The posterior leaflet is to the lower left side, between 6:30 and 9 o'clock, and the septal leaflet here is on the top between approximately 10 o'clock and 2 o'clock. And one of the features of the Pascal TR repair system is that we can bridge the central gap of the patient, and we don't have to actually attach one leaflet to the other, but we use the central spacer to overcome this central gap that most often is in the commissure between the anterior to posterior to the septal leaflet. So this typically is a trigone that will always be open. There is a new system now, which has overcome actually the use of the classic Pascal implant that you see in comparison above. So since August 2020, we have the commercial possibility to also implant the smaller Pascal ACE implant. The main features are that the central spacer is slightly slimmer. The elongation works exactly as with the Pascal implant. The nitinol design is the same. We also have independent clasps, but it's very important that we have a 6 millimeter instead of a 10 millimeter profile and a central spacer. And the system is far easier to maneuver between the cords, especially in the tricuspid space. So to my knowledge, after the first data that I will show you, which was still acquired with the Pascal classic system, the Pascal ACE system has overtaken 95 to 100% of TR treatment, at least in Europe, and also the US are now switching over to the Pascal ACE implant, especially on the tricuspid valve. And Jörg and I were the 2 centers that proposed this change very much. And I think it also goes ahead with a lot of successful implant cases in the tricuspid field. And it's also easier to image, by the way. So the central spacer, as you see here, is almost the same as on the Pascal classic system. It also fills the regurgitant gap. But as you see in the middle, this is slightly smaller and thinner. The clasp situation is slightly elongated. So you get about approximately 1 to 2 millimeters, as I'll show you in a technical slide later, more leaflet into the Pascal ACE than into the classic Pascal. And it's also easier to maintain the leaflets on the device. On the other hand, because there is less material, there's also less shadowing in transesophageal imaging, which is another benefit to use the ACE over the Pascal, especially in the tricuspid field. What is very nice and unique to the system is that it has only one row of frictional elements or teeth that bite into the leaflet. And the situation that if you elongate, you stay with your frictional element, as you can see on the right, in the atrial part, and you can still elongate to clear yourself of the cords without even bringing the frictional element near the leaflets or into the ventricle, which also adds security to your procedure. Here are some technical specimens and some do's and don'ts, and you see the comparison between the classic system. And what I would like to highlight is that actually the clasp is slightly longer. If you see, it's 10 millimeters versus 9 millimeters, and also the central part is closer to the center of the device. Look at these situations. So there is a distance in the Pascal implant, and there is no distance in the Pascal Ace implant. If you look into the leaflet capture ready position into the central part of the image. And these features actually enable us, together with the independent clasping, to approximate the center of the leaflets or tip of the leaflets closer in the device, then use the spacer that is, as you see, smaller here, still to attach the leaflets against those and to close the device. Also in the elongation mode, you can see that we have 1 millimeter more, which totally goes to the clasp system. So we engage more leaflet than with the classic Pascal. This is a very important difference to the devices. So this is the new system, one of the first cartoons to see the stage capture. We call this the Tarzan maneuver. You shouldn't overdo this because you can rotate the device while you do this. So I personally like to clasp actually simultaneously first, if the gap allows for this, because this will keep the position of the leaflets in one space, and then you can optimize and reopen one of the sides. If the gap is too large, you typically take the more solid and the longer leaflet from the free wall, as the free walled annulus will follow your device easier than the whole heart, left heart. So it's always better to use the interior or the posterior leaflet first, and then move over to the septum, which is also called the anchor leaflet in tricuspid regurgitation treatment. Some strategies here to see how we do the imaging. I very much like the transcatheter images of transgastric views, which is very important, as you can see the gap, as you can see the rotation of your device easily. And you should make sure that you have different angulations than you're used in normal ventricular imaging. So it's very important that these images are done at slightly larger angulation. So while you typically do a 20 to 30 degree transgastric, actually here you should prepare yourself to use 30 to 50 degrees, and also to align yourself that you see the rim here from the inflow chamber and the outflow chamber of the right heart very nicely. Then we go to different angulations, and it's not important, as you see, to see the aortic valve. It's more important in a deep esophageal view that is rarely used for other valves, to really cut the beginning and the orifice of the right coronary artery. Doing so, you typically have an 80 to 90 degree view that goes exactly to the commissure between the anterior and the septal leaflets. By doing a biplane, you exactly get a perpendicular view on your clasping or grasping zone. That is the elongation of your clip arms in order to get your device set. If you move over from the interior to more central parts, make sure that also your angulation will change. So while the commissural or mid part of the anterior leaflet is typically visualized at 70 or 80 degrees, the central part is done at 90 degrees. And if you move over to the posterior side, you also have to upgrade your echo TOE images, sometimes to 100 and 110 degrees. And it's very important for your interventional imager to be aware of this so that you're always perpendicular. So the valve is not a straight line, and this depends on the size of the septal leaflets. This is more pronounced in longer and larger septal leaflets, which are also easier to do your intervention on. And the most important two zones to actually do your TEER is this very posterior part of the anterior leaflet and the posterior leaflet that is just slightly above. And you see these angulations here nicely in this biplane imaging, which is done, as you can recognize on the left image, in a deep esophageal. And how can you recognize this? You see that the right atrium is next to your TOE probe and not the left atrium, like in a mitral procedure. This is very important to do this differently than before. And the right-hand side is the corresponding 90-degree view. So if you go more posterior, you have to add degrees. If you go more anterior, you have to reduce your degrees, as seen here with a minus. So I think this is very nice, and this is an example of it here again with the new Pascal ACE device, that you can elongate the system. And here you see that the frictional elements stay on the atrial side. So you never engage, if you don't move in too far, you never engage with the cords. And this makes the Pascal system, especially a Pascal ACE, a very, very safe procedure to see and to get between the cords, as shown here in this cartoon. So I'll show you one real, and this was actually in Europe, one of the first Pascal ACE implants. A 73-year-old female with signs of congestion and heart failure. She had a large ERA, as we discussed it with Becky Hahn, 0.75, 0.8, a very typical size, can be even more. Edge-to-edge therapy was done in mitral in June 2020. She has a two-vessel disease, COPD, permanent atrial fibrillation as 90% of the patients, and a pacemaker. So you get everything you like in this special. And here you see the implant. I'll try to remove the sound just a second. I'm sorry for that. Here you see how we do it. It's basically a deep transesophageal. You can appreciate that we have a severe regurgitation that goes over the whole interior leaflet and even to the posterior leaflet. You can also see that we need more flexing actually to get posterior as this elevates. And you can also see the pacemaker here engaging in the posterior leaflet area. So this is actually a very typical patient. And here we see a mitral repair with a mitral clip. And I use this case very often actually to show the differences in the fluoroscopic view. And this is the small Pascal. And you can see that the small Pascal already is 50% wider than the small mitral clip. So this corresponds to the new W systems. And one of the possibilities with the system is, of course, that we are unkeyed. So we can use any angulation. And I try to use an areocranial, as you see, where you see the curve very nicely. And here you see that we catched very, very effectively with the Pascal, and we have eradicated everything anterior to it. This was the goal. And now we go in a slide clover technique to the second device that we will implant in the next step. And you will see that we get a very good result. So now we do the second clip here. Now we decided for not a clover, but two anterior septal. You see how the leaflet is on the device. I'll just try to get off the sound just a second. I'm sorry. Again, this always gets on. You see how nicely you can see with the thinner ACE system, also the image quality improves. We're doing it transgastric, but also transesophageal, deep transesophageal. The up there is transgastric, and I typically close always in transgastric because I can control the rotation. And if you look now, there is trace tricuspid regurgitation in this severe system. Just some data at the end. So the Pascal repair system has an optimal retention system, which bites with 4 individual teeth into the fibrous tissue of the leaflet, thus causing very little harm. And it's also that the stability of the leaflet is more pronounced, not at the tip, but more at the base of the leaflet. And this is one of the features that we have not multiple frictional elements. So the first compassionate use data has been published, and also the 6-month now. And we have achieved a TR less or equal 2+ with the Pascal and the Pascal ACE system in about 90% of the patients, which I think is a very good sign. And we've also seen something we published in 2013 on the mitral valve, also on the tricuspid valve. And you see the comment by Neil Pham on the right-hand side that we had a favorable right ventricular remodeling and also an annular reduction that was highly significant in this first information. And here you see the change in the New York Heart Association class. Of course, it's a single-arm trial, so there is always a slight placebo effect with it, but you can also see that the 6-minute walk test was favorable. New York Heart Association class here in the 1-year outcomes is stable to 30 days. So like in the mitral, and what we've seen at PCR for the 2-year TRILUMINATE data, we see that 30 days is predictive of the next 1 or 2 years in those patients. So we don't see a deterioration of the results. There will be additional data, which is led by Sushil Kodali from Colombia, the site of Becky Hahn. And you see that the CLASP TR EFS, as well as the new TriClass study, which will be a randomized studies, are underway to engage a lot of information. So this is data from the US, small numbers, 34 patients, as you see, but very high success rates. Mean implant rate is low, 1.2. This is the classic Pascal system. You see no MACE rates, no MAE, and no myocardial infarction, no mortality. And this is throughout all tricuspid treatment. And again, PISA error A reduced, vena contracta about half, TR severity reduced, New York Heart Association class improved to 90%, KCCQ scores improved by approximately 15, where 8 is significant, and 6-minute walk about 71 meter, which is quite typical in heart failure. So we have more options with the nitinol-based Pascal, and especially since August 2020 with the Pascal ACE TR tier system, preparation of the patient already discussed after the first talk with optimal medical therapy and diuretics is essential prior to the procedure. ACE is more capable to penetrate the dense chordal structures of the tricuspid. Both Pascal and ACE are safe and feasible. Single arm analysis shows functional benefit in 6-minute walk and QAL as measured with the KCCQ, and randomized controlled trials are underway with more than 1,500 patients in repair and replacement for the first time after 30 years of surgical therapy. So I think we have a very bright future for that. And with these last slide, I end my talk, and I hope it's good for a lot of discussions. Thank you very much.
I think it was an excellent review about the use of Pascal for tricuspid regurgitation. I was impressed by your results, and congratulations. And I think we don't have any more time. So Dr. Spargas has already told me to proceed to the next speaker, Dr. Hausleiter, who is going to give us a lecture regarding the simultaneous and significant mitral and tricuspid disease, transcatheter edge-to-edge approach combinations. And I think we can have a short discussion at the end if there is time. Thank you.
Yes, thank you very much for the invitation to participate today in your nice symposium. After these brilliant presentations from Stefan and Becky, it's now my honor to talk to you a little bit about the simultaneous treatment of both diseases, the mitral and the tricuspid regurgitation, and what can we do with the transcatheter edge-to-edge approach in these patients. These are my conflicts of interest. Now, we do all know that in surgical patients, there's a class 2 recommendations for the treatment of combined mitral and tricuspid disease, especially, or other way around, even if the TR is not graded as severe, the surgeons are tending to operate on those patients if there is concomitant dilatation of the tricuspid annulus. There have been some retrospective data showing that those patients with the concomitant treatment have a better outcome, and this is currently being investigated in the ongoing CTSNet network trial, this randomized clinical trial, which will be presented later this year. And I'm pretty confident that we will see that the concomitant treatment by surgery of both diseases will have a significant impact on outcomes. But what about the diseases and when we're treating those with an interventional approach? What I'm showing here is the outcome, the mortality data of more than 700 patients treated in the DRAMI registry, the German mitral clip registry, and you see that those patients who have concomitant disease, moderate or severe TR, have an increased mortality over the first year. And you see also there's an increase in mortality if the patient has severe TR. If we go a little bit more in detail in these data, then it's very intriguing to see that the patients already have an increased in-hospital mortality after treatment of mitral valve, you see.
Ich sehe Ingrid nicht in deinen Kontakten. An wen soll sie gesendet?
Excuse me. In hospital mortality, you see that the mortality rises from 1.5% to almost 6%, a significant increase in the presence of severe TR. This is almost the same at the 30-day outcome, not reaching statistical significance, but you see again an increase from 2.8 to almost 8% mortality in this early follow-up. So we have to ask the question, when is the right time if we are considering a tricuspid treatment? Can we really wait a couple of weeks, or do we need to do it early? Now, the first question is probably what we have to consider is how prevalent is the combined disease overall? And I try to summarize this in this slide. Here you see different studies which have been published, the DRAMI registry, which I already told you about. Then there are publications from Zurich, the Italian registry, data from Hamburg, a study from Stefan von Barleben from Mainz, and our unpublished data from Munich. And when we are looking at the number of patients which we're considering, you see that we're talking here about more than 2,300 patients which have been treated with a mitral clip on the mitral side. If we're looking just for severe TR, then you see that the prevalence is around 17%. If we are combining moderate and severe TR, you see this is increasing significantly. Then we're talking about even 53% of patients who have significant tricuspid disease. And so every second patient would fall into this category. Now the question is this improving after therapy, after the mitral clip therapy? And you see that at follow-up, echocardiographic follow-up, still around 40% of patients still had either moderate or severe TR. So if you calculate the reduction, then you see that we have this reduction from 54% to 39%. And this translates in a really modest reduction of TR by the treatment of mitral regurgitation. It's only reduced by approximately 27%. And it's not only reduced, there is, for example, in the study from the Zurich group, also the presence of an increase in TR at follow-up. And this was also about 15%. This demonstrates how variable the TR is, the grading is, how dependent the TR is, probably, as we all know, from the volume status. And this all has a significant impact on our assessment. And we have this very nice data from Mainz showing that if you treat the mitral valve, you see this improvement in TR early on, from baseline to 30-day follow-up. But if you consider those patients for the next year and repeat echocardiography, then you see that there is a lack of a further TR improvement. So everything what happens early after the treatment, which is, on the other hand, a good sign that we can probably have this 30-day endpoint to re-evaluate the TR and to see if we need to do a repeat treatment, if we have not done this early on. Then there are some investigations to try to identify those patients who have an improvement of TR versus those who might not improve. And you see in this smaller study from Hamburg, including approximately 70 to 80 patients, there were some significant predictors for an improvement. So those were patients with a lower Euro score, with less renal disease, smaller RV sizes, and also more significant mitral disease with less pulmonary arterial hypertension. Those patients tended to have a better improvement of TR compared to those where the TR did not improve. And most likely, I think that this assessment of the right ventricular dimensions, more specifically probably the annular dilatation, would be a very important parameter to look at to identify those patients who might benefit from a concomitant tricuspid treatment when we are doing the mitral valve. Very similar to the ongoing surgical data from the CTSNet networking trial. Now, the other important aspect is, now if the TR improves, this apparently has also an impact on outcome. You see in the study from Hamburg, again, patients who had an improvement had less mortality over a 2-year course compared to those patients where the TR did not improve. But of course, considering the previous multivariate analysis, there were many predictors also more in favor of the patients who had a TR improvement. So shall we really perhaps treat those patients simultaneously during one procedure? There are many pros and cons for doing this. And one of the most important questions is, of course, what's happening in the long term. And what we tried in this analysis here is that we're trying to compare the outcomes from 2 retrospective studies. What you see in gray here are the patients from the TRAMI registry, which I have shown you in the first slide, with severe TR. And as you remember, these had a mortality of 33% in the first year. And we compared this patients where only the mitral valve was treated, but the patients who had severe TR with those patients from the TRIVALVE registry, the registry which Stefan has already talked to you about and shown you, where patients received a concomitant treatment during the same procedure for the mitral regurgitation and for the tricuspid regurgitation. And you see in this retrospective comparison that there might be a potential impact on mortality if you treat both valves at the same time. And there are further data supporting this. This is on the left side, a study from Philip Lutz and our group, where we evaluated the patients in terms of the heart failure hospitalization rates. You see that in the green, patients who had treatment of both valves had a lower need for repeat hospitalizations, a significant impact here. And you also see that those patients had a better symptomatic improvement compared to those where only the mitral valve was treated. So there are many signs, not strong, but supporting that the concomitant treatment might be beneficial for those patients. So what are the reasons to perform simultaneous repair of both valves in a single procedure? Of course, one of the most important ones is that we are avoiding a repeat hospitalization with repeat general anesthesia in old and fragile patients with often multiple comorbidities. Now, I think the patients will be very grateful if we can treat everything in one procedure instead of having 2. There are issues about the costs and the reimbursement, of course. Most current insurance systems in Europe currently favor a separate treatment, but in terms of the patients, it might be better to have a single treatment, and that might also be cost effective over the long term because we're reducing the number of hospital stays, the number of procedures. So at the end, this might be cost beneficial. We have an earlier improvement of heart failure symptoms, which I think is very intriguing and helpful for the patients, and the potential to reduce also in-hospital and early mortality. And as I have shown you initially, there is an increase in mortality with severe TR already in those patients with severe TR in the hospital earlier hospital stay compared to those who have no TR. So with this, I would like to conclude. TR, as we have seen already in the previous talks by Stefan and Becky, TR is really an under-recognized predictor for mortality, even early mortality. And this is not only true for patients with TMVR, as we have shown in this presentation. Moderate and severe TR in those patients who have mitral disease is very frequent. As I said, more than 50% had moderate or severe TR. TMVR only resulted in a modest TR improvement. Only about every fourth patient had a relevant reduction of TR. And finally, the simultaneous MR and tricuspid valve treatment might be considered in selected patients for improving outcomes. Thank you very much for your attention.
Thank you, Dr. It was a very nice overview regarding the impact of and the value of simultaneous treatment. I don't know if there are some comments or questions from the panel. Just one question I have from the audience for the virtual audience. But so they ask, what about severe TR, RV dilatation, but also PPM wires? What about that? I think Dr. von Bardeleben has already showed you that it's feasible, especially with the Pascal. We showed a very nice case. In the gastric view, how was the wire? I don't know if you have any comment regarding this question.
Yeah, I think in the trials between 10 and 16% of the patients had pacemaker wires. Very often it was included that they impinged one leaflet severely. So typically they're in the commissures, especially posterior. They're not decremental to the result of your treatment. That's very important to recognize. So the majority of pacemaker leads can stay in the valve and is not necessarily causing the regurgitation. The majority of about 20% is doing that. And then removal, replacement, and other means are interesting options, and also the microplacement. So to remove the wire with a transvascular laser extraction, for instance, and the placement of a micra is a possibility. It's of course not cheap, that's clear, and only so far single chamber support. But in the future, we'll see also dual chamber microsystems, and I think the prices will come down dramatically over the next 5 years. So it's very interesting to see that. And we could potentially use the same 24, 22 French sheath system, steerable sheath, actually to implant all three situations, mitral, micra, and tricuspid. But of course, the prices have to improve further.
I would like to add to that patients with an interaction of the leads with the tricuspid valve have to be evaluated very, very carefully by the echocardiographer. It's sometimes very, very difficult to estimate how much interaction there is between the valve and the leads. Then we have to consider that in the presence of leads, imaging gets a lot more difficult than without leads. And finally, if there is an interaction, sometimes we have an adherence of leads to the leaflets. Then also the consideration of removing the leads is valuable, but can also introduce significant problems, because then we might also lose some leaflet tissues with the extraction, which will make the further repair treatment very difficult. We have seen all the different options. In the future, probably, which we have not discussed so far today, but probably the replacement options with tricuspid valves might be a very valuable option in those patients where we have a significant interaction of leaflets and leads.
Totally agree, Jörg. That's the beauty of the laser extraction. So we can cut actually the anchor out, and we leave just the sheath part, the silicon, on the leaflet, and we simply clip it. So this is, you're absolutely right. It has to be done in an expert center. And the second thing I would just like to add is that CT, so 10-phase CTs is also very nice. So you see the leaflet, you see the device in totality, and you can also evaluate this interaction as Jörg put it out already. So 3D echo and CT is very valuable for this question.
I would like to ask, in terms of improving imaging, in addition to the caveats that you mentioned before, Stefan, have you seen any role for intracardiac, especially 3D intracardiac echocardiography?
Yeah, there is also good news, even though it's not yet the end of the innovation chain, but since 1 month, we have the first 4-dimensional ICE catheter, actually CE mark. So this will become available. It's a Siemens volumetric system, which is available, and we will start in 2 weeks' time actually to do these interventions. We've already done them together with Evoque implants, as Jörg pointed out. So in the replacement, it's very nice because you can use the steerable sheath and the flex option of the ICE catheter to nicely see the anchors of the replacement system, or in some cases that are very difficult. We did this in a double mechanical aortic and mitral surgical replacement. So, you know, then you have no transesophageal views anymore. So we use TOE transgastric and a right atrial ICE probe, and this really works. It's, of course, still also quite expensive. The probe costs about, it's one way with 2 possibility refurbishments. The probe costs 2,000 euros and you can refurbish for 500 euros each. So you could use it 3 times. The new system by Philips may even become cheaper, but it's not yet in human use. All we have is dog and in vitro images, but there will be 3 main players. With Bioscience Webster, there will be a 4th. They have bought the Nuvera system. So I think in the next 3 to 4 years, we may be even using totally conscious patients with local anesthesia, and we won't use perhaps TOE anymore because Nuvera and some of the systems offer excellent image quality from the right atrium.
Between you two guys, we have a tremendous expertise on tricuspid intervention. I think your combined volume is probably the majority of Germany. So I'd like to take advantage of having you both here and ask you how often you reject a patient because of bad imaging or because of anatomic characteristics that are unfavorable for edge-to-edge tricuspid repair.
Jörg first.
It's a very good question. I think in the beginning, and this is also my recommendations for all other sites, you have to be very, very selective in your patient selection. Because you will see that echocardiography is very difficult, and also the steering in the tricuspid valve is not that easy as compared to the mitral side. In the more experience you get, and Stefan probably has can also allude to that, if you have done several hundred of those procedures, then of course you're taking more risks, and consider also patients where the imaging quality, for example, is very, very limited. Furthermore, we do have options sometimes to consider those patients for additional treatments. So if the valves are very, or the TR gaps between the leaflets are very, very large, then we would consider sometimes compassionate use treatment with some valve implantations. But overall, I would think today probably only 5% of patients, in summary, are being turned down for either imaging or severe anatomical reasons. It's probably even less than 5%.
That's amazing. So it's approaching the mitral edge-to-edge rejection rate if it's down to 5% with you guys. Excellent. And a question about the simultaneous, the concomitant treatment of these valves. I guess, like Jörg said, you are trying to find some indices to guess when you need to do them simultaneously, or you can defer the tricuspid, like annular dimensions, or if the patient has pulmonary hypertension. So in your current practice today, how often you do together these two valves, edge-to-edge repair, like a proportion of those who have significant disease in both valves?
Well, if in Munich, if the patient has significant disease in both valves, we always try to do it at the same time. We are not waiting for a couple of days or weeks and do the second valve later. So whenever it's technically feasible, both valves are severe, then we are doing those at the same time. Our experience is that those patients have the best profit from both procedures.
And Stefan?
I agree, but we do it slightly different. So we do it early staged, and there are reasons for that. So once what has been shown by Jörg is that if you have something like a just severe TR and you don't have a lot of anatomical situations, I would screen out those patients and wait 1 or 2 months, not very long, and do a very fast staged procedure. This has two advantages. One is that we can recompensate and close the gaps a little bit more. So the stress on the tier systems and also the success of the procedure is, in my opinion, even superior to a direct simultaneous, and it's almost simultaneous. If you do it 2 months later, for the patient, I think it's not outcome relevant. So we prefer 90% fast staged procedure if the TR persists. I would say that we would do everybody who has massive or torrential if it's treatable. And Jörg has nicely shown that 90%, 95% can now be treated. I would say a short septal leaflet, a large annulus beyond 5 centimeters, a gap beyond 10 millimeters. Those are predictors for only a slight improvement. Everything that has a septal leaflet above 1.5 centimeters, a ring size below 5 centimeters, and favorable imaging is nowadays really, really effectively treatable. And you've seen the results by Jörg in live cases. You've seen my case today. This is really the reality nowadays. So in 80–90%, we can achieve quite good results. Not always mild or trace, but also moderate, maybe superior for the patient than torrential or massive.
So, Stefan, I understand that you would wait for those 27% that Jörg told us that will get some improvement of the TR after fixing the MR. So approximately 1/3 of patients, and he also told us that he will see this improvement in 1 month. So I guess that's why you're waiting 1 or 2 months.
That's how we published this, and this is what we analyzed in our 606 patients. We started TR. We have done now between 300 and 350 tricuspid valves in Mainz, and we started the first 500, as Jörg said, with almost simultaneous treatment. It was 60% of our cases were simultaneous, only 40% staged. We went down a little bit, and we're now at 80–90% staged and only 10 to 20% simultaneous. If you have a massive TR, this will never become mild. So there, you can also argue, like Jörg did it, you improve cardiac output immediately. You can do that. If your septal leaflet is good, if your anatomy is good, do it immediately. I have nothing against it, because it's like in a flail with TAVI and mitral disease. If you have a caudal rupture, waiting will not improve things. So treating immediately will be beneficial. That's the concept of MITAVI. But if you have a functional disease with not so much dilated annulus, then also different approaches, I think, should be discussed. I don't say that we know the correct percentage yet. Perhaps it's nearer with Jörg or it's nearer with us. I don't say that we know it yet, but we will evaluate this in the next 3 years, and I think we will have a definite answer in the future.
I think that the surgical data from the CTSN network trial will also help us a little bit in our decision making. And if this cutoff of 40 millimeters in the septolateral dimensions is somewhat predictive for surgery, we might evaluate a similar diameter also for those interventions in the future.
Absolutely, I agree with you, Jörg. Yeah.
I would like to ask both of you, do you use a particular protocol to prepare your patients for tricuspid interventions, like medical-wise, particular diuretics, or what do you want to see in the 15, 20 days before the patient comes in?
Stefan, you want to start?
Okay, I can. So what we typically try to do is we try to get a protocol of the last year of the different weight situations of the patients. So I try to get what we call the dry weight of the patient. So this can be quite fascinating. So I have patients that we diuresed between 2 kilograms and 15 kilograms compared to a tricuspid treatment. And so what we do is typically we see the patient in the outpatient clinic. We try to see whether they're in a relatively compensated shape or decompensated shape. If they're in a decompensated shape, I give them 2 to 5 days before the procedure, and I diurese them down either by filters or by IV diuretics. And what we look for is that we get a slight increase in the creatinine values, and we get a decrease in the gamma GT levels of the patient. So gamma GT and BNP are very nice predictors of your compensation state. And by doing that, we can sometimes reduce the gap between 2 and 5 millimeters. That's half a centimeter to get the leaflets closer to each other. And if you then do the treatment, just waiting 5 days, you get dramatically better results, and the patients stay in that result situation because the device then works for you, and they typically diurese better after the treatment. That's also a very important lesson to learn. So you can slowly reduce, but you should never get rid of the diuretics. That's very important. Also, the additional medication, if you read the publication that Jörg cited, we did a multivariate analysis, ejection fraction, MR, TR, pre-procedure, but beta blockers have no improvement. Diuretics and AT1 receptor antagonists and ARNIs are beneficial, not ACE inhibitors, interestingly. I would use these components actually to get the patient better. If he has a moderately impaired function, we also sometimes do levosimendan and milrinone prior to the procedure, just 2 days prior to the procedure, and then phase it out after the procedure. Those would be the concepts that we do. And in 5 Wood units or 4.5, we sometimes even use sildenafil to get down if the patient has, for instance, a high pulmonary vascular resistance or an intermediate below 5, but beyond 3.5. We sometimes also pre-treat these patients and then get rid of sildenafil afterwards.
Some 2 additional aspects, because we do it almost the same, is the day before the procedure, we're repeating a transthoracic echo and trying to evaluate by the subxiphoid image view, which is then very similar to a transgastric, the gap size. And if the gap size is still significant, then we would defer the treatment and continue with diuresis if possible until we have really an optimized state. Another very helpful trick for the procedure is if you have an option to tilt the table, so that you put the head up and the legs low, so that you get the venous pooling of your blood in your lower extremity, which significantly reduces the gap size also in the annulus during the procedure, and that makes everything a lot easier than when you try to grasp the leaflets.
And the last one is you can even apply on the thorax anterior pressure. That was done in the early days when we only had NT, the small clips. Actually, we also use sometimes manual pressure on the thorax, and this brings the anterior and posterior leaflet down to the septum. This also works, but you don't have to use fluoroscopy for the poor guy who has to press on the thorax. But this can also help. We did 2 cases like that in the early days, but we never reused it in the last 200.
Yeah.
Those are excellent comments, and we do appreciate your expertise on the subject. Lots of tips and tricks to utilize.
Stefan, I sensed, sorry, my connection is not very stable, but I don't know if I interrupted somebody. I hope not.
Nope.
Okay, Stefan, I sensed an excitement about the use of Pascal ACE in the tricuspid. Did I sense it correctly?
Well,
and
yeah.
Can you tell us why?
Yeah, I think it's always good to have a large toolbox. And as I said, I see a clear superiority of this second device in the Pascal space to really improve results, improve imaging, as Jörg pointed it out. The most important part in the beginning is not the interventionalist. Actually, if you are very calm and you know how to elevate the device, if you know anatomically where your caval vein is and your right atrium and your tricuspid valve, etc., I think that the interventionalist has a pretty nice job if the car window is cleaned. And the car window is always the echocardiographer in the room. So I myself, doing hundreds of implants, I really rely that the echocardiographer is excellent in your room and that he trained before to visualize 4 different views. And this is mid-esophageal, deep esophageal, plus biplane and transgastric. This has to be done in any center that wants to start, also in Greece. I can only highlight that they should do 50 diagnostic TEEs and look at the tricuspid valve. That's the simple equation. In the beginning, like Jörg, we did in 1 or 2 cases also transthoracic, but in the last 200, we never switched from TOE to something else. We were always capable to get an image and to do the procedure in at least 2 out of the 3 views that I just mentioned. That's very important. And this is only training for the imager. He is your road book for the car, and he's on the side seat of your Porsche if you want to go forward. So clean the window, have your echocardiographer do a good job, and then it's easy to drive.
We had Fabian Praz earlier with us in the mitral session, and he introduced us to the concept of annuloplasty by edge-to-edge. And he wondered if annuloplasty with a nitinol device like the Pascal in the mitral would be as effective as with a device like MitraClip, which closes very, very stably. Do you think that this concept might apply in the tricuspid also?
You will see it. We have an accepted publication on this question. We did one with Dr. Schmidt in 2013 with the old classic MitraClip. And we have now done an evaluation comparing the shorter and the XT clip systems of generation 3. And this is done in 150 patients and accepted in circ intervention. It will come out in 3 weeks or 4 weeks' time. And then your question is answered. It's true that the classic Pascal, the P10, does less on the annulus and the ACE does more on the annulus. That's perhaps why Mainz and Munich like to use the ACE system. And it works especially well with the nitinol on the tricuspid side because the annulus, as I said, is less calcified and it's more pliable. It follows, it's more compliant. It follows the device. And as you have a smaller spacer and longer clasps that you close in a more central part, as I showed you on the technical slides in my talk, I think the ACE is more effective on doing an additional annuloplasty than the classic Pascal. So it works definitely on the tricuspid, and you will see it in publication in circ intervention in about a month.
In addition to that, one I think has to consider not only the reduction in annulus size for the mitral and tricuspid valves, but also the potential risk of introducing leaflet tears and leaflet destructions with the device. Because if you're pulling too much on a fragile leaflet, then you can also, of course, introduce some damage. And this is a trade-off which you always have to do with those devices in terms of the device selection for your individual patient.
But there we have the compliance of the nitinol, which will open. So if the device comes under pressure, you see that in fluoroscopy very nicely. So if you give volume to the patients with a Pascal device, the Pascal device will slightly open and it will do this, you know. And if the patient is recompensated, then the Pascal does this. It stays almost closed. So you can even do on a fluoroscopy, you can see how much pressure is on the annulus and on the ring tension. So this is quite new marker that will also be analyzed in the future.
But this is only available with the 19-hole shape of the Pascal and not, of course, with the mitral clip with its stainless steel components.
Absolutely. My topic was Pascal in this talk, so I'm just alluding to
That's for the entire toolbox.
Yes. No, but we all know there are different situations and different concepts, etc. Also, of course, the stress of other devices having 6 millimeter width is also less than with a 4 millimeter width. So there's general physics. The component, the metal component, is one part of the game, but also the width and the shape of the device. So we see a whole continuum. I wouldn't say one device is bad and one is clearly better. They all have their advantages and mild disadvantages, one or the other. So it's important to select the patient, and the more you do, the better you can do this.
So I think this should conclude this terribly interesting discussion. We learned a lot over the past hour from the Becky Hahn's discussion on tricuspid valve regurgitation, RV function, all the data that we need to keep in mind when we assess these patients who are often in very difficult situations, as well as our experts, Dr. Hausleiter and Dr. von Bardeleben, who shared with us tremendous experience, many tips and tricks. I think this was a really an outstanding discussion, lots to take from it. I personally have to listen to it again to pick up all the pearls. So with that, I would like to thank you all and conclude this roundtable. Thank you very much.
Thank you. Bye-bye.
Thanks for the invitation. Thank you very much. Bye-bye.
Thanks for being with us.
Hello, Roxana. Hi.
So, hello everybody, and it is a great honor and privilege for me to introduce this round table. I would like to thank Dr. Sparias, who is a great friend and colleague and collaborator all these years, for the kind invitation. First, I would like to introduce Mr. Vinny Bapat, or Dr. Vinny Bapat, Mr. because he's FRCS, cardiothoracic, and doctor because now he works in the US. So we're going to analyze various things about mitral and tricuspid. So first, Dr. Bapat is going to tell us about understanding mitral valve-in-valve and valve-in-ring. Thank you, Vinny.
Thank you very much, Dr. Isis. These are my disclosures, and good morning from US. It's 6:30, and but it's a pleasure always to join and share some thoughts of a field which is evolving very rapidly. This is one of my first cases when I was in London. We did a mitral valve-in-valve. You can see it's a Sapien XT transapical device. We felt, mitral valve should be really easy and nice because these are large valves and all the valves are stented valves. So less chance of PPM, easy to position, and everything should be nice and easy. But we were wrong. We have learned a lot since that time. This was nearly 7 years ago, that there are concerns. There's concerns about malposition, concerns about embolization. High gradients and PPM has become really relevant now in mitral. And of course, the main Achilles heel, which is LVOT obstruction. And it's an interaction between the three things. More importantly, in mitral, mainly to do with the native anatomy. So when I look at mitral valves, I go through some certain things before I accept a patient. It's not that can I do it, but should I do it? And the valve-in-valve planning, the most important piece always is what's the prior surgery. So go through all the notes which are written, understand if there are any complications, nuances of it I should know of. I also assess with my team the risk of reoperative surgery because as we know, patients want bioprosthetic valves because they don't want to be on anticoagulation. So it becomes a very important question in managing these patients. The detail of the valve can be brought from, the card which patient carries, operation notes, which can sometimes be unreliable. And then more importantly, we assess what are the chance of complications. You can see very well here that all valves don't look same. Each valve looks different. It's made different. For example, the one in the top is a pig valve or the porcine valve, while one that's a Hancock. The second one is a mosaic. Third one is a magna. So all these valves look very differently. And as physicians treating it, we should know which one is which. This is my checklist I run through. And this seems very long, but actually this is pretty tidy. So the first thing, I'm going to just take an example of one of my patients treated recently. And how we do it is first we look at the implant card and say this patient has a Hancock 2. We look at the Hancock 2, how it looks under fluoroscopy. I know that it is made of porcine leaflets, that means thin leaflets, not so tall, less chance of LVOT obstruction in my head. The second thing is all the leaflets are sutured inside the stent post. So this is again very important. And the fourth point, which is most important, is that there is a sewing ring marker. So this is going to really help me in positioning the Sapien 3 if I'm using it very, very properly and precisely. The second thing I want to check is what size. Each valve comes in different sizes. So here in this patient, for example, it was size 27. So I go to the next thing, which is what transcatheter valve I'm going to use now. And there are 2 or 3 valves currently used for these treatments. So one is Sapien 3, which is mainly in Europe and United States. The Sapien 3 or my valve in Asia and some parts of Europe. And then there are some similar balloon expandable valves in Brazil and South America. But essentially, we are looking at balloon expandable valves. And my talk will be essentially related to Sapien 3. Now, choosing the size is not that easy in mitral. This is one of the patients done in one of my close friends' center in Cologne. You can see that they deployed the valve absolutely perfectly, but within less than a minute, this valve embolized. And you can see this again and again, you wonder why. I also found that in certain cases, like this patient, for example, this is a very beautifully expanded valve in valve, and this was a 29 Magna, and this was a 23 Sapien 3. 3 months later, this valve migrated. And the reason is these valves we realized were being deployed in a parallel fashion. That means the Sapien is parallel to that of the original surgical valve. So we realized at that time that the closing pressures in mitral is extremely high, which we all know very well. So if we do parallel deployment, it's not very good, but a conical deployment is what we need. And since that time, we published this paper many years ago. All the mitral devices, if you look at, mainly in Sapien, in MAC, valve in ring, etc., are always deployed in a conical manner. And this is very important. So we need slightly more oversize in mitral than aortic valve. In aortic valve, we take 1 millimeter oversize is fine. But in mitral, you at least need 2 millimeter oversize or 1 millimeter oversize with extra CC, which we use in Sapien. So here, Hancock 27 as a stent ID of 25, but true ID of only 23. So we will be using a Sapien 26. In future, hopefully, such as my valve, we'll be using 24.5, an intermediate size device. The approach is usually transeptal now. Only in difficult anatomies, we tend to use transapical, but most of the patients we use transeptal. There are, of course, you can see here multiple areas where you go into transeptal, but essentially what we'll be choosing is posterior and inferior, which is in between 5 and 4, so as to get adequate height from the mitral valve annulus. The most important thing in planning, other than choosing the right size, is the risk of LVOT obstruction. Now, this is very real. LVOT obstruction, as we know, can happen after any mitral therapy, whether it's valve in ring, valve in MAC, or TMVR devices. And the reason this happens, again, this has been published by me and Dr. Nico Piazza's group. If you flare it, the risk is going to be definitely higher as the anterior leaflets get pinched open into LVOT as a fixed SAM. This is the earliest computerized model we did in St. Thomas's when I was working there. And we found that if the aortomitral annular angle is less than 115, the risk is pretty high. And this just shows you how the computational model works. Today, we necessarily don't need to have this, because if you have a 3-Mensio, you can analyze it with what is called as neo-LVOT. This has been published by Philip Blanque's group and Jonathan Lipsy group. And this really gives us a very nice idea. Anything less than 200 millimeter square for Sapien is less. And I think for each devices, it's very different. LVOT risk for pericardial valves is definitely higher, and for porcine valves is lower. As you can see that in the bench test, we have demonstrated that the pericardial leaflets tend to go up like this. So the Sapien is fully covered, while the porcine leaflets tend to crumple down a bit, and hence the stent can be exposed a bit. So this is, again, back of your mind is very important in planning if you don't have access to 3-Mensio or another sophisticated software. Now, this is becoming more and more relevant as, you know, we have done more cases, we have come across more problems, we have explanted a lot of patients' Sapien valves or operated them again. So residual gradient is critical. These are just a couple of cases. Apologies, the video is not playing, but essentially you can see that the flare is too much. That means the Sapien valve is not inflated fully. And this led to a very high gradient to start with. And now these patients, when the gradients become high, you know that the mitral valves don't tolerate that very well. It can lead to thrombosis, halt, as well as other issues. Recently, people are trying to modify the valves with true balloon. The only problem is the biggest true balloon we have is size 28. So cracking or fracking is not that possible or easy, but if you have a very small valve like size 25, we should probably do it. And we have done a lot of bench testing on this now, and this will be soon published as well as presented at TVT or TCT soon. The last thing is proper positioning during the procedure. And the reason I bring this up is I showed you how valves look differently. This is probably the top one is the easiest one, which is Magna. You can see very nicely where the sewing ring is, so you can nicely position Sapien. But bottom is a mosaic valve where it can be very tricky. So again, it's very important that we do this properly. So our teaching has been, if you have a mosaic which has got the eyelets at the tip, allow the Sapien to be just beyond it or at the level of it. And this allows a very precise positioning of the Sapien valve into the mosaic valve. Lastly, anticoagulation. I think it's of course mandatory, patient is in AF, but in our experience, size 23, if you have used it, or patients with higher residual gradients, we monitor these patients very closely and give them anticoagulation at least for 3 months. And then we do CT scan, and then we do CT guided anticoagulation in these patients. This is extremely important. Now coming to a more interesting talk, and just to inform you all that FDA has just approved valve in the ring as an indication for Sapien just 10 days ago. So last year around 90 cases were done in United States. I think next year and this year it will be probably 300 or 400. You can see that the mitral valve in ring is a much more and complicated issue. There are multiple rings, and hence it's very important to understand what different rings are. These are rigid rings, these are semi-rigid rings, and these are flexible bands. And the examples I'm showing you are just complete bands and complete rings. There are bands which are incomplete as well. So this leads to a lot of complications, and it's at least again, our experience has been more than 6-7 years, starting from London. The basic teaching is all rings are not good for valve in ring, only few are. So we look at 3 important things when the patient comes. Can the ring become circular? Can it give a good anchor? And what size the ring is? Because some rings are size 40. These are very big for valve in ring at present. And secondly, from the procedure point of view, I'm looking at, is it easy to position S3, and is it radio opaque or not? Believe me, some rings are not radio opaque. Very quickly to highlight some examples, this is a Sorin Memo 3D ring and a Physio 2 ring. Example is of a Physio 1 ring. You can see beautifully it can become fully circular. While if you take this ring, which looks very similar, this is a rigid St. Jude ring. You can see at the end of this deployment, although the deployment looks beautiful on one plane, on the other plane, you can see there is a very big gap on both sides. These rings are not very good. They can give you okay result in the start, but this is not a good ring for early and midterm result at all. This leads to a lot of problems such as intravalvular and perivalvular leak. There are some rings which can be modified slightly because they are open anteriorly, but these are again rigid rings. You shouldn't do these patients unless these patients are extremely high risk and there is no other option but valve in ring procedure. Anchoring is very simple. Rigid rings and semi-rigid rings give very good anchoring, but flexible bands are borderline. And I'm just going to show you an example of a Durand band. You can see that the band looks like a nice circular band, but when it's implanted, it's very crumbly and it can expand. So this has sometimes led to some interesting problems such as delayed embolization in our experience. So we advise to do a CT scan based area or balloon sizing in these patients before doing valve in ring. This is the Cosgrove band, which is the incomplete band. I wouldn't advise anybody to do valve in ring unless there are some specific nuances which have been looked into. This valve stayed for 2 years and then we had to operate this patient. So why I'm saying that incomplete bands or incomplete rings, you shouldn't do Sapien or another device, is the bands are sometimes sutured, what is known as trigon to trigon, which is like a closed C. And then sometimes they are sutured as open C, that means commissure to commissure. So what happens is when you deploy something from inside in this configuration, the inner part can go inside and hold the sapien sometimes. But if it's a other configuration, it just opens up, so it doesn't give you any anchor. So if you have an open C configuration, don't do it at all. If you have a closed C configuration, then try and see if you have an anterior aortic prosthesis or calcification, which can give you a help in anchoring, such as TAVR device or surgical valve anteriorly. Now, these things are very important. They look very minor, but if you do cases otherwise, you are probably going to land up in trouble in 50% of them. So it's very important to understand different configurations. Here I'm showing you the same band in different configurations under CT scan. So again, really very important to understand that. So my checklist, semi-rigid ring gives you good anchor, good circularity. Rigid ring gives you good anchor, but not circularity. So don't do it unless really needed. Complete band can give you anchor if the CT area is quite low for a sapien and the oversize is at least 40%. And it can become circular because it's very, very flexible. And the last thing is incomplete ring doesn't give you good anchor and there's no matter of circularity. So just be very careful when you are even contemplating these cases. So these are the ring types which are there. They need, the one with star are the bands which need future additional planning. Lastly, coming to the dimensions, label size doesn't mean anything. This is a 32 size physio, and actually the average diameter is 27. So we are doing a very big project now to update the app, and you will be seeing that soon. The results in the app will be given very clearly to advise you whether to proceed or not and which size ring to use. Lastly, but not the least, some rings are radio opaque. Some rings are just not radio opaque, so you need to use echo for positioning. This becomes very, very important. Ring profile, quickly to mention, if ring is flat, it's very easy to position the Sapien 3, but if the ring is 3D, it can lead to leakage on one side. So again, be very careful about positioning. So conclusion-wise, valve-in-valve is a very good procedure. A PPM can be still a problem. Valve-in-ring is very good in high-risk patients, but I think we should choose the rings which are suitable only. It's very important to do that. And, the valve-in-valve app, which is free and available, we are going to update this middle section, which is the dimensions, because we are going to provide people with bench dimension, bench area, and CT area, so that it becomes very easy. These dimensions are irrelevant at present because they are surgical dimensions. And again, to highlight that a lot of information is already there in the app regarding these two topics. Thank you.
Thank you very much, Vinny. Great talk. Lots of tips and tricks, and we are very, very pleased to hear all this information. Lots of new things that I haven't even thought of it. Myself, I'm a surgeon. I've done a few valve-in rings, but not many, obviously. And I haven't even thought of all these details. Very, very important. And I think it is very important for the surgeons to really write down exactly what they do, especially if you use incomplete rings, whether they go from commissure to trigon, commissure to commissure, trigon to commissure, because all these scenarios are real scenarios, and it's extremely important for people down the line to know all these details. I wanted to ask you, have you dropped the age of the patients that you implant with bioprosthesis due to the fact that you've got so much huge experience with transcatheter mitral valves?
So that's a really great question, because we are looking at, and Roxana will completely agree, that the theme today is lifetime management of these patients, or sequencing it is called. So I'll give you two scenarios. If there's a 70-year-old who comes to me with a degenerated mitral valve, he's relatively fit, and I operated him 2 days ago. he doesn't want anticoagulation risk at all. I will reoperate him. I will put in another biological valve in him. So his relative risk of reoperation is low. But let's take another example of a patient who say, I've done a mitral repair, he's in his young, 50s or late 50s or late 60s. And I promised him that this repair is going to work wonderful throughout his life, but it has failed in 4 years. Now, I know that it could be technical, it could be anything. Now, I know that if I reoperate him, I'm going to replace his valve. So this is a patient, I will think, can we do a valve in ring or a valve in valve even, for example, if it's a patient, to prolong the next step, which is inevitable in him, if I do it today or 5 years later. So we are changing our look. It's not just the age now, but I think life expectancy of the patient. I'm looking at constantly, am I doing something good for this patient so that the next step becomes easy for the patient? And I think it's a very difficult calculation. And sometimes, so the fun part is most of the time, patients go to cardiology sometimes 80% of the time they go first. If they will come to me and say, I think you should reoperate this patient because this is relatively low risk. And there are times I go to them, which is say my mitral valve failure or mitral repair failure, and say, I think let's do the valve in ring so that in 5 years down the line, I can operate him once and for all and put in a bioprosthetic valve. And I think that's becoming a reality in mitral for sure.
Thank you. Kostas?
Yeah, hi, Vinny. Thanks for your very nice presentation update. And I want to ask you about access. How confident you are with transeptal access now? Do you think it's come to maturity and it's time to completely abandon the transapical approach? Do you think that it offers all the coaxiality that you need when you do valve in valve and especially valve in ring? How confident you are, and if you've moved completely to transeptal away from transapical?
Yeah, that's another great question. So practically in last, I would say 4 years, we have only done one transapical, and that was, we had to do aortic and mitral, and the femorals and carotids were not good. So we decided just do transapical and do both the valves together. But other than that, I think coaxiality is the most important thing. And it starts from the puncture site you choose, the wire you use, and just a slow inflation, especially in valve in ring, it becomes very, very important. Recently, Adam and his team has published what is called as the Emery angle. It's a bit complicated to understand. It took me a lot of time. I'm a surgeon. I look at very simple things. But I think we have to pay attention to these things, as you said. If you are doing, say, transeptal first time, I would do it in a valve in valve rather than valve in ring, for example. Or if I'm doing it in valve in ring, I would use a uniplanar ring rather than a 3D profile ring. So, or call for a friend to help you during the case, because there are minor things which matter a lot. And we know that towards the lateral commissure or towards the LA appendage area, you can get a higher tilt, as I showed you in the slide, and you can get some leakage through that if you don't position it properly. But transeptal in United States now, last year's statistics, is at least 97% are being performed through transeptal. So it's not just expert centers, but most of the centers who are doing the cases.
I think the Sapien Ultra with an extended skirt, the outside skirt that is now 50% of the stent, is very helpful, particularly in these cases of mitral valve in ring.
Yeah.
And final question about the LVOT obstruction. Do we have anything new there apart from the lampoon technique?
No, so currently alcohol septal ablation and lampoon are the two adjuncts which are used. Of course, if you want to use alcohol septal ablation, you should do it much before. Recently, actually, Brian Wisenant, who is quite keen and he takes a lot of interest in this area, came up with another very nice combination of, you should also measure the anterior mitral leaflet on CT if you can. If it's more than 25 millimeters, tends to be at a higher risk. So that's something of a new thing we have started measuring because of his experience. If he has a patient where again, with LVOT, if you don't have sophisticated software, I would say that aortomitral angle, which you can measure on any software or even on echo, less than 115 degrees, small ventricle, pericardial valve, these are, quite high indicators of LVOT obstruction. These are the things we have to keep in mind. And the lampoon technique is useful, but it needs some expertise. And I think it will slowly evolve into a very mature procedure. I'm pretty sure about that.
Great, thank you. And sorry, Michael, yes, go ahead.
No, I wanted to ask whether the issue about anticoagulation in mitral valve in valve, with the flow dynamics being different, and there may be some stasis in the valve leaflets in the ventricular side. So I wonder, what is your input on that?
I completely agree. We were so surprised that we found more problems in mitral. And the reason is we forgot completely that actually the mitral valve opens at very low pressures. So, and we are using a pericardial valve, and these pericardial valves, of course, if they are not fully expanded, can give you geometric problems in terms of leaflet opening. So luckily, as it happens, 50 to 60% of patients are already on anticoagulation for something. So it takes away our burden. But in the other patients, if we use size 23 sapien, 23 is very small valve, or if the valve's not opened properly, the oversize is too much, we put these patients on anticoagulation electively. And what we do is at 3 months, we stop it. We bring them back after 3 months, and then we get a CT scan to see whether there's any early indication of halt. And if not, then we bring them back at 1 year, and then we continue, monitoring them closely. I think that's the only way to do it at present, at least.
Thank you, Vinny. And now, if Andonis allows you, I think we should continue with Roxana, because it's the theme is closer to yours. And then Antonis will be the last with the PVL closer. So it's our great pleasure to have Roxana Maheron with us. And she will tell us about the landscape of TMVR studies that is booming lately. And we need your help, Roxana, to understand what is going on and what we should expect here.
First of all, I want to thank you for having me here, and Chronia Pola, Constantino, for your name day that just passed. But more importantly, just really following Vinny and that wonderful talk, it kind of like really puts things into perspective of how difficult the landscape of the mitral valve therapies are. I mean, we didn't mention, the transeptal, for example, what we just heard is these heroic, incredible, beautiful work that Vinny has led over the years, and others. And now we have approval for mitral valve and valve, yet we know so little about this space, and there's still so much more to learn. We didn't talk about the anticoagulation, and as you see, it's really a sort of not really well studied, very difficult to do clinical trials in this arena. And I think that's the part that is going to be really important for us to discuss and to talk with all of you. We have to kind of think about this, the success story of TAVR from a science project, standard of care in just a decade. I don't know where we would be without all of the science behind all the clinical trials that were able to kind of be accomplished in the space of the aortic valve. But then in transcatheter mitral treatments, it really is a different animal, isn't it? I think we've heard over and over again the differences between the pathobiology, the complex anatomy, the difficulty in understanding the different patient profiles, the fact that we're dealing with we can't just start on the sickest patient population, or maybe we have to, and we'll go through that whole scenario of how we went from one to another, and how difficult it is for us to kind of navigate the field of mitral valve therapies in terms of prospective randomized trials. And I think really important is this idea of the differences and what we're seeing in the TMVR space. These are usually younger patients. The pathobiology could be functional or degenerative. So that's two different pathobiologies altogether. Can't put them in one space to study them prospectively. The gold standard, I think, no questions, continues to remain in the younger patient, mitral valve repair preferred, and still a surgical therapeutic, very different than where we are today with TAVR. And durability is going to be a very, very big issue. And I wouldn't even say that we currently know where we are with durability 10 years down the line, even in the aortic position. I want to talk about the access site. While the transapical should be completely gone now, and we should be going through a transeptal, what about the closure devices and all the other things that are going on in that whole arena on the venous side? And then, of course, the inherent technical risk that we've already heard. The big one is these large transeptal holes that we're making and the possibility of having to do closure. And I wanted to kind of discuss that, and maybe in the arena, we will get some idea to kind of have a discussion. So very, very different. And of course, the degenerative MR versus functional is a whole different story. And we know already that the clinical trials in the arena have to be sort of separated, perhaps, based on the pathobiology. The guidelines are also somewhat limited in mitral regurgitation. We're waiting for those the changes or the hopefully improving the class for mitral therapies as we go along. But the current best transcatheter mitral valve repair was down to 2B, and hopefully we have already picked this up to a much better place. So the different approaches, the toolbox is tremendous. And as such, currently, I think the one device that we're using is the mitral clip. And all these other ones have had their issues, and we have prospective randomized trials. And I think about all of the different kinds of clinical scenarios and imagine that the Academic Research Consortium getting together with MVARC, led by Greg Stone, was so important for us to kind of set this field forward. So as a result, at the moment, obviously, and based all on COAPT, which was it took us 7 years to enroll patients in the COAPT study, but well worth it, because when you do a study that is very well done in the select patients who would have a benefit, you will get a good result. And I think we remember this when mitral FR was presented, and then a month later, COAPT was presented, tells you the difficult arena that we're dealing with in percutaneous mitral valve therapies. This was a completely negative study, absolutely no difference between the two. And a month or 2 months later, Greg Stone had a standing ovation when we looked at this study, 600 patients, very well conducted, took 7 years to do, and it took no issue whatsoever to show that all-cause mortality and heart failure hospitalization separated almost immediately in the postoperative time and continued to separate. And the numbers needed to treat were in the single digits, and a tremendous impact on how we now treat our patients with functional MR. And of course, the big thing that I loved, what Michael Mack put up here, that was a few years ago. And I think we know now that the COAPT trial has really is not the only boat. And I think many, many more will follow. So what do we learn from those two trials is that it's patient selection, timing, and conducting a trial in a very high level way in this arena is key. COAPT confirms that synergy of drug and device therapies are tremendous in heart failure patients and functional MR. And then these competence centers where there is proper implantation expertise. Listening and hearing Vinny Boppet explain the intricacies of just mitral valve and valve, and I'm certain he's got the same intricacies in his selection of patients for the clip are tremendously important. And then the generalizability, is this just in a niche population, or does this open the doors for us to think about things outside of the box? And where we are now is this tremendous number of trials, a lot of them in studies going forward, and the enthusiasm has not gone away. In fact, we're very excited about this arena. We're excited about EMBARK 2. We want to make sure that the second wave forward in standardizing how we speak in this arena is standardized across the board, so we could make important advances in patients who require mitral valve replacement or even repair. And of course, the potential for replacement for applicability of primary and secondary MR is tremendous. The ease of implantation, imagine where we could be if we could come up with a great way of replacing the valve without issues. But I would say this is a dream because we have a long way to go before we get here to this arena. And I think the issue is the following, and we have to think together as sort of what we think, you know, our think tanks, our collaboration across the board. There's high variability and instability of the anatomy. One size doesn't fit all. And I think it's a very difficult arena. The apparatus is tremendously important. We've learned that from years, decades of understanding mitral valve repair versus mitral valve replacement over the years with our surgeons. And of course, this very difficult understanding of makes it very, all of these differentials makes it very difficult to standardize an approach across the board for mitral valve replacement. And of course, there are very important delivery challenges. We've already heard about all of those already. And I think it's important to understand that what we're all looking for. We're looking for this sort of golden nugget in the mitral space. We want to be able to anchor, seal, and avoid interference. We want an adaptable, recapturable, durable device, and we want it to be user-friendly. So we're asking for a lot. And I think this is why we have a slower pace to where we need to get to. And I do believe that this arena is going to be incredibly exciting. The Apollo study, I think in patients with severe symptomatic mitral regurgitation, this is a single-arm study of 1,150 patients recruiting. And I think this is a very important study for us to evaluate. And then there's the Summit trial with the Tendyne device. That's more of a, obviously the anchoring is in the apex, a very interesting study that is now recruiting. The first phase trial is still undergoing adjudication. We're working on that at our center. And it's a very interesting, and think about how these trials are differing so that, and are so different, and the devices are so different. So poolability of data will be extremely difficult to do when we go forward, because it's not just about the patient, it's about the anatomy, it's about what each device offers that's different than the other. And I think it makes this field even more complicated than we ever imagined. And you know what? There are 30 ongoing trials at the moment. So if you ask me to clean up this puzzle, it's going to be extremely difficult. But it takes collaboration, understanding across the board what we're looking at, understanding our limitations, and knowing that we're not going to have answers tomorrow. And as anxious as we are, we need to pay a lot of attention. So what do we have to do? We have to better implement our heart teams, surgeons, cardiologists, but trialists who design these studies. And of course, very importantly, standardizing the definitions of the things we're looking for, not just on the endpoints, but how we select patients in these trials and how we would define them so that later on, when we need to pool them, we're able to do this. And these standardization is not just in the procedures, but also in the definitions of endpoints, definitions of who fits where in patient demographics, and then very importantly, how we design trials around this. And then let's not forget optimal medical management in these patients. Each time you place a valve and go through these procedures, you may be changing the biology and the pathobiology and, of course, the physiology of that patient. And as such, the medical management will change. And then we didn't even touch the anticoagulation, antithrombotic regimens in these patients that absolutely should be figured out. So I think very, very important. And also, lastly, is the durability and all these important issues that we must think about over the years. So we have a long way to go, but I think I remain extremely excited about how we're all been working together and how we imagine the future of mitral valve therapeutics in a much, much better way as a team together and hopefully designing studies together, populations, and standardizing how we look at things going forward. Thank you so much for having me.
Thank you very much indeed. Thank you. Kostas, please.
I confess it's one of the most complicated fields for trialists, right? Because it's not just what we have. We have so many new startups, so many suggestions for new TMVRs, but it's also the necessity, what we're really lacking currently in our treatment. So now we have the MitraClip. So a TMVR has to position itself somewhere around, the edge-to-edge repair. If we had a TMVR 10 or 15 years ago, it would be a different animal. So that's why I think we saw that some of these trials, like the Apollo trials, it started with a comparative trial between surgery and TMVR. And in the process, it changed to a single arm study just for the TMVR. And the summit, we had many iterations, right, in the protocol, Roxana. It started differently and it proceeds differently. It has to adjust to what is currently valid in our treatment armamentarium.
Well, that was just sort of an example of how difficult this whole arena is. I mean, I think if we, I can't imagine without us constantly talking to each other and understanding how best to proceed. And I think, the Apollo investigators did the right thing. It was going to be a very, very difficult feat. Vinny knows this. He was in the center where the PI is at Columbia, and I at Mount Sinai with David Adams. This was difficult. Almost impossible. And I think that it was a right decision to go to where they went, because it would be comparing in a very difficult way, and recruitment was difficult, as well as understanding what would we gain at the end of the road. And I think in this arena, we have to constantly keep thinking on our feet. And as we learn and go forward, I mean, I think the mitral clip is a beautiful story, right? It started with the Everest, then went on to the French study, which was completely negative in functional MR with heart failure patients with And then when COAPT came, and it was a select patient population and it took 7 years to enroll patients, we saw the incredible benefit in those select patients. And now it's a niche, to me, it's a niche rather than this one size fits all. And I think that's how we have to think for each of these devices, that it's not going to be the device that's going to take over for everyone. Very different than what we had in aortic valve disease. Vinny, what do you think? I mean, I think you've been through this more than anyone else, and you watched that change happen in front of your eyes. And as a surgeon, you can tell us how difficult that was.
I think this is, you have rightly touched on it, and you have summarized it very well. And I think the only way forward was to make it single arm. And I was of that opinion. I was the global PI for the Intrepid in Europe and the early feasibility, is to get an indication in patients who are not suitable for mitral clip and then proceed. And as for Summit now, again, there is a change, but they are again enrolling rapidly because of that. My question to you, Roxana, would be, and this has always been I've always asked Marty is why can't we have one trial design for everyone? And I'm not saying that it fits everything, but at least primary endpoints and some secondary endpoints. The reason is one can tailor them to, suit the end result, so to speak. Nobody conducts a trial for it to fail for something, right? So not necessarily, So one is, can we have, like we have MVARC, can the clinical trialists who, like you, Greg, and few others and the regulatory bodies give us a robust, at least 80% framework where clinicians like us can draw a positive conclusion?
No, I think that's the goal, isn't it? All the time, we're really pushing forward towards that goal. But as this field on the mitral side is so difficult to do, I think we've accomplished it on the aortic side because we're in you know exactly how to proceed. If you have a device, you know what you have to do in order to go forward. On the mitral side, it's so much more complicated, and the patients are so different that a design that works for everyone is very difficult to come up with. That's what we're working on. MVARC 2 is doing exactly that. The endpoints and the definition of those endpoints have been standardized, and the FDA is behind them. So when sponsors go against those, they're just shooting themselves in the foot because they're not going to get forward. And I think it's going to be and it's not about just one group. It's a massive group. MVARC has 115 experts. It's not just 20 odd people sitting in a room. We met for literally 8 hours for 2 straight days, 8 hours this last month for MVARC 2. And we have working groups, and it's 115 people with FDA and payers and everyone sort of included in how do we proceed to get exactly where you want to go, Vinny. 80% standardization so that you could know how to get from step 0 to hero, And I think that's the way it has to be, but very, very difficult because the patient populations are different, and you would have different approaches with the devices having different mechanisms of action in how it's not just reducing, right? It's not just reducing MR. It changes the biology of that patient depending on whether you're using, let's say, an anchoring in the apex, like in the Tendyne device, or a replacement or a repair. It's all very, very different, and depending on what that patient is. So difficult to be 100% correct. 80% is a good goal, but still difficult to achieve.
So, Roxana, do you think the direct comparison of like Tendyne with MitraClip in a head-to-head comparison, like it's now in Summit, in a population that is suitable for either treatment, is a clever way to go or the fastest way to go?
It's a clever way, but a very risky way. And sponsors are risk averse, and I don't blame them, right? I mean, think about it. A clip versus, you know, your endpoint differential where you would have superiority or even non-inferiority could be very, very different because the device itself is functioning differently. And I think it's not just about stopping the leakage, right? It's about how that device is doing that. And I think it becomes more difficult. I mean, think about it. It's that we just started the very first randomized study of SAPIEN versus CoreValve. It's a decade later in a small annulus in SMART. And we're hearing a lot of negative things. You know, people don't like that kind of head-to-head comparison. But I believe comparative effectiveness is key because not all these devices are going to survive. And not everyone is going to be able to pay to have all of these devices on the shelf. So everyone has to come forth to find out what's the best device in whom and which 2-3 devices are you going to have at your fingertips to use down the line, depending on what your patient population is.
Collision studies sometimes are very courageous and generous, like the Everest 2, that was a direct collision study, head-to-head, a mitral clip with surgery, and it won. That was the only way, you know, to establish a new treatment. So I think comparing it with what we do today, which is mitral clip, it's also a very direct and honest way to do this comparison.
That's right.
Great. Thank you. And I think we have, it's now time to continue to our last presentation in this session by Dr. Halapas, who's been a part of our team for many, many years. And he was instrumental in the success of many things we've done over the last 10 years. And he's going to tell us about PVL, paravalvular leaks in the mitral valve position, and where we stand today and how we treat them. Adonis.
Thank you for having me, Kostas. It's a really great honor to be part of the Congress. And in the next minutes, I'm going to discuss about the defects, the PVLs in place of mitral regurgitation, in place of the mitral valve. So what we know up to now, no conflicts of interest, and what we know is that opposed to the, do you see my slides?
Yes, we see them very well.
Okay, thank you. So opposed to aortic defects, the mitral PVLs are more common, 7 to 70%. They're larger and sometimes more complex in anatomy. They're more symptomatic, and in repair sometimes it's more difficult. Regarding the location, they're most frequently located anterolateral or posterior and posterior medial. And regarding the shape, we've seen that in most of the cases, 80 to 85% are oval or crescent in shape with irregular borders. There are several factors that contribute to the development, such as significant annular calcification, fibral annular tissue, infective endocarditis, or corticosteroids, and of course, there are several technical considerations having to do with sizing of the existing valve and the suture disruption of the existing valve. In most of the cases, the PVLs occur early, relatively early in the first year post-operation, in almost 75%, and the rest 25% occur lately, but in both cases, we have always to concern about the infective endocarditis. Clinically, most of them are asymptomatic with a relatively benign clinical course. However, up to 5% of the cases can lead to severe clinical consequences, such as congestive heart failure that occur in most of the cases due to volume overload. And we've seen that mainly with large leaks, or symptomatic hemolysis that occur in almost 40% of the cases. It is more often in mitral compared to aortic position. And lately, with the use of new generation valves, we've seen this complication less often. This is a very nice image coming from Garcia, showing the different mechanisms and hemodynamic patterns having to do with PVLs at the site of the mitral valve. And just to mention the fragmentation, the collision when that is suddenly decelerated in the left atrial appendix wall, or the acceleration when they pass through very small and short leaks. So it is very important in terms of survival to proceed with the treatment of these PVLs, and the best recommended approach, of course, is the surgery, and especially when the PVLs are combined with infectious endocarditis, the association of instability of the mechanical prosthesis. However, the reoperation, it is usually associated with relevant morbidity and mortality, and they're often characterized by recurrency. That was the reason why the PVLs at the European guidelines at 2017 had the surgical approach as a class 1 indication, and they recommend the surgical approach, especially when there was combined with endocarditis or when there is hemolysis, and they gave at that time the 2B indication for the transcatheter approach, not because of its safety, but maybe because of the less experience at that time. Recently, the guidelines from the other side of the ocean, the American guidelines, upgrade this indication to 2A, and they recommend these procedures to be performed in centers of expertise when there are suitable anatomical features having to do with the size, having to do with the complexity, and having to do with the distance of the defect from the serum ring. Of course, there are several limitations to proceed with a percutaneous approach, such as the large defects when they involve more than 1/3 of the circumference of the prosthetic annulus. The stability of the prosthetic valve in stable working valves are a relative contraindication. Of course, there are several case reports in the literature where transcutaneously treated these unstable prosthetic valve defects, the presence of thrombus, and of course the active endocarditis. Regarding the diagnostic part, the gold standard is the echo, and especially the transesophageal echocardiography, which by the use of 3D analysis with color, the QLab analysis can give us very useful information in order to define the anatomy, the orientation, the shape, the size, and of course to evaluate the severity. However, we always have in mind the dropout phenomenon, which gives us the impression of false anatomical defects. And when we want further to define the anatomy of these defects, we have to proceed with 3 ECG-gated computer tomography with 3D and 4D reconstruction, in which we can have information regarding the anatomy and, of course, the optimal crossing angles. Fusion techniques can be useful during the procedure, give us dynamic information that can help us in order to proceed with a wire cannulation across the PVL. And these are the most common exercises, most commonly used the transseptal approach and the graded approach. We have to be very careful during the puncture of the septum. We have to go posterior and slightly superior so to have enough space for working inside the left atrium. When there are defects, especially posterior or septally oriented, then we can use as an alternative approach the transarticular approach, which is direct and easy access, and sometimes we don't face resistance problems to cross the PVL. Of course, the transfemoral approach through aortic valve was used not so often anymore. It has the disadvantage of mechanical, electrical, and hemodynamical compromise due to compromise of the different devices with aortic valve, and it is mostly used for defects in place of the aortic valves. When we need a further support, then we extremely can use these loop techniques in order to increase our support during our procedure. And of course, imaging is very important with 3D transesophageal echocardiography, giving us information regarding the correct position of the defect, the correct function of the postphatic valve during the implantation and after they release it, and of course the degree of the residual PVL. And of course we can use different orthogonal fluoroscopic projections, either the right anterior oblique where we can see the mitral ring or the mitral device on each side, and it is very helpful during the implantation of the device, or the left anterior oblique in which we can see the mitral valve end phase, so we can easily confirm that our wires and devices pass through the defect and not through the valve. There are several devices being used to treat the PVLs. Most of them are the vascular black devices for nitinol, most of them round in shape with the exception of the AVP3, which is oval in shape, not used in USA, having only CE mark approved for the treatment of PVLs in Europe. In USA, they used most often the AVP2 and the ambulance duct occluder. And just to mention that the VSD devices are very stiff and often worsen the hemolysis. The only up to now dedicated devices is the Occlutech, having CE marked since 2014 from nitinol. Is a double disc device with two geometries, square and rectangular, with a secure mechanism and can be applied for both transapical and transfemoral approach. And in this configuration, we can see the most important parameters that we have to estimate in order to choose the correct device. So it is the size, if it is small or large, is the shape, if it is round or oval or crescent in shape, and of course the complexity. And we can see that in most of the cases, the AVP3 and the Occlutech rectangular device, it can be the more appropriate. And in case where we have large, complex defects interrupted by sutures or tissue creating small PVLs, we can use different techniques in order to apply more than one device, either at the same time like the double wire technique or subsequently like the hopscotch technique. One issue during the procedure is the resistance and the friction to advance the sheath through the lead. And there are several techniques in order to overcome, like using a stiffer wire. If it is possible, smaller hydrophilic catheters to change the access site to a different point. And there are some cases reported in the literature showing that by using inflated fan guns in the other side of the defect and by the so-called pulling and pushing technique, we can overcome this problem. What important is also the several peri-procedural complications. According to the literature, are not so often seen. It is less than 5%. And just we have to point out the device interference with the prosthetic valve. This can be done either during the implantation, but sometimes we can see this interference after the release of the device that can change the device the orientation and then can obstruct the mechanical valve. And that can cause a hemodynamic device. So we have to be ready in order to remove with the use of a snare the implanted device. Of course, the embolization of the device implanted, it is reported less than 5% in most of the cases. And thromboembolic events, therefore, it's very important to have an ACT more than 300. And we have, of course, complications having to do with access sites. This is a very nice publication recently published in Eurointervention. Almost 200 cases, 70% having to do with defects in place of the mitral valve, where you can see that the large defects, more than 10 millimeters in maximum diameter, were less than 20%, and those who have a maximum diameter more than 50 were almost 5%. And regarding the complications, we can see that the defects in the aortic position are to treat the defects in the aortic position transcutaneously. It's a very safe procedure. The same is also true for the mitral, where we can see that the embolization, either early or late, it is less than 1%. And the more common complications seen having to do with access site complications and recurrence of the hemolytic anemia. Recurrency is often used when we don't seal these defects completely, and this is very important to try to complete to seal the defects complete. And in case of recurrency of hemolysis due to residual PVL, there are different strategies. I think the one like wait and hoping that the visualization of the occlusion device is going, which we going to diminish the shearing forces on red blood cells, and therefore it's going to decrease the hemolysis, could be one of our choice. In the literature, the first case reported for the closure of the defect in mitral position was 2003, 20 years ago. Since then, we have a small series regarding the defects in the mitral position. And we can see from this meta-analysis that in general, the technical and procedural success is very high, more than 80%, but it is less compared to aortic. This is a very nice study coming from recently from Spain, multi-center study showing that the procedural success in place of mitral lesion has to do with experience and of course with the device choose. And data coming from the Occlutech also revealed that the device procedural and clinical success, it's more than 85, almost 90% in most of the cases. Recently, we had published the Greek experience from different centers, almost 40 cases, 70% were defects in place of mitral position. And we see that the AVP3 was the most frequently used device, and the transseptal approach was the access site in 60 to 70% of the cases. Finally, data coming from Mayo Clinic showed that when we compare the surgical closure with transcatheter closure, there was not relevant difference in terms of short and long-term mortality. And they suggest that when we have a severe mitral paravalvular leak, symptomatic paravalvular leaks in place of mitral valve, when there is active endocarditis, then the choice must be the reduced surgery. In all other cases, we have to think always and first for the percutaneous treatment, and if that's not possible, then to proceed with the surgery. At the end, I'm going to close with an off-label use of these devices. In patients treated after mitral clip, we've seen often severe residual RMR, and we can proceed with closure gaps either between the clips or at the site of the clip by using the AVP2 in most of the cases with sufficient results. And in conclusion, I have to say that the transcatheter treatment of the PVLs in mitral position can be challenged, especially when the defects are complex and large. However, the success rate is very high. And with that, I want to thank you for your attention.
Thank you, Adonis. That was an excellent presentation and update on the transcatheter PVL closure. I hope that the TMVR transcatheter mitral valve replacement will have zero need for transcatheter closure in the future, thanks to the brave trialists like Roxana and Vinny we have today, and the brave trials they're going to organize and to prove them. And Adonis?
I was very, very surprised. Thank you very much, Antonis. Great presentation. I was very, very surprised to see that transeptal is the preferred choice even in Greece, because it seems to me that transapical is so much easier, but obviously it is more interventional choice. Would you like to comment on that, please?
Always we try to have a less invasive access. Most of these cases are cases of high surgical risk. So the trend is always to go from more to less invasive procedure. And I think the transcatheter approach, especially nowadays with the use of steerable catheters like Angelis, we can orient our devices even in medial and septal defects in place of mitral position, can give us this opportunity. So I think that according to the recently published data, we have always to try first transeptally, and if that's not possible, then we have to think about the transapical approach as an alternative approach.
There is no question that this technique has saved lots of surgical hours, during redos and so on, and has diminished a lot of the risk of redos. It is certainly very, very useful technique to have in our armamentarium. I think that probably we should develop better devices in order to be able to close better the shapes of the paravalvular leaks. I don't know your opinion about that. I mean, it seems to me that we have circular shapes, but really that the leaks are not circular.
I think that in very complex crescent in shape defects in mitral position, the use of the ABP3 or the occlutech, the rectangular shaped occlutech, could be a very good choice. However, when one device is not sufficient enough in order to close these defects, then by using more than one devices, either if they're round in shape, simultaneously or subsequently implanted, we can have a satisfactory result. And data coming from the occlutech recently published in the Eurointervention, the success rate was almost 90%. In the occlutech. So I think that, of course, this is an issue, but although there is a limitation of the devices we have or dedicated devices we have up to now, the results are very satisfactory. And I think that even in patients that were not only high risk, but also intermediate risk patients, we can think about this procedure as a first option.
Thank you. I don't know whether Vinny or Roxana has anything to add.
Yeah. So I have a question, Dr. Chapa. Great talk again. I was involved in a lot of these when I was in London with Shaq Qureshi, going transapical in complex. I've learned recently that, and been part of it, that CT fusion, not fusion, but CT is also becoming important in pre-planning. Is that what you do as well, especially in complex leaks, where also in cases where there's a lot of mitral calcification in presence of a mitral valve already? CT has helped us a lot in getting the right projections to start with, so that when you're doing the case, it's just easier.
Yes, of course, the transesophageal echocardiography is very useful. However, for planning our procedure, in order to evaluate the anatomy and to see the orientation of the angles and the projections, they are going to use the CT, the ECG-gated CT. It is very useful for such information. So it is our part of our protocol always, such cases, to proceed always with a CT analysis of the defects.
Thank you.
Roxana, do you have anything?
Yeah, I wanted to. It was an exceptional talk, excellent. I had a little bit of a connection issue, but wanted to just ask you how, most of these patients, if you're using transesophageal, do you actually ever see that you will be going to ICE? How far along are we with ICE? Do you ever use it in these procedures? And do you see sort of a way that it could become more tolerable for the patient, not having to have general anesthesia, etc.?
A very nice question. I don't have any experience by using the ICE in treating these defects. Could be an option, I think, but I'm not sure about the artifacts that you can face by using the ICE during the procedure, especially with the mechanical valves. So,
Vinny, do you have any experience there? Or because I was seeing that there are now so much technology has improved in ICE. Now they're even doing some 3D, 4D ICE. So where do you see that in this arena?
I think Steve can probably answer it better. He's already raising his hand from Mainz.
We have Stefan with us from the next session. So Stefan.
Right, I've used ICE both in 2D and in 4D, both in vitro and also in vivo. And it works really, really nice. So especially if you can move either by a second transeptal puncture into the left atrium, or you go directly from the caval vein with a puncture on the other leg. You go directly next to even a 29 French device. You can go in the caval vein up to the right atrium. You use steerable sheaths like those from Occlutech or Oscor, and then you can get into any angulation on the annulus, on the valves, etc. It works really well. We have only done a couple of cases, but I have now 16 ICE catheters in stock at the moment, and we're starting the CE Mark Siemens model first, and later this year we expect trials on the Philips system, which is a matrix ICE. So you get almost, in a smaller angle, you get almost TOE-like images from within the body. You don't have to intubate the patient anymore, so you can theoretically do mitral and tricuspid interventions, even replacement with local anesthesia. You don't need anesthesiology anymore.
Thank you very much. I think this concludes this roundtable because we have exceeded the time. So thank you very much all, and I hope we see you all next year.
Next year.
Thank you very much.
Take care. Thank you.
Expect you all in Athens next year. Thanks for being with us.
Thank you so much. Bye. See you all.
Bye, Vinny.
You can start, George.
The title of this section is A Peek into the Future and has to do with the most recent developments in the field of mitral and tricuspid valve. There will be 4 presenters. All of them are faculty members in prestigious European universities, and somehow they manage in their departments to develop study ground for the treatment of heart valve diseases. They will unfold the portfolios of some of the biggest technology producing companies and will show us what is hidden in each portfolio. So we better start, and we are all anxious to listen to what they have to tell us. The first speaker is Dr. Fabien Praz. He's an interventional cardiologist and a faculty member at the University of Bern in Switzerland. He will talk to us about repair and replacement of the mitral and tricuspid valves with the Abbott portfolio. Dr. Praz.
So thank you very much. Thank you for having me, for the kind invitation. Very happy to be back here. So I will drive you through the different technology from the Abbott portfolio, looking at repair and, as you know, also replacement for the Tendyne valve. So again, I have shown this this morning, but a very important slide with technological development in the recent year of edge-to-edge repair, and also now with the CE mark for the tree clip, and for competitors as well, as you can see with the Pascal device. So all these devices that have been developed now since 2018 have a CE mark and are commercially available for the treatment of the mitral and the tricuspid valve. In the case of the Pascal device, it's the same device and the same system for both valves. In the case of the Abbott system, with the mitral clip, you have a dedicated device for the tricuspid valve. I will come back on some details at the end of this presentation. So that's a landscape you can see here. So during long time, only one device for the mitral valve, the INT-R device since 2003. Then up from 2018, the XTR, and now we have the fourth generation of the device with four different sizes for the treatment of the mitral valve, and very recently as well, the same implant sizes for the tricuspid valve that have been introduced in Europe just a few weeks ago. Before you had it only the XTR and the INT-R option together with a tree clip or the tricuspid version of the catheter. So the particularity of the Gen 4 is the control gripper actuation, the different sizes of the device with a wide size of the device and the smaller one, NT, XT, NTV, and XTV. So this gives you a lot of option and add a bit of complexity as well into the selection of the device. You can actuate, control the gripper independently, and this allows you to make some optimization, but also to capture the leaflet independently from each other in case you need to do that, which is actually quite useful for tricuspid intervention, essentially. So I would like to show you a case how this technology can be used in a concrete patient. So it's a 77-year-old patient that is high risk and has been selected for transcatheter treatment. You can see that we have a quite not so easy anatomy with a commissural problem, probably a small flail or prolapse, commissural A333, very medial, and for that reason we have selected the NTV version of the Gen 4 mitral clip because of his ability to be used in commissural lesion and his small size, preventing entanglement into the commissures. And what we have done, you can see here, first grip with a simultaneous gripper actuation. Both gripper fall down on the arm of the clip and on both leaflet, and then we close the clip and look at the first result. All this is very medial, as you can see in the commissural region of the mitral valve. And what you see on the 3D view on the right here, you see that we have a reduction of MR, but we still have very medial jet coming from the extreme commissure of the valve. And that is not acceptable in that situation, and that you will need to address. And instead of moving actually this clip again, what we have done, we have reopened both arms of the clip, but have let the gripper on the anterior leaflet dropped so that the anterior leaflet is still captured. And then in a very gentle movement, as you can see on the animation, you will move a little bit the catheter towards posterior. And you can see here during the clip that, during the video clip, that the posterior leaflet is coming more and more on the posterior arm of the clip. And this is called optimization and allows you, without without doing big movement and repositioning the clip to optimize the leaflet capture. And that has an effect most of the time if you don't change, of course, your angulation, because that would be a bit dangerous. You only optimize the capture. And in that situation, you can see that we could go to mild regurgitation just by doing this maneuver without moving the clip. So what we have seen in the recent data is that this technical evolution I have just shown translates also into an improvement of the result. And what you can see is not so much an improvement into the success of the procedure, but more into the optimization, with more and more patients that are able to leave the operation room with mild or grade 1 or trace mitral regurgitation. This is a bit at the cost of more device implantation, so we are more liberal in the use of multiple implants. This may change with the Gen 4 because of the different size of the device, but that was what we could see in the data. And also something very reassuring, we see that the number of patients having a single leaflet device attachment, or leaflet complication, as we call it now, is decreasing and is very small in the very recent series. Of course, this is not only technology, but also growing operator experience. Sometimes, but your patient is your mitral regurgitation patient has this kind of pathology with very large calcification of the leaflet, and that's a patient that will not be so easy to clip. And for that, there is, of course, another CE-approved solution, which is a tendine valve that you will introduce transapically. The tendine valve is a self-expanding valve that is secure at the apex with a pad. It is available in multiple sizes and can be customized to the patient anatomy, as also a smaller profile that can be implemented in order to minimize the risk of LVOT obstruction. And this technology is available for the treatment of mitral regurgitation, but not only, also for patients having moderate mitral annular calcification and some degree of stenosis. That's our patient, again, with, as you can see, calcification of the anterior and posterior leaflet, the simulation of the valve, the CT measurement and CT planning of this procedure is extremely important. There is valve simulation that is done, and the LVOT is measured in a lot of details and during different phases of the cardiac cycle in order to exclude the risk of LVOT obstruction. You can see here the neo-LVOT, which is the LVOT after valve implantation, that can be simulated on the CT images, and that should be in an adequate range to prevent this complication. Also, the access, which is a transapical access, can be simulated and anticipated. Also, the rotation of the valve. So all this multimodal planification plays here an extremely important role. In that case, we decided, because of the calcification that you could see, because of the anatomy, to perform a pre-dilatation of that valve in order to be able to better expand the tendine valve. In a second step, you can see on the right side the sheath that is already introduced through the apex and through the mitral valve. Then the valve is expanded slowly in the left atrium and oriented in the right position. You see on the right a very good result without LVOT obstruction. So these two technologies are complementary. There are criteria and also a different risk profile of these two technologies that can be tailored to the individual patient. We have, for example, more risk of thrombogenicity with transcatheter mitral valve replacement. Of course, this patient will need anticoagulation. There is a risk of LVOT obstruction. There is some surgical, it's a surgical procedure, so some intrinsic risk linked to surgery. And on the opposite, transcatheter mitral valve repair is a very safe procedure, but in some case will not be able to reduce completely mitral regurgitation and is less standard. Anatomical criteria are important to define which therapy will be the best one. As you can see, a commissural MR or a small mitral valve area calcification, as I showed in the example are also criteria favoring replacement. And there are also some secondary mitral regurgitation patients that may benefit from this therapy, patients with small valve area, atrial, secondary mitral regurgitation, or patients with extremely severe leaflet tethering that may be better served with a replacement strategy. And also in the future, patients who are having failed surgical or transcatheter repair, have already a clip in position, could also benefit from a tendine implantation. The data in 100 patients show a very safe procedure, actually, with a low number of complications, and also a really nice reduction of mitral regurgitation that is, of course, more predictable than what you can see with mitral clip, and maybe also more durable. You see here the result at 2 years that are actually very sustained in terms of MR reduction. The last system I want to talk about is a tri-clip Gen 4 with 4 size of device, very similarly as on the mitral side. Also, the ability to have control gripper, that is very new. We have it since 2 or 3 weeks now, and also a dedicated knob, which is the SL knob, that will help you to go septal or lateral in a translational movement that is very useful, actually, in patient with you want to treat on the tricuspid side. So dedicated system giving you, as you can see here, the possibility to move the device laterally and septally in a pure way, and giving you the opportunity to correct mispositioning that can sometimes be seen on the tricuspid side. The dedicated study was a TRILUMINATE study, and it showed here are the 1-year result published in JACC and reported by Philippe Lourdes. You can see that you have a nice reduction of TR that was also durable in that patient. Of course, you will not achieve mild or trace tricuspid regurgitation in all cases, but in a good proportion of cases, you are able to reduce TR in a way that will help him clinically. And you see the result, 40% reduction in rehospitalization for heart failure, a quite interesting endpoint for that patient. This is an example of a patient we treated last week with a Gen 4 device. You see an anterior septal mainly jet with a very severe secondary TR in this patient. Here is the grasping view, severe TR. And after the implantation of 2 XTV device, we were actually able to achieve a nice result. Maybe I can show you that. So the XTV, you can see here a reduction to mild TR with 2 XTV in the anterior septal position. And probably this XTV, we will need to gain more experience on that, but this XTV clip will be probably the one used more often on the tricuspid side. It has long arm and is wide, reduce TR effectively, and help you to grasp the thin leaflet of the tricuspid valve. So let me conclude by showing again that technical development are really expected to broaden eligibility and improve outcome. We are complementary technology, repair and replacement that are luckily available and commercially available in Europe. And of course, as always, the operator and center experience, the volume also will continue to play an extremely important role as it comes also to multimodal imaging and planning of this procedure. Thank you very much for your attention.
Thank you very much, Dr. Pratt. It seems like the basket from Abbott is full of goodies, a lot of good material there. The results with the clip, they're good, and it seems like every new generation of clip that comes to practice improves the results a little bit better, it makes technically easier to approximate the leaflets, I guess. And this tri-clip thing, it's very, very interesting. I'm a surgeon. We have problems with the tricuspid valve, the forgotten tricuspid valves that they were not fixed properly at the first time. They end up to be a big pain. This Tendine valve, I know that's the first one that took the permission to get implanted in Europe, I think.
Yes.
That was a year ago.
Yes.
A couple of years ago. Yeah. It has to be applied through the apex. Again, I'm a surgeon. I'm afraid to touch the apex of a ventricle that it's dilated, it's spherical. It has suffered because of the mitral valve insufficiency. Seems like the TAVI didn't do very well through the apex, and it had to be done through the femoral artery to show some good results. I really worry. And the left ventricle with the stenosis of the aorta is not a bad ventricle, just a thick wall. That's all it is to it. Here we have a bad ventricle, really dilated, it's spherical. If you have bleeding from the apex, you have to be in the operating room. I assume you do all these cases in the operating room.
Yes, so the Tendine is done in an hybrid room, as you mentioned, for that reason, and the surgeon play, of course, a very important role in the selection of the patient and during the procedure. You are absolutely right, mentioning this, and you know the indication actually for Tendine is mainly for patient having a left ventricular function of more than or equal to 30%, and that's also actually the population of patient that has been treated in the study. But we have to mention that the largest part of the experience from the Tendine valve comes actually from patients with secondary MR, and that's the results have been quite good in terms of safety in the global feasibility study. So we don't see so much of the complication you mentioned. Also in terms of strokes, I want to mention this. Of course, it's a different environment, I would say, because we are not in the calcified situation of the aortic stenosis when we treat patients with secondary MR. But of course, we will need to investigate this more and to look at the exact indication for that device. But it's the first one that is really working, and I think it is helping a lot of patients, also patients with MAC. We don't have so good option and that are increased risk for conventional surgery.
And I noticed the complication rate through that approach wasn't very high, it was 1%, I think. That's what you show us. Do you have any other information that makes us worry?
You mean the complication rate from access bleeding?
From access going to the apex, you know.
That was not so high in the global feasibility study. So they were something between 1% and 3% of bleeding complication. So that was rather a safe procedure. One of the parameter is also the pad. You know, you implant a small pad at the apex that is also closing the apex, and this is working quite well. But of course, you need to have surgeon experience in closing that apex.
Thank you, Dr. Pras. Dr. Spargias,
if I mean, we have another surgeon here. You have another surgeon. You have Dr. Maisano. So, can we ask him if he shares your worries about transapical access in mitral valve disease? Francesco, what's your opinion?
So first of all, there are many things to be discussed. First of all, there is a big difference between the mitral approach. The transapical from Tendine is not because we need a large bore access. The issue is that we use the apex to fixate the valve, and this probably is a major advantage. We see this, for instance, now with calcified valves. This is the only device at the moment available for calcific valves. And one of the reasons is that you have a special fixation model, which is using this apex as a point of fixation using a kind of tendon, like a corda, a big corda is a big suture, basically, which is used to fixate the valve. The other point I think mentioned by Fabienne is that yes, there is this pad is distributing the tension on the apical approach. And to be honest, although I totally agree with you that I am also very scared about transapical. I've been probably the first surgeon who abandoned transapical probably back in 2007. On the other hand, the quality of the wall of the mitral patients is better than the quality of the aortic patients. Don't ask me why, but they look to be more fibrous. It's a more fibrous tissue. It's less muscular. There's probably less hypertrophy. So also the sutures, they hold much better. So this is important to know. On the other hand, I also believe that in the future, most of the transcatheter procedures on the mitral valve will become also transfemoral. So this, I don't think Tendyne will remain forever the solution, but at the moment is the best.
Thank you, Dr. Maisano. The next, thank you, Dr. Price, thank you. The next speaker is Dr. Varde Leben from the University Medical Center of Mainz in Germany. He's an interventional cardiologist who is also head of the cardiovascular imaging department. He's the head of the Heart Valve Center, which is a well-known center for innovative work in valvular disease. He will talk to us about the same subject, repair and replacement of the mitral and tricuspid valves with the Edwards portfolio. Let's see what is hidden in this basket now.
Thank you. It's a large basket, Professor Marcus. Thank you for the very kind introduction. Hello, Fabien, Francesco, hello, Costas. And it's my pleasure to speak now about repair and replacement of the mitral and tricuspid valves with the Edwards portfolio. These are my disclosures. We all know that mitral regurgitation is a progressive disease and that mitral regurgitation actually is the most predominant of the heart valve disease. It carries a mortality that can range between 20 to almost 50%. What is recognized in the recent years is that it's not only a dysfunction dilatation of the ventricle, but also of the atrium together with the annular structures. The latest position papers of the 4 working groups of the European Society of Cardiology has highlighted that there are also new interactions between revascularization and valve treatment that go in favor for TEER treatment. The repair and replacement portfolio consists of a leaflet therapy portfolio, which is the Pascal and Pascal ACE, that is depicted here in the middle, up to a replacement strategy coming from the CardioQ valve and now as the EVOC valve. In the beginning, there has been a focus on the annuloplasty, which is a dedicated possibility to reduce annular size, both in mitral but also in tricuspid repair. You can see it's a transfemoral system that looks very much like the other leaflet therapies. It's a 22 to 24 French approach. You can see it's a steerable catheter that goes to the annulus of the mitral valve. And after deploying between 14 and 17 anchors, you can then cinch over a wire the annular size and reduce the perimeter there by about 5 centimeters. Here's an example. You see the typical position, which will be projections in LAO and RAO. You see the regurgitation. Of course, not a severe tethering is favorable for this method. Here, I just depicted you the mitral system CE-mark trial data, and you can see that over a time period of 2 years, we can gain a sustained reduction in MR. Also, the survival is quite favorable. As we see here, we have only a mortality of 21% at 2 years' time. Other possibilities are, of course, for degenerative disease to support chordal structures, here with the Harpoon system that uses as the first in its kind for transapical access, actually a sheath that is just above 10 French. And you can nicely see that we only need minimal access roots, as mentioned by Francesco just minutes ago. This is only a 2.5 to 3 centimeter intercostal excess. You can nicely see here the posterior prolapse. You go through the chief into the apex. You puncture through the valve. You place a nitinol anchor shot in the leaflet and then can tension the device to nil MR as you see it here. And this can also be done with a combination therapy of Cardioband and the tensioning of cords, as you can see here. And you can nicely appreciate that this is only a trace MR result. There are other strategies that are pretty similar to the HiLife system. Here, the Encircle, which uses a tissue valve, an aortic valve, the Sapien 3, with a fully covered stent graft. And you can see that we use an M3 docking system in the chordal space and across the mitral valve, in which then transeptally a Sapien M3 valve is being deployed. Most interventions on the mitral valve with the Edwards portfolio in the range of more than 2,000 implantations have been done with the Pascal and Pascal Ace transcatheter system. It's unique that it uses a central spacer, has independent leaflet grasping, as now seen in the 4th generation of the MitraClip. And we have a device elongation, as well as specific material, which is nitinol, which gives its way. The CLASP study showed that also here, the 30-day mortality overall with 0.9% was extremely favorable. You see that there was no need for renal replacement therapy, as no contrast is given in these procedures, and also reintervention rates around or below 1% are very favorable in such an early experience. Overall, at the long run, at 1 year, we have a 92% survival. This is a mortality of only 8% at 1 year, and an 82% freedom from heart failure hospitalization, which is like in the Tendyne and in other projects reduced by more than 50%. MR reduction has been shown to be sustained at both 6 months and 1 year, and this is correlate adjudicated, as you can see here, in 109 patients. The sustained MR reduction is seen not only on FMR, but also on DMR patients, which is very important as we group these two different entities. And of course, their mortality and outcome burden at 1 year is different. Functional and quality of life improvements have been shown with KCCQ improvements between 15 and 16 points, and also an increase and amelioration of New York Heart Association functional class down to 1 and 2 in about 90% of patients, which is also very favorable. At the moment, we are running also in Mainz as a European PI, the CLASP 2D to F trial, which is a large multi-center trial with almost 1,000 patients that are randomized and categorized between 2D, which is degenerative or primary disease. Here we have a 2-to-1 randomization versus the Pascal system against the MitraClip system, and the Pascal 2F, which is a 1-to-1 randomization. And there's a follow-up throughout 5 years to compare both devices. Here, just a short example of a procedure just to show we're using fusion images. You see very nicely that we can shorten the device here in the atrium. We have a very good overview, good image quality on the mitral valve. We have 2 independent grasping or clasping possibilities here, raising both clasps. You can then remove the pin and independently actuate the 2 grasps, which are done. Here you see the nice orientation from anterior to posterior. And you can appreciate that it's very easy to set up the leaflets on the device, and then you simply put down the 2 clasps, as you will see in a second, and you can immediately, one after the other, is being engaged. Sequential clasping in this case, you close the system. This is 30 seconds. This is real time what you see here, and there's trace MR at the end. So a very sustainable result. And this is highlighted also in the early commercial experiences, which is 1,200 patients, technical success rate of 99.8%, no serious events, acute efficacy reaching less than 1+ MR, which is a surgical result in 73%, less than 2+ result even in 97%. And in the learning curve is very short. As you can see here, the comparison of the first 5 to 10, and then more than 25 procedures. And you can see that you save about half an hour just within your first 5 to 25 cases. There is a strong interaction between mitral and tricuspid valve, also for outcome. As we showed recently, tricuspid valve anatomy is influenced by ventricular size, atrial size, and annular size. And it's very important to highlight imaging in this regard. And this is why it's so important that the core competency for an interventional imager are being highlighted now in the US and also in the European Society of Cardiology on the right-hand side with the colleagues from Milano. Also, cardiac CT gains an even larger role over time, and we published in December 2020 the role of computed tomography in the added value of transcatheter interventions, especially annuloplasty and valve replacement, that is more and more important for these procedures. Imaging also improves on the mitral valve. Here you can see the latest versions of glass view, which allow to look through the valve and see Doppler, three-dimensional Doppler images. On the right-hand side, it's a posterior tricuspid regurgitation, and you can see this from the side, the relation to the aortic valve, and you can do multiplanar analysis of these. The transcatheter tricuspid landscape is diverse, but you see with the red crosses that there is a number of already failing systems. So we lose about 40% of those devices that try to enter the market, also surgical concepts. And tricuspid valve is often complex because of thin leaflets, thin chordae, and large annuli. Again, we have pretty much the same basic portfolio here with the Pascal ACE, and the Evoque valve, which gains momentum. We have more than 100 implants now of the Evoque valve in tricuspid worldwide. Again, I start with one of the early CE mark devices that actually Francesco has done first worldwide, me second worldwide on the tricuspid valve. You see the implant is pretty much the same than on the mitral. The system is inverted. It's also done transvenous. We don't need transeptal punctures here. So it's a very favorable device. We can then change the cardioband with a maximum length of 12 centimeters by up to 5 centimeters. Here you see a typical situation of the relation to the right coronary artery before and after the implant. You can see here the regurgitation before and after the implant in its cardioband case. Also here we have data for 1 year and now just published also 2-year results, also favorable, very sustainable, 83% survival at 1 year, which is also favorable in the sick patient cohort. There are new features this year with Cardioband 1.5 and another iteration coming up. So improvements on fixator, anchor change, etc. Are now available mid this year. Again, the Pascal platform is important to change the Pascal ACE on the tricuspid as it's able to penetrate chordae much easier. You can see this here, independent clasping on one side, improvement on the other. So we drop on the left-hand side the clasp, we can elongate, reposition the device, and keep the retention elements actually always on the atrial side so we don't engage with the teeth in the chordae. Very successful also. I'm sorry for the sound. I'll remove that just to show you a Pascal ACE implant. I'll try to get this lower, very severe regurgitation. And just to show you, because of the short time that we have here, just the results, two devices implanted here. Remove the sound. You can see the width comparison to a mitral clip that we've just seen in the talk by Fabien. Again, very nice imaging, easy to maneuver, easy to steer. We then close the device and you see a trace result of the severe regurgitation. The next thing is to use CT and overlay in replacement techniques. And this is from the first 25 patients just published in March this year in JACC Intervention. We now have a totality of 100 patients, and Sushil Kudali just at ACC reported the next 56 patients in this regard with very favorable results. We have a 0 mortality at 30 days for replacement, no myocardial infarction, no stroke, no device embolization, some conduction system disturbances, which is AV block, which is also known to surgeons because of the Koch triangle. But you see the TR severity reduction is very profound. New York Heart Association class improvement, also very profound. Here, a case of a carcinoid patient. You see a severe free regurgitation We appreciate this easier in the cath lab actually during the procedure here on the right-hand side. Sorry, I have to go one back because the computer is slightly slow. Just a second, I'll try to start this again. Just to appreciate the severe free regurgitation, it was a venoconstructor area of more than 4 centimeters square, not 0.44 centimeters square, so tenfold of typical mitral situations. Here you see the multiplanar reconstruction like in CT and echo during the procedure, the catching of 9 anchors to the leaflets. And here you can see the liberation of the device in fluoroscopy and an overlay. And we can nicely see no regurgitation whatsoever, no PVL, good functioning of the tissue valve, which is a sapien valve inside the VOC. And on the next image, I can share with you the 1-year follow-up of this patient, still extremely nice function, enlargement of the left ventricle, remodeling of the right ventricle by 50% reduction in volume. So a very nice outcome. So I come to my conclusions. Mitral and tricuspid interaction treatment has implications on outcome and benefits in selected patients. Edwards addresses both valves with a huge toolbox of devices on leaflets, annulus, chordae, and replacement. Cardioband repair is moving from mitral to tricuspid treatment. We have the tree repair study, and TR replacement is a new transcatheter transfemoral transvenous option. So we're not talking about transapical access here with the EVOC. It uses a completely percutaneous approach for TTVR, and repair and replacement is tested in the next 3 years in more than 2,500 patients in randomized trials against placebo or optimal medical therapy in the US and Europe. We have the device comparison CLASP to D2F, the TriCLASP and TriScent2 randomized controlled study, which will start enrolling in June, July this year. Thank you very much for your kind attention. I'm open for your questions.
Oh, thank you so much for the talk. Concerning the cardioband, are we moving from the mitral position to the tricuspid position, or we stay in the mitral position too? It seems like they had some complications there, complications mainly with bleeding.
Yeah.
Is that a concern?
The situation is that we will see 1 or 2 iterations in the future. There's one which is called the system 1.5, which will be rolled out this year. But of course, we're using 6mm anchors, and we're placing these anchors very close to coronary arteries and in hinge points, which may be fragile. The system works quite well on the tricuspid, but if you look at the total numbers, leaflet therapy and, in my opinion, also replacement will be a very strong competitor to annuloplasty in the very near future.
I never could understand why we surgeons fail when we try to repair that valve. I mean, we put rings, all kind of rings, rigid rings, semi-rigid rings, bands along the posterior annulus. We never managed to improve survival of these patients with functional mitral regurgitation. I mean, the results, they were pretty constant. No survival, just only some quality of life, if you cannot name it quality of life. We decreased the rate of hospitalization, that kind of stuff, but not actually. And you do have to show some survival with a ring, not with a ring, but mainly with a clip. How you explain that? Is that because you don't have the surgical mortality there, or you have actually improved survival?
I think we have some first propensity score analysis of that, and it's exactly your last point. If you look for tricuspid there, it's even easier to see. We gain a momentum by having 10% less mortality at the time of the procedure, and we're then running with a good result in parallel to surgery. So we're not better than surgery necessarily, but we have less procedural impact to the patient, and in some instances, a better selection bias on these patients, as the pre-analysis, pre-diagnostics are much more intense than what we typically have seen the last 20 years in surgery. While there we looked mostly at the regurgitation, we now look more at pulmonary vascular resistance, we look more at the overall risk score, some revascularization issues, contraction, looking into strain imaging for ventricular performance. And I think the fine-tuning in patient selection is one of the key points, plus less impact with a transvenous application of a valve repair. Transvenous and transeptal are so incredibly safe. We currently have an in-hospital mortality in tricuspid of 0% and 30-day mortalities somewhere between 0 and 1.5%. I think this is the key point. And we just reported the 2-year outcomes on the first single-arm study, and there we have a 2-year mortality in tricuspid repair of 18%, and at 1 year of 7.1%. So this is less at 1 year than the in-hospital mortality that we see with our surgical colleagues.
Thank you, sir. Thank you very much. Kostas, we can proceed with the rest of the discussions.
Yeah, I think Christophorus is ready to present the next one.
Good.
Thank you,
you.
Stefan.
Okay.
Thank you for the invitation.
Thank you very much.
First of all, I would like to thank the organizing committee for the invitation to participate in this international meeting for transcatheter heart valve in Athens. And next speaker is Professor Søndergaard, professor from Copenhagen University Hospital in Denmark. Professor Søndergaard is particularly involved in the treatment of congenital and structural heart diseases, and he will address the issue of repair and replacement of the mitral and tricuspid valves with the Medtronic portfolio. Unfortunately, he could not be with us in this moment, and in a few seconds we will see his presentation by video.
Thank you for the invitation to give this talk on mitral and tricuspid valve replacement using the Intrepid transcatheter valve. These are my potential conflicts of interest. So the Intrepid transcatheter heart valve is designed as a dual stent. There's an outer stent which comes in 2 sizes, 42 and 48 millimeter, which is going to anchor the valve to the annulus and the leaflets by both using radial force but also small hooks. And inside this stent there's another inner stent which is 27 millimeter, consisting of 3 leaflet bovine pericardial valve. And since there's 2 stents, the outer stent is going to take all the movement during the cardiac cycle, which is not, all of it is not translated to the inner stent. And finally, there's a flexible brim, which is going to sit at the atrial wall and allow for tissue ingrowth. This animation shows how to implant the Intrepid valve from a transapical approach. So typical transapical approach, insert the delivery sheet into the left atrium, open the brim, and during fluoroscopy and echocardiography guidance, bring it to a proper position before it's finally released. And as you see here, all the mitral apparatus is preserved during this, and the brim is sitting on the floor of the left atrium, and thereby allow for tissue ingrowth and mitigating the risk of paravalvular leak. These are the baseline demographic data from the Intrepid global pilot study. So 50 patients was included. Mean age was just above 70 years. Most patients were male, and almost all patients was in function class 3 and 4. As you can see, most of the patients actually had a secondary mitral regurgitation or a combined primary or secondary mitral regurgitation. Left ventricular ejection fraction was moderate impaired, around 40% at mean. At baseline, almost all patients had a severe mitral regurgitation. 30 days after mitral valve replacement using the Intrepid system, 75% of the patients have no mitral regurgitation, and the remaining patient had only a mild mitral regurgitation. And among those, only 1 out of 4 had a paravalvular leak. The remaining patient had a transvalvular leak. The improvement in mitral regurgitation was also reflected in the patient's symptomatic status. So again, at baseline, almost all patient was in function class 3 and 4, whereas afterwards, around 80% of the patient was in function class 1 or 2. Also, there was a significant improvement in quality of life. So to summarize this Intrepid global pilot study on 50 patients, there was a very high device implant success, 98%. 30 days mortality in this early experience was 14%. 3 died due to severe bleeding from the apical puncture. 3 died due to heart failure, and 1 patient from transcatheter valve malposition. 1-year survival rate was 77%. 3 patients died of sudden cardiac death, all patients with low ejection fraction and no ICD. There was no death after 6 months, no device malfunction, no hemolysis or thrombosis. There was no or only mild mitral regurgitation in all survivors, and 80% of the patient was in function class 1 or 2. Since the global pilot study, there has been modification on the valve itself, so that the inflow portion in the left ventricle has now been changed, both so it's now recapturable and also to reduce the risk of left ventricular outflow tract obstruction. There's also been a change in the brim, which is sitting in the left atrial wall, whereas the fixation zone and the leaflets and tissue are unchanged. Since the majority of the patients who are referred for transcatheter mitral valve replacement is suffering from secondary mitral regurgitation, it's important that these patients can be treated despite they have an impaired left ventricular function. And using large core transapical access will exclude quite a few of these patients from this therapy. So of course there's been a lot of work from all devices to try to change from a transapical approach to a transfemoral transeptal approach. This also applies to the Intrepid transcatheter system. So there's now a steerable delivery system which is used for transfemoral transeptal approach. It's using the same valve as for the transapical approach. The valve which is coming in, as I said before, in 2 sizes, 42 and 48 millimeter, but there will be additional sizes out. Particularly will be an extra large size because quite a few of these patients have very large mitral valve annually. So this slide showed the continuous innovation of the Intrepid system. So the first generation valve, as I said, was a transapical approach and was used in this global pilot study. In the red box, you see what's actually used today. It's a second generation valve, which most importantly is reseatable. And also it's a transfemoral approach using a 35 French system. And these are the 2 systems which is used both in the Apollo trial and in the early feasibility trial. There will be soon a next generation device which is bringing the delivery system down to a 29 French size, and also, as I said before, an extra large valve to treat patients with large mitral annually. And furthermore, there will be further device iteration in order to be able to expand for the anatomic criteria and improve the performance of the valve. This slide shows the growing clinical experience with the Intrepid system. The first in man procedure was done in 2014. In 2015, Medtronic acquired the system. In 2017, the Apollo pivotal trial was launched. 2019, the mitral transfemoral early feasibility study was launched. In 2020, the tricuspid early feasibility study was launched. So today, more than 300 patients has been treated with the Intrepid system, both as a transapical and a transfemoral approach to the mitral or tricuspid valve. For the ongoing Apollo trial, there is now more than 65 sites activated, more than 1,000 patients has been screened, and more than 200 patients has been enrolled in this study. So there's a large and even growing global clinical experience with the system. Of course, as for all these procedures, patient selection is very critical, and there's a very rigorous screening and case review before accepting any patients. And also, both the pre- and post-procedure management is carefully planned. Again, remember, these patients are mainly coming forward due to secondary mitral regurgitation. So these are heart failure patients more than heart valve disease. So it's very important to have heart failure specialists in to optimize the patient before the procedure, and also to take care of the patients immediately after the procedure. The design of the Apollo trial has recently been updated. So it's now including patients who are not suitable for any approved transcatheter mitral valve system or any surgical mitral valve treatment. So it's patient who's normally not offered any treatment. The study will allow up to 300 roll-in subjects, and then there will be two arms. The primary cohort, which will consist of between 250 and 500 patients with primary or secondary mitral regurgitation, and they will undergo a transcatheter mitral valve replacement with the Intrepid system. Primary endpoint will be all-cause mortality or heart failure hospitalization after 30 days, or no significant improvement in quality of life at 1 year. The second cohort will be the patient with mitral annulus calcification, and that will enroll up to 300 patients who's going to be treated with transcatheter mitral valve replacement using the Intrepid system. For this study, the primary endpoint is going to be all-cause mortality or heart failure hospitalization at 1 year. For patients in the MAC study, it's going to include patients with moderate or severe mitral regurgitation in the presence of mitral annulus calcification, or patient with moderate mitral regurgitation and mitral stenosis in the presence of mitral annulus calcification. This was a cohort of patients who initially was excluded from this therapy, but I think it's now proven that these patients, at least selected patients, will actually benefit from this treatment. For the early feasibility study on the transseptal mitral valve system, again, it's going to be the same valve implant as for the transapical approach, but now using the steerable delivery system, which currently is 35 French. And to bring it in, there's a number of dilators to increase the size of the access before introducing the sheath. There will also be a stability bench to place the delivery system, so it's easier to control any movements. The early feasibility study on the transfemoral mitral system will be conducted to evaluate the safety and performance of this system. It will include up to 30 patients with severe symptomatic mitral regurgitation who are not eligible for surgical approach. It will be conducted in the US, including up to 11 sites, and also the data is going to be used to improve future technology on this system. The delivery system with multiple directional steering is also used for implanting the Intrepid valve by a transfemoral approach in the tricuspid position. It's the same valve implant, but this time using less oversizing in order to reduce the risk of conductions abnormality. The early feasibility study on the Intrepid tricuspid transfemoral system is done to examine the safety and the performance on the Intrepid valve in the tricuspid position. It's going to include up to 15 patients with severe symptomatic tricuspid regurgitation at 11 sites in the US. Also, again, the data is going to be used for further technical improvement of the system. So I hope this was a useful overview on the Medtronic Intrepid program used both in the mitral and the tricuspid position. Thanks a lot.
Okay, very instructive presentation. Are there any comments from our audience? Has anyone some question before to introduce next speaker? Okay, if there is no comment, next speaker does not need any special presentation. Francesco Maisano is the head of cardiac surgery and the valve center of the San Raffaele Hospital in Milano, Italy. He has a large experience on structural interventions with both surgical and catheter-based therapy, and he will share with us his experience on the repair and replacement of the mitral and tricuspid valves with a portfolio of CardioValve. Professor Maisano, please.
So first of all, thank you for the invitation to all of you, particularly to Patakos, to Kostas, Sparges, and so on. I really miss in-presence meeting with you guys because I miss the Greek food. But besides that, let me share with you some of the information with a startup device, which I disclose I'm consulting with. Is a startup in Israel, not an easy country for many reasons. And one of the problems, for instance, has been in the last year, the lockdown after the COVID has been slowing down the clinical trials related to this device. So we still remain in front of a device which is in a very early stage of expertise. It's a device which has been designed from day one to be a transfemoral device and to be as simple as possible delivery. And actually, it is a device which allows an implant similar to lifted devices with lifted grasping, very similar to TEER, followed by the release of an atrial flange and the full release. So in 3 steps, this device can be delivered. It is a device which is recently also possible to implant on a tricuspid position. Actually is the same device, but there has been an improvement in the delivery system. Specifically, I will tell you what is exactly happening there. And there are, as all we know, there are some challenges of adapting mitral devices in the tricuspid position, but this has been overcome. It is a device which has been designed to cover a full range of sizes. Probably is the one that has the largest range at the moment. And this is ranging from annual diameter below around 40 to beyond 55. One of the main advantage, in my opinion, of this device is the height, is the size of this of the let's say not the size, the height, the impingement in the left in the LVOT is very limited. Also, the shape has been designed to really reduce to the minimum the risk of LVOT obstruction, as you can see here in this particular image after a CardioValve implantation. It is a very short device, and being short makes it also easy to be delivered. You see the navigation of this device through the septum and through the mitral valve is relatively easy. It is a device which has been designed to be robust and durable. Again, we are in front of a valve with double stent. One stent is mainly taking care of the fixation. One stent is mainly taking care of the valve leaflets. And the 2 stents are working together to sandwich the leaflets, as you can see on the right side of this slide. The leaflet is going to be sandwiched between the 2 rows of stents, and there will be also a ceiling cuff in the middle. The ceiling cuff, you can see it here, is designed to be inflated from the side ports of the valve, which means basically that in case there is any area where there is no contact between the stent leaflets, the stent and the mitral leaflets, this actually will generate a flow into the inflatable cuff, which will inflate the cuff and seal this area of non-coaptation. So basically, it's been designed to really minimize perivalvular leaks. And using this approach, this valve does not need to be oversized. And this is a big advantage in terms of AV block, specifically for the tricuspid valve. So it's another feature of this valve, which has been designed not to be oversized, and that's why it also has a wide range of possibilities. Now, these are the technical details, and regarding the clinical experience, as I was mentioning before, this company is almost 1.5 years, which is very slow in recruitment because of different reasons, but the main one has been really the lockdown in Israel, which did not allow a startup company to operate worldwide. Anyhow, there have been a number of compassionate cases and very few cases which have been enrolled in this HIAD trial, which is a early feasibility trial running in the US and in Europe. In terms of the procedure, I think I will show a short video showing in parallel different cases, just to show how reproducible is the procedure. Basically, there is a steerable device which allows you to enter into the left atrium. The valve is opened in the left atrium. The ventricular arms are opened in the left atrium. And at this time, the system is aligned depending on the anatomy of the patient. You want to be in the middle. You have this nice echo guidance. Once the device is aligned, you can cross the valve leaflets and basically grasp the leaflets. This is a procedure which really resembles a typical edge-to-edge transcatheter repair. Basically is a structure which is going to engage the leaflets, anterior posterior leaflets almost completely, and once the engagement is confirmed by echo, then the atrial cuff can be released, and the final maneuver will be to completely open the stent. You can see here, this is the final release of the valve, and through all this procedure there is never any issue of low flow, and this is the final steps of the procedure, and you can see here consistently no PV leaks, no significant LVOT obstruction in these patients. The number of cases which have been done is here, so you see is not a big number of cases. Most of the cases I've been doing them or proctoring them, and there has been a decent reproducibility, besides 2 cases where I was not there and there was a bit of difficulty because of the unpreparedness of the supporting team. Again, we're talking about not a Medtronic, Edwards, Abbott, we're talking about a startup. Procedures have been successful in most occasions with no MR, no PV leak, no AV block. You can see here in most occasions have been procedure attempted and cardiovalve implanted with a procedural time which has been relatively long, but you can imagine these are again first in men's almost, and the procedural time which is you can see here average 40 minutes, but in principle most of the time has been spent to acquire imaging and to understand in these first cases what to do. I can imagine in the future this procedure to become very fast. There are few patients who survived in this series. I hope so. There are few patients surviving in this series with durability of the valve. So, all the patients who survived the procedure are alive and well at 3 years, almost 3 years follow-up, and there is no sign of valve deterioration. Let's see here as well. Now, unfortunately, the results in this series has not been, in terms of mortality, we have seen a high mortality in most occasions, not related to the device itself, but mostly because of the device selection. Anyhow, now there is a new project which has been just started, which is on the tricuspid side. The main changes in the tricuspid device have been related to the length of the delivery system and specifically of the nose cone, which has been shortened because the right ventricle is a bit shorter than the left ventricle. And on the other hand, the rest of the delivery system is similar. There will be a next generation which will take account of the different angulation of the inferior vena cava to the annulus. For this reason, at the moment, this is a short video. It's a short video that shows more or less exactly the same functionality we've seen on the left. It's on the right side. And the only challenge, again, is that the right ventricle is much smaller, much shorter. So for some reason, you may have problems. But this is a first in man which has been selected to have a good angulation between the inferior vena cava and the annular side. You can see here the first steps of the procedure. We decided in this particular case to advance the device over the wire, although maybe in future will not be necessary. The wire was parked in the pulmonary artery. Once the device has been positioned in the right ventricle, the procedure has been done as usual. Obviously, there were a number of uncertainties related to the quality of the imaging, which was not so bad. We used, as you see here, a coronary wire to have an idea about the location of the annulus. The legs have been opened, and once the position, the coaxial position has been confirmed, the leaflets have been crossed, have been grasped, and finally the device has been deployed. You can see here. Very important learning. Obviously, when you look at this on RAO, you think you are not in the middle. You can see here, but don't forget that obviously there is a distance between the ostium of the right coronary artery and the annulus. Anyhow, this is the final release with the valve working very well. No PV leak, no heavy block. It was just, well, it was only just a tiny PV leak, sorry, at the level of the septal commissure, anteroseptal commissure. But other than that, you can see this is a little leak. Other than that, uneventful. Unfortunately, this patient, again, did not survive the status. This was a case done in an emergency state. She was already in heart failure, advanced heart failure with requiring a lot of support, and she had already renal and acute hepatic failure. She did not survive because of this, but the valve worked perfectly. So basically, again, it's a device which is demonstrating a good functionality. It is based on a very strong surgical-like design, very low profile. There has been a strong effort to produce a robust frame for durability and for fixation. It has been designed to be used both in the left and the right side with little changes in the delivery system functionalities. It is a device which has a low profile and basically has very little risk of LVOT obstruction when it goes to the mitral position, and obviously this is not a problem for the tricuspid. In general, it is a device that requires more experience and will be tested in many centers, including in the group in IGEA Hospital in the future. With this, I will thank you for your attention.
Thank you very much, Professor Maezano, for this excellent and new, of course, data you present to us. I see the hour. We have a couple of minutes for some remarks or questions from the audience or from other participants.
I would have a question, if possible.
Please, Michael, do it.
I was wondering, how far do we think we are with any of these devices till we get a CE mark? Because all of these look very promising in the tricuspid space, and be very important to get a CE mark to be able to move forward at some point.
Yeah, I mean, it's a good question. I think there will be CE mark trials soon. There are a number of CE mark trials actually going on for more established devices. On the other hand, overall, there are not so many cases. But I agree with you that we need a tricuspid replacement system for some patients because leaflet repair is not always feasible. On the other hand, at this moment, in specific institutions, specific areas of the world, is not bad to be before CE mark. For instance, I moved from a very rich country like Switzerland, where there was a reimbursement for tricuspid interventions. In Milan, there is no reimbursement, so we are very happy to participate to trials because in this case, we can reimburse these procedures. But anyhow, the future is in that direction. There will be, for sure, CE mark because tricuspid implants are very low risk and they're using the same device as in the mitral with very little modifications of the delivery system.
Professor Maezano, how soon do you think that systems as the TriClip could be included in the European or American guidelines for, let's say, the 2B indication?
Well, you know, guidelines are very complicated. I wish I should not answer to this question in an honest way. So I will try to be as much politically correct as I can. There is enough data today to support indication for these devices in most patients. This is the reality. There are many other treatments, including, I would say, diuretics, which have nothing compared to what has been already collected for edge-to-edge repair with different platforms. So in principle, there should be a higher indication grade. Obviously, 2B is what you can achieve with the data that we have at the moment, specifically because of the COAPT versus MITRA-FR. If MITRA-FR was not done, probably we would have probably even a class 1 indication in selected patients. I think we should go on with the 2A indications in the next future, hopefully, specifically for functional MR. And there are trials which are going to test also edge-to-edge in degenerative patients, high risk or intermediate risk, and hopefully we will get a higher class indication also in the degenerative side. In terms of the replacement, I really believe that those patients who qualify for replacement in the next future will have a high advantage of being treated percutaneously. So in general, there are many reasons why we still do not have guidelines for these procedures, but we will see what happens in the next future. We need to put all together heart failure specialists, the surgeons, interventional cardiologists, imagers, arrhythmologists. Everybody wants to say something about these devices, and that's why there is a little bit of confusion and delay in a total appraisal.
Before I ask to Dr. Marcos to end this session, I would like just to say that what I have learned from this session.
Well, we have a lot to discuss, but we don't have much time. I think the time is over. I have a good feeling about this valve, Dr. Maizano. I do have a good feeling. I don't know, looks simple, and you stabilize the valve totally on the leaflets, don't you? You sandwich the leaflets. That's what you do.
Yes. It is mainly a sandwiching on the leaflets. There is no much interaction with the annular portion of the valve.
And your answer with a yes or no, I think you did exactly drop the knife to get the wire as they were used to ask us to do a few years back. I think you're holding the knife too. You haven't regret you have done the switch, getting the wire, have you?
No. First of all, I didn't drop the knife. I use the knife regularly.
I know you haven't.
Against my enemies, particularly.
Yeah, right.
No. I believe in a combination of surgery and interventional procedures. But obviously, interventional procedures have a huge advantage compared to surgery, which is the safety profile, particularly in the short term. Obviously, you need to negotiate with uncertainty about the long term. But, I always say, everybody, before you get to long term, you need to survive the short term. So I love procedures where I don't feel bad because I have been thinking about long term.
George, what I wanted to say, you said that in just one phrase that you have a good feeling about this valve.
Yes,
this is the thing I wanted to say, that I have a good feeling about this valve, Francesco. I don't know if Fabienne and Stefan wanted to make a comment before we close.
You're on mute, Stefan. You're on mute. Thanks to everybody for being here with us. I've been hiding in the background, so thank you for everybody here being with us.
Yeah, thank you very much. I think the point on the guidelines is a very important one that Francesco raised. And you've seen the position paper with 4 working groups, and Francesco knows from inside out of the time span that this took. And I think it's very important that we need, let's say, interim updates of the guidelines. I'm very sure that the next guidelines, at least in Europe, will differ slightly from the US guidelines and will ignore certain publication and certain data evidence that we've seen here and discussed here. So I think also these concepts have to be renovated and refurbished. And that's a very important part for the Union and the ESC. That's my personal belief, without classifying any of the decisions and the results that we will see in August and September in any regard.
Costa, I think we can conclude, and thank you very much, all of you. It was an excellent session. Thank you very much.
Bye-bye.
Thank you, everybody.
Bye-bye.
So without any further delay, we will proceed with the next session that involves cutting-edge transcatheter and surgical approaches. The first speaker is a pre-recorded talk from Professor Tamburino from University of Catania, who will be addressing the subject of transcatheter treatment strategy in patients with aortic stenosis and mitral regurgitation.
So, dear colleagues, it's a real pleasure being with you, even though at distance, only via web. But I think and I hope the next year we'll be presenting directly in person in Greece. So thank you to the organizer for inviting me. Today we will be talking about the transcatheter treatment strategies in patients with aortic stenosis and mitral regurgitation. So we know that the rate of concomitant significant mitral regurgitation in patients with aortic stenosis ranges between 2 and 33%, and in comparison to a single valve procedure, double valve surgery, replacement or repair, is associated with an increased morbidity and mortality. This is something that all of us, we know. Transcatheter techniques have evolved and offer less invasive treatment alternatives to double valve surgery in patients deemed at high or prohibitive surgical risk. What we know is that the presence of mitral regurgitation in patients undergoing TAV is a predictor of higher mortality. So it's very important to check and follow the mitral regurgitation in order to establish if there is the need of a treatment. I said that we need to check and follow the mitral regurgitation because we know that after TAV or TAVI, the rate of severe mitral regurgitation and moderate mitral regurgitation reduces over the time across the first 6 months with an increase of the lighter mitral regurgitation degrees. So it's very important following the patient and deciding what to do at the follow-up. We also know that there are some predictors of improvement in the mitral regurgitation. It's easy to understand. The left ventricular condition in terms of diameter, of thickness, of ejection fraction, the presence of atrial fibrillation or absence of atrial fibrillation, pulmonary hypertension, principally, and mainly the etiology of the mitral regurgitation. If it is a primary mitral regurgitation, the possibility of a reduction is unlike as compared with the functional mitral regurgitation. So, said that, I would say that there are 3 possible strategies. One is medical therapy for heart failure in patients that undergo TAV, have a poor ventricle that remains poor, they have a mitral regurgitation. They could be treated with clip, but they could also, if asymptomatic, if old patient with a short expectancy, natural expectancy of life, could undergo a medical therapy. The second choice is the combined TAVI and transcatheter mitral valve intervention. At the same time, in the same procedure, is very costly because you pay double and receive only one reimbursement. And the combined approach is predominantly interesting the primary MR patients because we know that the disease of the valve is difficult that they go back and returns to normal. But the third strategy is the stage transcatheter therapy that is possible and should be reserved mainly to patients affected with functional mitral regurgitation. And it is important when there is a reserve of a left ventricle, there is something to give to the patient, and in terms of functionality and volumes and symptoms, and it could be possible to treat the patient. We have only a registry. It's a retrospective international registry, LAMTRAC. The AMTRAC is collected 106 patients, so there are not so many patients with such double therapy. And among these 106 patients, 6 underwent a simultaneous clip, TAV and clip, and the remaining 100 underwent TAVI and deferred mitral clip. And what was demonstrated is that the procedure is safe, feasible, and that there is a clear improvement in MR grade and in near functional class. So, summing up, we can say that most studies report a significant improvement of mitral regurgitation after aortic valve replacement. And this was mostly attributed to the reverse left ventricular remodeling and the improved LV function. And so impact mainly in patients with secondary MR. A staged approach should be chosen in functional MR, treating the aortic valve first and MR if the patient remains symptomatic. This is an important point to be attention. And in primitive MR, where the the valve structure is not expected to improve, the combination approach should be preferred. There is a lack of studies, so we do everything on a personal basis, on a personal feeling, on a personal choice. Now, it's my pleasure to show you a case of a rescue mitral clip that was performed 15 days after TAVI in a patient where there was a problem. It's a classical case presentation with a clinical history, clinical presentation similar to many other patients affected of aortic stenosis. We have a severe concentric LV hypertrophy, severe gradient, small LV dimension, 24 millimeters, severe mitral annular calcification with some degeneration of mitral valve leaflets, no LV outflow obstruction. The patient was at intermediate risk and we went for TAVI. This is the TAVI as usual in local anesthesia, transfemoral approach, 29 evolute are mitral valve with no aortic regurgitation. And day 1 after the TAVI, the patient developed pulmonary edema. And we observed some of the anterior leaflet of the mitral valve with a severe LVOT obstruction and a severe MR, new onset MR due to the SAM. So this is something of unexpected that may occur. So we treated the patient medically, but we were unsuccessful. The patient was still dyspnoic, no heart compensation. We tried to wait to see if there was any accommodation, but nothing to do. We chose the percutaneous mitral valve repair through the mitral clip implantation. Septal ablation is another option, but I would say that it's not something that should be done when there is the clip that is more definitive. So the mitral clip was implanted in a 2P2 position with an immediate disappearance of mitral regurgitation, SAM, and LVOT obstruction with good hemodynamic compensation, clinical stability. So the patient was discharged at day 1 after the clip was implanted with low post-procedural gradient in aorta and in mitral space. This is the 6 months follow-up showing that the patient has a good echo images with still low gradient, and the patient remained asymptomatic throughout the entire follow-up. So, in conclusion, the take-home message, the new onset systolic anterior motion of the anterior mitral valve leaflet in patients after TAVI is an unusual, occurs seldom. is a rare pathophysiologic mechanism needing a post-procedural development of mitral regurgitation and eventually LV outflow obstruction. In this case, bailout mitral clip implantation is an effective strategy for the management of this complication. Septal ablation is also an alternative, but probably is associated with less predictable outcome, and I would say that it is not well suitable to treat acute complication in patients with such complication. Thank you for your attention. Thanks again for the invitation. Hoping to see you again.
Microphone, Dr. Tsourlakis. Το μικρόφωνο. Dr. Tsourlakis' microphone is off. So if we can turn this on. Okay, now it's okay. Now much better.
Λοιπόν, Dr. Tamburino was perfect. In this case, we saw before. We just decided to continue with the next speaker, which is Dr. Spitsis, and after all the moderators decided that the dialogue could be at the last moment of this session. Let's proceed with Dr. Spitsis, known as consultant cardiac surgeon.
Thank you. Thank you, Apostole.
Γεια σου, Αντώνη.
So I hope that you can see my slide.
Yeah, perfect.
Okay,
we see them well.
Yes. So I would like to thank the organizing committee, my very good friends, Kostas and Greg, for the kind invitation. I'm really honored by it. So my topic today is hybrid approaches in transcatheter heart valves. And this is the list of my disclosures. And there is no doubt that in recent times, interventional cardiology has made a very rapid and extreme progress, but to a certain extent, the same applies to cardiac surgery as well. So in cardiac surgery, as you know, we have moved from full sternotomy to mini sternotomies, minimal invasive cardiac surgery, to mini thoracotomies with direct vision, and also to total endoscopic and robotic procedures. And I think sooner or later, in the years to come, these large incisions of median sternotomy will be very, very few and far in between. And we're going to move to more or less scarless cardiac surgery, like the incisions that the two young people on the right side of the screen had. These were both mitral cases. As far as mitral tricuspid and congenital heart defects, as well as tumors, are concerned, we use nowadays periareolar incisions that they are really tiny in both men and women. And when we want to operate on aortic and hypertrophic cardiomyopathy and also aortic root, we use this essentially single-digit one-finger incision, which is higher up. It's not a periareolar, obviously. It is in the second intercostal space on the right. And the reason that we do that is not cosmesis, not only cosmesis, because certainly the cosmetic result is outstanding, but the main reason that we do that is better viewing angle that allows the surgeon to perform a more precise and better repair. I know that this is not proven, but myself, I'm convinced, and I'm trying always to convince all the surgeons that they come and visit us in our department in order to get used to these approaches. Also, shorter hospital stays, less pain, no infection, better outcomes. This means that we have to operate on the screen and we have to increase our screen time. Like in this procedure, that this is a hybrid electrophysiology procedure for arrhythmias coming from the LV. That was a combined procedure with the interventional electrophysiologists. Ourselves, we did epicardial procedure, and the interventional electrophysiologist did the endocardial approach. So back to our topic, hybrid approaches in transcatheter heart valve scenarios, different scenarios. There is no question that there are several scenarios that we can combine forces in the heart team, and certainly we can do approaches within the heart team. So TAVI may very well be combined with PCI, of course, and with OCAB, for example, in a patient that we open the chest, has got an aortic valve stenosis and also triple vessel disease, severe triple vessel disease, porcelain aorta. This patient probably we're going to do the OCAB, no touch aortic technique with mammaries, and then second stage procedure at TAVI in the cath lab, or if we know that in advance, maybe we can do it in a hybrid room. TAVI combined with mid-cab, again, for proximal LAD disease, for example, and symptomatic aortic stenosis, combined with mitral clip, of course, combined with TMVR, and certainly TAVI combined with an endoscopic, total endoscopic approach, like a total endoscopic mitral valve repair or replacement. And I will give a couple of examples of hybrid approaches with transcatheter heart valves. This is a 79-year-old patient with severe aortic stenosis and moderate mitral stenosis in class 3 with a Euroscore 2 of 3.4 and pulmonary hypertension. This patient was treated by Dr. Sparias and his team, Hygieia team, with a core valve. And the result was outstanding. No paravalvular leaks, no pacemaker implantation, very low peak gradient, very low mean gradient, an excellent valve. But in the meantime, postoperative, the patient developed gradually more and more symptoms of due to his mitral stenosis. Also, the patient had some COAD, and the patient was decided to have, as a second stage approach, as next procedure, a total endoscopic approach of mitral valve replacement. And this is the CT scan. As you can see, there is quite a lot of calcification in the aortic arch and descending, but not as much in the distal ascending aorta that we're going to clamp. Also, the reason that I stopped the video here is that you see that there is something in the interatrial septum. It looks like a mass in the interatrial septum. Kostas, I haven't told you about that. I'm going to tell you now. This mass has the characteristics of fat tissue, but you can see the interatrial septum is something that it is problematic. So this was the transesophageal echocardiography. You can appreciate severe mitral stenosis, no paravalvular or intravalvular leaks of the core valve. The core valve seems to work fine. There is a bit of MR, not a lot. A clear left atrial appendage without thrombus. And you can see a calculated mitral valve area 1.2, but as we said, the patient was severely symptomatic. And a core valve that works nice. This is the 3D of the mitral stenosis, of course. There is some mitral annular calcification, not a lot, grade 1 probably in the areas of P3 and P2. And this is the core valve that we have said that works excellent function. So we decided to do a total endoscopic approach. And as we have already said that there was a mass in the interatrial septum starting from the SVC all the way up to IVC. We had some trouble catheterizing the SVC from the femoral vein. Here is the extent of the fat tissue in the interatrial septum. And we had to do a lot of tries in order to get the cannula inside the SVC, but finally we managed by twisting, rotating, and pushing. And so cardiopulmonary bypass wasn't a problem. This is the cross clamp. This is the Chitwood clamp that goes around the ascending aorta, distal ascending aorta, because we shouldn't forget that up to this area, we have the core valve. The core valve comes up to here. So comes up to the fat body of the aorta. We give the Pelagia obviously in the ascending route to stop the heart. And here we're going to open the atrium, and you can see all this is a mass that made our job in exposing the mitral valve a bit more complicated, because we had to lift all the tissue of this tumor. You can see here this tumor. This is fast forward, but the mitral valve was very heavily calcified, a bit of mitral annular calcification, not a lot. We had to use the Ronzers, as you can see. We have excised the anterior leaflet. Here we take a bit of the posterior because it is very heavily calcified, and we have to be able to put a reasonable size prosthesis. Again, fast forward to put the annular sutures, and we have chosen to put a mechanical valve, so we were afraid of interfering with the core valve. This is a low-profile mechanical prosthesis if you compare it with the biological ones. Anyway, the patient was on anticoagulants. And you can see the prosthesis works nicely, no problem at all. And we calculated the valve area 3.8, very nice, low gradients. 1 month after the operation, the patient was implanted with permanent pacemaker because he developed some intermittent problems with heart block. But 2 months after the operation, he does really great. He has an excellent outcome. And the histology of this tumor came back as benign tumor from fat, so it was a lipoma. Obviously, there are other scenarios of hybrid approaches in total endoscopic cardiac surgery. Total endoscopic cardiac procedures combined with either PCI, and it can be either structural, adult congenital heart defects, or aortic valve problems, or mitral valve repair, as we have already said. And this is something that we do this type of combinations very, very often in our practice. Last week, we did 3 cases in combination with within the heart team, 3 cases of hybrid approaches of endoscopic cardiac surgery plus interventional cardiology. So you shouldn't think that this is something rare. This is something very, very common. If you feel that it is not right to crack the chest open, then you're going to find ways of keeping the chest closed. Obviously, this shouldn't be our main aim. The main aim is to achieve the best result with the lowest possible risk. And if you can achieve that by a combination therapy, then we are obliged to do that. So second case is this case of a 77-year-old man who had a flail P2, as you can see, anterior jet of eccentric jet of MR, and also some proximal LAD disease. So again, we decided within the heart team to do total endoscopic mitral valve repair plus PCI for the LAD disease, for the single vessel disease. And as you can see, the P2 is quite elongated in all the dimensions, anterolateral and also intracommissural, and has ruptured cords coming from both the anterolateral and posteromedial papillary muscles, as you can see, significant jet, very good function. This is the endoscopic image, and here you can see the redundant tissue in the P2. We have elected, as we normally do, to respect and not to resect. So we have decided to use lots of synthetic cords. This is my preference, and this is something that we do in everyday practice. We try not to resect tissue. So here we put these marks in order to mark the areas that we are going to implant the synthetic cords. And next, obviously, we're going to calculate the optimal length of the cords. And there are several ways of doing that, and we have developed our own ways, but this is beyond the purposes of this meeting. And here you can see that we have anchored these loops, Gore-Tex loops in the anterolateral and in the posterior medial papillary muscle. We remove this metal net that we use to expose the ventricle. And again, we expose now the leaflets in order to anchor the other side of the chordal loops to the free edge of the P2. And we use 3 cords from the anterolateral to P2 and another 3 from the posterior medial to P2. And here is the sizing of the annulus, true size annulus 35. We have elected to use a semi-flexible, incomplete band simulus, link Medtronic. And here is the TOE, the postoperative TOE, absence of MR. Again, very good result. No SAM, as you can see, no stenosis, coaptation length of 12 millimeters, excellent result, very low gradients, max gradient of 3.9, mean 2. And this is the angioplasty, the PCI that took place 4 days post-op, and on the 5th day, the patient went home by Dr. Ninos and his team, my cardiologist colleague. So, in conclusion, I would like to conclude, Mr. President, about the hybrid approaches in heart disease. I think that hybrid approaches of interventional cardiology and also minimally invasive cardiac surgery might be safe and feasible methods of treatment in high-risk patients presenting with multiple pathologies who are not eligible or who are at very high risk for conventional surgical or interventional solutions. Thank you very much.
Thank you. Dr. Pitsis, you are clearly the cutting edge of Greece. And so that's why it's our honor to have you with us today as we put our best face forward to our international colleagues who are here with us. So thank you very much for presenting. In the sake of fairness to all speakers and in the sake of the fact that we want to leave time at the end for discussion for everybody, I'm going to move on now to our next speaker. And at the end, we're going to have a lot of questions for you, Dr. Pitsis. Thank you very much. The next speaker is our good friend and esteemed colleague and the world famous and illustrious Dr. Peyman Sardari Nia, who is going to be speaking to us today from Maastricht, where he is the director of mitral surgery and the head of training for the EACTS mitral training program. A renowned innovator. He's been awarded for his mitral valve simulator. Today, he will be discussing thoracoscopic repair and beyond. Thank you very much, Dr. Sardari. You have the microphone. Let's just get your slides to be full screen. Thank you.
Yeah, do you see my slides?
Perfect,
Greg?
full screen. Yes.
Good afternoon, all. Thank you for the kind introduction. You are too kind, like always. And thank you for the very kind invitation indeed. I'm going to talk about mitral valve surgery, and the focus will be beyond, because I think you already know what are the results of mitral valve surgery. But I just want to touch on some controversial issues. So these are my disclosures. I think we have to distinguish between opinions, assumptions, and evidence. Now, just let's zoom in on evidence, because as you know, around 10 to 20% of what we provide patients are based on RCTs, the highest level of evidence. But if you zoom in on the RCTs, you see that minority of patients are in the real world would be eligible for the original RCT eligibility. And I mean, that is also not so surprising if you see 2 randomized controlled trial on MitraClip providing different kind of results. And this is also very interesting study published in JAMA just last year, and they reviewed all the RCTs in cardiovascular intervention of the last 10 years, and what they saw, obviously you have a lot of them being sponsored by industry, composite endpoint, short follow-up. But what was very interesting, the fragility index. And fragility index is the number of patients you need to switch the significance of the finding of the randomized control trial and how many patients were needed to switch that, only 5. So RCT is a great invention to box in the effect of intervention, but it's also a great tool to design a trial in favor of intervention. So the problem of mitral valve surgery and valvular heart disease is much complexer than that. So what are the issues that we should know? And those issues that we should know are related to the patient-centered care. And the question that you have to ask yourself, what do our patients want and need? Obviously, they want to have a timely referral for intervention. They want to survive a procedure. They want to get intended treatment. They want to have it as less invasive possible, be better off after that, predictability and durability. Now, about 50% of the patients with severe symptomatic mitral regurgitation are not referred for any surgery. And it's based on the EuroHeart survey, 92 centers in 25 countries, and you would say that mostly are patients with functional mitral regurgitation. But if you had degenerative disease, you had more chance to be not referred. And you would say this study is published in 2007, and in 2021, we are doing much better job. Look, this is a study published in just last year, 100,000 patients hospitalized for mitral valve regurgitation in France. Only 8% were referred for an intervention. And if you look of 92% of patients with severe mitral regurgitation not referred for intervention, the majority was a degenerative disease. And why is that important? Because around 70% mortality or all-cause readmission at 1 year. So this is a very important issue. So refer your patients as early as possible. The second issue about the mortality and complication. Patients want to survive a procedure, but this really depends where you land. These are based on 2 publications, landmark publication in New England Journal of Medicine. One is over 14 different cardiovascular and oncological procedures in 2.5 million patients. They found a direct association between volume of the hospital and surgical mortality, and a subsequent study established that it is the surgical volume that is responsible for the operative mortality. What about the mitral valve repair? If you look at the US, you see that this is a publication based on STS database in 2010. There's not many things has changed ever since. This is the full repair rate of all pathologies. For the degenerative is around 65. In Europe, it's the same. This is a publication in France. And if you zoom in for the degenerative disease is 70%, and in Netherlands is hovers around 65%. And you have to understand, for degenerative disease in an expert center, you need to get a repair rate more than 95% to 99%. What about minimal invasive? Because patients want to be treated in a minimal invasive fashion. That is an exception and a routine that is based also in a publication of STS database in 2018. You get that only 23% of the patients get a less invasive procedure. And by less invasive procedure, I mean it goes from mini thoracotomy to robotic assistance. With regard to the symptom relief and quality of life, we're not so very good at that. There's only incidental reporting and predictability. This is only rested in the physician hand during the operation. So we can predict a population outcome, but individual predictability is not present. And the most importantly, that is the durability. This is a publication based in JACC, all the operations done in New York State, and you see that if you do more than 25 operations per year, you have a marked reduced incidence of mitral reoperation in the first year. So with regard to the mitral repair schools, there are 120 different techniques to repair a mitral valve, but there are two schools. But what is important to know that the freedom from reoperation is more than 90% at 15 years for a posterior prolapse, less for the anterior and leaflet prolapse. So the results are very excellent. And as previous speaker has indicated, conventionally we approach the mitral through median sternotomy, but I think there are many techniques in minimal invasive approach, and the most advanced one is a totally endoscopic approach with the 3D camera. But to overcome the learning curve of such an operation, you need over 100 cases to overcome your learning curve, and you need to do a couple of these cases per week in the beginning at least to retain your result. What are the evidence and results of endoscopic or minimal invasive approach? These are all the meta-analyses published to date on the comparative studies with regard to the safety, mortality, efficacy. There is no difference with the sternotomy, which is a good thing. There are differences, obviously, in recovery of the patient, bleeding, the ICU stay, and so on, which is, in some studies, you see a marked difference, at the other need. And you have many single institute, single setting studies showing excellent results. And I think one of these studies that we published was based on meta-analysis for reoperative mitral valve surgery, where we saw a marked difference with reduced mortality, length of hospital stay, reoperation for bleeding, and similar incidence of stroke. So patients with reoperative mitral valve surgery will benefit the most from this kind of approaches. As you know, there are more than 70 different devices being developed as a transcatheter, and one would think, which one is going to be leading development? I think you have to consider that none of them will provide any solution, the full mitral valve pathology. You cannot beat surgery, but what you have to consider these new technologies as a tool in a toolbox to treat your patients with. And you look at the mitral clip. After 17 years, it is still best in P2 prolapse, and the results are between 40 to 65%, reducing the mitral regurgitation to grade 1. So based on this, this is how we have organized our program in Maastricht, namely based on a concept of personalized medicine, focus on the whole process of care, work with dedicated heart team, and use preoperative planning. So you have more tools to treat patients. So you need some tools to select your patients to see which patient will benefit from which treatment. And what are the results? This is, as you know, heart team is the class 1 in the recommendation in both US and European guidelines, but there is no data on it. It is a level evidence C, and this is a first study showing that if you come together as an imaging cardiologist with expertise on mitral, intervention cardiologist, expertise on mitral, and mitral valve surgeon, you can provide a better care for your patient with a marked superior survival. So patients following a treatment by the dedicated heart team had 61% lower adjusted relative risk of mortality, adjusted for 14 different predictors and prognosticators. So this is, for example, a patient with a P2 prolapse, relatively young patient with a poor left and right ventricle function. So this patient, for example, in our heart team, we thought this patient would be benefit for with a off-pump procedure, and we treated this patient, for example, with a transapical neocord implantation, as you see here. So with the excellent result, after 3 months, this patient came back with improved left and the right ventricle function. This is a patient 40 years old with the Barlow disease. Obviously, this is a kind of pathology that you would say this patient will benefit best from a surgical approach. So in the heart team, we answer the question, is the patient suitable for a procedure, and would the patient benefit from it? Here, at this age, this is all about durability of a procedure, which is done endoscopically. This is another patient. It is actually a functional mitral regurgitation, a patient with impaired left ventricle, pulmonary hypertension, pre-dialysis, malignant melanoma, inferior infarction. And this is a patient that we, for example, thought would be more suitable for a transapical tendine procedure. This is the valve, tendine valve. And that is the results of the valve placement. So only in a dedicated heart team, when you work together, you are able to provide a customized individual care to your patients. And you have to remember, these patients, a different process of mitral valve disease, all were discharged at the 3rd or 4th operative day. And that is only possible if you work together. The other issue, and that is one of the last part of my presentation, is if you have more tools to treat your patients, you need to use new technology like 3D reconstruction, 3D printing, simulation, to select your patients, to plan your procedures, and to perform your procedure. This is actually a platform that we are using for more than 7 years now, and we upload any imaging modality, and we get the hologram of the patient's anatomy, and we can plan our operations. Obviously, there is a lot of advancement on the field of imaging, but even you can go further. You use a computer model of the mitral valve. You can use this computer model and 3D print the mitral valve that we have processed and developed in Maastricht with the simulation that we have developed. And we can put the valve of any patient in a simulation. We can repair it and go to the OR. So you have to appreciate the concept here, and not the fact that you have to need to do this in every patient, but in the future we will have computer simulation in which we can choose which repair technique and which device we are going to use. So in conclusion, I think any mitral valve intervention should be considered as a tool in a toolbox, and the future is a smart surgery in which we work in dedicated heart team. We use technology to tailor the treatment that we choose for our patient, and use simulation for predictability. And this is now simulation physical, but in the future will be simulation in virtual. So based on this promise, there is a good cooperation between Maastricht and Athens for a couple of years now, where we have actually implementing the formula of success that I indicated before as a dedicated mitral heart team in Hygeia Hospital, where we actually could treat the patients with the same quality of care as we have in the program in Maastricht. And with that, I want to stop here. This is the Maastricht Mitral Masters, the webinar with live surgery that we have organized with my friend Craig. We have already organized 2 of them.
Greeting all, I'm very honored and pleased to welcome you back in Maastricht virtually. We have a very exciting program, renowned faculty, and we will do also a live case.
I was just going to say welcome, man. It's an honor to be here with you, Dr. Jim.
We have a very esteemed faculty this morning. And in Europe, we have Michael Borger. He'll be speaking from Leipzig, Thomas Modine from Bordeaux, Frank Van Praat from Aalst in Belgium. And we're going to talk about the heart team. We're going to give great talks today. And we'll also have a way we can do some questioning and answering. And Greg will handle all of that.
So you see, this is the lowest port of the diaphragm. So what I do is I put a stitch here. Here is the valve thin. So this is a normal valve tissue. So you have to, what you do during testing is confirming the pathology that you see on the echo.
Let's go to the video now and see that video that Dr. Sardari wanted to show us.
So now I would like to explain to you a suturing map that we have developed.
Thank you very much, Dr. Sardari. Unfortunately, due to time constraints, I think we have to go on.
Speak about this topic.
There's a very...
Thank you.
Perfect.
Thank you for bearing with me.
Thank you for the exceptional talk. I think now you have another 300 people who are going to be attending your next Maastricht Mitral Masters, and we all look forward to it. You gave an exceptional talk. As we said, questions and discussion will be at the end out of respect for all of our speakers to have equal time. So I'll let Dr. Mitropoulos introduce our next speaker.
It is with my great pleasure to introduce to the podium Aphrodite Jifa, who's the Chief of Pediatric Cardiology at Mitera in Hygeia Hospital, who will be informing us about the new developments in the percutaneous tricuspid valve repair or replacement. Aphrodite.
Hello, thank you, Kostas Spargias and the faculty for inviting me. I'm very pleased to talk to you about the news on the pulmonary valve. Obviously, pulmonary valve implantations is used for mainly congenital heart disease patients. The first one was implanted in 2000 by Philip Bonhoeffer, who is a pediatric cardiologist. And basically the thinking behind it was that there is a large population of congenital kids who needed reoperations for pulmonary valve implantation. Lots of them had comorbidity syndromes, and therefore they were of high surgical risk. The main group of patients that need a transcatheter pulmonary valve are tetralogy of Fallot patients, but there's also other patients who have an RV2PA conduit, such as truncus arteriosus patients, or patients who've had a Ross procedure for aortic valve disease or a transposition of great arteries. And indeed, in the US Melody Valve trial, it seems that most of the patients had pulmonary valve atresia, stenosis, Fallot, and the other groups. Obviously, there's lots of patients who have RV2PA conduits in our cohort. So the approved indications for TPVI are when there is a biological valve, plenty of them, where we do the valve-in-valve procedure, or RV2PA conduits, such as a Contegra, a Hancock valve, etc. There's a lot of patients who have pulmonary homograft in the pulmonary position, and this is also a very good indication as the homograft gets calcified, as we will see later. But TPVI is also used when there is no valve and no conduit, and it's used on native RVOTs as well, whether there is a transannular patch or not. And obviously that will take place when there is high-risk patients, and if we discuss with surgeons and the patient is really not for surgery, they are multi-operated, some of them have scoliosis or other skeletal anomalies, lung hypoplasia, syndromes, and other predisposing factors for them to have a complicated surgical course. The patients that we can implant pulmonary valves are kids and adults. Kids should be usually about 5 years of age and about 25 kilos. This has come down for the Melody valve to 25, for the Sapien to 35 kilos. And because of the data, the recent data that pulmonary valve implantation is better through the transcatheter route, it's now added in the ESC guidelines of 2020 for adults with congenital heart disease, that this is a revised clause where it does mention that if you do need to implant a pulmonary valve, if the anatomy is suitable, then it's best to do it transcatheter rather than surgical. So we need to work up the patient really well with cardiac MRI, sometimes a cath, exercise testing, and 24-hour tape, and all the other indications to assess whether a valve is needed or not. And the available valves that we have in our hands today are the Melody valve, that was the first to be implanted, the Edwards valve, and the Venus P valve. The Melody valve is a bovine jugular vein, which is shown onto a balloon expandable stent, a CP stent. There's more than 25,000 implants worldwide, and there's a lot of experience with this valve. The Edwards valve, there's less implantations, but it's a very, very good valve, and there's a less incidence of endocarditis. We'll talk about it a little bit further later. And the venous P valve is a Chinese valve on clinical trial in Asia, Europe, and the US. And basically, this is a valve for larger RVOTs. The RVOTs obviously are different in shape and size, and therefore the valves that we have in our hands are not all suitable for these very, very diverse RVOTs, and only 20% of our patients that need a redo pulmonary valve can be sorted out with a transcatheter valve. And therefore, Medtronic is now having the Harmony valve, which is a modified Melody valve on trial. There was the TPV 22, but now there's another valve, the 25 on trial, which is a shorter valve. And you see that the edges are quite splayed. So this is for larger RVOTs, and we hope that with this, we will be able to sort out more patients with transcatheter route. When there is a valve already in place, it's really very easy. You know, we look up on the valve, the internal diameter, external diameter, and depending on that, we choose the size and type of valve that we will implant. It's very important to make sure the coronary arteries are not in the way. Obviously, when there is a valve already, this is okay, unless we are to crack the valve and open up the diameter of the valve, and if the coronary arteries are closed, then we have to be careful too. The indications are the usual, with the RV volume more than 160 meters per meter square, or the RV-LV ratio of more than 2. This is a case where the coronary artery was really very close to the very calcified aortic homograft. The aortic homografts are actually calcifying much worse than the pulmonary homografts, and the right coronary artery was right behind the sternum because this patient had a Ross procedure, but we managed very carefully to implant a valve in this one. And this is another patient where actually his left coronary artery was extremely close to the calcium of the homograft, and this patient we didn't do, and the surgeon said that actually he was also afraid to take out this bit of the wall, and therefore he just took out the homograft and left this back wall in place. This is very crucial because, as we know from literature, it has happened in the past. This is a case from Germany where the valve was implanted and the patient arrested. There is no flow in the left coronary artery here, and therefore we always have to do a balloon testing when there is no biological valve in place to make sure that the coronary artery, is usually the left, is not occluded. This is a case where there's more problems than just the valve. You see that the right pulmonary artery at the hilum is very stenosed, and therefore this patient will have to have this problem sorted out during the same catheter procedure. This is an Atlas balloon, high pressure balloon going up to sort out this peripheral stenosis. It doesn't make sense to go in for the valve and leave other problems there. This calcified homograft was so calcified that we couldn't really pass not even this balloon through, and therefore we had to dilate it up first. You see that this is an internal jugular approach because the femoral veins were completely occluded. And then with the TPVIs, we usually implant a stent first. So this is the pre-standing for scaffolding. We dilate it up to make sure that we have a good passage through. You see here a little bit of contrast medium. Obviously, this patient had a lot of adhesions, but there is a small hematoma there which is contained. And then we implant the valve. This is another patient who already has a valve, which we crack with, you see here, with a high pressure balloon. This is an Atlas 24 in order to fit in a better diameter Edwards valve. And this is the transfer of the Melody valve with the carrot, which goes within the pre-stented RVOT already. And the final testing to make sure that we have no pulmonary regurgitation. The RV2PA gradient has to be less than 20, so we should not leave stenosis behind. This is another older patient in heart failure who had azygos continuation of an interrupted IVC. You see that it goes into the coronary sinus, and therefore, since the IVC was interrupted, we would not be able to use the femoral route, and we had to go IJ as well. You see here the calcified conduit. And on this patient, again, we did pre-stenting with a cover stent to make sure that there was no crack of the calcium, and if there was, that we wouldn't get a hemothorax, and then we implanted the valve. And another case, this is an Edwards valve coming up to go within another pre-implanted, surgically implanted biological valve. Having a pacemaker leads is not a contraindication for us. We just have to be careful that we are away from the leads as we go up or down with our sheaths. And the leads should not be fresh. We usually leave 6 months after implantation of either pacemaker or defibrillator leads. This is a patient who has a transtricuspid valve, as you see here, lead. And this is another patient who's had surgical Alfieri of his tricuspid valve because of regurgitation. With TOE, we decided which orifice was of the Alfieri of the tricuspid valve was bigger, and we went through that in order to pass through our sheath and pass through the valve. And these are the x-rays, AP and lateral, that we have to check on the next day. Potential complications are obviously homograph rupture, as we said, and acute hemorrhage, and that's why we are all scrubbed up, ready to go with our surgeons there. Luckily, that doesn't happen very easily or very often. Arrhythmia is a problem, obviously infection is a problem. And there is an argument that transcatheter pulmonary valves have a high infection rate. It is indeed true that there is an SBE risk of 4 to 16% as compared to 2% in the surgical group. And there's obviously research on the subject why the Melody valve is actually getting infected more frequently than the Contegra valve, which is a surgically implanted one. So 7.5% of Melodies, 20% Contegra, 2.4 of homographs on this report would get infected post, but the Edwards seems to have a lower risk. And so there was a study in 2017 which actually concluded that the bacterial adhesion was higher on the bovine jugular vein for Staph aureus and sanguinis. And also that rate was increased in traumatized Melody valvular leaflets. And the thinking behind this is that the Contegra, which is also bovine, doesn't get infected when it gets implanted surgically because there's less handling onto the valve than there is with Melody. But there's also interinstitutional differences for endocarditis and the way the implanters handle the valve, obviously. And as Dov McElhinney said on this editorial in 2017, we do not have enough information about endocarditis and its implication with any type of RVOD conduit to pass judgment. But there is continuous registry and registration of these episodes. And in the US, there's this National Cardiovascular Data Registry improving patient and adult congenital treatments. This is for all treatments on kids and adults with congenital heart disease. And they have now included the TPVR module and whether there's endocarditis after the implantation. So we've done at Mitera and Hygeia, we've done 27 patients, 21 transfemoral and 6 IJ, and we had only one patient with fungal endocarditis who had very poor hygiene and then had a surgical prosthesis, which also got infected with fungus. And therefore, for us, it's very important, as with the surgeons, of course, to be able to prepare the patients and mainly stress the importance of the dental hygiene and the yearly dental appointments. So a couple of slides on what we know recently about whether it's better to go transcatheter or surgical for pulmonary valve replacement. This meta-analysis from 2020 actually shows that there is no difference in terms of risks. And the TPVR is a safe alternative, but it's also better for the patient. It's far better for the patients who are at high risk, and the cost is the same. So in the future, more valves are coming onto the market. As we said, Medtronic is preparing, is on a clinical trial with a Harmony valve. There's been 40 valve implantations with 6-month follow-up so far. These are data from John Cheatham, which were presented in Sky in 2021, a couple of weeks ago. And obviously, in the patients that they implanted the Harmony valve, there was mainly a cohort who had pulmonary regurgitation, as we see here, that was then sorted out. So in conclusion, the therapies, the TPVI therapies for patients with congenital heart disease have really altered the management. And we should recognize which patients need this therapy and offer to them before it's too late and before right heart failure settles in. With the continuing technology, the evolution of technology, new valves are coming onto the market, and hopefully the new valves will be suitable for the majority of the patients. But key to the success of the patient is the patient preparation and also the collaboration of the specialist team with all the subspecialties. And with that, I would like to thank the heart team at Hygeia for the wonderful collaboration over the past 10 years, and our team, the congenital heart team at Midera. Thank you very much.
We are astonished, Mrs. Zifa. Thank you very much for your presentation. You are excellent. And hopefully we expect more from you. We can proceed to the next speaker, Dr. Apostolos Zikas, who is speaking about the advances and current status in left atrium appendage occlusion. Mr. Zikas.
The microphone.
Microphone.
I'm mute. Can you hear me?
Yes, we can hear you.
And unfortunately, we can see you and be jealous. Unfortunately, we can see you as well.
Well, I apologize. Well, I had to do this trip. I'm on a voluntary work mission in the GNC, so we're seeing patients all over the GNC. But nevertheless, I would never miss that Congress, which is fantastic. And my topic is on the advances and current status in left atrial appendage occlusion. And these are my disclosures. So we all know that according to the guidelines, AF patients should receive oral anticoagulation for prevention of stroke and thromboembolism. However, despite the fact that everybody's trying to follow the guidelines, the actual implementation of these guidelines is not always optimal. In this registry, less than 50% of patients were treated according to the guidelines. And in this slide, you can see that the introduction of the new anticoagulants did increase slightly only the use and the adherence of these patients. So approximately 40% of OIC eligible patients are not receiving the proper therapy right now. The main reason has to do with the adherence of these patients, and no matter which anticoagulant you use, this still remains problematic. And here you see in this study that was published and was presented in 2019, the patients that discontinue the NOAC treatment as compared to patients that remained on OAC treatment, they behave, if you see the curve, they behave as they didn't have any treatment at all, which means that they are at risk for stroke and thromboembolism. So the question is, can we do something different? Can we switch? And left atrial appendage occlusion, at least on the endovascular approach, is increasing gradually all over the world. You see this slide in the United States that approximately 600 centers perform left atrial appendage occlusion in the States right now in 2019. And the annual number of procedures is close to 30,000, which is really remarkable. However, due to the lack of randomized clinical trials, we only have a few. At least the EC guidelines have not changed, and also the American guidelines remain the same. And it's an indication 2B. So, which means that patients may be considered for percutaneous LA closure if they need oral anticoagulation and they cannot take it due to contraindications for long-term use of this therapy. However, and you see here the surgical excision of the left atrial appendage, which had also an indication of 2B, level of evidence C, but this has changed, and this is actually what I'm going to show you mostly in this presentation. Before doing that, I will just show you briefly the PROTECT AF trial that was published years ago that shows that the patients that received the Watchman device and were eligible for oral anticoagulation, then received the Watchman device on top of anticoagulation and then switched to dural antiplatelet therapy, they had a remarkable statistical significant difference in all-cause mortality in the intention to treat analysis in the 4 years. We don't have randomized clinical studies in the era of NOACs. The only one we have is the PRAG 17, but this is a small study that showed the non-inferiority for the LA closure versus NOACs in a small group of patients. So years ago, we tried to standardize the definition in order to conduct these studies, and because that was one of the important problems that we had in order to compare the similar things and then be able to see what is the benefit for the patients. And I just chose this table to show you that the theoretical indication for closure of the left atrial appendage is all over the place. I mean, it can be a contraindication to oral anticoagulation, but this is not something very specific. Sometimes we say we have a relative or absolute contraindication, but we don't really know. And if you see on the second part here on the number B, there is another indication when we don't have a contraindication for the medication, but we do have a thromboembolic event or a documented presence of thrombus in the left atrial appendage despite adequate therapy. So the group of patients is quite mixed. So the only thing we have now recently is this paper that was published a few years ago, and it's a consensus paper from the ESC group that we try to see what should be done. And we say that patients that are suitable for oral anticoagulation should receive oral anticoagulation. This should be our main goal. However, patients that are not suitable or they have contraindications, they should offer LA occlusion, or at least this potential therapy should be discussed with them. And there are different patients, for example, a patient that had a stroke on warfarin, as I said before, a patient that just had a high Hess-Bled score, or a patient that has renal failure, is difficult to treat. And all these patients should be discussed ideally in a team discussion, not in an individual, on the individual doctor basis, but also together with other physicians. So what was published recently, and that was just last week, is the Laos 3 randomized clinical trial that was published in New England Journal of Medicine last week. And this study, it's a large randomized clinical study that included patients that had a CHA2DS2-VASc score of at least 2, and they randomized patients to undergo heart surgery for any reason, plus left atrial appendage occlusion, surgical occlusion, versus surgery alone. And the primary outcome was the ischemic stroke, including transient ischemic attack with positive neuroimaging or systemic embolism. And remarkably, the participants, the research personnel, and the primary care physicians, of course, other than the surgeons, were unaware of the trial group assignments. And these are the baseline characteristics of these patients. As you see here, we have approximately almost 5,000 patients that were randomized. The age was, of course, in the randomization was around 71 years old. And what we see here is that the CHA2DS2-VASc score was 4.2, which is similar to the studies that we do for endovascular LA closure, quite sick patients. So continuing with the baseline characteristics, we see that the majority of patients underwent valve procedures and then were randomized to either go lone valve procedure or combination with surgical left atrial appendage occlusion. So the outcomes of these trials were remarkable. We see that for the a larger number of events, the study was positive, which meant that the patients did better if they had their left atrial appendage occluded. And as we see here also, in the secondary endpoint, there were also positive outcomes, with the exception of the death from all cause, as you see here. Now, another remarkable thing to see is that the most of the benefit was started after the 30 days after surgery. Here we see the two curves that divide. And this is the main table of the comparisons between the occlusion versus no occlusion. Overall, there was a benefit for occlusion in all parts. And the overall, as you see here, we have 7% in the control group as the primary endpoint and 4.8% in the occlusion group, which meant that occlusion was better, and that was statistically significant with the level of evidence, as you see here, of 0.1. And these two curves start to divide early, and the study was positive. So there are ongoing clinical trials now in the endovascular end. We have the randomized clinical trial that compares the Amulet device versus Watchman device that finished, and we expect the results to be presented this year. And this, of course, this study compares an FDA study that compared the two devices for the American market. And also we have other trials that are ongoing. These trials are done in patients with a contraindication to oral anticoagulation for several reasons. Others had intracranial hemorrhage, or others had a high Hess-Bled score. All are randomized, and they are recruiting pretty well. Another trial that is ongoing is a combination of LA closure with a Watchman device plus AF ablation as compared to AF ablation alone. This is also enrolling pretty well. And the two very, very important trials that are also already enrolling patients are the Champion EF and the Catalyst trial. The Champion EF compares the Watchman Flex device versus contemporary oral anticoagulation therapy, more than 2,000 patients, 150 sites. And this is a one-to-one randomization for the Watchman device versus the NOACs in all comers, which means that here we don't have any contraindication for oral anticoagulation. This is a direct comparison of the so-called local therapy versus the systemic therapy. And on the other side, the Catalyst trial, similar to the Champion trial, 2,650 patients eligible for long-term anticoagulation. And the study has started enrolling in March 2020, and it's going pretty well from what I hear. So as a take-home message, percutaneous left atrial appendage occlusion offers the option of a local therapy for AF-related thromboembolism prevention. For surgical left atrial appendage occlusion, after the results of the Laos trial that was published last week, it showed that the risk of ischemic stroke was lower with concomitant LA closure during surgery than without it. We do have results from lab registries on the LA closure that are very promising, and more evidence from new randomized clinical trials are coming. But again, in any case, the proper patient selection and collaboration between interventional cardiology, neurologists, or other specialists are going to be the key for success. Well, thank you very much.
Great. Thank you very much, Dr. Tsikas. I think that's a wonderful talk. And I think it's good that we have almost 10 minutes now for discussion. The first question I wanted to ask is, I don't know if you've seen the recently published cardiac surgery trial, LA03, that produced outstanding results for patients where patients in AFib, where surgically their left atrial appendage was excised and oversewn. It was not allowed for a purse string, or the left atrial appendage clip was used. I think give us some of your viewpoints on comparing and contrasting the endovascular therapy and the surgical therapy. Clearly, they're aimed at different patient populations.
I did present that study just now. Yeah. So
your thoughts?
Of course, you cannot extrapolate surgical therapy with endovascular therapy. However, we do believe in the field of percutaneous closure that this is going to be a very important trial also for the endovascular therapy, because it shows that there is a proof of concept. It means that if you excise or close the appendage and you do it properly, as the surgeons did in this trial, not as previous trials, the LEOS 1 and the LEOS 2, it does have a significant benefit for the patient. So the percutaneous LA closure is booming worldwide without real evidence. And we have to admit that we don't have much evidence from randomized trials, and we do need more evidence. So I think that the surgical, it's one of the few times
These are the issues with connecting to that. Yeah, we have now surgical randomized data, so that's strong, and I think this will be an impetus for Transcatheter. Thank you very much, Dr. Tsolakis or Dr. Mitropoulos. Questions
to
for
Dr.
our
Zikas,
speakers?
probably. I want to ask something to Dr. Zikas. You listen to me, isn't it?
Yes.
Yes, perfect. If you're operating a person with without atrial fibrillation and without any other problem, and you're going to take off to remove an aortic valve or a mitral valve, and you find the appendage perfect, what do you propose to do? To close the appendage, to excise the appendage, or to do nothing and wait till the arrhythmia to become to the patient?
Well,
do you have any idea?
Well, I'm not a surgeon, but the evidence that we have now is only for patients with atrial fibrillation. So we don't have evidence for, let's say, primary prevention.
Primary prevention, there is no evidence yet.
Yes, but on the other hand, and I'm sure the surgeons in the group that will agree that if you have a patient with rheumatic mitral stenosis with a left atrium that is huge, no matter if he doesn't have atrial fibrillation right now, he might develop that very soon. So I guess in that case, early closure, surgical closure would be justified. But again, we don't really have data on that.
Yeah.
Thank you very much.
Dr. Mitropoulos, I'm very tempted to ask Dr. Sardari and Dr. Pitsis for some of their thoughts on minimally invasive mitral surgery, but I want to hear your questions to them or to any of our other speakers.
Yeah, I have. I would like to ask something, Dr. Sardari. What will be the position of the European Society regarding credentialing endoscopic mitral surgery, and how would that include the stimulation that you have been working and essentially pioneering in that?
So I think it is very politically difficult for credentialing institutes of programs, but I think what we have done at the European level is to set up an educational program, which is simulation-based since 2015. And we have published the results of those who have been on this program, that it facilitates the implementation and the learning of this kind of surgery. I hope that European societies will get more involved and understand that nowadays, because of the fact that the procedure is getting more technical, our patient population becomes more aged, there are so many restrictions, ethical, economical, and so on, that we need to have a different kind of training philosophy for those who do interventions, whether intervention cardiologists or surgeons. So simulation-based training based on the concept of air pilot training. Yeah? So if you are an air pilot, even you change your airplane, you have to be fully trained, and then you are going to do what you need to do. So that is a task, a very important task that is upon us. And yeah, if we don't do it, I think the governments at some point will be oblige us to do that.
Dr. Pitsis, I think I want to hear your thoughts. In the US, there's a big push towards publishing surgeons' outcomes. And I think maybe even beyond credentialing, that this is kind of a way to let the public know who's doing what and what's going on. To be completely honest with you, I think in Greece, it'll be very, very hard to get objective data as to what each person is doing, especially with regard to the fact that if you actually want to understand what a surgeon is doing, you don't just look at mortality percentage. You look at O to E ratios, observed to expected. So if I'm doing case and I have a 2% mortality, I may be worse surgeon than Dr. Sardari, who's doing more complex cases and has a 10% mortality. But his expected was 15 and my expected was 1%. So I'm double and he's at, much, much less than where he should be. What are your thoughts on where we're going to go eventually in Europe and in Greece with this, Dr. Pitsis?
Quite, Greg. I totally agree with you, and it's a shame that in a procedure like TAVI, today in Greece, everything is documented, and we know mortalities 1 month, 6 months, 1 year for each heart team and each center, and we don't have the same about surgery. So I think this is something that should take place and should happen, and also to make things more complicated as far as Fotis' question is concerned, there are 2 more societies dealing with minimally invasive, ISMICS, as you know, Foti, and also there is a new society club, which is the Endoscopic Cardiac Surgeons Club, already has 90 to 100 members from all over the world. It is a universal, it is like the mitral repair club, and sooner or later it's going to have hopefully thousands of members. So I think it's a matter of the societies and also the governments to safeguard this area. Yes, I quite agree. It has to be monitored the same way like TAVI does and MitraClip does.
Perfect. I think with that being said, we're at exactly 6:30 p.m. and we have Dr. Vardas with us for the next session. Dr. Mitropoulos, let's hear your closing comment. Yes, please.
For Dr. Zifa, it appears that pulmonary valve endocarditis might be the final frontier for the percutaneous treatment, but now the data are encouraging that in certain situations, if not in the majority of them, the percutaneous pulmonary valve is safe. What do you think?
Yes, absolutely. I think there is a lot of factors coming in. It's like with TAVIs, TPVI is also a heart team decision, and we always assess the benefit versus the risk. In fact, there is lots of congenital interventional cardiologists who say that even if there is a risk of endocarditis in a certain patient who cannot be operated, then the risk of the transcatheter procedure with endocarditis is less than the risk of not doing anything or with surgery. And therefore, endocarditis has stopped being one of the, as you say, the final frontiers for us, because it seems that we are getting a feel about what's happening with it, and we are having different ways of bypassing it, like in our center.
That's a very nice answer. Recently, Dr. Zifa, you know, in I can't remember which cardiac surgery journal, they published about tricuspid endocarditis in adults, and with aspiration of foreign particulate matter plus antibiotics, and proving that some of this could be successful. So I think transcatheter approaches are really pushing the limit. That being said, we're 1 minute over, and I can see that Professor Vardas is waiting for us, as well as President Kanakakis. A big thank you to everyone, to my co-moderators, Dr. Tsourlakis and Mitropoulos, and to all of our excellent speakers. Thank you for joining us.
Thank you, Greg. Thank you very much. Thank you, Apostole.
Thank you.
Thank you. 30 seconds, and we move on to the next topic.
Good afternoon. Good afternoon to this very important session, which is indeed rather political and to some degree related to health economics, but also it is an educational session. The pleasure is great because the organizers had asked me to chair this important topic together with Professor Stefanadis, who unfortunately at the moment is traveling out of Athens in the island of Ikaria. But it is also a pleasure because I will chair this session with one of the main organizers, Dr. Grigoris Patakos. So now, the title of this session is Training Requirements, Specialties and Subspecialties and Device Approval Landscapes in the area of transcatheter heart valves. As I said, we will chair the session together with Dr. Patakos. I think, Grigori, you agree that we have to invite the first presenter, Professor Michalis, who has to talk about training in transcatheter heart valves. Why, how, where, by whom, and current status. And he will present the view of the cardiologist.
Yes. Dr. Vardas, at the request of Dr. Sparias at the last minute, he's decided to make this the only Greek language session for the benefit of the fact that it's geared towards a Greek audience. Οπότε θα μπορέσουμε να το πούμε στα ελληνικά, γιατί προσδιορίζουμε αυτές τις ομιλίες προς το ευρύτερο κοινό της Ελλάδας και είναι κάτι που είναι συγκεκριμένα και αποκλειστικά για τη δική μας χώρα. Οπότε ο κύριος Σπάριας μου ζήτησε να είναι το μοναδικό session το οποίο θα είναι στα ελληνικά. Κύριε καθηγητά, κύριε Μιχάλη, σας ακούμε και σας ευχαριστούμε που ήρθατε μαζί μας.
Καλησπέρα σε όλους. Ευχαριστώ πάρα πολύ την Οργανωτική Επιτροπή και τον κύριο Βάρδα που έχει την καλοσύνη να με προλογίσει. Και ας ξεκινήσουμε. Καταρχήν... Okay. Παίρνοντας λοιπόν τον τίτλο της ομιλίας «Εκπαίδευση στις διαδερμικές καρδιακές βαλβίδες», πώς, γιατί, πώς, πού και από ποιον, καταρχήν θα ήθελα να πω ότι μιλάω κυρίως για TAVI, γιατί είναι και η μόνη διαθέσιμη διακαρδιακή ενδοκαρδιακή βαλβίδα, τουλάχιστον εμπορικά στην Ελλάδα. Μόλον και τα υπόλοιπα δεν θα είχαν διαφορά. Θα προσπαθήσω να πάρω ένα προς ένα αυτά τα ερωτήματά σας και να προσπαθήσω να τα απαντήσω. Το πρώτο πράγμα είναι γιατί. Δεν νομίζω ότι θέλει και πολλή απάντηση στην ερώτηση γιατί. Δεν νομίζω οτιδήποτε μπορεί να αποκτηθεί χωρίς να υπάρχει κατάλληλη εκπαίδευση. Ας πάμε τώρα στο πώς. Το πώς όταν έχουμε να εκπαιδεύσουμε, και αυτό αφορά γενικότερα την εκπαίδευση, έναν ήδη εκπαιδευμένο ειδικό ιατρό, η εκπαίδευση μπορεί να επιτευχθεί με δύο τρόπους. Ο ένας τρόπος είναι με αυτό το οποίο λέμε συνεχιζόμενη ιατρική εκπαίδευση ή συνεχιζόμενη επαγγελματική βελτίωση, και το άλλο είναι με ένα οργανωμένο πρόγραμμα εκπαίδευσης. Ας ξεκινήσουμε πρώτα-πρώτα με το οργανωμένο πρόγραμμα εκπαίδευσης. Όταν κάνουμε οργανωμένο πρόγραμμα εκπαίδευσης, πρέπει να δημιουργήσουμε τις απαιτήσεις, το τι είναι τα απαιτούμενα της εκπαίδευσης. Το πρώτο πράγμα που πρέπει να ορίσουμε είναι ο χρόνος. Σε αυτές τις περιπτώσεις ο χρόνος είναι τουλάχιστον ένας. Δεύτερο, πρέπει να ορίσουμε ποιο θα είναι το curriculum της εκπαίδευσης, το οποίο ουσιαστικά λέει σε τι πρέπει να εκπαιδευτεί κάποιος. Εδώ θα πρέπει να ξεκαθαρίσουμε ότι μπορεί, ειδικά για πράγματα τα οποία είναι καινούρια, να απαιτηθεί να εκπαιδευτούν ιατροί στο ίδιο αντικείμενο, οι οποίοι όμως προέρχονται από διαφορετικά backgrounds. Στη συγκεκριμένη περίπτωση θα μπορούσαμε να πούμε ότι μπορεί να εκπαιδευτεί τόσο ένας καρδιοχειρουργός όσο και ένας καρδιολόγος. Όμως σε αυτή την περίπτωση αυτό που πρέπει να καταλάβουμε είναι ότι τα αντικείμενα στα οποία πρέπει να εκπαιδευτεί είναι διαφορετικά για την κάθε μία ειδικότητα. Και σε κάθε περίπτωση θα πρέπει αυτά τα αντικείμενα να εξεταστούν από το σύνολο της ιατρικής κοινότητας και να υπάρχει συμφωνία. Και αυτό ουσιαστικά εδώ είναι ο ρόλος τον οποίο παίζει η UEMS. Αυτό είναι το οποίο κάνουμε στη UEMS. Το δεύτερο πράγμα είναι ότι με βάση αυτό το αντικείμενο εκπαίδευσης θα πρέπει να φτιάξουμε αυτά τα οποία πλέον είναι της μόδας, τα entrustable professional activities. Τι σημαίνει αυτό? Θα πρέπει να ξέρουμε δηλαδή ένας επιτυχημένος εκπαιδευτή, ένας άνθρωπος που εκπαιδεύτηκε επιτυχώς, τι αναμένουμε από αυτόν να μπορεί να κάνει στο τέλος της εκπαίδευσης. Μετά θα πρέπει να ορίσουμε με ποιον τρόπο θα ελέγξουμε τον εκπαιδευόμενο, και το οποίο είναι ουσιαστικά δύο πράγματα. Το ένα είναι να εγκρίνει ο εκπαιδευτής του ότι έχει εκπαιδευτεί και να το επιβεβαιώσει, και το δεύτερο πράγμα είναι εξετάσεις. Να ορίσουμε ποια είναι τα εκπαιδευτικά κέντρα και ποια είναι τα κριτήρια που πρέπει να τηρούν, και επίσης να ορίσουμε ποια είναι τα κριτήρια, ποια είναι τα καθήκοντα και πώς θα εκτιμάται η απόδοση των εκπαιδευτών. Αντίθετα, όταν έχουμε αυτό το οποίο λέμε συνεχιζόμενη ιατρική εκπαίδευση, αυτό που είναι πλέον ορίζεται σαν συνεχιζόμενη επαγγελματική ανάπτυξη, τότε θα πρέπει να ξέρουμε ότι μιλούμε για πολλά μικρά διαστήματα εκπαίδευσης. Το περιεχόμενο της εκπαίδευσης δεν είναι απόλυτα ορισμένο από πριν, αλλά ορίζεται σε συμφωνία με τον εκπαιδευόμενο και εξαρτάται από τις προσωπικές του ανάγκες. Είναι επαγγελματικά προσανατολισμένο. Ο τρόπος με τον οποίο εκτιμούμε τον εκπαιδευόμενο είναι από τα credits, τα CME τα οποία παίρνει, τα οποία με τη σειρά τους αυτό το οποίο εκτιμούν είναι την ποιότητα του προγράμματος, καθώς επίσης και το τι επέτυχε ο εκπαιδευόμενος, και τέλος ποιος θα είναι ο πάροχος της συνεχιζόμενης ιατρικής εκπαίδευσης. Αυτή είναι από ορισμό μέχρι σήμερα οι επιστημονικές και οι επαγγελματικές ιατρικές οργανώσεις, καθώς και βέβαια πάντοτε παίρνει ποιος είναι ο ρόλος της βιομηχανίας στην εκπαίδευση αυτή, η οποία επιζητά να έχει, και αδικαίως ή αδίκως, να έχει πολύ μεγαλύτερο ρόλο σε όλη αυτή την προσπάθεια. Ας πάμε τώρα λιγάκι γενικότερα πάλι σε ένα πώς γίνεται η εκπαίδευση. Καταρχήν εξαρτάται αυτό το οποίο πρόκειται να εκπαιδευτούμε σε ποια φάση της ανάπτυξης του βρίσκεται. Μιλάμε για έναν εντελώς νέο τομέα. Καταρχήν, όταν έχουμε ένα νέο τομέα ο οποίος μόλις αναπτύσσεται, όπως για παράδειγμα ήταν οι βαλβίδες πριν από 15-20 χρόνια, τότε έχουμε τους πρωτοπόρους. Αυτοί ουσιαστικά ξεκινούν τα πάντα από το μηδέν και όλα βασίζονται στα δικά τους skills, στην ιατρική τους γνώση, στην προσωπική τους εμπειρία και την πεποίθηση. Αυτοί επίσης θα πρέπει να ξέρουμε ότι συνήθως προέρχονται από έναν κλάδο ο οποίος είναι κοντά στο αντικείμενο το οποίο πρόκειται να επιλύσει. Δηλαδή, για παράδειγμα, μην ξεχνάμε ότι ο Γκρούτζικ ήταν αγγιολόγος, ακτινολόγος και καρδιολόγος, ο οποίος ξεκίνησε την αγγιοπλαστική, όμως μπορεί να είναι και από κάτι εντελώς διαφορετικό. Μην ξεχνάτε ότι ο άνθρωπος που ξεκίνησε τους κρατηριασμούς ήταν ένας ειδικευόμενος ουρολογίας. Άρα, στην πρώτη αυτή φάση μπορεί οι άνθρωποι να προέρχονται πραγματικά, να είναι πραγματικά pioneers και να προέρχονται από κάπου εντελώς ξεχωριστά. Από τη διάρκεια με τις φάσεις μεταξύ στη φάση της ανάπτυξης, δηλαδή από όταν ξεκίνησε, αλλά προτού όμως αυτή η μελέτη, προτού η καινούργια αυτή μέθοδος γίνει πραγματικότητα και καθιερωθεί, τότε έχουμε δύο πράγματα. Μπορεί να έχουμε ένα πρόγραμμα structure, το οποίο τότε έχουμε τα εξής πράγματα. Αν θέλαμε να χρησιμοποιήσουμε ένα οργανωμένο τρόπο εκπαίδευσης, είναι σαφές ότι δεν μπορούμε να έχουμε ένα core curriculum. Δεν μπορούμε να έχουμε σαφείς intrustable professional activities. Το assessment μπορεί να γίνει μόνο από τον εκπαιδευόμενο. Τα κέντρα τα εκπαιδευτικά θα μπορούσαν να υπάρχουν, ξέρουμε ποιες είναι οι ανάγκες τους, αλλά είναι πάρα πολύ λίγα και έτσι μόνο πολύ μικρός αριθμός ιατρών θα μπορούσε να εκπαιδευτεί και δεν θα μπορούσε να καλύψει τις ανάγκες της μεθόδου. Επίσης, το ίδιο ισχύει για τους εκπαιδευτές, ότι θα μπορούσαμε να είχαμε εκπαιδευτές. Αντίθετα, αν κάνουμε CPD συνεχιζόμενοι, τότε ό,τι κάνουμε με το CPD μπορούμε να το κάνουμε. Και βέβαια πάλι εδώ θα μπει ο ρόλος της βιομηχανίας, ο οποίος είναι εξαιρετικά ισχυρός σε αυτή την περίπτωση, μολονότι δεν έχει ποτέ επίσημα αναγνωριστεί. Έτσι, κατά αυτή τη φάση νομίζω ότι και πάλι απαιτείται να έχουμε CPD και δεν μπορούμε να έχουμε structured πρόγραμμα. Όταν όμως φτάσουμε πλέον στη φάση της καθιέρωσης, μπορούμε να τα έχουμε και τα δύο, μπορούμε να έχουμε core curriculum, μπορούμε να έχουμε intrastable activities, μπορούμε να έχουμε assessment, μπορεί να έχουμε training και κέντρα εκπαίδευσης και σε αυτά τα οποία να είναι αρκετά πλέον και έτσι μπορούμε να εκπαιδεύσουμε επαρκή αριθμό εκπαιδευομένων και μπορούμε να έχουμε εκπαιδευτές. Αφού λοιπόν τα έχουμε όλα αυτά, θα μπορούσαμε όμως να έχουμε και ένα πρόγραμμα μικρής συνεχιζόμενης εκπαίδευσης. Για τους λόγους για τους οποίους είπαμε και προηγουμένως ότι έχει όλα τα κριτήρια τα οποία απαιτούνται για να μπορέσει να λειτουργήσει. Άρα σε αυτή τη φάση θέλουμε και τα δύο. Και τα δύο είναι πάρα πολύ σημαντικά και ο λόγος που είναι σημαντικά είναι γιατί εάν έχουμε έναν νεαρό, έναν άνθρωπο ο οποίος είναι πολύ κοντά στη φάση στην αρχή της καριέρας του, τότε ένα νέο επεμβατικό καρδιολόγο ή ένα νέο καρδιοχειρουργό, τότε το οργανωμένο πρόγραμμα είναι αυτό που του ταιριάζει. Αλλά εάν έχουμε έναν μεγαλύτερο συνάδελφο, ο οποίος θέλει να αποκτήσει εμπειρία σε κάποια αργότερη φάση της καριέρας του, τότε αυτός είναι πάρα πολύ δύσκολο να μπει σε ένα οργανωμένο πρόγραμμα και αυτός είναι υποχρεωμένος να τα μάθει αυτά μέσα από τη διαδικασία της συνεχιζόμενης εκπαίδευσης. Επίσης θα πρέπει να ξέρουμε ότι η συνεχιζόμενη εκπαίδευση είναι απαραίτητη και για οποιονδήποτε ήδη έχει πάρει την εκπαίδευση για να μπορέσει να συνεχίζει να την διατηρεί. Και στα πλαίσια αυτά, από ποιον μπορεί να γίνει. Άρα, στη φάση που είμαστε σήμερα στην ΤΑΒΗ, πρέπει να πούμε ότι το how πρέπει να είναι και από οργανωμένο πρόγραμμα, αλλά και από CEPD. Τώρα, από ποιον θα πρέπει να υπάρχουν κέντρα τα οποία να έχουν να είναι certified αυτά τα κέντρα και βέβαια η UEMS εδώ προσφέρει όλα τα κριτήρια του τι απαιτείται για να αποκτήσει ένα certification. Ένα οποιοδήποτε κέντρο πρέπει να έχουμε certified trainers και εδώ τα κριτήρια τα έχουμε ορίσει στη UEMS. Η συνεχιζόμενη εκπαίδευση, έχουμε τα UEMS credits της IACME, τα οποία τα έχουμε και ειδικά στην καρδιολογία, είναι από κοινού με την Ευρωπαϊκή Καρδιολογική Εταιρεία και βέβαια έχουμε την εκπαίδευση την οποία εκ των πραγμάτων, ό,τι και να πούμε, προσφέρει η βιομηχανία, μόλον ότι αυτή δεν αναγνωρίζεται επισήμως χορηγώντας CME κέντρα. Και πού θα γίνεται αυτή η εκπαίδευση? Θα γίνεται στα κέντρα τα οποία έχουν οριστεί. Όπως είπαμε παραπάνω, θα γίνεται σε συμπόσια, θα γίνεται σε workshops, θα γίνεται σε scientific meetings και θα γίνεται και σε training centers. Τώρα, ας πούμε λίγα λόγια για το ρόλο της βιομηχανίας, η οποία εξορκίζεται, αλλά η οποία θα πρέπει να σκεφτούμε πολύ σοβαρά το πώς προσφέρει. Η βιομηχανία πληρώνει έτσι κι αλλιώς για έρευνα και για εκπαίδευση, είτε έμεσα, είτε άμεσα, είτε έμεσα, και πληρώνει επίσης και για τη δημιουργία των κατευθυντηρίων οδηγιών έμεσα, γνωρίζοντας όλοι ότι άνθρωποι οι οποίοι συμμετέχουν στις κατευθυντήριες οδηγίες βασίζονται σε μελέτες που έχουν επιδοτηθεί από έρευνα και οι ίδιοι πιθανώς να έχουν κάποιες σχέσεις με τη βιομηχανία, τις οποίες σαφώς και δηλώνουν, και αυτός είναι ο τρόπος με τον οποίο γίνεται αυτό το biased. Η εκπαίδευση από τη βιομηχανία, ο ρόλος της βιομηχανίας κατά τις δύο πρώτες φάσεις είναι σαφής και είπαμε ότι δεν μπορεί να παραληφθεί και έτσι γίνεται. Κατά τη διάρκεια της τρίτης φάσης είναι επικουρικός. Και εδώ υπάρχουν δύο πράγματα που πρέπει να ξέρουμε όσον αφορά την εκπαίδευση. Υπάρχει καταρχήν η εκπαίδευση όσον αφορά γενικά τη μέθοδο, γενικά για την ΤΑΒΗ. Και είπαμε ότι ο ρόλος τον οποίο έχει η βιομηχανία στις δύο πρώτες φάσεις και επικουρικός στην τρίτη. Υπάρχει και η εκπαίδευση για οποιοδήποτε από τις τρεις φάσεις ενός προγράμματος, της ΤΑΒΗ εδώ, και στο οποίο το ρόλο τον έχει η βιομηχανία. Τώρα, πώς θα μπορέσουμε να ξεπεράσουμε το σκόπελο ότι μπορεί η βιομηχανία πέραν της εκπαιδεύσεως να επηρεάσει τις ιατρικές μας αποφάσεις. Αυτό οφείλουμε να πούμε, μπορεί να εκπαιδευτεί μόνο με βάση την ακεραιότητα, την ηθική των γιατρών και των ερευνητών και επίσης χρησιμοποιώντας τους υπάρχοντες κανόνες. Οι οποίοι υπάρχοντες κανόνες είναι η δήλωση του conflict of interest. Μέχρι εκεί έχουμε φτάσει σήμερα, δεν ξέρω εάν θα γίνει κάτι άλλο αργότερα. Και αφήνω ένα ανοιχτό ερώτημα, το οποίο θα μπορέσουμε να το συζητήσουμε και αργότερα, εάν μπορεί, αν ποτέ πρόκειται να υπάρξει και αν είναι δυνατόν να έχουμε events τα οποία να είναι απευθείας οργανωμένα από τη βιομηχανία και τα οποία να παίρνουν CME credits. Είναι κάτι το οποίο και αυτό συζητιέται και το οποίο προς το παρόν εξορκίζεται. Τώρα, εάν θα θέλαμε να πούμε πού πρέπει να εστιαστεί ένα curriculum το οποίο αφορά το TAVI, τότε νομίζω και τι πρέπει να ξέρει κάποιος, ασχέτως από πού προέρχεται, ο καθένας θα ακολουθήσει διαφορετικούς τρόπους για να μάθει, θα πρέπει να ξέρει σχετικά με την νόσο της αορτικής βαλβίδας, πώς γίνεται η διάγνωση, πώς γίνεται η εκτίμηση, πώς γίνεται, ποιος είναι ο χρόνος επέμβασης, θα πρέπει να ξέρει και να αναγνωρίζει και να αντιμετωπίζει τις συνοσυρότητες, θα πρέπει να γνωρίζει διαθυραγκικό υπέρηχο, να ξέρει να καταλαβαίνει το τι λέει το διεισοφάγιο υπέρηχο, να έχει πάρα πολύ καλή εκπαίδευση όσον αφορά την αξονική αγγιογραφία, η οποία είναι φτιαγμένη έτσι για το TAVI, να ξέρει να χρησιμοποιεί τα διάφορα softwares τα οποία θα μπορούν να κάνουν τις μετρήσεις, να ξέρει πάρα πολύ καλά περιφερικά αγγεία και ιδιαίτερα πώς να μπορεί να κάνει παρακεντήσεις και πώς να χρησιμοποιεί τις συσκευές σύγκλησης, να ξέρει να αντιμετωπίζει τις επιπλοκές των περιφερικών αγγείων, να μπορεί να καθοδηγεί μεγάλες συσκευές μέσα στο αρτηριακό σύστημα, να μάθει πώς γίνεται η τοποθέτηση των βαλβίδων, να ξέρει να αντιμετωπίζει αρρώστους κατά τη διάρκεια της παραμονής τους σε μονάδα εντατικής θεραπείας, να αναγνωρίζει ποιες είναι οι ανομαλίες του ρυθμού οι οποίες σχετίζονται με το TAVI και να ξέρει πότε να ζητάει να τοποθετηθεί βηματοδότης, να ξέρει αντιθρομβωτικές αγωγές και να μπορεί κλινικά και ηχοκαρδιογραφικά να παρακολουθεί τους αρρώστους μετά την επέμβαση του TAVI. Αυτά ήθελα να σας πω. Σας ευχαριστώ πολύ. Ελπίζω να παρέμβω.
Ευχαριστούμε πάρα πολύ, κύριε καθηγητά. Είπατε πάρα πολύ ενδιαφέροντα θέματα. Αν συμφωνεί και ο καθηγητής κύριος Βάρδας, νομίζω ότι θα ήταν ωραίο να ακούσουμε και την καρδιοχειρουργική άποψη και μετά να έχουμε χρόνο για σχόλια. Τι λέτε, κύριε Βάρδα?
Ασφαλώς. Θα προχωρήσουμε.
Οπότε, με πολύ χαρά θα μας μιλήσει τώρα ο κύριος Αργυρίου, ο οποίος δεν χρειάζεται καμία σύσταση, γιατί τον ξέρει όλη η Ελλάδα. Ευχαριστούμε πάρα πολύ που είσαστε εδώ μαζί μας. Και ένας άνθρωπος που ασχολείται ιδιαίτερα με τέτοιου είδους θέματα και πέραν των καρδιοχειρουργικών του ικανοτήτων, νομίζω, και στα θέματα οργάνωσης, πολιτικής, γραφειοκρατίας και εκπαίδευσης είναι ειδικός. Σας ακούμε, κυρία Αργυρίου, και ευχαριστούμε που είστε εδώ μαζί μας.
Ναι, με ακούτε?
Πάρα πολύ
Ακούγομαι?
καλά. Ναι, απλά να βάλουμε σε πλήρη οθόνη τις διαφάνειες.
Δεν το έχω. Ωραία, οκ. Καταρχάς θέλω να ευχαριστήσω την Οργανωτική Επιτροπή για την τιμητική πρόσκληση που μου έκανε να μιλήσω σε αυτό το session. Βέβαια είναι λίγο δύσκολο να μιλήσω μετά τον καθηγητή τον κύριο Μιχάλη, γιατί αναπτύσσει πιο ακαδημαϊκά ένα θέμα. Εγώ θα είμαι λίγο πιο στο on the job, ας πούμε. Κύριε καθηγητά, μπορείτε να με διακόψετε ό,τι ώρα θέλετε για σεβόμενοι το περιορισμένο χρόνο. Ευχαριστώ. Λοιπόν, δεν έχω conflict of interest και πρέπει να σας πω η ερώτηση είναι why. Δεν θα το περιορίσω στο training. Θέλω να σας πω ότι τα τελευταία χρόνια οι καρδιοχειρουργοί θέλουν από maximal invasive να γίνουν minimal invasive surgeons. Αλλάζει και πρέπει να μετατραπούν σε πιο λιγότερες επεμβάσεις. Μια δεύτερη απάντηση στην ιστορία που λέγεται why είναι γιατί υπάρχει ένας δείκτης ο οποίος λέγεται compound annual growth rate και είναι ο πιο σημαντικός δείκτης για ένα προϊόν και φαίνεται ότι αυτός ο δείκτης στην TAVI είναι πραγματικά εκρηκτικός, δηλαδή προβλέπουν μια αύξηση 18% για την Ασία και 13,8% για όλο τον κόσμο, που μεταφράζεται στην πράξη σε περίπου 13 δισεκατομμύρια κύκλο εργασιών μόνο για την TAVI, χωρίς να περιλαμβάνονται όλες οι υπόλοιπες Transcatheter. Και αυτό μόνο για την Αμερική και για 5 χώρες της Ευρώπης. Έτσι λοιπόν στο why, εκτός του ότι θέλουμε να έχουμε μια συμμετοχή σε αυτή την επανάσταση που γίνεται, είναι και γιατί βλέπουμε ότι στους υψηλού κινδύνου ασθενείς φαίνεται να γίνεται standard of care η διακαθετηριακή αντιμετώπιση των βαλβίδων. Επίσης φαίνεται ότι στους μέσου κινδύνου φαίνεται να είναι μια εναλλακτική, αποδεκτή εναλλακτική λύση. Τώρα για τους low risk μάλλον φαίνεται ότι θα πιεστούμε πολύ για να αποδεχτούμε ακόμη και αυτούς τους αρρώστους. Υπάρχουν δύο διαφορετικά πράγματα. Το ένα είναι το market pool και το άλλο είναι το technology pool. Το market pool είναι αυτό το οποίο υπάρχει ανάγκη για την αγορά και το άλλο είναι το technology pool, το οποίο μας πιέζει η αγορά για να μπορέσουμε να το αποδεχθούμε. Γιατί χρειάζεται όμως ένας καρδιοχειρουργός εκπαίδευση για τη στάβλη? Χρειάζεται γιατί έχει μαύρα μεσάνυχτα όσον αφορά τους καθετήρες και τα σύρματα. Χρειάζεται γιατί έχει μαύρα μεσάνυχτα όσον αφορά από τις ακτινοσκοπικές εικόνες. Μαύρα μεσάνυχτα ακόμα και στις δυσκολίες οι οποίες παρουσιάζονται κατά τη διάρκεια μιας τέτοιας επέμβασης. Σε μερικά κέντρα υπάρχει κάποια γνώση όσον αφορά την αξιολόγηση των αξονικών και επίσης έχει σχετική εμπειρία στα νοσοκομεία στα οποία κυρίως γίνεται επίγουσα καρδιοχειρουργική των διαφόρων προσπελάσεων. How, λοιπόν. Το δεύτερο ερώτημα είναι πώς. Ξεκινήσαμε το 2017 και η Επιτροπή Εκπαίδευσης, στην οποία ήταν και ο κύριος Δεδεηλίας και ο κύριος Δουγέννης, προτείναμε στο Υπουργείο να γίνει αλλαγή του τρόπου ειδικότητας και να πάρει 6 μήνες η επεμβατική καρδιολογία ή η επεμβατική πνευμονολογία και συγχρόνως να υπάρξουν 2 διαφορετικές κατευθύνσεις, μία καρδιοχειρουργική και μία θωρακοχειρουργική. Έτσι λοιπόν ο καρδιοχειρουργός που πρόκειται να βγει θα κάνει και 6 μήνες cath lab εκπαίδευση. Συγχρόνως, μέσα στο γνωστικό αντικείμενο της ειδικότητας, βάλαμε τις έχουν εμπειρία για τις άλλες οδούς προσπέλασης των αγγείων, έχουν εμπειρία στο να μπορέσουν γρήγορα να κάνουν μια στερνοτομή και να βάλουν στην εξωματική τον άρρωστο. Δεν έχουν εμπειρία όσον αφορά την εκτίμηση των αξονικών με αξονική τομογραφία του aortic root να μπορέσουν να εκτιμήσουν. Δεν έχουν καθόλου σχεδόν εμπειρία στις αγκιοπλαστικές των στεφανιαίων, δεν έχουν εμπειρία σε ανάγκη για valve-in-valve άμεσα την ώρα που γίνεται η πράξη έτσι και δεν έχει τοποθετηθεί σωστά. Επίσης δεν έχουν εμπειρία σε καινούργιες τεχνικές όπως είναι τα Sentinel, το Basilica ή το Intentional Fracture of the Fusion Ring. Έχουν όμως εμπειρία μετεγχειρητική. Ξέρουν καλή βηματοδότηση, ξέρουν την αιμοκάθαρση, ξέρουν τα εγκεφαλικά, ξέρουν την περικαρδιοκέντηση, ξέρουν να αντιμετωπίζουν όλοι οι καρδιοχειρουργοί τις αγκιακές επιπλοκές και έχουν εμπειρία με τις μεταγγίσεις. Μέχρι τώρα εμείς δουλεύαμε κατά κύριο λόγο ένα πρόγραμμα το οποίο ήταν το πιο απλό, το Radiant, όχι για κανέναν άλλο λόγο, αλλά γιατί ήταν κλεψιμέικο, δηλαδή μπορούσαμε να το κατεβάσουμε χωρίς να έχουμε πρόβλημα. Τώρα αρχίζουμε και χρησιμοποιούμε το Trimensio. Το Trimensio το χρησιμοποιούσαμε για τα αγκία, γιατί κάνουμε αρκετά θωρακοκυλιακά ανεβρίσματα τα οποία χρειάζονται branch και όλα τα υπόλοιπα. Wise skills. Η καρδιοχειρουργοί, η εμπειρία που είχαν μέχρι τώρα στα σύρματα ήταν στο μπαλόνι και στα κέντρα τα οποία κάνανε FET, στα οποία χρειαζόταν να μπορέσουν να κάνουν, εκτός εάν κάνανε ενδαγκιακή χειρουργική. Οι υπόλοιποι όλοι οι καρδιοχειρουργοί δυστυχώς δεν έχουμε καθόλου εμπειρία στα σύρματα και στους καθετήρες. Χρειάζεται κανένας να ξέρει, είναι 5% η ανάγκη για alternative access, αλλά και αυτό το 5% ένα κέντρο το οποίο θέλει να αντιμετωπίζει όλους τους αρρώστους πρέπει να μπορεί να το αντιμετωπίσει. Δεν φαίνεται να πέφτει στη διάρκεια των χρόνων ιδιαίτερα από το 5%. Ένα 5% θα μείνει από άλλη οδό. Χρειάζεται να ξέρουμε το valve-in-valve. Ναι, χρειάζεται, γιατί φαίνεται ότι μένει σταθερός στα emergency που πρέπει να βάλεις valve-in-valve επεμβάσεις. Έτσι λοιπόν προσδιορίζουμε ότι πρέπει να προσδιορίσουμε ποια είναι τα αδύνατα σημεία μας, και τα αδύνατα σημεία μας είναι διεγχειρητικά, procedural skills, με τους καθετήρες και με τα σύρματα, και επίσης πρέπει να κάνουμε ένα καλό planning, ας πούμε, και interpretation των απεικονιστικών μεθόδων. Στα κέντρα, πρέπει να πω ότι τα κέντρα τα οποία είναι πολύ εξοικειωμένοι με όλα τα σύρματα, Lander, Safari, Vertebral, όλα αυτά τα σύρματα χρησιμοποιούνται στην ενδαγκιακή χειρουργική, στα κέντρα τα οποία κάνουν ενδαγκιακή χειρουργική. Είναι πρόβλημα η εκπαίδευση, είναι μεγάλο πρόβλημα η εκπαίδευση. Κοιτάω ένα πρόγραμμα που υπάρχει στον Καναδά, και στον Καναδά λοιπόν διαπιστώνεται ότι με τους ειδικευόμενους, τους καρδιοχειρουργούς, κανέναν δεν τον αφήνουν ούτε να χειριστεί το τραπέζι. Καλά, εννοείται, το 100% δεν τους αφήνουν να ανοίξουν το delivery system, ούτε να κάνουν βαλβιδοπλαστική, ούτε καν να κάνουν crossing της βαλβίδας. Από την 1η Ιουλίου του 2017 στην Αμερική, στις Ηνωμένες Πολιτείες της Αμερικής έγινε υποχρεωτικό οι καρδιοχειρουργοί να έχουν 5 βαλβίδες σαν πρώτοι χειριστές και 10 βαλβίδες σαν βοηθοί, διαδερμικές βαλβίδες. Επίσης πρέπει να κάνουν 5 καθετηριασμούς για στεφανιογραφίες και να έχουν βάλει και 10 μπαλόνια. Όμως βλέπουμε ότι τελικά αυτό δεν είναι ευκταίο στην Αμερική, και σε ένα άρθρο το οποίο βγήκε λέει ότι δεν πειράζει, ας μπορούν να κάνουν μια προεγχειρητική αξιολόγηση του ασθενή και να μπορούν να αξιολογήσουν τον ασθενή, να κάνουν μια επιλογή της βαλβίδας, ποιο device χρειάζεται, να κάνουν κάποιες μετρήσεις βαλβίδας και να ξέρουν τα χειρουργικά βήματα, όπως επίσης και να ξέρουν την μετεγχειρητική φροντίδα, καθώς και επίσης και την αντιμετώπιση των επιπλοκών. Επειδή λοιπόν ως residents είναι μικρή η εκπαίδευση την οποία μπορούν να προσφέρουν, ξαναγυρνάω λίγο εκεί πέρα που είπε ο κύριος Μιχάλης τι θα πρέπει να έχουν. Θα πρέπει λοιπόν, η μία πρόταση είναι το fellowship να περιλαμβάνει 50 εκτιμήσεις αξονικών τομογραφιών για διαδερμική βαλβίδα, 25 σαν πρώτος χειριστής, 50 σαν δεύτερος ή τέλος πάντων συμμετέχουν σε αυτή την ιστορία, 10 transmitral, αυτό είναι λίγο υπερβολικό θα έλεγα, 20 στεφανιογραφίες ή τίβαρα ας πούμε, και να έχει συμμετοχή σε workshops τόσο για TAVI όσο και για Transcatheter. Για τη συμμετοχή των εταιριών στην εκπαίδευση δεν έχω καμία αμφιβολία ότι πράγματι οι εταιρείες προσφέρουν μεγάλη εκπαίδευση. Και ήδη όπως το είπε και ο καθηγητής, οι πρώτοι εκπαιδεύτηκαν από εταιρείες. Οι εταιρείες είναι κάθε φορά μέσα στην πράξη που γίνεται. Στην ορθοπαιδική 30 χρόνια ακόμα μπαίνουν οι εταιρείες μέσα και δίνουν συμβουλές. Δεν πρέπει να είμαστε ιδεολειπτικοί. Οι εταιρείες προσφέρουν καλή εκπαίδευση και στην απάντηση αν πρέπει να πάρουν και εσύ ή μη, αυτό νομίζω ότι εγώ θα ήμουν πάρα πολύ θετικός για κάτι τέτοιο. Το ερώτημα είναι αν πρέπει να είναι 6 μήνες ή 1 χρόνος. Πράγματι στην Αμερική υπάρχει συζήτηση γι' αυτό, αν θα πρέπει να είναι 6 μήνες ή 1 χρόνος το fellowship. Αλλά αυτό εξαρτάται από άλλους παράγοντες, εξαρτάται από το volume που έχει το κάθε κέντρο. Θα δημοσιευτεί αυτή τώρα η εργασία. Πήρανε 80 καρδιοχειρουργούς και 80 καρδιολόγους στην πολιτεία της Νέας Υόρκης για να δούνε το 2016 πώς πήγαν τα περιστατικά τους όταν τα κάνανε είτε καρδιολόγοι είτε καρδιοχειρουργοί. Είναι λίγο άδικο γιατί οι καρδιοχειρουργοί κάνανε το 72% ενώ οι καρδιολόγοι κάνανε το 28%. Είναι άδικο και για τις γυναίκες που είναι λιγότερο από 2%. Τι διαπιστώσανε? Μεγάλος αριθμός ξένων ήταν αυτοί, οι οποίοι δεν είχαν κάνει τη σχολή, τη βασική σχολή, την ιατρική στην Αμερική. Ένα 35% ήταν ξένοι. Αλλά αυτό που διαπιστώνουμε είναι ότι στην Αμερική υπήρξαν πάρα πολλοί οι οποίοι ήταν χωρίς να έχουν την πιστοποίηση της επεμβατικής καρδιολογίας. Τέλος πάντων, το συμπέρασμα σε αυτή τη μελέτη στα γρήγορα είναι ότι είτε το κάνει ο ένας είτε το κάνει ο άλλος, έχουν εξίσου καλά αποτελέσματα μέσα στο νοσοκομείο, in-hospital mortality outcomes. Που το ιδανικό είναι να γίνεται σε μια υβριδική αίθουσα. Έχουμε όλη υβριδική αίθουσα, δεν έχουμε. Ακόμα και στην Αμερική το 54,7% γίνεται σε υβριδική αίθουσα. Πρέπει να γίνεται σε υβριδική αίθουσα. Ναι, πράγματι. Γιατί υπήρξαν και εργασίες οι οποίες έχουν δημοσιευτεί μάλιστα και πρόσφατα, αν μπορεί να γίνει και σε κέντρα τα οποία δεν έχουν καρδιοχειρουργική. Μα η πιθανότητα του να συμβεί κάτι είναι πολύ μεγαλύτερη από ότι να σου συμβεί τροχαίο ατύχημα κατά τη διάρκεια που πηγαίνεις από εδώ πέρα στα Γιάννενα. Οπότε, ωστόσο, φοράμε την ασφάλεια, τη ζώνη ασφαλείας. Άρα, νομίζω ότι υποχρεωτικά θα πρέπει να γίνεται σε κέντρα τα οποία έχουν υβριδικές αίθουσες. Δυστυχώς, στην Ελλάδα έχουμε το πολύ αίθουσες υβριδικές. Η υβριδική αίθουσα απαιτεί μια αλλαγή νοοτροπίας. Δηλαδή, εκεί η συνεργασία, το collaboration είναι απαραίτητη προϋπόθεση και είναι ο κύριος στόχος. Και πρέπει να αλλάξει δηλαδή όλη η νοοτροπία, πώς αντιμετωπίζω τους συναδέλφους και πώς αντιμετωπίζω την άλλη ειδικότητα, το background από το οποίο προέρχονται όλοι αυτοί. Έτσι λοιπόν δεν θα πρέπει να σκεφτόμαστε με όρους, ας πούμε, ατομικούς για την αντιμετώπιση ενός ασθενούς, αλλά θα πρέπει να σκεφτόμαστε με όρους τι μπορούμε να κάνουμε όλοι μαζί για αυτόν τον ασθενή. Στο training by whom, εδώ είναι ένα λίγο δύσκολο θέμα, το οποίο θα πρέπει να εκπαιδευτούμε από διαφορετικές ειδικότητες. Δηλαδή πρέπει να εκπαιδευτούμε εμείς σαν καρδιοχειρουργοί από καρδιολόγους, από καρδιοχειρουργούς, από αγκιοχειρουργούς, από επεμβατικούς ακτινολόγους, από ακτινολόγους οι οποίοι του αξονικού. Πρέπει να αναγνωρίζουμε την μεγάλη συνεισφορά των ειδικών στις εταιρείες, καθώς επίσης και από τους μοναδίστες. Υπάρχουν εμπόδια στην εκπαίδευση, υπάρχουν εμπόδια. Το πρώτο εμπόδιο που φαίνεται να είναι ο χαμηλός αριθμός περιστατικών. Επίσης, φαίνεται είτε καρδιολόγοι είτε καρδιοχειρουργοί να μην θέλουν να εκπαιδεύσουν καινούριους ειδικευόμενους. Αυτό συναντιέται στην Αμερική και μάλιστα έχουν γίνει και παράπονα επίσημα. Τι θα μπορούσε να γίνει για να μπορέσει να γίνει ένα...
Αργυρίου, 2 λεπτά ακόμη.
Σε λιγότερο. Να γίνει μια συγκεντροποίηση, δηλαδή τα περιστατικά όλα να πηγαίνουν συγκεντρωμένα σε μία μεριά. Εμείς λοιπόν στο νοσοκομείο μας χρησιμοποίησαμε και τις 4 βαλβίδες, γιατί θεωρήσαμε ότι πρέπει να εκπαιδευτούμε και από τις 4. Ήρθανε όλοι οι Έλληνες και οι ξένοι ως πρόκτορες για να μπορέσουμε να εκπαιδευτούμε και κάποιοι από εμάς εκπαιδευτήκαν στο εξωτερικό, είτε από τις εταιρείες είτε σε ένα πρόγραμμα σε ασθενείς. Τι κάναμε διαφορετικό? Κάναμε το εξής. Όλοι θα πρέπει, οι επεμβατικοί καρδιολόγοι και όλοι οι καρδιοχειρουργοί θα πρέπει να συμμετέχουν σε αυτή την ομάδα. Δεν θα μπορεί να λείπει κάποιος με άδεια και να μην μπορεί να γίνεται μια τέτοια επέμβαση. Άρα λοιπόν όλοι πρέπει να έχουν μια συμμετοχή σε αυτό το πράγμα. Η αλήθεια είναι ότι οι καρδιοχειρουργοί είναι σε αδύναμη θέση σε αυτή την ιστορία για έναν και μόνο λόγο, ότι είναι μεγαλύτερης ηλικίας. Δηλαδή όλοι μας είμαστε πάνω από 61 χρονών, με αποτέλεσμα να μην μπορείς να μάθεις old dogs new tricks, είναι κάπως δύσκολο. Αυτή τη στιγμή το νοσοκομείο μετά τον κορονοϊό, μέσα σε 2,5 χρόνια, έχει κάνει ένα πρόγραμμα το οποίο συμμετέχουν όλοι. Έχει ενισχυθεί πάρα πολύ η υποδομή όσον αφορά τους αγκιογράφους, με biplane, με υβριδική αίθουσα, με C-arms. Αυτά ήταν τα καλά του κορονοϊού. Το κακά ήταν ότι γίναμε κορονοσοκομείο και ακόμα δεν έχουμε επανέλθει για να μην μπορούμε να δουλέψουμε. Το μεγαλύτερο πρόβλημα όμως δεν είναι τι εκπαίδευση θα κάνουμε. Το μας πρόβλημα σε εμάς είναι έχουμε ειδικευόμενους στην καρδιοχειρουργική. Όχι μόνο στην Ελλάδα, αλλά και στο εξωτερικό. Ευχαριστώ πολύ.
Σας ευχαριστώ και εγώ πάρα πολύ, κύριε Αργυρίου, για την πολύ ωραία παρουσίαση. Νομίζω ότι αν...
Κύριε Βάρντα, έχουμε χρόνο για ένα γρήγορο σχόλιο ή το έχουμε υπερβεί?
Γιατί να μην το κάνουμε στο τέλος το σχόλιο, αφού έχουμε ακούσει και τους άλλους δύο συναδέλφους, οι οποίοι θα μιλήσουν τώρα, και από εκεί και πέρα θα δούμε τι χρόνος έχει μείνει για να μπορέσουμε
ερωτήσεις στο τέλος.
Κάνουμε ακριβώς αυτό. Τώρα που έχω μπροστά μου το πρόγραμμα, λοιπόν, θα ήθελα να παρακαλέσω να ακούσουμε 2 εκλεκτούς συναδέλφους, έναν από την Αθήνα και έναν από την Κύπρο, σχετικά με το ίδιο θέμα που το παρουσιάζουν 2 διαφορετικοί άνθρωποι από 2 διαφορετικές πρωτεύουσες. Το θέμα είναι device approval and reimbursement, different landscapes, και ως εκ τούτου θα πρέπει να ακούσουμε την άποψη του κυρίου Κανακάκη, που είναι πρόεδρος της Ελληνικής Καρδιολογικής Εταιρείας, και μετά να ακούσουμε και την άποψη του κυρίου Γεωργίου από την Κύπρο. Κύριε Κανακάκη.
Καλησπέρα και από μένα. Ευχαριστώ πολύ για την πρόσκληση, την Οργανωτική Επιτροπή, για αυτό το υψηλό επίπεδο συνέδριο με διεθνή συμμετοχή, που συνεχίζεται και φέτο. Του χρόνου ελπίζω να είμαστε όλοι από κοντά. Θα είμαι πολύ σύντομος για να μπορέσει, γιατί αυτό το θέμα θέλει πιο πολύ συζήτηση και από τους ανθρώπους που έχουν εμπειρία γύρω από αυτό. Γι' αυτό θα είμαι πολύ σύντομος, μια και εγώ δεν ανήκω σε κέντρο που έχει τη δυνατότητα λόγω καρδιοχειρουργικής, μη ύπαρξης καρδιοχειρουργικής κλινικής να ενεργεί TAVI. Λοιπόν, η αορτική στένωση, η βαλβίδα της είναι η πιο συχνή βαλβιδική πάθηση στις δυτικές χώρες με ευξημένη επίπτωση. Και η TAVI αυτή τη στιγμή είναι αυτή που έχει επικρατήσει σαν επέμβαση στους ασθενείς που δεν μπορούν να χειρουργηθούν και στους υψηλού κινδύνου ασθενείς. Και βέβαια τα ευνοϊκά αποτελέσματα στους ενδιαμέσους και χαμηλού κινδύνου ασθενείς τη βάζει πάλι στο παιχνίδι και σε αυτή την κατηγορία. Έτσι, ο αριθμός των εμφυτεύσεων φαίνεται ότι θα αυξηθεί τα επόμενα χρόνια 4-5 φορές πάνω στην επόμενη δεκαετία. Και έτσι υπάρχει το πρόβλημα της ποιο θα είναι το cardiovascular care σε αυτή την περίπτωση και βέβαια αν είναι cost effectiveness η βαλβίδα και ποια είναι η οικονομική επίπτωση που έχει στα περιορισμένα budget των χωρών στον τομέα της υγείας, όπως είναι και η Ελλάδα. Ποιοι είναι λοιπόν οι παράγοντες που μπορούν να εμποδίσουν αυτή την επέκταση της TAVI? Είναι τα δεδομένα από το durability της βαλβίδος, πόσο καιρό δηλαδή μπορεί να είναι σε καλή κατάσταση. Αυτή τη στιγμή έχουμε δεδομένα 5 με 8 χρόνια. Από 5 έως 8 χρόνια έχουμε δεδομένα. Αν δεν έχουμε καλά δεδομένα μακροχρόνια, τότε δεν θα επεκταθεί η βαλβίδα στους νέους και στους χαμηλού κινδύνου ασθενείς. Πρέπει το heart team να λειτουργεί πάρα πολύ καλά σε σχέση και με το κόστος σε φουτίλ ασθενείς, εκεί που υπάρχουν σοβαρά comorbidities και δεν υπάρχει μεγάλη περίπτωση μακράς επιβίωσης. Πρέπει να είναι πολύ καλά οργανωμένοι και όλα αυτά έχουν σημασία για το reimbursement και για το οικονομικό πρόβλημα που αφορά τις διαβαλβητικές επεμβάσεις. Αυτή είναι μια διαφάνεια από μια μελέτη στο European Heart Journal που έδειξε ότι ποια είναι οι πραγματικές ανάγκες των χωρών στην Ευρώπη και στη Βόρεια Αμερική. 118.000 είναι περίπου στην Ευρώπη, γύρω στις 60.000 στην Αμερική και εδώ μέσα συμπεριλήφθηκε η χώρα μας. Αυτό που θέλω να πω εδώ είναι από πρόσφατα δεδομένα που δώσαμε εμείς σαν ελληνική καρδιολογική εταιρεία τον Άτλαντα, που ξέρει ο κύριος Βάρδας που έχει ασχοληθεί ιδιαίτερα. Τα τελευταία 2 χρόνια στη χώρα μας οι βαλβίδες TAVI είναι από 650-680 περίπου ετησίως. Και βλέπετε εδώ ότι οι πραγματικές ανάγκες της χώρας, όπως είναι αυτή τη στιγμή, κυμαίνονται από 1.800 έως 4.000, με μέσο όρο κοντά στις 3.000 βαλβίδες. Πρέπει να μπαίνουν και μπαίνουν 650. Τώρα, αν αυτό επεκταθεί στους ενδιαμέσου και χαμηλού κινδύνου ασθενείς, τότε οι πραγματικές ανάγκες στη χώρα μας φτάνουν κοντά στις 6.000 οι βαλβίδες. Και αυτή τη στιγμή μπαίνουν, είπαμε, γύρω στους 680. Στην επιτροπή που συμμετέχω και εγώ στο Υπουργείο για την έγκριση, συζητήσαμε πρόσφατα και για τους ενδιαμέσου κινδύνου ασθενείς με θετική εισήγηση και για τους ενδιαμέσου κινδύνου ασθενείς για TAVI. Όπως καταλαβαίνετε, μπαίνει αμέσως ένα θέμα για τη χώρα μας, θέμα κόστους και ποια είναι τα μέτρα τα οποία μπορεί να κάνουν την TAVI cost effectiveness procedure. Είναι ότι θα πρέπει να γίνεται καλή επιλογή των ασθενών, ούτως ώστε αυτοί που έχουν προσδόκιμο επιβίωση πάνω από 1 έτος και δεν είναι χειρουργήσιμοι θα πρέπει να επιλέγονται. Επίσης, τώρα θα επεκταθούμε και στους ενδιαμέσους κινδύνου ασθενείς και στους υψηλού κινδύνου ασθενείς και πρέπει να δούμε το κόστος πώς είναι εκεί. Θα πρέπει, για να είναι cost effectiveness η επέμβαση, θα πρέπει να χρησιμοποιείται η διαμοιραία προσπέλαση. Φαίνεται ότι με τις άλλες προσπελάσεις, διακορυφαία και δεν υπάρχουν στοιχεία ότι η επέμβαση αυτή είναι cost effectiveness. Και βέβαια για να είναι και στις άλλες κατηγορίες, και στους διαμέσους και στους χαμηλού κινδύνου ασθενείς, για να μπορεί η επέμβαση αυτή να είναι οικονομικά συμφέρουσα, θα πρέπει να μειωθούν στο ελάχιστο οι επιπλοκές της επέμβασης, όπως είναι η παραβαλβητική διαφυγή, το stroke και η ανάγκη για βηματοδότηση. Να γίνεται όσο γίνεται πιο μίνιμαν η επέμβαση, μετά την εμπειρία που έχει αποκτηθεί σε ορισμένα κέντρα. Και βέβαια το σημαντικό, για το οποίο θέλω να το συζητήσουμε, κύριε Βάρδα, αν έχουμε στο τέλος χρόνο, είναι ότι πρέπει να γίνεται διαπραγμάτευση για τη τιμή του kit, του TAVI, και τη τιμή της βαλβίδος. Και βέβαια θα πρέπει το ICER, δηλαδή το Incremental Cost Effectiveness Ratio, το ICER, να είναι κάτω από το ακαθάριστο εγχώριο προϊόν, το ανακεφαλή ακαθάριστο εγχώριο προϊόν. Και αυτό δεν είναι έτσι στις περισσότερες χώρες μεσαίου και εισοδήματος. Ακόμα και στη χώρα μας είναι οριακά. Δεν έχουν γίνει όμως μελέτες στη χώρα μας πάνω σε αυτό. Θυμίζω ότι αυτό το ICER είναι η διαφορά ανάμεσα σε 2 μεθόδους που χρησιμοποιούμε, δηλαδή είναι η ποιοτική εκτίμηση μιας επέμβασης. Αυτό που λέμε QALY. Και τώρα, δεδομένα για το cost effectiveness έχουμε από εδώ για τους ασθενείς που δεν είναι χειρουργήσιμοι. Εκεί 98% είναι cost effectiveness υπάρχει για την βαλβίδα. Επίσης, στους υψηλού χειρουργικού κινδύνου ασθενείς. Ένα ερώτημα που υπάρχει στη βιβλιογραφία, τι γίνεται με τους ενδιαμέσους και χαμηλού κινδύνου ασθενείς. αν υπάρχει πραγματικά, αν είναι οικονομικά συμφέρουσα η TAVI. Και τα δεδομένα που έρχονται από το TCT, αυτό είναι από το Derstein στην Καλιφόρνια και από το Houston, από το Ohio, δείχνουν ότι με ένα κόστος που ξεπερνάει τις $4.000, έχουμε καλύτερη επιβίωση και ποιότητα ζωής με την TAVI έναντι της χειρουργικής επέμβασης και στους low risk ασθενείς. Αυτό είναι μια σημαντική μελέτη και δείχνει δηλαδή ότι η TAVI σε χαμηλού κινδύνου ασθενείς είναι cost effective και οι ευκαιρίες για να το κάνουμε αυτό σε καλά κέντρα και στη χώρα μας είναι να μειώσουμε το κόστος της ίδιας επέμβασης αλλά και τις επιπλοκές. Μόνο με αυτές τις περιπτώσεις θα έχουμε στους χαμηλού κινδύνου ασθενείς αποδοτικότητα. Και βλέπετε ότι σε σύγκριση η νοσοκομιακή θνητότητα ήταν 3,3% στη χειρουργική αντιμετώπιση και 2,3% στην διαβραβητική προσπέλαση. Επομένως, έχουμε στοιχεία σε αυτό. Αυτό που δείχνει χρόνο με το χρόνο πάλι από το TCT η σύγκριση της TAVI με τη χειρουργική αντιμετώπιση δείχνει ότι σιγά σιγά το κόστος της TAVI ελαττώνεται, ελαττώνοντας λίγο το κόστος της βαλβίδας της ίδιος, αλλά και το ίδιο το κόστος των υλικών που χρησιμοποιούνται και της παραμονής στο νοσοκομείο. Και έτσι έρχεται σε ίδια επίπεδα ή ακόμα και καλύτερα το 2017 από το 2014 σε σχέση με τη χειρουργική αντιμετώπιση. Γιατί γίνεται αυτό? Γίνεται γιατί μειώνει σημαντικά το χρόνο παραμονής στο νοσοκομείο. Στα ελληνικά νοσοκομεία, από συναδέλφους και μπορεί να μας πούνε και μετά, λένε ότι μπορεί να μείνουν 1 με 2 μέρες αν πάει πολύ καλά η επέμβαση και να βγουν οι ασθενείς. Βλέπουμε από το 2014 μέχρι το 2017 ότι από 7,6 μέρες παραμονή πήγαμε στις 3,8 μέρες με την TAVI. Λατώθηκε και στην χειρουργική αντιμετώπιση, αλλά κατά 17% μόνο, έναντι 51% στην TAVI η διάρκεια παραμονής στο νοσοκομείο και αυτό έχει σημαντική επίδραση στο κόστος. Τώρα, τι αναμένεται μέχρι το 2025? Αναμένεται ότι θα έχουμε πολύ μεγάλη αύξηση μέχρι και τετραπλασιασμό των διαδερμικών επεμβάσεων στις βαλβίδες και εδώ που μιλάμε για την TAVI, με κρατούσα τη διαμοιραία προσπέλαση, η οποία είναι και cost effective. Γιατί, όπως είπα, θα αυξηθεί και η transapical, λιγότερο η transaortic, αλλά δεν θα είναι δεν έχουμε στοιχεία ότι θα είναι cost effective μέθοδος. Τι γίνεται τώρα με τα μοντέλα πληρωμής? Στην Ελλάδα έχουμε το CAN, αλλά βλέπετε ότι υπάρχουν διάφοροι τρόποι πληρωμής στην Ευρώπη. Υπάρχει το DRG στις βόρειες χώρες, υπάρχει το Fee for Service and Device, αυτό είναι νομίζω ότι είναι στο Βέλγιο. Το DRG και Add-on Reimbursement, αυτό γίνεται στη Γαλλία και στην Ηνωμένο Βασίλειο και περιοχικά και στην Ιταλία μπορεί να υπάρχει Add-on Reimbursement. Τώρα υπάρχει ακόμα και διαβάθμιση στην αποζημίωση αναλόγως με το ύψος της βαλβίδας, αυτό είναι περιορισμένο, αλλά δεν θυμάμαι σε ποια χώρα. Πάντως αυτά είναι τα δεδομένα και η πρώτη τελευταία διαφάνεια είναι αυτή, είναι από το European Heart Journal το 2021 που έχει τη χώρα μας εδώ και δείχνει ότι το πόσο θα χρησιμοποιήσουμε τη διαδρυμική παρέμβαση στις βαλβίδες εξαρτάται από το ακαθάριστο εγχώριο προϊόν ανακεφαλή και βλέπετε ότι είμαστε λίγο πάνω από την Τουρκία και την Πολωνία, τη Ρουμανία και την Αίγυπτο, αλλά είμαστε κάτω από όλες τις χώρες της Κεντρικής και Βόρειας Ευρώπης και από τη Σλοβενία και από την Ισπανία και από το Βέλγιο. Άρα εξαρτάται πάρα πολύ από τι ακαθάριση εγχώριο προϊόν έχει η χώρα και μην ξεχνάμε ότι βγαίνουμε από μια οικονομική κρίση 10 ετών, ακολουθεί επιδημία και το ερώτημα είναι γιατί να έχουμε αυτή την τιμή, την πήρα από το Ιπποκράτη, μου δίνει ο κύριος Τούτουσας, γιατί να έχουμε αυτό το CAN με 18.927 η βαλβίδα και 35.000 το CAN. Και το ερώτημα είναι, και το θέλω για συζήτηση, γιατί τελειώνω με αυτή τη διαφάνεια, είναι γιατί εμείς δεν μπορούμε να κάνουμε μια κεντρική διαπραγμάτευση για τις βαλβίδες, όπως έκανε το Ισραήλ και η Ουγγαρία, που έχει 6.000 και 8.000 τη βαλβίδα και εμείς μια χώρα με αυτά τα προβλήματα να την έχουμε σε 18.927 το kit της βαλβίδας. Αυτό είναι ένα σημαντικό ερώτημα, γιατί έχει να κάνει και με την επέκταση των κέντρων διαδρυμικής αντιμετώπισης των βαλβίδων που αποφασίσαμε στην Επιτροπή του Υπουργείου. Ένα μεγάλος αριθμός κέντρων έχει πάρει έγκριση, βέβαια θα κριθεί με το ΦΕΚ στα 2 χρόνια και ιδιωτικών και δημόσιων νοσοκομείων, αλλά με αυτή την τιμή της βαλβίδας είναι αδύνατο να αποκτήσει το learning curve, είναι αδύνατο να αποκτήσουν τις προϋποθέσεις για να συνεχίσουν κέντρα εφύτευση βαλβικών βαλβίδων. Όπως είπα στην αρχή, για τη χώρα μας οι ανάγκες, όταν πάμε σε διαμέσους και χαμηλού κινδύνου, θα φτάσουν τις 6.000 βαλβίδες, από 4.500 μέχρι 6.000 βαλβίδες στο τέλος. Το άλλο είναι ότι για το Mitra Clip δεν υπάρχει το Edge Repair και γίνονται αιτήσεις στο ΑΙΣ, στο Ανώτερο Υγειονομικό Συμβούλιο, και να πάρουν έγκριση χρηματοδότησης χωρίς να υπάρχει κενό, όπως και για τις δομικές καρδιοπάθειες το ίδιο. Αυτή τη στιγμή στη χώρα μας τρέχει ένας κεντρικός διαγωνισμός και γίνεται σε διαβούλευση για τις βαλβίδες και για τα άλλα υλικά επεμβατικής καρδιολογίας. Και το ερώτημα είναι κατά πόσο μπορούμε μέσα από αυτό το κεντρικό διαγωνισμό να μειώσουμε τη τιμή της βαλβίδος για να μπορούμε να έχουμε βιώσιμα κέντρα με καλά αποτελέσματα σε αυτό το θέμα. Ευχαριστώ πολύ για την προσοχή.
Ευχαριστώ πάρα πολύ, κύριε Κανακάκη, για την πολύ ενδιαφέρουσα παρουσίαση. Και τώρα θα περάσουμε να ακούσουμε την άποψη του κυρίου Γεωργίου. Απλά θα ήθελα να τονίσω ένα πράγμα, ότι φαντάζομαι να συμφωνείτε, ότι όλα αυτά τα οποία είπατε, από μόνα τους, τεράστιας σημασίας, για να χωρέσουν θέλουν μια ημερίδα, την οποία έχουμε ήδη προγραμματίσει εμείς σαν εταιρεία καρδιαγγικής έρευνας που ασχολείται με θέματα υγείας και οικονομίας, να την κάνουμε κάποια στιγμή, διότι είναι δραματικά σημαντικά και αληθινά αυτά τα οποία είπατε. Αλλά ας ακούσουμε πρώτα και τον κύριο Γεωργίου και μετά θα επανέλθουμε. Απλώς θέλω να επισημάνω ένα πράγμα μόνο πριν δώσω το μικρόφωνο στον κύριο Γεωργίου. Στον κύριο Αργυρίου. Άκουσα με πολύ προσοχή αυτό το οποίο είπε ο κύριος Αργυρίου για το Compound Annual Growth Rate. Ένα νούμερο που το χρησιμοποιώ τα τελευταία 10 χρόνια στην Ευρώπη. Και θέλω να περάσω ένα μήνυμα. Κοιτάξτε πώς αλλάζει η καρδιολογία. Η McKinsey το 2012, όταν την καλέσαμε στην Ευρωπαϊκή Καρδιολογική Εταιρεία να μας κάνει μια εκτίμηση των επόμενων ετών, της επόμενης πενταετίας, πώς θα είναι τα πράγματα, μας είπε ότι τα πράγματα θα είναι δύσκολα, διότι το Compound Annual Growth Rate της φάρμακοβιομηχανίας είναι minus 13% ετησίως. Minus 13% ετησίως. Okay? Compound Annual Growth Rate. Και ο κύριος Αργυρίου και πολύ σωστά είπε ότι αυτό το νούμερο για την βαλβίδα έχει εκθετικό χαρακτήρα, έχει τεράστιο χαρακτήρα. Αλλάζει δηλαδή η όλη σημασία της οικονομίας στην καρδιολογία. Κύριε Γεωργίου, το βήμα είναι δικό σας.
Καλησπέρα κύριε Πρόεδρε, καλησπέρα και στους υπόλοιπους εκλεκτούς συνομιλητές. Θα ήθελα να ευχαριστήσω για ακόμα μια φορά την Οργανωτική Επιτροπή για τη μεγάλη τιμή. Κατά γενική παραδοχή, ελάχιστες είναι εκείνες οι ιατρικές παρεμβάσεις που το γνώρισαν τέτοια καταξίωση μέσα σε ένα τόσο μικρό διάστημα, σε ένα σύντομο χρονικό διάστημα των λίγων χρόνων, όπως η διακαθητηριακή εμφύλιψη ορτικής βαλβίδας. Υπολογίζεται ότι τον επόμενο μήνα, σε όλο τον κόσμο, θα έχουν διενεργηθεί στο σύνολο 1 εκατομμύριο τέτοιες επεμβάσεις. Δεν μπορεί όμως κανείς να παραβλέψει τις μεγάλες ανισότητες που παρατηρούνται μεταξύ διαφόρων χωρών στην υιοθέτηση αυτής της τεχνικής. Έτσι, για παράδειγμα, πρόσφατα δεδομένα που κυκλοφόρησαν πριν από λίγες εβδομάδες, στη Γερμανία διενεργούνται περίπου 300 τέτοιες επεμβάσεις ανά 1 εκατομμύριο πληθυσμού ανά έτος, ενώ ο μέσος ευρωπαϊκός όρος είναι 141 τέτοιες επεμβάσεις και στην Ελλάδα, όπως ανέφερε προηγουμένως ο κ. Κανακάκης, είναι κοντά στις 60. Εντύπωση προκαλεί και ο μεγάλος αριθμός των κέντρων όπου διενεργούνται επεμβάσεις TAVI στις διάφορες ευρωπαϊκές χώρες, με την Ελλάδα να κρατά τα ενία. Κάπου εκεί είναι και το ποσοστό της Κύπρου, ανά 1 εκατομμύριο πληθυσμού, είναι περίπου 4 κέντρα ανά 1 εκατομμύριο πληθυσμού, στα οποία διενεργούνται αυτές τις επεμβάσεις. Και αυτό έχει τη σημασία του. Να μου επιτρέψετε τώρα να κάνω μια σύντομη αναφορά στα δρόμενα της Κύπρου όσον αφορά στο σύστημα υγείας, γιατί έχει και αυτό τη σημασία του. Μέχρι πρόσφατα είχαμε ένα σύστημα το οποίο είχε εφαρμοστεί από την εποχή της απεικιοκρατίας και στην ουσία έχει εξελιχθεί σε δύο παράλληλα ανταγωνιστικά συστήματα, εκείνο του δημόσιου και εκείνο του ιδιωτικού τομέα, τα οποία στην ουσία ήταν δύο υδροκέφαλα συστήματα με πολλά προβλήματα. Το σύστημα, τόσο από την κοινωνία όσο και από τους ίδιους τους λειτουργούς υγείας, είχε κατά επανάληψη κριθεί ως ανεπαρκές και δυσλειτουργικό. Η γύραση του πληθυσμού, που οδηγούσε και στην αύξηση του επιπολασμού των χρόνιων νοσημάτων, Το ψηλό κόστος των υπηρεσιών υγείας, αλλά και η πρόοδος που καταγράφεται το τελευταίο χρόνο στην ιατρική και στην τεχνολογία της ιατρικής, επέβαλαν την ριζική μεταρρύθμιση του. Η ιστορία του ΓΕΣΥ, του Γενικού Συστήματος Υγείας, είναι μακρά. Ξεκίνησε πριν από 20 περίπου χρόνια. Τροποποιήθηκε νομοθεσία 5 τουλάχιστον φορές. Οι αρμόδιοι για την εφαρμογή του και τον σχεδιασμό του έτυχαν συμβουλής και γνώμης από εξειδικευμένους οργανισμούς, όπως αυτό που ανέφερε ο καθηγητής κ. Βάρδας στον McKinsey προηγουμένως, αλλά και τον Παγκόσμιο Οργανισμό Υγείας, και εστίασαν γενικά σε ένα σύστημα το οποίο να είναι καθολικό, να είναι κοινωνικά αλληλέγγυο και να δίνει το δικαίωμα στον ασθενή να επιλέγει τόσο το θεράποντα γιατρό, όσο και το κέντρο στον οποίο θα νοσηλευτεί και από το οποίο θα λάβει ιατρικές υπηρεσίες. Το νέο σύστημα υγείας, το οποίο εφαρμόστηκε από την 1η Ιουνίου του 2019, πριν από ακριβώς 2 χρόνια, όσον αφορά την εξονοσοκομιακή φάση, και πριν από ένα ακριβώς χρόνο, 1η Ιουνίου του 2020, για την ενδονοσοκομιακή φάση, βασίζεται κυρίως σε συνεισφορές εργοδοτών, εργαζομένων, καθώς και από μέρος των γενικών εισόδων του κράτους, ενώ η συνεισφορά του καθενός έχει στην ουσία προκαθοριστεί και στην ουσία παρέχει μια καθολική κάλυψη. Δικαιούχοι είναι όλοι οι πολίτες οι οποίοι έχουν την συνήθη διαμονή τους στο κράτος, στις ελεγχόμενες περιοχές από το κράτος. Στοχεύει στο να είναι οικονομικά βιώσιμο, έχει ένα σφαιρικό προϋπολογισμό, τον οποίο απαγορεύεται να το υπερβεί ο οργανισμός, ο οποίος είναι ο αρμόδιος για την εφαρμογή του συστήματος, και παρέχει ένα ευρύ φάσμα υπηρεσιών υγείας. Εδώ βλέπετε τον τρόπο με τον οποίο καλούνται οι μισθωτοί, οι συνταξιούχοι, αλλά και το κράτος να συνεισφέρει σε αυτό το σύστημα υγείας. Αξίζει αναφοράς ότι ο κόσμος, η πολιτεία και γενικά ο κόσμος αγκάλιασε το σύστημα υγείας, δεν διαμαρτυρήθηκε για τη νέα φορολογία που στην ουσία επιβλήθη για να μπορεί να έχει αυτές τις υπηρεσίες υγείας, αναγνωρίζοντας όλη την ανάγκη να εφαρμοστεί το νέο σύστημα. Το σύστημα λοιπόν συμμετέχουν παροχής υπηρεσιών υγείας τόσο από τον δημόσιο όσο και από τον ιδιωτικό τομέα, οι οποίοι είναι συμπεριμένοι με τον ασφαλιστικό φορέα, τον Οργανισμό Ασφάλισης Υγείας, που είναι ένα νομικό πρόσωπο δημοσίου δικαίου και είναι αρμόδιο τόσο για την εφαρμογή του, όσο και για τη ρύθμιση και για τον υποπτικό ρόλο που η πολιτεία του ανάθεσε. Ο δικαιούχος έχει δικαίωμα ελεύθερης επιλογής του κέντρου και του γιατρού από τον οποίο θα τύχει ιατρικών υπηρεσιών. Το επίκεντρο του συστήματος είναι ο ρόλος του φύλακα, του gatekeeper, τον οποίο διαδραματίζει ο προσωπικός γιατρός, γιατροί με εξειδίκευση στη γενική ιατρική, στην εσωτερική παθολογία και στην παιδιατρική, και ο ρόλος των ασθενών στα κέντρα λήψης αποφάσεων σταδιακά ενδυναμώνεται. Όσον αφορά τώρα την ενδονοσοκομιακή περίθαλψη, ασκείται από όλα τα δημόσια νοσηλευτήρια του νησιού, τα οποία πλέον διοικούνται από ένα ξεχωριστό οργανισμό, τον Οργανισμό Κρατικών Υπηρεσιών Υγείας. Μέχρι πρόσφατα τη διοίκηση των νοσοκομείων την είχε κεντρικά το Υπουργείο. Να αντιλαμβάνεστε, για 6 επαρχίες να διοικεί τα 6 νοσοκομεία της Ελεύθερης Κύπρου το Υπουργείο Υγείας. Πόσο υδροκέφαλο ήταν αυτό το σύστημα και πόσα προβλήματα είχε. Οι 5.000 επαγγελματίες υπάγονται πλέον του τομέα της υγείας στο δημόσιο, υπάγονται πλέον σε αυτόν τον οργανισμό. Η ενδονοσοκομιακή περίθαλψη ασκείται φυσικά και από τα συμπευλημένα με τον Οργανισμό Ασφάλισης Υγείας ιδιωτικά νοσηλευτήρια. Περίπου 90% των νοσηλευτηρίων του ιδιωτικού τομέα αυτή τη στιγμή είναι συμπευλημένα με το σύστημα. Η βασική μονάδα αποζημίωσης διαφέρει από νοσηλευτήριο σε νοσηλευτήριο. Και ισχύει το εξής παράδοξο, ότι ένα κέντρο μπορεί να αποζημιώνεται για μια εγκιοπλαστική, για παράδειγμα, με ένα α ποσό, και ένα β κέντρο με ένα α ποσό συν κάτι ή πλην κάτι. Αυτό καθορίστηκε με βάση τον αριθμό των διαθέσιμων κλινών, την πληρότητα των παρεχόμενων υπηρεσιών υγείας, τη διαθεσιμότητα εντατικής θεραπείας, αλλά και του τμήματος πρώτων βοηθειών. Ήταν στην ουσία όμως ένα καλό εργαλείο στα χέρια του Οργανισμού Ασφάλισης Υγείας για να διασπάσει στην ουσία τα ιδιωτικά νοσηλευτήρια, τα καλούσε ένα-ένα ξεχωριστά και με αυτόν τον τρόπο μπορούσε να καθορίσει και τη βασική μονάδα αποζημίωσης τους. Η αποζημίωση γίνεται με βάση τα DRGs, τα Diagnosis Related Groups. Είναι ένα σύστημα προοπτικής αποζημίωσης τόσο των κρατικών νοσοκομείων όσο και των ιδιωτικών κλινικών με βάση την πρωτογενή διάγνωση. Όσον αφορά τώρα τον ιδιωτικό τομέα, για σκοπούς εφαρμογής του σφαιρικού προϋπολογισμού, για σκοπούς λοιπόν, κάποιο λόγο έχω χάσει μια διαφάνεια. Λοιπόν, για σκοπούς εφαρμογής του σφαιρικού προϋπολογισμού, η κάθε υπηρεσία αναπροσαρμόζεται μηνιαίως ανάλογα με τον όγκο των υπηρεσιών και των περιστατικών, ούτως ώστε η δαπάνη να μην υπερβαίνει την προϋπολογηθήσα για τη συγκεκριμένη ομάδα υπηρεσιών. Έχουν οριστεί οι ελάχιστες τιμές αμοιβής από τον Οργανισμό Ασφάλισης Υγείας για τους γιατρούς. Σημειώστε ότι το 90% των γιατρών εξακολουθούν να είναι ελεύθεροι επαγγελματίες, δεν είναι υπάλληλοι των ιδιωτικών νοσηλευτηρίων, και καθορίστηκε ο κατάλογος Z των ιατροτεχνολογικών προϊόντων και αναλώσιμων, στα οποία περιλαμβάνονται και συσκευές εμφύτευσης, τόσο των Tavios και των Mitra Clip. Και εδώ ίσως είναι το σπουδαιότερο, ότι ο Οργανισμός Ασφάλισης Υγείας είναι ο καθήλυν αρμόδιος για τη διαπραγμάτευση και την αγορά των αναλωσίμων. Τόσο τα κρατικά όσο και τα ιδιωτικά νοσοκομεία πάβουν να έχουν την υποχρέωση να διαπραγματεύονται ξεχωριστά για την αγορά των αναλωσίμων. Τα αγοράζει κεντρικά ο οργανισμός και τα διανέμει μετά από μια συγκεκριμένη διαδικασία στα κέντρα τα οποία είναι συμπευλημένα με τον οργανισμό. Για να γίνει αποζημίωση ιατρικών παρεμβάσεων στις δομικές παθήσεις της καρδιάς, απαιτείται η θετική κατάληξη της ομάδας καρδιάς, καρδιοχειρουργική κάλυψη on-site, πιστοποίηση από τις εταιρείες κατασκευής βαλβίδας ότι ένας επεμβατικός καρδιολόγος μπορεί να εφαρμόσει αυτόνομα και να διενεργήσει αυτόνομα αυτή την εμφύτευση, συμπλήρωση και υπογραφή ενός σχετικού πρωτοκόλλου, το οποίο θα δούμε σε λίγο, και την προέγκριση από την Ειδική Επιτροπή του Οργανισμού Ασφάλισης Υγείας. Σε αντίθεση λοιπόν με τις αγκιοπλαστικές, όπου πάμε απευθείας και διενεργούμε τις πράξεις χωρίς να παίρνουμε προέγκριση, για όλες αυτές τις παθήσεις, τις δομικές παθήσεις της καρδιάς, απαιτείται προέγκριση. Εδώ είναι το πρωτόκολλο το οποίο θα πρέπει να συμπληρωθεί και θα πρέπει να σταλεί στον Οργανισμό Ασφάλισης Υγείας για προέγκριση. Σε αυτό περιλαμβάνεται ρητά η αναφορά ότι υπάρχει καρδιοχειρουργική κάλυψη on-site και ότι ο επεμβατικός καρδιολόγος είναι πιστοποιημένος να κάνει αυτή την επέμβαση. Περιλαμβάνονται επίσης όλα τα στοιχεία που αφορούν το ανατομικό αναμνηστικό του ασθενή, εξετάσεις οι οποίες μερικές φορές είναι πελαλίτικες, αλλά οφείλουμε να τις κάνουμε, όπως πυρομέτρηση και μερικές φορές έλεγχο καροτίδων κλπ. Και αξονική αγκιογραφία, καθετηριασμός καρδιάς, υπερηχογράφημα καρδιάς, διαθωρακικό και μερικές φορές και δυσοφάγιο, και ακολούθως, αφού καταγραφεί τόσο το Euroscore 2 όσο και το STS Score και επεξηγηθεί ο ρόλος για τον οποίο η ομάδα καρδιάς αποφάσισε να παραπέμψει αυτό το πρωτόκολλο για έγκριση, και αφού το απογράψει ο καρδιολόγος και ο καρδιοχειρουργός, αποστέλλεται στον Οργανισμό Ασφάλισης Υγείας. Το πρωτόκολλο αυτό το αναρτά ο επεμβατικός καρδιολόγος στον ηλεκτρονικό ιατρικό φάκελο του ασθενή, ενώ σχετική ειδοποίηση αποστέλλεται και στον οργανισμό για σκοπούς προέγκρισης. Η ιατρική λειτουργία του οργανισμού, οι οποίοι είναι μόνιμοι υπάλληλοι εκεί στον οργανισμό, προβαίνουν σε αξιολόγηση του αιτήματος και σε περίπτωση που πληρούνται τα κριτήρια, τότε μέσα σε ένα εύλογο χρονικό διάστημα που δεν ξεπερνά τις 2 εβδομάδες, ενημερώνεται ο επεμβατικός καρδιολόγος ότι η επέμβαση έχει εγκριθεί. Αυτή είναι η ιστοσελίδα στην οποία αναρτούμε τις προεγκρίσεις, και για αυτή τη στιγμή, έτσι, για να κάνω μια αναφορά στα TAVI, 3 βαλβίδες είναι εγκεκριμένες από το σύστημα, η βαλβίδα της Edwards ως balloon expandable και 2 self-expanding βαλβίδες, αυτή της Medtronic και αυτή η Accurate Neo της Boston. Σε περίπτωση που η ιατρική λειτουργία του οργανισμού κρίνουν πως ένα αίτημα δεν δικαιολογείται επαρκώς, έχουν τη δυνατότητα να ζητήσουν γνωμάτευση από ομάδα καρδιολόγων, τα οποία ορίστηκαν από την καρδιολογική εταιρεία. Προσωπικά δεν γνωρίζω ποια είναι αυτά τα 2 άτομα στα οποία έχει αναθέσει η καρδιολογική εταιρεία το ρόλο αυτό. Είναι άτομα τα οποία δεν έχουν σύγκρουση συμφερόντος και δεν είναι άτομα που ασκούν επεμβατική καρδιολογία στο επίπεδο να κάνουν επεμβάσεις TAVI ή Mitra Clip. Το Τμήμα Οικονομικής Διαχείρισης του ΟΑΗ διενεργεί την άμεση διαπραγμάτευση με τις εταιρείες για την κοστολόγηση και την αγορά των αναλωσίμων και των συσκευών. Όπως είπα και προηγουμένως, στα ιατρικά κέντρα δεν έχουμε καμία ανάμειξη με την αγορά ακριβών αναλωσίμων. Για την αποφυγή προσυνεννόησης στις τιμές μεταξύ των κυρίαρχων στον χώρο των συσκευών εταιριών, ο Οργανισμός Ασφάλισης Υγείας, στην ουσία μετά και από υπόδειξη των κέντρων επεμβατικής καρδιολογίας, προχώρησε σε ποσόστοση της αγοράς συσκευών. Γνωρίζοντας ότι στην πλειονότητα των περιπτώσεων ένα 80% μπορεί να γίνει με οποιαδήποτε βαλβίδα, ο οργανισμός λέει στις εταιρείες το 80% των συσκευών θα αγοράζονται από μια εταιρεία. Οπότε τους αναγκάζει να προβούν σε μειώσεις των τιμών, ούτως ώστε να είναι πιο ανταγωνιστικές για να μπορέσουν να κερδίσουν το 80% της αγοράς από την πίτα της αγοράς των αναλωσίμων. Και μια εικόνα για το τι γίνεται αυτή τη στιγμή στην Κύπρο. Θα αναφερθώ κυρίως στη διακαθετερική εμφύτευση αορτικής βαλβίδας, γιατί για τα Mitra Clip είναι κάτι καινούριο σε εμάς. Τώρα έχει ξεκινήσει τόσο στο δημόσιο όσο και στον ιδιωτικό τομέα. Όσον αφορά στα TAVI, το 2019 έγιναν περίπου 125 επεμβάσεις, 80 στο δημόσιο και 45 στον ιδιωτικό τομέα. Το 2020, με 7 μήνες εφαρμογή του συστήματος, αυτός ο αριθμός ανέβηκε στις 190 επεμβάσεις, 100 δηλαδή στο δημόσιο και 90 στον ιδιωτικό τομέα, όσο για το 2021 υπολογίζω ότι περίπου θα γίνουν μέχρι και 240 επεμβάσεις μέσα σε αυτό το χρόνο. Και αν πάμε πίσω σε αυτή τη διαφάνεια που είδαμε προηγουμένως, η Κύπρος το 2019 ήταν κάπου εκεί και το 2021 προβλέπω ότι θα ανεβεί κάπου εδώ, όπως βλέπετε στην διαφάνεια. Κύριε Πρόεδρε, αγαπητοί συνάδελφοι, είναι κατά γενική ομολογία ένας δείχτης για την αξιολόγηση της οικονομικής κατάστασης μιας χώρας, αλλά και η κατάσταση της δημόσιας υγείας είναι το καθόριστο εγχώριο προϊόν, το προσδόκιμο επιβίωσης, η περιγεννητική θνητότητα και πολλοί άλλοι τέτοιοι δείχτες. Κατά την προσωπική μου άποψη, από την πλευρά ενός καρδιολόγου, η ποιότητα ζωής αλλά και η πραγματική δημόσια υγεία εξαρτάται από την ικανότητα ενός πολίτη να έχει πρόσβαση σε σύγχρονες φαρμακευτικές θεραπείες, να μπορεί να υποβληθεί σε πρωτογενή αγκιοπλαστική σε οποιοδήποτε μέρος της χώρας βρίσκεται και να μπορεί να γίνεται επέμβαση TAVI σε προχωρημένες ηλικίες και εκεί που ενδείκνυται. Κλείνοντας και αναγνωρίζοντας και τιμώντας το ρόλο του καθηγητή κ. Βάρδα στην καρδιολογία, όχι μόνο στα στενά γεωγραφικά πλαίσια της Ελλάδας, αλλά και στην Κύπρο και στην υπόλοιπη Ευρώπη, θα αναφέρω τα λόγια του γκουρού της καρδιολογίας, ενός άλλου γκουρού, του Ευγένιου Μπράουνβολτ, ότι ζούμε μια ιστορική στιγμή αναφορικά με αυτές τις επεμβάσεις των δομικών παθήσεων και θα είμαστε περήφανοι και θα το λέμε στα εγγόνια μας ότι είμαστε και εμείς μέρος αυτής της μεγάλης επιτυχίας. Ευχαριστώ για την προσοχή σας.
Ευχαριστώ πάρα πολύ, κύριε Γεωργίου, και δεν σας κρύβω ότι με κολακεύετε εξαιρετικά. Όπως είπα και νωρίτερα, σε αυτή την session, απόψε, την τελευταία, τίθενται θέματα τεραστίας σημασίας. Είναι άλλωστε, αν θέλετε, αυτό που από το 2010 εξήγησα στην Ευρωπαϊκή Καρδιολογική Εταιρεία, η οποία περιέργως ήταν εντελώς sleepy, θυμότανε, ότι η καρδιολογία, εάν θέλουμε να δώσουμε τον ορισμό της καρδιολογίας, δεν είναι μόνο η επιστήμη της καρδιολογίας. Είναι τα οικονομικά της καρδιολογίας, είναι τα socio-economics τα οποία σχετίζονται με την καρδιολογία και την ιατρική ευρύτερα. Είναι τα gaps, τα inequalities, ο τρόπος με τον οποίο εφαρμόζονται οι guidelines και που απόψε εδώ, με την ευκαιρία του ότι απευθύνομαι σε senior καρδιολόγους, ψαγμένους καρδιολόγους, να μιλήσω έτσι τη γλώσσα που όμορφα χρησιμοποιεί ο κύριος Αργυρίου κατά καιρούς, για ψαγμένους καρδιολόγους, αυτό γίνεται σαφές. Απόψε, ειδικά σε αυτή τη συζήτηση. Με την ευκαιρία, Γιάννη, το slide το οποίο σου παρουσίασες από τον Μπερμέχο, της ομάδας του Baumgartner, είναι παρμένο από τον Άτλαντα. Τον Άτλαντα, το οποίο φτιάξαμε με τον Εμμάνουελ τον Μπαρμπάτο και το οποίο δημοσιεύσαμε και δείξαμε ότι είναι ενδεικτική, όχι αποδεικτική, ενδεικτική η σχέση του ακαθαρίου εθνικού προϊόντος με τον αριθμό των επεμβάσεων που γίνονται. Εντάξει. Τώρα, δεν θα πω τίποτα άλλο, είναι τεράστιο θέμα και νομίζω ότι όλοι εσείς...
Συγγνώμη πάνω. Αυτό που λες ακριβώς δεν ισχύει μόνο για τις βαλβίδες. Το είχαμε δει και για την πρωτογενή αγιοπλαστική πάλι. Ότι είχε να κάνει με το...
Ασφαλώς. Πάντως, με ένα μικρό αστεράκι, δεν θέλω να πω σε λεπτομέρειες, αλλά οι στατιστικολόγοι για αυτό τον πίνακα που έδειξες και κάτι συναφείς πίνακες, μας πήραν πολύ χρόνο. Δεν ήθελαν με τίποτα να χρησιμοποιήσουμε τη λέξη significant, διότι δεν είναι στατιστικά αποδεδειγμένο αυτό, είναι ενδεικτικό, είναι indicative, ότι σχετίζεται, έτσι. Αλλά επειδή την κάνω τη συζήτηση, επειδή είσαστε senior άνθρωποι και θέλω να είμαι σαφής. Όμως, νομίζω ότι θα συμφωνήσετε ότι αυτά τα θέματα πρέπει να συζητηθούν σε μια ημερήσια, σοβαρή συζήτηση και να δούμε πολλά θέματα. Τώρα, εγώ θέλω να αναδείξω ένα-δύο θέματα και θέλω τη γνώμη σας και μετά θα μιλήσει και ο κύριος Πατακός ασφαλώς και όλοι εσείς. Ένα θέμα το οποίο δεν με ικανοποιεί για τη χώρα μου είναι ότι μένει σιωπηλή μπροστά στις εξελίξεις της τριγλόχινας και της μητροειδούς οπλοάς διακαθαριακών βαλβίδων. Εσείς πολύ λογικά μιλήσετε κυρίως για TAVI. Και μιλήσετε κυρίως για TAVI, γιατί αυτή τη στιγμή στην οθόνη αυτό που γίνεται επίσημα reimbursed και διορθώστε με αν κάνω λάθος, είναι το TAVI. Το Εθνικό Σύστημα Υγείας επισήμως δεν έχει αποφασίσει τι θα κάνει μπροστά στις εξελίξεις, στις δραματικές εξελίξεις των διακαυτεριακών προσθέσεων, βαλβίδα, επιδιορθώσεων, όπως θέλετε να το πούμε, της μητροειδούς και της τριγλόκινος. Αυτά δεν μπορούν να παραμείνουν σιωπηλά. Στο έτσι πρέπει να τα δούμε με ουσιαστικότητα, να τα αναδείξουμε και να δούμε και στη τελευταία ανάλυση τι θα κάνουμε. Παλαιότερα είχαμε το ίδιο πρόβλημα με τους απεινιδωτές, 20 χρόνια πριν, έτσι. Δεν ξεκινάει η καρδιολογία σήμερα. Και εγώ τότε είχα πει πριν 20 χρόνια, δεν μπορεί η νέα τεχνολογία να μπλοκαριστεί. Βρέστε 15 κέντρα που τα εμπιστεύεστε και δώστε την ευκαιρία για ένα αριθμό πράξεων, ιδιωτικά και δημόσια. Κάτι κάντε όμως. Θέλω να σταματήσω εδώ και να ρωτήσω εάν υπάρχουν θέματα τα οποία πρέπει να συζητήσουμε απόψε, εκτός από αυτό που ανέφερε. Ή να μιλήσετε, κύριε Κανακάκη, θέλετε από εσάς να ξεκινήσουμε για το θέμα της πώς το βλέπει η πολιτεία, αν έχετε γνώση, το θέμα της τριγλόκινος και της μητροειδούς.
Για το θέμα της μητροειδούς θα δοθεί, πιστεύω, πολύ σύντομα ΚΕΝ, γιατί έχει πάρθει υπό απόφαση από την Επιτροπή ότι θα πρέπει να δοθεί ΚΕΝ και σε ποια κατηγορία ακριβώς με στοιχεία από τις μελέτες τις πρόσφατες, ποια ακριβώς θα είναι η ομάδα η οποία θα πρέπει να κάνει mitra clip ή edge-to-edge repair, δεν αφορά μόνο το mitra clip. Αλλά για το θέμα της τριγλόκινος πιστεύω ότι θα υπάρξει καθυστέρηση. Δεν θα υπάρχει άμεσα. Περιμένουμε δηλαδή περισσότερα στοιχεία για να μπορέσουμε να προχωρήσουμε στην Επιτροπή από ό,τι γνωρίζω. Τώρα, όσον αφορά το θέμα του reimbursement, εδώ, όπως τόνισα και στην ομιλία, υπάρχει και ένα θέμα. Έχει μείνει σταθερή η τιμή. Υπάρχει αυτή τη στιγμή ένας κεντρικός διαγωνισμός. Έχουν βγει προδιαγραφές, έχει βγει σε διαβούλευση. Είναι ευκαιρία να μπορέσει να μειωθεί η τιμή της TAVI για να μπορέσουν τα κέντρα που έχουν πάρει έγκριση να ανταποκριθούν. Αλλιώς δεν πρόκειται να ανταποκριθούν. Με τόσο αργή, είπε ο κ. Γεωργίου ότι μέσα σε 2 εβδομάδες στην Κύπρο δίνουν απάντηση για το θέμα της βαλβίδας. Εδώ, για να πάρεις απάντηση, να περάσει στα δημόσια νοσοκομεία ένας χρόνος. Είναι μεγάλο το διάστημα. Δηλαδή, δεν νομίζω ότι μπορεί να γίνει κάτι.
Θέλω να σταματήσουμε εδώ. Βλέπω μια ειδοποίηση και επειδή είμαι πολύ ευαίσθητος σε αυτά, ότι έχουμε υπερβεί το χρόνο κατά 10 λεπτά. Το οποίο δυστυχώς είναι δερματικά μεγάλη η καθυστέρηση αυτή. Δεν μπορούμε να κάνουμε συζήτηση. Έγιναν ωραίες παρουσιάσεις, βγήκαν συμπεράσματα, αλλά τι λέτε, κύριε Πατακέ, που είστε και από τους βασικούς οργανωτές? Όταν το μήνυμα είναι ότι έχουμε καθυστερήσει 10 λεπτά και περιμένουν τόσοι συνάδελφοι, εγώ θεωρώ ότι πρέπει να σταματήσω τώρα, αυτή τη στιγμή.
Κύριος Πάργης.
Νομίζω ο κύριος Πατακός έχει αποχωρήσει.
Κύριε Σπάνια, τι λέτε? Πέστε μας εσείς.
Εγώ έπρεπε να κάνω ένα PCR test για να είμαι OK για την επόμενη εβδομάδα, γι' αυτό έλειψα για 1-2 ώρο, να πάω και να έρθω.
Όχι, άλλο λέω.
Πρόλαβα και παρακολούθησα τις τελευταίες 2-3 ομιλίες. Ομολογώ ότι πρόλαβα και άκουσα από τον κύριο Αργυρίου και μετά. Ό,τι άκουσα με βρίσκει σύμφωνο 100%. Εντυπωσιασμένος με το μοντέλο της Κύπρου. Είναι απίστευτο το ότι η Κύπρος φέτος και του χρόνου θα έχει TAVI implantation rate όπως η Γερμανία και εμείς παραμένουμε στατικοί όλα αυτά τα χρόνια. Νομίζω όλη αυτή η δυσλειτουργικότητα πρέπει να ξεπεραστεί, διότι πλέον αρχίζει να γίνεται εμφανές ότι ο αντίκτυπος είναι στους ασθενείς. Νομίζω ότι πρέπει να σκεφτόμαστε όλους αυτούς τους ασθενείς. Είναι κρίμα ένας ασθενής που μπορεί να αντιμετωπιστεί διακαθηριακά και αντιμετωπίζεται έτσι στην Κύπρο, στη Γερμανία, οπουδήποτε στην Ευρώπη, να λύνεται το πρόβλημά του και εδώ να μην παίρνει πρακτικά καμία απάντηση για πάρα πολύ καιρό και να καταλήγει σε περίεργους δρόμους και διαδρομές για να λύσει το πρόβλημά του. Νομίζω ότι αυτά πρέπει να λυθούν και όπως είπε ο κύριος Κανακάκης και όπως ακούσαμε ότι γίνεται στην Κύπρο, αυτά λύνονται με μια κεντρική καθοδήγηση και αγορά όλων αυτών των ακριβών συσκευών κεντρικά σε πολύ χαμηλότερες τιμές, οπότε έτσι πάβει να ισχύει το επιχείρημα ότι είναι ακριβά τα υλικά και δεν πάβει να ισχύει
επιχείρημα. Νομίζω ότι όλα αυτά θα γίνουν πολύ σύντομα και νομίζω ότι πρέπει να προχωρήσουμε στο επόμενο session, γιατί έχουμε πάρα πολλούς συναδέλφους με πολλά ενδιαφέροντα περιστατικά μητροειδούς και τριγλόχινας, πιστεύω, σήμερα. Χτες φτάσαμε στις 10:30 το βράδυ και ήταν ίσως ένα από τα πιο ενδιαφέροντα sessions και ελπίζω...
Ωραία, πρέπει να προχωρήσουμε.
Μια κουβέντα θα ήθελα να πω, κύριε Βάρδα, προτού τελειώσουμε. Ένα μόνο πράγμα. Νομίζω ότι είναι μια πολύ καλή πάσα προς εσάς να οργανωθεί διαμέσου της Cardio Research, να πάρει την πρωτοβουλία και να κάνει επιτέλους αυτή την ημερίδα. Νομίζω ότι το πρόβλημα ξεκινάει από εμάς. Θα πρέπει να αποενοχοποιηθούμε. Οι καρδιολόγοι πάσχουν από ένα έντονο ενοχικό σύμπλεγμα ότι ξοδεύουν τα λεφτά των συμπολιτών. Δεν τα ξοδεύουν οι καρδιολόγοι. Οι καρδιολόγοι έχουν κάνει δραματικές μειώσεις στους προϋπολογισμούς για την καρδιολογία. Αυτό πρέπει να τελειώσει. Το χρωστάμε στην επιστήμη, το χρωστάμε στους αρρώστους μας. Η αποενοχοποίηση είναι το βασικό πρόβλημα. Και αυτό
αυτή η απενοχοποίηση είναι σημαντικό. Είναι σημαντικό. Θυμάμαι που έλεγα ότι ένας βηματοδότης στοιχίζει 0,7 ευρώ την ημέρα και είναι το πιο cost-effective προϊόν που έχει παράγει η ιατρική, έτσι. Και το ακούγανε έτσι περίεργα. Αλλά θέλω να σταματήσω γιατί έχω μεγάλο σεβασμό στους επόμενους. Θα υπάρχουν εκλεκτήσεις.
Αλλά αυτό ήθελα να πω και νομίζω ότι έχετε πλέον την ευθύνη να το οργανώσετε.
Ωραία, ευχαριστώ πάρα πολύ για την δουλειά μου.
Μία τελευταία κουβέντα, κύριε Βάρδα, για να ενισχύσω αυτό που είπε ο κύριος Μιχάλης για την ενοχή των καρδιολόγων. Για παράδειγμα, δεν υπάρχει καμία ενοχή των καρδιοχειρουργών όταν κάνουν μία τριγλόχινα isolated, η οποία είναι 2B ένδειξη. Και δεν υπάρχει κάποιος που να απαγορεύει ή έστω τέλος πάντων να συζητάει για το αν θα πρέπει να γίνει αυτό ή όχι. Έτσι γίνονται ελεύθερα.
Είναι μεγάλο το θέμα, θα το συζητήσουμε άλλη φορά, διότι άμα ξεκινήσουμε τώρα να συζητάμε καρδιοχειρουργία, σταματάμε εδώ. Σταματάμε. Προχωράμε στην επόμενη κυρία προς τους τεχνικούς.
Καλησπέρα σας και από εμάς, μετά από ένα καταιγιστικό session σε ένα εκπληκτικό συνέδριο με διεθνούς φήμης ομιλητές. Θα μπούμε και στην καθημερινή πράξη που, όπως και χθες, και πάλι τράβηξε μεγάλο ενδιαφέρον, και γρήγορα λόγω στενότητας χρόνου να περάσουμε στον καρδιοχειρουργό μας, τον κύριο Χριστόφορο Κοτούλα, ο οποίος θα μας παρουσιάσει πρώτος ένα ενδιαφέρον περιστατικό. Κύριε Κοτούλα, το πόντιμο δικό σας.
Καλησπέρα και από μένα, ακούγουμε.
Μια χαρά.
Θα σας παρουσιάσω, ευχαριστώ πάρα πολύ για την τιμή. Θέλω να πω ότι το νοσοκομείο το δικό μας, το 401, το πρόγραμμα ξεκίνησε το 2013, διεκόπη το 2018 και πιστεύουμε πολύ σύντομα να ξαναρχίσουμε. Η ομάδα του 2013 μέχρι το 2018 είναι αυτή που βλέπουμε και το περιστατικό στο οποίο θα παρουσιάσουμε. Πρόκτορας ήταν ο καθηγητής ο κύριος Τούτουζας. Πρόκειται για ασθενή 69 χρονών, νύχα 3, με χρόνια AF, με PTCA στη δεξιά το 2010, καπνιστής, βαρύς, με κατανάλωση αλκοόλ, σοβαρή και λιπόδη διήθηση ύπατος και δυσλιπιδεμία. Προηγούμενος καθητηριασμός έδειξε ότι ήταν βατή η ενδοπρόθεση δεξιά και υπήρχε στον πρώτο διαγώνιο 90% και στον LAD 60%. Σοβαρή στένωση της αορτής με πολύ σοβαρή ανεπάρκεια τριγλόχινος, με πολύ υψηλή πίεση πνευμονικής, μεγάλη περικαρδιακή συλλογή υπάρχουσα, χωρίς εικόνα όμως επιβωματισμού, 11 Euroscore 1. Παρόλα αυτά είχε πορσελανοειδή ανιούσα αορτή, όπως φαίνεται και στις αξονικές, έτσι ώστε και μεγάλη καρδιά, έτσι ώστε αποφασίστηκε από το χάρτη με το νοσοκομείο ότι πρέπει να κάνουμε τάβη. Βλέπουμε όμως ότι υπήρχε διάχυτη αθυρομάτωση τόσο στα μοιραία αλλά όσο και στις υποκλίδιες. Καλή γωνία. Βλέπετε εδώ πέρα αναλυτικά ότι η δεξιά ήταν απαγορευτική με 3,8 mm, η αριστερά πολύ ωριακή, 8,3 σαντιμέτρια από την ανιούσα για να μπούμε, διακορυφαία μπορούσαμε να μπούμε, προβλήματα στις δύο υποκλίδες και από εκεί και πέρα ετηθήκαμε στο ΚΕΣΥ να κάνουμε διακορυφαία, γιατί πιστεύαμε ότι έτσι θα μπορούσαμε να κάνουμε πιο καλή προσπέλαση. Σκεπτόμενοι ότι από όλα αυτά θα ήταν το καλύτερο το διακορυφαίο. Η ομάδα καρδιάς μαζί με τον καθηγητή τον κύριο Τούτουζα συσκεφθήκαμε ξανά και τελικά αποφασίσαμε ότι ίσως ήταν στο οριακό, στο πολύ οριακό, στην πολύ οριακή διάμετρο της αριστερής μοιραιάς να προχωρήσουμε από εκεί. Για την επιτυχία όμως και για την αποφυγή προβλημάτων, η επέμβαση έγινε με τοπική αναισθησία και μέθη, αλλά κάναμε cut down έτσι ώστε να μην έχουμε περαιτέρω προβλήματα. Πραγματικά, όπως φαίνεται εδώ πέρα, προωθήσαμε τη βαλβίδα, και μέσα από όλα αυτά τα προβλήματα τελικά ανοίξαμε τη βαλβίδα σιγά σιγά. Η τοποθέτησή της ήταν πάρα πολύ καλή, όπως βλέπετε, για να μην ήταν ελάχιστη η παραβαλβιδική, χωρίς προβλήματα, και παρόλα αυτά εμφάνιση κολποκυλιακού αποκλεισμού ασθενής, βάλαμε βηματοδότη και έφυγε καλά την 5η μεταχειρητική μέρα. Το θεαματικό είναι ότι η σωστή τοποθέτηση της βαλβίδος είχε ως αποτέλεσμα και το χαμηλό gradient, όπως βλέπετε, είχε μια ταχύτητα 2,35, σε σύντομο χρονικό διάστημα να παρουσιάσει εξαφάνιση σχεδόν της περικαρδιακής συλλογής, και πτώση των πιέσεων, που σημαίνει περιπτώσεις χωρίς άλλα πράγματα. Σας ευχαριστώ πολύ που με ακούσατε.
Ευχαριστούμε και εμείς τον κύριο Κοτούλα. Ενδιαφέρον περιστατικό. Δείχνει ότι και εμείς οι καρδιοχειρουργοί μπορούμε να έχουμε ένα ρόλο πέρα από την άποψη και τη γνώμη για το heart team, και σίγουρα το μέλλον σε αυτές τις θεραπείες ενέχει και επεμβατικότητα και χειρουργική ίσως δυνότητα. Τα συγχαρητήριά μας. Εάν θέλουν οι συνάδελφοι του πάνελ να συζητήσουν την προσπέλαση και τα δεδομένα, το μόνο δικό μου σχόλιο είναι ότι είναι εμφανές ότι αυτοί οι ασθενείς με τη δυσλειτουργία της δεξιάς και με τα υπόλοιπα προβλήματα έχουν μια μοναδική ευκαιρία με τη διακαθετηριακή μέθοδο, ενώ χειρουργικά, ακόμη και στα πιο έμπειρα χέρια, θα ήταν μια σημαντική περιπέτεια αυτό το χειρουργείο. Τελικά,
να κάνω ένα σχόλιο αναφορικά με την εντόπιση μιας βλάβης μέτριας ενδιάμεσης βαρύτητας στον πρόσθετο εκατοντά κλάδο, που είναι κάτι συχνό που βρίσκουμε την ώρα που διερευνούμε το ενδεχόμενο να προβούμε σε διακαθετηριακή εμφύτευση χειρουργείο σε τέτοιους ασθενείς. Και είναι πάντα η απόφαση έτσι δύσκολη και θα πρέπει να βασιστεί σε δεδομένα. Είναι γεγονός πως πολλές φορές βρισκόμαστε προδιλήμματος τι πρέπει να κάνουμε. Θα πρέπει να επαναιματώσουμε δηλαδή τον πρόσθετο εκατοντά κλάδο, για να θα πρέπει να το αφήσουμε φαρμακευτικά. Σε αυτό τρέχει βιβλιογραφία φυσικά αναφορικά με το αν θα πρέπει να αντιμετωπίσουμε τη στεφανία νόσο πριν, κατά ή μετά το TAVI. Απλώς μια αναφορά στο ρόλο των λειτουργικών δοκιμασιών, που μπορεί ο πνευματικός καρδιολόγος να μετρήσει αυτή τη βλάβη με τα pressure wires, που έχουν αρκετή αξιοπιστία, παρά το γεγονός ότι αρχικά αμφισβητήθηκαν. Τόσο το IFR όσο και το FFR μπορούν να συνδράμουν σε αυτή την προσπάθεια της εντόπισης της βαρύτητας μιας βλάβης. Απλώς να κρατάμε υπόψη ότι το FFR θα πρέπει να είναι κάτω από 0,82 και όχι κάτω από 0,8 που συνηθίζουμε να λέμε για τις υπόλοιπες βλάβες. Ευχαριστώ.
Κύριε Γεωργίου, συγγνώμη, να απαντήσω. Θεωρήθηκε ότι το σημαντικό ήταν η στένωση και σε δεύτερο χρόνο θα βλέπουμε. Το θεαματικό είναι ότι ο ασθενής είναι...
Το πρόβλημα ήταν η αορτική στένωση, δεν υπάρχει.
Το θεαματικό είναι ότι αυτός ο πολύ βαριά ασθενής με τα συνυπάρχοντα προβλήματά του είναι ακόμα εν ζωή και είναι σε καλή κατάσταση. Ευχαριστώ πάρα πολύ.
Ευχαριστούμε. Να προχωρήσουμε στο επόμενο, κύριε Γεωργακόπουλε.
Καλησπέρα και από μένα. Θα προχωρήσουμε με το επόμενο περιστατικό. Θα παρουσιαστεί από την κυρία Αγγέλη. Θα είναι σε μαγνητοσκόπηση σε βίντεο. Η κυρία Αγγέλη, όπως ξέρετε, είναι καθηγήτρια στην πρώτη πανεπιστημιακή κλινική στο Ιπποκράτιο. Και ας ξεκινήσουμε με το βίντεο.
Good evening, ladies and gentlemen. I would like to present an interesting case. This is a man, 82 years old, with severe MR. He presents worsening dyspnea on exertion lately. The history is presented in this slide. He has hypertension, hyperlipidemia. He has a history of cabbage and PCA. He has also asthma and chronic kidney disease. The medications are presented. And concerning according to ECG, he has a pacemaker, and we present also the the cath lab data. According to the evaluation, the STS risk mortality is high, and the Euro risk 2 score is also high. And the patient is determined to be high for surgical mitral valve replacement due to age, surgical reparation, and comorbidities. And the patients, I have to remind, that has severe MR and also severe TR. Heart team plan is to proceed to age-to-age mitral valve repair with mitral clip. And what about the severe TR? We decided to proceed to mitral clip implantation in order to improve the symptoms, stabilization of kidney function, and further escalation of medical HF therapy. And you see the first transophageal view. You see that the left ventricular is enlarged with depressed ejection fraction, no LA thrombus and no pericardial effusion. And you see 3D of mitral valve morphological data from LA perspective. You see a degenerative mitral valve with class between P1 and P2 and P2 and P3 segments. We measured the AP diameter and intercommissional diameter. And you see also, using color Doppler, the severe MR, the regurgitant volume calculated 65 millimeters, and PASP was a high 72 millimeter of mercury. We recorded the pulmonary vein velocities. You see the planted systolic velocity compared to diastolic. And we proceed to the mitral clip implantation. First step is atrial septal puncture. Using color Doppler, we demonstrate the severe mitral regurgitation and the clip oriented to the regurgitant area. Clip oriented to the mitral valve. And we crossed the mitral valve to grasp the leaflets successfully. After the first implantation, the residual mitral valve regurgitation was moderate, so we proceed to the second clip implantation. You see that the two clips are parallel. And the post-implantation of the second device, you see that the residual MR is mild and the mitral valve gradient is 2 millimeters of mercury. And using 3D, we demonstrate pre and post procedural mitral valve regurgitation, which is acceptable, and pre and post pulmonary vein recordings. You see the normalization of pulmonary vein velocities and the significant reduction of V wave after final LA pressure recorded. And finally, we demonstrate the iatrogenic ASD, which is measured 0.9 centimeter. But interestingly, we demonstrate sun directionality mainly right to left. As we have already decided by our team, we continue with clip implantation, off-label application of mitral clip in tricuspid valve. You see them guiding the clip towards the tricuspid valve. We try not to interfere with the pacemaker leads. You see that the clip is oriented at the tricuspid valve regurgitation. Transgastric view, you see the clip that is implanted between anterior and this direction is a correct direction. You see again the tricuspid leads using the 3D evaluation and the clip. After grasping of TR leaflets, you see that the TR, using color Doppler, you see that TR is significantly reduced. And using fluoroscopy, we demonstrate the 3 clips, 2 at the mitral valve and 1 at the tricuspid valve. So the question is, closed or not to close the iatrogenic ASD? we know that the magnitude of right to left shunts depends on PV resistance or systemic vascular resistance, PA pressures, and shunt diameter. And recently, we have presented that there is a significance of shunt directionality of iatrogenic atrial septal defect in different clinical scenarios. There are no enough data, and there are conflicting findings in the literature, with other studies showing that the majority of iatrogenic ASD spontaneously close within 12 months. But what about the mitral clip implantation? There are some concerns of iatrogenic ASDs closure, particularly for patients with non-ideal mitral clip outcomes. In cases with elevated right atrial pressures, the shunt right to left should result to a reduction of right ventricular pressures without significant changes in the left ventricular pressures. No data have been published about the clinical significance of long-term subclinical deoxygenation following iatrogenic atrial septal defect formation. So we decided not to close. We left the left ventricle and right ventricle to retrain on the new loading conditions. Maybe in the future a bioabsorbable or puncturable ASD device should be implanted. So far, due to COVID era, we had only telephone follow-up, and the patient was in a good clinical condition in EHA 2, and the saturation is 92%. Thanks for your attention.
Ένα πολύ καλό αποτέλεσμα από την ομάδα του Ιπποκρατίου στο βαρύ αυτό περιστατικό. Θα ήθελα να ζητήσω αν θέλει να σχολιάσει κάποιος το γεγονός ότι η απόφαση ήταν η ταυτόχρονη τοποθέτηση των κλιπς τόσο στη μητροειδίως και στην τριγλόχυνα βαλβίδα. Δεδομένου του καλού αιμοδυναμικού αποτελέσματος μετά το mitral clip στη μητροειδή, θα άφηνε κανείς την τοποθέτηση των clip στην τριγλόχυνα σε δεύτερο χρόνο ή θα προχωρούσατε ούτως ή άλλως με την ταυτόχρονη τοποθέτηση?
Να κάνω εγώ μία παρέμβαση.
Ναι.
Καλησπέρα σε όλους. Είναι ένα μεγάλο δίλημμα. Οι μελέτες δείξαν ότι εάν διορθώσουμε τη μητροειδή με το mitral clip σε ένα ποσοστό 40-50% βελτιώνει την τριγλόχυνα, χωρίς ωστόσο να μπορούμε να προβλέψουμε 100% ποιοι από αυτούς τους ασθενείς θα βελτιωθούν. Σε αντίθεση με την χειρουργική πρακτική που όταν γίνεται χειρουργείο στη μητροειδή βαλβίδα θεωρούμε σωστό να κάνουμε και την τριγλόχυνα εφόσον έχει σημαντική ανεπάρκεια ή διάταση του δαχτυλίου σύμφωνα με τα guidelines. Εδώ έχουμε τη δυνατότητα να επανέλθουμε στον ασθενή και να δούμε σε δεύτερο χρόνο την τριγλόχυνα 2 ή 3 ή 4 μήνες μετά εφόσον επιμένει. Για λόγους κόστους βέβαια σε κάποιους ασθενείς έχουμε κάνει ταυτόχρονες επιδιορθώσεις, αλλά νομίζω ότι είναι πιο σόφρο να πάμε βήμα-βήμα και να το δούμε το όλο θέμα σε δεύτερο χρόνο.
Ευχαριστούμε τον κύριο Νινιά για το σχόλιο.
Νίκο, ένα σχόλιο και από σε αυτό. Είχαμε το μεσημέρι ένα session με τον Βαντελέμπεν και με τον Hausleiter που συζητήσαμε αυτό. Και αυτοί οι δύο που είναι πολύ high volume στην τριγλόχυνα και οι δύο έχουν διαφορετικό approach. Ο Γιώργο Hausleiter είπε ότι τα κάνει ταυτόχρονα, αν είναι σημαντική η ανεπάρκεια της τριγλόχυνας, την κάνει ταυτόχρονα με τη μητροειδή. Ενώ ο Βαντελέμπεν είπε ότι αφήνει 1 με 2 μήνες και επανεκτιμά. Και πράγματι από τα στοιχεία που παρουσίασε ο Hausleiter, περίπου 30% όπως είπε και ο Βλάσης, στον ένα κιόλας μήνα μετά τη διόρθωση μητροειδούς, βελτιώνεται σημαντικά και η τριγλόχυνα και έτσι δεν χρειάζεται να γίνει. Επομένως, αν καθυστερήσουμε και περιμένουμε 1 μήνα, όχι περισσότερο, περίπου 30% αυτών των σημαντικών ανεπαρκειών θα φύγουν από σημαντικές και έτσι μία παρέμβαση, αν την κάνουμε σε όλους ταυτόχρονα, περίπου στους 3, στους 10 δεν θα χρειαζόταν. Μπαίνει το θέμα κόστου σίγουρα και η πρόβλεψη που θα μπορούσε να γίνει εδώ, ότι αν είναι torrential η ανεπάρκεια της τριγλόχυνας με ένα δακτύλιο ο οποίος είναι μεγάλος και με μία πνευμονική υπέρταση η οποία αρχίζει και με καλά ανατομικά χαρακτηριστικά, σε αυτές τις περιπτώσεις κατέληξαν και οι
ότι καλό είναι να γίνεται ταυτόχρονα. Σε διαφορετική περίπτωση να πάνε spaced apart 1 με 2 μήνες.
Ευχαριστούμε, Κώστα. Κύριε Γεωργίου, θέλετε να παρουσιάσετε το επόμενο περιστατικό?
Ευχαρίστως. Εκ μέρους του καθηγητή κ. Τούτουζα, το επόμενο περιστατικό θα το παρουσιάσει η κυρία Δρακοπούλου. Κυρία Δρακοπούλου.
Ευχαριστώ πολύ. Να ευχαριστήσω και εγώ την Οργανωτική Επιτροπή εκ μέρους του καθηγητή μου, του κυρίου Τούτουζα. Και βέβαια να συγχαρώ και εγώ προσωπικά την Επιτροπή για την πολύ μεγάλη επιτυχία του συνεδρίου. Θα παρουσιάσουμε στα επόμενα λίγα λεπτά ένα περιστατικό από την ομάδα μας, τον καθηγητή τον κύριο Τούτουζα και την κυρία Αγγέλη και την Αλφα Καρδιολογική Κλινική. Πρόκειται λοιπόν για έναν ασθενή ο οποίος υποβλήθηκε σε διακαθετηριακή valve-in-valve τοποθέτηση μάιβαλ βαλβίδα στην βιοπροσθετική μητροειδή. Πρόκειται λοιπόν για έναν ασθενή 80 ετών, ο οποίος παρουσιάστηκε στα τακτικά ιατρεία μας με συμπτώματα καρδιακής ανεπάρκειας και μάλιστα ήταν σε λειτουργικό στάδιο κατά νύχα 3, με ένα καρδιολογικό ιστορικό. Ο ασθενής είχε υποβληθεί σε καρδιοχειρουργική επέμβαση με αντικατάσταση μητροειδούς βαλβίδας το 2012, 9 χρόνια δηλαδή νωρίτερα, και αρχικά είχε υποβληθεί σε αντικατάσταση μητροειδούς βαλβίδας γιατί παρουσίαζε σοβαρή ανεπάρκεια αυτής με φλέιλ της πρόσθεσης γλοχίνας στο A2 scallop και στην υπάρχουσα διάταση της αριστερής κοιλίας. Τότε λοιπόν έγινε τοποθέτηση μιας βιοπροσθετικής βαλβίδας 33 mm EPIC, η οποία όπως γνωρίζουμε έχει ένα internal diameter στο 28,5. Να πούμε ότι κατά τη διάρκεια της χειρουργικής επέμβασης, και είναι πολύ σωστό να κοιτάμε αναλυτικά τα πρακτικά του χειρουργείου, έγινε και σύγκληση του ανοιχτού ειδούς με ράμα. Βλέπουμε εδώ από την διαφορετική μελέτη, ο ασθενής από την αριστερή παραστερνική τομή παρουσιάζει διάταση της αριστερής κοιλίας. Η βαλβίδα είναι in situ και well seated, η μητροειδή. Βλέπουμε ότι έχει σημαντική ανεπάρκεια με ένα έκεντρο jet προς το οπίστιο τείχομα του αριστερού κόλπου. Δεν παρατηρείται ιδιαίτερη ανεπάρκεια της τριγλόχινας βαλβίδας, ενώ από τις κορυφαίες τομές αναδεικνύεται πολύ ωραία η βιοπροσθετική βαλβίδα. Βλέπουμε ότι υπάρχει διατηρημένο κλάσμα της αριστερής κοιλίας, αμφικολπική διάταση, διάταση του αριστερού κόλπου και αυτό το έκεντρο jet που πηγαίνει προς το οπίστιο τείχομα έως και τις πνευμονικές φλέβες. Και βέβαια δεν βλέπουμε πάλι και εδώ από την κορυφαία τομή ιδιαίτερη ανεπάρκεια της τριγλόχινας βαλβίδας. Από τη δυσοφαγική μελέτη που πήγαμε να δούμε το μηχανισμό ουσιαστικά της λειτουργίας της βιοπροσθετικής βαλβίδας, αναδεικνύεται πολύ ωραία και μας έκανε εντύπωση, γιατί είναι κάτι σπάνιο, το ότι η βαλβίδα παρουσίαζε ρήξη ουσιαστικά της γλοχίνας της βιοπροσθετικής βαλβίδας. Βλέπετε εδώ, δηλαδή ήταν μια εκφυλιστική νόσος και βλέπουμε ότι αναδεικνύεται πολύ ωραία και το έκεντρο jet, το οποίο πηγαίνει προς το medial wall του αριστερού κόλπου με σοβαρό βαθμό ανεπάρκεια της βαλβίδας, χωρίς να παρουσιάζει ιδιαίτερα στενοτικά φαινόμενα. Και από την surgical view βλέπουμε εδώ τις γλοχίνες της βιοπροσθετικής βαλβίδας με το έκεντρο jet προς το οπίστιο και medial τείχομα του αριστερού κόλπου. Ο ασθενής οδηγήθηκε στο heart team, όπου έγινε συζήτηση για το επόμενο βήμα και τα ερωτήματα ήταν πώς θα προχωρήσουμε με χειρουργική αντικατάσταση εκ νέου της μητροειδούς βαλβίδας, δηλαδή redo cardiac surgery. Το δεύτερο ήταν να κάνουμε διακαθετηριακή τοποθέτηση valve-in-valve στη μητροειδή. Και το τρίτο ήταν να πάει συντηρητικά, το οποίο βέβαια απορρίφθηκε εξ αρχής γιατί ο ασθενής είχε πολύ έντονη συμπτωματολογία και ήταν στη μέγιστη θεραπευτική αγωγή για καρδιακή ανεπάρκεια. Τελικά αποφασίστηκε λόγω του υψηλού διαχειριστικού κινδύνου και της προηγηθήσας καρδιοχειρουργικής επέμβασης ο ασθενής να προχωρήσει σε διακαθετηριακή τοποθέτηση μητροειδούς βαλβίδας και μάλιστα το πρώτο πλάνο ήταν να γίνει transeptal. Οπότε αποφασίστηκε και στη συνέχεια ο τύπος βαλβίδας που αποφασίστηκε να γίνει με τοποθέτηση MyVal, με τη λογική ότι είναι μια βαλβίδα που έχει το πλεονέκτημα ότι μπορεί να αποσυρθεί σε περίπτωση που δεν περάσει από το μεσοκολπικό διάφραγμα. Να δούμε λίγο τα χαρακτηριστικά της MyVal βαλβίδας. Είναι μια σχετικά καινούργια βαλβίδα που πήρε πρόσφατα CE-mark για την διακαθετηριακή αντικατάσταση της αορτικής βαλβίδας. Είναι από βόηο περικάρδιο, τρίπτυχη βαλβίδα και ουσιαστικά έχει αρκετές πολλές επιλογές όσον αφορά το μέγεθος. Ξεκινάει από 20 mm έως και 32, ενώ έχει και αυτό το ceiling ουσιαστικά που έχει ένα προφίλ που έχει υψηλό radial strength. Προχωρήσαμε στην διενέργεια του Cardiac CT, το οποίο, όπως είναι γνωστό, μας παρέχει πολύ καλή πληροφορία όσον αφορά το μέγεθος, το internal diameter της βιοπροσθετικής βαλβίδας, αλλά και τον κίνδυνο που μπορεί να παρουσιαστεί μετά την τοποθέτηση για απόφραξη του χώρου έξοδου της αριστερής κοιλίας. Και βλέπουμε εδώ ότι μπορεί με simulation να δούμε τη βαλβίδα πάνω ουσιαστικά στις εικόνες του ασθενούς και να υπολογίσουμε την επιφάνεια του LVOT, του νέου LVOT μετά από την τοποθέτηση της βαλβίδας, που εδώ υπολογίστηκε στα 530 μιλιμέτρα ανά τετραγωνικό, το οποίο θεωρήθηκε πολύ low risk, εφόσον το όριο θεωρείται ότι είναι το 250. Επίσης, μας βοηθά πάρα πολύ αξονική στο να δούμε το ακριβές σημείο που θα είναι το καταλληλότερο για το transeptal puncture, το οποίο είναι inferior και posterior, ενώ μπορούμε να δούμε και πολύ ωραία ποια είναι η γωνίωση που πρέπει να έχουμε στη λιχνιά μας για την καλύτερη τοποθέτηση της βαλβίδας. Και να πούμε ότι η σωστή τοποθέτηση είναι να φτάσουμε στο ventricular edge της προϋπάρχουσας βιοπροσθετικής, δηλαδή το 80 με 90% της νέας βιοπροσθετικής να είναι στο ventricular side και μόνο το 10 με 20% στο atrial side. Να πούμε ότι η βαλβίδα αυτή, όπως βλέπετε, δεν έχει πολύ καλό radio, δεν έχει πολύ καλά markers για να μπορέσουμε να ανιχνεύσουμε πολύ καλά το επίπεδο της βαλβίδας. Εδώ βλέπουμε ότι έγινε τοποθέτηση προσωρινού βήματοδότη, αλλά και με την κοιλιογραφία και το pigtail στην αριστερή κοιλία φαίνεται η σημαντική ανεπάρκεια της βιοπροσθετικής βαλβίδας. Προχωρήσαμε λοιπόν στην επέμβαση υπό γενική αναισθησία και διεσοφαγική καθοδήγηση. Βλέπουμε εδώ λοιπόν το πρώτο step ήταν το transeptal puncture από την δεξιά μυρία φλέβα, προχωρώντας προς τον δεξιό κόλπο. Ανιχνεύουμε εδώ και το ράμα το οποίο είχε τοποθετηθεί στο πρώτο χειρουργείο του ασθενούς. Έγινε λοιπόν το transeptal puncture αρκετά posterior και inferior. Βλέπουμε εδώ και με την τρισδιάστατη επικόνηση, αλλά και με το φλωρόσκοπι πώς αντιστοιχούν οι εικόνες για να καθοδηγήσουμε τον επεμβατικό. Στη συνέχεια έγινε μπαλούν σεπτόστομη, ουσιαστικά έγινε διάταση του puncture με ένα μπαλόνι που ήταν 14 χιλιοστά και με διεσοφαγικό υπερηχογράφημα καθοδηγούσαμε εδώ πολύ ωραία, αλλά και με το φλωρόσκοπι βλέπετε εδώ το waist ουσιαστικά του μπαλονιού. Οπότε και φαίνεται εδώ πώς δημιουργήθηκε αυτό το έλλειμμα στο μεσοκολπικό από την μεριά του αριστερού κόλπου. Στη συνέχεια έγινε crossing της βαλβίδας με οδηγό σύρμα 0,035 και επί του σύρματος προωθήθηκε το pigtail με τη βοήθεια ενός steerable sheath agilis, το οποίο βοηθούσε στην πολύ καλή, ουσιαστικά ένα πολύ καλό support του pigtail. Στη συνέχεια αφαιρέθηκε το οδηγό σύρμα, προωθήθηκε ένα πιο stiff σύρμα και στη συνέχεια αφαιρέθηκε και ο pigtail καθετήρας για να προχωρήσουμε στην φόρτωση της βαλβίδας και στην αφαίρεση και του agilis. Οπότε βλέπουμε εδώ πώς προωθήθηκε η βαλβίδα επί της προϋπάρχουσας βιοπροσθετικής, τόσο με το διεσοφαγικό όσο και με το φλωρόσκοπι. Βλέπουμε λοιπόν εδώ την βαλβίδα, όπως τη βλέπουμε με το διεσοφαγικό υπερηχογράφημα με explain σε δύο τομές και παρακολουθούμε το βάθος της βαλβίδας για να καθορίσουμε το ακριβές βάθος και να καθοδηγήσουμε το σωστό βάθος ουσιαστικά, όπως είπαμε, πρέπει να είναι στο ventricular edge της προϋπάρχουσας βαλβίδας. Εδώ λοιπόν γίνεται το deployment της βαλβίδας, βλέπουμε πόσο σταματάει η ροή ουσιαστικά από τη μητροειδή και πόσο contrast έχουμε στον αριστερό κόλπο στη φάση του deployment, μέχρι την τελική διάνοιξη της βαλβίδας και όπως βλέπουμε εδώ και με την αντίστοιχη αγγιογραφική εικόνα. Ουσιαστικά εδώ υπάρχει ακόμα το σύρμα μέσα στην βαλβίδα, έχει ένα πολύ καλό αποτέλεσμα. Βλέπουμε και με τη τρισδιάστατη επικόνηση πόσο ωραία βλέπουμε ότι έχει ανοίξει τη βαλβίδα και είναι circular, ακολουθεί δηλαδή την προηγούμενη βιοπροσθετική βαλβίδα. Ενώ προχωρώντας και στις τελικές μας εικόνες, η βαλβίδα δεν είχε καθόλου ανεπάρκεια, με ένα πολύ καλό mean gradient και ουσιαστικά και με την κοιλιογραφία φάνηκε ότι δεν υπάρχει υπολοιπόμενη ανεπάρκεια, χωρίς να υπάρχει βέβαια και αναστροφή στις πνευμονικές φλέβες πλέον. Όσον αφορά το μεσοκολπικό, που πολύ ωραία συζητήθηκε και νωρίτερα στο περιστατικό της κυρίας Αγγέλη, και εκεί έγινε μια συζήτηση για το κατά πόσον αυτό το έλλειμμα μας προβληματίζει. Στην παρούσα φάση, και γιατί ο ασθενής δεν παρουσίασε σημαντική διάταση των δεξιών καρδιακών κοιλωτήτων, αποφασίστηκε σε δεύτερο χρόνο, εφόσον κρίνεται σκόπιμο, να επανεκτιμηθεί η σύγκληση. Οι πιέσεις πριν και μετά, βλέπουμε πόσο μειώθηκαν οι πιέσεις ουσιαστικά του αριστερού κόλπου και βελτιώθηκε αιμοδυναμικά ο ασθενής. Ταυτόχρονα αυξήθηκε και η συστολική πίεση της αορτής. Και να πω δύο slide απλά για τη συζήτηση, ότι πρόσφατα δημοσιεύτηκαν τα αποτελέσματα της Mitral Trial τόσο σε βιοπροσθετικές βαλβίδες το 30 days και 1 year outcomes, όσο και σε περιπτώσεις ανουλόπλαστη rings, αλλά και σε περιπτώσεις valve in max, σε native δηλαδή βαλβίδες, με ένα πολύ ωραίο editorial που δημοσιεύτηκε μετέπειτα από αυτές τις 3 δημοσιεύσεις και τι μας λέει, ότι ουσιαστικά σε αυτές τις περιπτώσεις που χρησιμοποιήθηκε Sapien κατά το κύριο λόγο S3 υπήρχαν πολύ καλά αποτελέσματα ως προς το valve in valve prosthesis, δηλαδή ουσιαστικά είχαμε πολύ καλά αποτελέσματα σε προϋπάρχουσες βιοπροσθετικές βαλβίδες. Βλέπουμε εδώ ότι οι περισσότεροι excluded ασθενείς αφορούσαν την ομάδα που είχαν valve in MAC, όσον αφορά τα κριτήρια δηλαδή του screening. Πολύ καλά αποτελέσματα λοιπόν στις βιοπροσθετικές βαλβίδες, λιγότερο καλά σε δακτυλίους και κυρίως σε δακτυλίους οι οποίοι ήταν αρκετά rigid και δεν μπορούσαν να διαταθούν με τη βιοπροσθετική βαλβίδα, και επίσης κάποια ικανοποιητικά αποτελέσματα και στο valve in MAC, που τονίζεται εδώ και πολύ η σημασία της απόφραξης του χώρου εξόδου της αριστερής κοιλίας. Όσον αφορά τώρα το περιστατικό μας, βλέπουμε εδώ ότι δεν υπάρχει βιβλιογραφία όσον αφορά την τοποθέτηση.
Να δώσουμε χρόνο και στους υπόλοιπους, αν έχετε την καλοσύνη να ολοκληρώσετε για να δώσουμε
Είναι
χρόνο.
το τελευταίο slide. Απλά να πω ότι υπάρχει μόνο αυτό το case series, το οποίο αναφέρεται μεταξύ των 5 περιστατικών μόνο ένα περιστατικό με αντίστοιχη περίπτωση MIVAL σε βιοπροσθετική μητροειδούς μέσω του Transcatheter approach. Ευχαριστώ πολύ και συμπερασματικά να πούμε ότι μεγάλη σημασία σε αυτές τις περιπτώσεις έχει το screening, η σωστή επιλογή των ασθενών και το σωστό planning όσον αφορά την επέμβαση. Ευχαριστώ πολύ.
Εμείς ευχαριστούμε. Ήταν πολύ ενδιαφέρον το περιστατικό και πολύ ενδιαφέρουσα και η παρουσίασή σας. Κάποιο σχόλιο από τους κύριους Γεωργακόπουλο, Περέα ή Νινιό?
Έλεγα, κύριε Γεωργίου, για χάρη οικονομίας χρόνου, επειδή είναι πραγματικά όλα ενδιαφέροντα, αλλά είμαστε αρκετά πίσω, να προχωρήσουμε σε βιντεοσκοπημένη παρουσίαση ενός παρόμοιου περιστατικού. Είναι πολύ ενδιαφέροντα περιστατικά και εμείς που συμμετέχουμε στο Heart Team, στο Νάσιο και συνεργαζόμαστε με τους επεμβατικούς μας, έχουν πολλά challenges. Από τον κύριο Ευτυχίου να το παρακολουθήσουμε και ίσως μπορέσουμε μετά για 1-2 λεπτά να κάνουμε μια συνολική συζήτηση. Παρακαλώ το βίντεο του κυρίου Ευτυχίου.
Good afternoon. The next case is a transcatheter mitral valve replacement, a case through which we will be able to see the most important considerations and aspects of this procedure. The patient was a 73-year-old female who was admitted with acute pulmonary edema due to severe bioprosthetic mitral valve stenosis. She had a history of mitral valve endocarditis 5 years ago, which was treated with a mitral valve replacement using a 25mm Sorin per gag or more. She had also an LV pseudoaneurysm, which was also treated with a patch. She has had severe comorbidities. She had insulin-dependent diabetes. She had hypertension, severe asthma, CA breast, which was treated with radiotherapy, pulmonary hypertension, and chronic renal failure. Of course, she had a high risk for a surgical redo mitral valve replacement with a Euroscore 2 of 21.9% and an STS score of 26.6%. She had a preserved LV systolic function, but her mitral valve was degenerated with thickening of leaflets and restricted motion. She had severe stenosis with a mitral valve area of less than 1 square centimeters and a mean mitral valve gradient of 20 millimeters of mercury. She had also severe, moderate to severe TR with right ventricular systolic pressures of 80 millimeters of mercury. The right and left heart catheterization confirmed the presence of postcapillary pulmonary hypertension with a mean pulmonary artery pressure of 60 millimeters of mercury and severe mitral valve bioprosthetic stenosis with a mean gradient of 21 millimeters of mercury. She didn't have any significant coronary artery disease. A CT scan showed that the internal diameter of the mitral valve bioprosthesis was 20 by 21. The area was 337 square millimeters and the perimeter was 65.4 millimeters. The mitral aortic distance was 6 and the mitral aortic angle was 125 degrees. Now, based on our CT measurements and the mitral valve in valve app, which is very useful to select the appropriate valve for the procedure, we decided that the patient would need a 23mm CB3. Here we need to stress out that even though the pericardium more is a pericardial valve, which increases somehow the risk of LVOT obstruction, has a relatively short height of only 15 millimeters, which decreases the risk of outflow obstruction. The left ventricular outflow tract obstruction is the Achilles heel of any transcatheter mitral valve intervention. Even though we don't know the acceptable residual LVOT dimensions, we do know that the outflow tract obstruction correlates with poor outcomes, and prevention of this complication is much better than trying to treat it after the procedure. We also know some of the factors that determine the risk and degree of this complication. For example, we know that the deeper we plant the valve, the higher the risk of obstruction. Therefore, we should aim to have 3 or 4 millimeters of the valve inside the left atrium. We know that the more we flare the valve during implantation, then we increase the risk of obstruction. However, here we have to say that if we don't flare the valve, then we increase the risk of embolizing the valve. We also know that the smaller the aortomitral angle is, then the higher the risk of obstruction we have. And finally, the presence of a septal bulge also increases the risk of outflow obstruction. Therefore, the CT analysis is important and significant to determine the risk of this complication. It's also good to know that there are some softwares that can safely predict the neo-LVOT area, and they can also help you in the planning and the guidance of the procedure. The left femoral vein was used to place a 6 French sheath and advance a temporary pacemaker up to the right ventricle, while we used the right femoral vein for our access site, and a 6 French sheath was placed initially, and Proglide was replaced for hemostasis later. The transeptal puncture was done using an 8 French SLO sheath loaded with a BRK needle and a SafeSep transeptal guide wire, and the transeptal puncture was done at 4 centimeters above the mitral valve. Of course, very importantly, anticoagulation was given with 7 thousandths of heparin IV. The SLO catheter was then replaced by an 8.5 French steerable catheter, the Agilis catheter, which is very useful to facilitate the crossing through the mitral valve bioprosthesis. Crossing was done with a standard wire, which was then exchanged with a pigtail through the Agilis catheter, which was then used to place the Landerquist stiff wire in the LV apex. Over the Landerquist stiff wire, a Medtronic Admiral Extreme balloon, a 9 by 40 millimeters, was used to do a septostomy. Septostomy is very important to have your valve later advance without any problems. And after the septostomy, both the balloon and the Agilis catheter were removed while keeping the Landerquist into the left ventricle. Over the Landerquist stiff wire, we then placed the 16 French Edwards E sheath, and through the sheath we crossed the Sapien valve as we would have done in a TAVI case. However, here we should remember that the correct orientation of the Sapien 3 valve is the exact reverse of a transfemoral TAVI case, where the inflow of the valve should be facing towards the balloon and the outflow of the valve facing the tapered tip. Also, it's very important to have the delivery system, while inserted, oriented with the manufacturer logo downwards, which will ensure that the direction of the flexion of the delivery system will be towards the mitral valve, again exactly opposite of the TAVI procedure. 3 mL of volume were added in the balloon of the 23 mm Sapien 3 valve, which was deployed in pacing at 120 beats per minute, and in an 80% of the valve being into the left ventricle, ensuring that we had at least 3 or 4 millimeters of the valve into the left atrium. We had an excellent result with a mitral valve mean gradient of 5 millimeters of mercury in the transesophageal echo, while the left ventricular outflow tract mean gradient was less than 7 millimeters of mercury, indicating again a very good result. The patient was discharged well with significant improvement of her symptoms. She was prescribed warfarin for 6 months. She is in sinus rhythm. Following her discharge, she had also a COVID-19 infection, which fortunately did not cause any severe pneumonia, and she did not need any hospitalization. She remains well 2 months now after the procedure with preserved LV systolic function and a mitral valve mean gradient of 7 millimeters of mercury in the last transthoracic echo. Conclusions. During procedural planning, you have to do an identification of the bioprosthesis, know how it looks in fluoroscopy, and what the true internal diameter of the valve is in order to choose the correct type and size of the transcatheter heart valve that you're going to use. You have to be aware of the risk of complications, with the most important being the left ventricular outflow tract obstruction and transcatheter heart valve embolization. Also, very importantly, don't forget to check the correct orientation of the implanting valve. A degenerated bioprosthetic mitral valve can be safely treated with a transcatheter approach using a balloon expandable valve through a femoral vein and a transeptal access. Careful planning is probably the most important part of the procedure. Thank you for your attention.
Εδώ θα ήθελα βέβαια να ευχαριστήσω και τον κύριο Σπάρια για την παρουσία του και την καθοδήγησή του στην διενέργεια του περιστατικού, και είμαι έτοιμος αν θέλετε να ρωτήσετε κάτι για το περιστατικό.
Εμείς να ευχαριστήσουμε κύριε Ευτυχίου. Υπάρχει κάποιος από το πάνελ που θα ήθελε να σχολιάσει όλο αυτό το κόνσεπτ του valve-in-valve για τις μητροειδείς? Είναι μια εκπληκτική καινοτομία που έχει λύσει τα χέρια σε πολλούς ασθενείς που, ενώ έχουν προσδόκιμο επιβίωσης, είναι σαφές ότι με την κλασική καρδιοχειρουργική προσέγγιση τα πράγματα θα ήταν αρκετά δύσκολα. Είναι βέβαιο, χωρίς να υπάρχουν trials, ότι η περιεγχειρητική θνητότητα θα ήταν ψηλότερη. Το ζητούμενο είναι η μακροπρόθεσμη και καλή λειτουργία της εμφυτευτής σας βαλβίδας, και αυτό πιστεύω θα το δείξει ο χρόνος, καθώς η βιομηχανία φαίνεται ότι βελτιώνεται. Σε μια προσπάθεια ανταγωνισμού προσπαθούμε εμείς οι καρδιοχειρουργοί να αντιμετωπίσουμε παρόμοια περιστατικά όταν υπάρχει αρκετό προσδόκιμο, με θωρακοσκοπική προσέγγιση, η οποία προφανώς είναι επεμβατική, αλλά έχει κάποια πλεονεκτήματα έναντι της επαναστερνοτομής. Κάποιο σχόλιο για το περιστατικό της κυρίας Δρακοπούλου ή του κυρίου Ευτυχίου, που ήταν και τα δύο εξαιρετικά και πολύ ενδιαφέροντα και αφορούν ένα μεγάλο δείγμα πληθυσμού, και συμφωνώ πολύ γρήγορα με τη ρίση και του κυρίου Σπάρια στο προηγούμενο session ότι πρέπει να δούμε κεντρικά, προσπαθούμε και εμείς από την Επιτροπή του και εσύ, όλες αυτές τις ομάδες ασθενών που ζητούν μια λύση να είναι επίσημο, να είναι ξεκάθαρο και να μπορούμε να το χρησιμοποιήσουμε, προσπαθώντας συγχρόνως να μειώσουμε τα κόστη χρήσης. Δεν ξέρω, κύριε Γεωργακόπουλε, ο κύριος Δινιός είναι κάποιος που θα ήθελε να πει κάτι?
Νομίζω, όπως είπατε, είναι ένα πεδίο που οι τεχνικές αυτές δίδουν λύση, γιατί οι υπόλοιπες λύσεις δεν είναι εύκολες και δυνητικά επικίνδυνες. Να προχωρήσουμε, θα έλεγα, λοιπόν, με τον κύριο Λεοντιάδη από το Νάσιο Καρδιοχειρουργικό Κέντρο, να μας παρουσιάσει ένα complex case με τη χρήση Mitra Clip. Κύριε Λεοντιάδη.
Ακούγομαι?
Ναι.
Ωραία. Καλησπέρα λοιπόν. Δεν είναι Mitra Clip, είναι κάτι αντίστοιχο, αλλά στη θέση της τριγλόχινας. Ευχαριστώ πολύ τον κύριο Σπάρια και την Οργανωτική Επιτροπή για την τιμή να συμμετάσχω σε αυτό το εξαιρετικό συνέδριο. Θα προσπαθήσω, επειδή καταλαβαίνουμε πιέζει ο χρόνος, να προχωρήσω όσο πιο γρήγορα μπορώ. Πρόκειται για μια ασθενή που είχε την ιδιαιτερότητα 51 ετών, είχε την ιδιαιτερότητα να έχει μεταμοσιευθεί το 2005 και μας απασχόλησε διότι περίπου 6 μήνες πριν την επέμβαση στην οποία προχωρήσαμε είχε αρχίσει να έχει δύσπνοια, εύκολη κούραση και επαναλαμβανόμενες νοσηλίες λόγω δεξιάς καρδιακής ανεπάρκειας με επαπειλούμενο υπατονεφρικό σύνδρομο, υψηλή χολυριθίνη, αρχόμενη κάμψη της δεξιάς κοιλίας, ψηλή τιμή BMP. Είναι σημαντικό να δούμε ότι είχε υποβληθεί σε 4 καρδιοχειρουργικές επεμβάσεις, όπως βλέπουμε κάτω. Το 2005, λόγω της διαταραχικής μυοκαρδιοπάθειας, σε ορθοτοπική μεταμόσχευση της καρδιάς. 3 χρόνια αργότερα, λόγω καταστροφής της τριλόχινας βαλβίδας από τις βιοψίες που είναι υποχρεωτικές σε αυτούς τους ασθενείς, όπως γνωρίζουμε, προχώρησε σε αντικατάσταση με βιοπροσθετική βαλβίδα. 8 χρόνια αργότερα εκφυλίστηκε η βιοπροσθετική βαλβίδα, ετέθηκε μια μηχανική μεταλλική βαλβίδα, τον Τρίτο του 2006, και 1 χρόνο αργότερα είχε την ατυχία ασθενής αυτή, η βαλβίδα θρομβώθηκε, όπως θα δείξω παρακάτω, οπότε έπρεπε να περάσει στην επόμενη καρδιοχειρουργική επέμβαση. Βλέπουμε εδώ πέρα λοιπόν σε αυτή την εικόνα που είναι 1 χρόνο μετά την μηχανική βαλβίδα, βλέπουμε πολύ ωραία ότι ο ένας ημιδίσκος είναι ουσιαστικά κολλημένος και αντίστοιχα πραγματικά 2 δοσέματος από το δεξιό κόλπο είναι μόνο από τον ημιδίσκο, ο οποίος παραμένει ανοιχτός. Την οδηγήσαμε και στο αιμοδυναμικό, επιβεβαιώθηκε βέβαια αυτό που βλέπαμε και στο 3D δυσοφάγιο, ότι μόνο ένας δίσκος άνοιγε, ο άλλος έμενε συνεχώς ανοιχτός, με αποτέλεσμα να έχει μια σοβαρού βαθμού στένωση στην προσθετική μητροειδή βαλβίδα, με μια μέση κλίση πίεση στα 12 mm στήλης αγίου. Οπότε, όπως καταλαβαίνετε, επαναχειρουργήθηκε. Αυτή τη φορά πήρε μια βιοπροσθετική βαλβίδα από περικάρδιο, την Περικάρμπον 29 mm, η οποία βλέπετε εδώ ότι είναι μέσα στο δακτύλιο της βαλβίδας. Είχε όμως την ατυχία, όπως βλέπετε, την 5η μετεγχειρητική ημέρα, όταν δηλαδή ήταν έτοιμη να πάρει εξιτήριο. Βλέπετε εδώ πέρα πολύ καλά ότι μία βαλβίδα παραμένει, η μία πτυχή, της βιοπροσθετικής βαλβίδας παραμένει σχετικά με καθυλωμένη κατά την διαστολή, με αποτέλεσμα έχει μια σοβαρού βαθμού κεντρική ανεπάρκεια, επαναλαμβάνω, άμεσα μετεγχειρητικά την 5η μετεγχειρητική ημέρα. Και όταν ποσοτικοποιήσαμε αυτό που βλέπαμε, προφανώς είδαμε ότι ήταν καθυλωμένη η βαλβίδα, είχε σοβαρή ανεπάρκεια στη βαλβίδα, μια βένα κοντράκτο 0,4 cm στο τετράγωνο, ένα regurgitant volume 60 ml, καλό κλάσμα εξώθησης αριστεράς κοιλίας και λίγο μέτριο στην δεξιά κοιλία. Στο διαθωρακικό υπερηχογράφημα αντίστοιχα βλέπουμε τα 3 posts της βαλβίδας, τους 3 πύργους, και εδώ πέρα βλέπουμε την σχετικά μειωμένη διάνοιξη της γλοχίνας της βιοπροσθετικής τριγλόχινας βαλβίδας, η οποία είχε ως αποτέλεσμα την ανεπάρκεια αυτής. Και σημαντικό είναι ότι έτσι άντεξε περίπου 2 χρόνια. Βλέπουμε όμως ότι ενώ το global strain της δεξιάς κοιλίας ήταν στο μείον 13%, ήταν λίγο πεσμένο, αλλά ικανοποιητικό για μια μεταμοσχευμένη ασθενή που είχε υποβληθεί ήδη σε 4 καρδιοχειρουργικές επεμβάσεις. Αργότερα άρχισε να κάμπτεται η δεξιά κοιλία λόγω της σοβαρής τριολογικής ανεπάρκειας. Το strain έπεσε στο μείον 9%, με μια μέτρια στένωση, μάλλον σοβαρή στένωση στη βαλβίδα πλέον. Βλέπουμε μια μέση κλίση πίεση στα 7 mm στήλης αγίου, αλλά και ένα τριγωνικό σχήμα στο continuous Doppler. Έτσι οδηγήθηκε αυτή στο η ασθενής στο heart team, συζητήθηκε, είχε όπως βλέπαμε επαναλαμβανόμενες εισαγωγές με δεξιά καρδιακή ανεπάρκεια, αρχόμενη κάμψη της δεξιάς κοιλίας και νομίζω ήταν προφανές ότι δεν μπορούσε να υποληθεί 5η φορά σε χειρουργείο, οπότε το heart team αποφάσισε να προχωρήσουμε σε διακαθετερική αντιμετώπιση της ανεπάρκειας της βιοποψητικής βαλβίδας με μια βαλβίδα Edwards Sapien 3. Έπρεπε προφανώς να το οργανώσουμε όπως πρέπει να οργανώνουμε τα πάντα που κάνουμε στο αιμοδυναμικό εργαστήριο. Με την αξιονική αγγιογραφία υπήρχε λίγο ασβέστιο στο εγγύσμα των στεφανιών, χωρίς όμως σημαντικές στενώσεις σε αυτά. Χρησιμοποίησαμε την αξονική καρδιάς, μετρήσαμε το internal diameter που ήταν 25 επί 25 mm. Το ίδιο χρησιμοποίησαμε και το γνωστό application που έχει αναφερθεί πολλαπλώς και είδαμε ότι για την βαλβίδα των 29 mm η βαλβίδα ενδεδειγμένη ήταν η Sapien 29 mm. Και η επέμβαση έγινε υπογενική αναισθησία και ο λόγος ήταν ότι χρησιμοποιήθηκε και διεισοφάγιο περιχογράφημα. Από την μοιραία φλέβα χρησιμοποιήθηκε ένα σύρμα Ablatz Super Stiff, το οποίο τέθηκε στην αριστερή πνευμονική αρτηρία. Δεν χρειάστηκε βαλβιδοπλαστική, γιατί να θυμίσω ότι η βαλβίδα ανεπαρκούσε, δεν είχε σημαντική στένωση και τέθηκε μια 29 mm Sapien 3 βαλβίδα υπό γρήγορη κοιλιακή βηματοδότηση και προφανώς, όπως είπε και ο προηγούμενος ομιλητής, πρέπει να δοθεί σημασία στο πώς θα τοποθετηθεί η βαλβίδα στο delivery catheter. Αυτό που πρέπει να προσέξουμε είναι ότι η βαλβίδα θα πρέπει να τοποθετηθεί 3-5 χιλιοστά εντός της δεξιάς κοιλίας, δηλαδή αυτά η απόσταση μεταξύ του μάρκερ της Edwards και του προσθετικού δακτυλίου πρέπει να είναι από 3-5 mm και τελειώνοντας ουσιαστικά να δείξω λίγο τις εικόνες. Βλέπουμε εδώ πέρα με ένα καθετήρα Judkins Wright, ανεβάσαμε ένα κοινό σύρμα στην αριστερή πνευμονική αρτηρία, αφαιρέθηκε αυτό, ανέβηκε το Ablatz Super Stiff, έγινε μια πολύ προσεκτική τοποθέτηση, βλέπετε με το κίτρινο βέλος τον προσθετικό δακτύλιο με κόκκινο βέλος στο μάρκερ, μια προσεκτική τοποθέτηση της βαλβίδας με το μεγαλύτερο μέρος από τα τριτός της κοιλίας. Έγινε μια αργή και ελεγχόμενη φύτευση της βαλβίδας, όπου με το που πλησιάσει λίγο το πρόστιο μέρος του τριλοχηνικού δακτυλίου ουσιαστικά έρχεται στο κέντρο η βαλβίδα και έχει καλύτερο orientation, ένα καλό αποτέλεσμα στο τέλος. Και αυτό ήταν το υπερηχογράφημα στο οποίο την υποβάλαμε πριν πάρει εξιτήριο. Βλέπουμε η βαλβίδα λειτουργεί καλά, δεν έχει ούτε παραβαλβιδική ούτε διαβαλβιδική ανεπάρκεια. Έχει μια μέση κλίση πίεση στα 3 mm στήλη συνταγύρου. Βγήκε από το νοσοκομείο σε υποσυντρόμ και ασπιρίνη. Δυστυχώς όμως έκανε επανεισαγωγή μετά από 4 εβδομάδες με αμφικυλιακή καρδιακή ανεπάρκεια. Πιθανώς έκανε οξεία απόρριψη του καρδιακού αιμοσχεύματος, πήρε θεραπεία για την απόρριψη. Δυστυχώς όμως μετά από 1 μήνα περίπου νοσηλείας κατέληξε. Και για να κλείσω μια σύντομη συζήτηση, η πρώτη επέμβαση σε αντικατάσταση σε βιοπροσθετική τριλόχυνα βαλβίδα έγινε πριν περίπου 10 χρόνια. Πρέπει να γίνει το sizing της βαλβίδας με ό,τι μέθοδο έχουμε, όπως έδειξα το application, την αξονική και το διαθωραϊκό υδροσφάγιο υπερηχογράφημα. Στις μεγάλες βαλβίδες πιθανώς καλύτερα αποτελέσματα έχει Sapien 3, στις μικρότερες, δηλαδή σε αυτές που έχουν outer diameter κάτω από 25 mm, οι βαλβίδες μελλοντικές. Οι βαλβίδες πάνε καλά και έχουν λίγα συμβάματα. Ευχαριστώ πολύ.
Ευχαριστήσουμε τον κύριο Λεοντιάδη. Είναι προφανές ότι τα εργαλεία για το TAVI μπορούν να εφαρμοστούν βέβαια και στην τριγλόχυνα όταν υπάρχει βιοπροσθετική βαλβίδα. Δεν ξέρω αν υπάρχει κάποιο σχόλιο σχετικά με το περιστατικό που μόλις είδαμε. Αλλιώς για οικονομία χρόνου νομίζω να προχωρήσουμε.
Οπότε το επόμενο περιστατικό θα παρουσιάσει ο κύριος Λάμπρος Λάκας από τα Ιωάννινα και αφορά μάιτρα κλίπ. Κύριε Λάκα.
Καλησπέρα και από μένα. Να ευχαριστήσω την Οργανωτική Επιτροπή για την πολύ τιμητική πρόσκληση. Θα προσπαθήσω να είμαι σύντομος λόγω του περιορισμένου χρόνου. Δεν έχω κάτι να δηλώσω. Το περιστατικό μας αφορά μια 84χρονη ασθενή, η οποία προσήλθε σε εμάς για διερεύνηση τρόπου αντιμετώπισης της σοβαρής πρωτοπαθούς ανεπάρκειας μητροειδούς βαλβίδας. Είναι γνωστή η ανεπάρκεια της αυτή τουλάχιστον 6 μήνες. Για την ανεπάρκεια αυτή ήταν σε στάδιο νύχα 3, το οποίο έκανε συχνές νοσηλίες σε νοσοκομείο της περιοχής της, όπου βελτιωνόταν η διουρητική της αγωγή και κάποιες φορές χρειαζόταν και έκανε παρακεντήσεις στο πλευρητική συλλογή λόγω της ανεπάρκειας και μία φορά χρειάστηκε να κάνει και τοποθέτηση μπιλάου. Όμως το τελευταίο διάστημα, παρόλο την OMT στην οποία βρισκόταν και τις πολλαπλές νοσηλίες, όπως βλέπετε, ήταν τις τελευταίες 3 εβδομάδες σε στάδιο νύχα 4. Από το ιστορικό της έχει κολπική μαρμαριγή, όπως ήταν αναμενόμενο, υποθυροειδισμό και COPD. Αυτή είναι η ακτινογραφία θώρακος κατά τη διάρκεια της νοσηλείας της σε εμάς. Μία από τις πολλές ακτινογραφίες ίδιες που είχε, παρόλο την διούρηση και παρόλο τις παρακεντήσεις που έκανε σε νοσοκομείο της περιοχής της. Στο πλαίσιο της διερεύνησης κάναμε στεφανιογραφία που δεν είχε σημαντικές στενώσεις στα στεφανία αγία. Το διεσοφάγιο που κάναμε δείχνει ότι έχει σοβαρή ανεπάρκεια μητροειδούς βαλβίδας. Είναι φλέιλ P3, πιθανότητα και σε ένα τμήμα του Α2. Είναι αρκετά medial το κομμάτι του φλέιλ. Δεν φαινόταν πολύ καλά στις μεσοεσοφαγικές λήψεις και ουσιαστικά εδώ βλέπουμε το κομμάτι που έχει σπάσει στην κομίσουρα λήψη και αντίστοιχα το βλέπουμε και στο τριδιάστατο ηχοκαρδιογράφημα. Και είναι τμήμα ουσιαστικά της medial κομισούρας. Βλέποντας ότι έχουμε αρκετή οπίστη αγλοχή, όχι φυσικά στο P3 που έχει σπάσει, αλλά ακριβώς λίγο πιο λάτερα, λίγο πιο δίπλα, και αυτό μας έδινε αυξημένη πιθανότητα για grasping. Προχωρήσαμε στη σκέψη του να κάνουμε ένα mitral clip. Αυτή είναι το explain view της ασθενούς για το flail τμήμα της. Βλέπουμε τη σοβαρή ανεπάρκεια. Αυτός είναι ο δεξής καθετεριασμός, δεν χρειάζονται λόγια, είναι μέση πίεση 30, 15 διαστολική πίεση της αριστερής κοιλίας, καρδιακός δείκτης 1,52. Είναι ουσιαστικά μετατριχοειδική πνευμονική υπέρταση με μειωμένο καρδιακό δείκτη με πάρα πολύ μεγάλη διούρηση και παρακεντήσεις. Έγινε χαρτί μου, βλέποντας ότι η ασθενής δεν έχει καμία βελτίωση και παρόλο που ήταν σε OMT και γίνεται ασθενής ασταθής μέρα με τη μέρα χωρίς πια να μπορούμε να κάνουμε κάτι γι' αυτό. Αποφασίστηκε τοποθέτηση αντλίας και να κάνουμε επίγουσα τοποθέτηση mitral clip. Το γύρω χοροδίο της ασθενούς ήταν φυσικά πάρα πολύ υψηλό. Το mean gradient στη βαλβίδα πριν την τοποθέτηση του mitral clip ήταν 4, το οποίο προφανώς θεωρήσαμε ότι είναι από την σοβαρή ανεπάρκεια της μητροειδούς βαλβίδας. Είχαμε αρκετά καλή απόσταση από το δακτύλιο για να μπορέσουμε στο puncture site για να μπορέσουμε να φτάσουμε προς τη μητροειδή βαλβίδα. Και επειδή ουσιαστικά είχαμε επίσης αγλοχή αρκετή, αλλά οριακό μήκος, αποφασίσαμε να τοποθετήσουμε ένα NTR clip, αποφασίζοντας ότι πραγματικά θα κινηθούμε προς το να κλείσουμε ουσιαστικά την medial κομισούρα. Διαλέξαμε το NTR καθώς το XTR clip έχει μεγαλύτερο μέγεθος και πιστεύουμε ότι θα περιόριζε την πιθανή τοποθέτηση ενός δεύτερου clip, ειδικά αν θέλαμε να πιάσουμε κομμάτι της προς την κομισούρα. Και φυσικά το Pascal, παρόλο που είναι μια πολύ ωραία συσκευή, θεωρήσαμε ότι είναι, αν είχαμε τη δυνατότητα, θεωρήσαμε ότι αυτό ένα πολύ μεγάλη συσκευή για αυτήν την ασθενή και προφανώς δεν θα ήταν κατάλληλο για μας. Η σκέψη θα ήταν αν είχαμε διαθέσιμο ένα 4ης γενεάς NT mitral clip, που προφανώς δεν το είχαμε, γιατί θα ήταν τουλάχιστον 50% πιο πλατή και με independent grasping, οπότε πιθανώς να το τελειώνουμε εκεί την τοποθέτησή μας με ένα clip. Κάνοντας το perpendicularity του NTR clip, το τοποθετήσαμε με επιτυχία πάνω στον πίδακα της ανεπάρκειας και μειώσαμε αρκετά την ανεπάρκεια. Βλέποντας ότι έχουμε υπολοιπόμενη αρκετή ανεπάρκεια με mean gradient 5 mm στη ταργύρου, αποφασίσαμε να πάμε για δεύτερο clip και αυτό NTR, και στην πραγματικότητα με διάφορες πολύπλοκες μανούβρες καταφέραμε να το βάλουμε ακριβώς πιο medial από το πρώτο clip. Βλέπετε εδώ τις διαδικασίες και ουσιαστικά κλείνοντας την medial κομισούρα, κάνοντας ουσιαστικά μία σύγκληση, μία ουσιαστικά τοποθέτηση mitral clip που άφησε ένα αποτέλεσμα not Alfieri-like. Άφησαμε μία οπή ουσιαστικά στην ένα κομμάτι ανοιχτό στην μητροειδή βαλβίδα και προφανώς αυτό δεν είναι μια φυσιολογία Alfieri. Εδώ βλέπουμε το τελικό αποτέλεσμα με μια υπολοιπόμενη ανεπάρκεια, η οποία την θεωρήσαμε αποδεκτή. Αυτή είναι και η αγιογραφική εικόνα των δύο clip side by side. Το mean gradient μετά και το τοποθέτηση του δεύτερου clip ήταν 6 mm στη τετραργύρου, οπότε το θεωρήσαμε απόλυτα αποδεκτό μετά από το τοποθέτηση δύο ξέροντας ότι έχουμε κλείσει την medial κομισούρα. Η ασθενής μεταφέρθηκε στην μονάδα παρακολούθησης καρδιοπαθών, αποσυλληνώθηκε την ίδια μέρα, έμεινε εκεί μόνο 2 ημέρες και μεταφέρθηκε μετά στο τμήμα. Αφαιρέθηκε την ίδια μέρα και η αντλία, σταματώντας πλέον η ασθενής να είναι σταθής αιμοδυναμικά. 6 μέρες μετά την τοποθέτηση του mitral clip έφυγε από το νοσοκομείο σε νύχα 2 στάδιο και σε πρόσφατο follow-up παραμένει σε νύχα 2. Σας ευχαριστώ πάρα πολύ.
Εμείς ευχαριστούμε τον κύριο Λάκα. Ήταν και σύντομος και πολύ ουσιαστικός στην παρουσίαση του περιστατικού του. Κάποιο σχόλιο από τους συνάδελφους?
Ένα πολύ σύντομο σχόλιο. Συγχαρητήρια Λάμπρο, εξαιρετική παρουσίαση και πολύ δύσκολο περιστατικό. Το συζητήσαμε και νωρίτερα στο συνέδριο ότι αυτά τα περιστατικά με την commissural prolapse είναι ιδιαίτερα δύσκολα. Απαιτούν πολύ καλό transeptal puncture, πολύ καλό steering προς την κομισούρα της βαλβίδας. Το orientation πρέπει να είναι σωστό σε ό,τι αφορά τη γραμμή της καθετότητας, την καθετότητα του κλιπ σε σχέση με τη γραμμή σύγκλησης και είναι πολύ σημαντικό τεχνικά να μπούμε με το κλιπ κλειστό προς τη βαλβίδα και να το ανοίξουμε κάτω από τα leaflets για να μην μπλέξουμε τον υποβαλβιδικό μηχανισμό. Νομίζω ότι διαλέξετε τη δύσκολη οδό, βάλατε πρώτα ένα κλιπ στο κέντρο και ένα κλιπ midi, αλλά το πετύχατε καταπληκτικά με ένα πολύ καλό αποτέλεσμα. Συγχαρητήρια.
Ευχαριστώ πολύ.
Για λόγους οικονομίας, λοιπόν, είναι εντυπωσιακά όλα τα περιστατικά. Άλλο ένα hot topic της εποχής είναι οι ασθενείς με συνοδό σοβαρή στεφανία νόσο, οι οποίοι ωστόσο χρειάζονται και έχουν και σοβαρή στένωση αορτικής βαλβίδας. Θα παρακολουθήσουμε μια παρουσίαση ενός πολύ ενδιαφέροντος περιστατικού από τον κύριο Καλογερά από το Ιπποκράτιο. Κύριε Καλογερά, σας ακούμε.
Καλησπέρα και από μένα, ελπίζω να ακούγομαι. Να ευχαριστήσω και εγώ την Οργανωτική Επιτροπή και τον κύριο Σπάρη για την τιμητική πρόσκληση. Θα είμαι πάρα πολύ σύντομος, δεν θα σας καθυστερήσω καθόλου. Δεν θα σταθώ τόσο στο procedure του TAVI σαν procedure, αλλά πιο πολύ στο management που μπορεί πολλές φορές να κληθούμε πριν από το TAVI, σε ασθενείς με συνοσυρότητες, όπως είπαμε, στεφανία νόσο. Πάρα πολύ συχνό σε αυτούς τους ασθενείς. Και περνάω στο περιστατικό μας. Πρόκειται για μια ασθενή 81 ετών, η οποία παραπέμφθηκε στο νοσοκομείο μας με επιδεινούμενη δύσπνοια, σε έδαφος γνωστής σοβαρού βαθμού στένωσης αορτικής βαλβίδας. Το ιστορικό της περιλαμβάνει ρευματοειδή αρθρίτιδα, υποκορτικοστεροειδή και μεθοτρεξάτη, πνευμονική ίνωση, η οποία επιβεβαιώθηκε επίσης και με αξονική τομογραφία και υπέρταση. Στην παρούσα admission ήταν σε δύσπνοια, το καρδιογράφημα της ήταν σε φλεβοκομικό ρυθμό και το υπερηχογράφημα επιβεβαίωσε τη σοβαρού βαθμού στένωση αορτής κάτω από 1 το άβα. Παρ' όλα αυτά, καλή λειτουργικότητα της αριστερής κοιλίας, καλή δεξιά κοιλία. Ευτυχώς για αυτήν, όπως θα δούμε, δεν είχε ανεπάρκεια στην αορτική βαλβίδα, παρά μόνο μια μικρού βαθμού ανεπάρκεια στη μητροειδή. Όπως πάντα, προηγήθηκε μια στεφανιογραφία, η οποία ανέδειξε μια σοβαρού βαθμού ασβεστοποιός βλάβη στο μέσο και απότμημα του στελέχους, με πάνω από 80% στένωση. Διάχυτη επίσης ασβεστομένη βλάβη στο εγγύς και στο μέσο τμήμα του πρόσθετου κατηόντα. Υπερισφωμένη ήπια θυρωματικό αγγείο χωρίς κάποια σημαντικού βαθμού στένωση. Και δεξιά, όπως βλέπουμε, αποφραγμένο αγγείο στο εγγύς τμήμα με retrograde collateral από τον LAD, αλλά και κάποια antegrade collaterals. Οπότε οι ανησυχίες μας, οι κύριες ανησυχίες, φαίνεται ότι είναι για μια ανεχείρητη ασθενή που χρειάζεται και CBG και αντικατάσταση αορτής άμα ήταν για χειρουργείο. Παρ' όλα αυτά έχει υποκείμενη πνευμονική ίνωση, χρόνια ανοσοκατασταλτική θεραπεία. Φαίνεται ότι πιο πολύ είναι για TAVI υποψήφια. Παρ' όλα αυτά, χρειάζεται επαναγγείωση πριν από την εμφύτευση, αφού έχει σοβαρού βαθμού στεφανία νόσο. Οι ανησυχίες μας είναι ότι δεν φαίνεται να υπάρχει εφεδρεία, να το πούμε έτσι, στεφανία για μια αγγειοπλαστική στο στέλεχος λόγω της αποφραγμένης δεξιάς. Έχει επίσης μικρή δυνατότητα στην κυκλοφορία για μια εφεδρεία στην κυκλοφορία για μια υψηλού ρίσκου αγγειοπλαστική λόγω και του σοβαρού βαθμού αορτικής στένωσης. Πολλά λοιπόν προβλήματα μαζί. Συζητήθηκε στο χαρτί, αποφασίστηκε για μια high risk PCI στο left main και στον LAD με ενδοστεφανία λιθοτριψία, με shockwave και μαζί ταυτόχρονα και βαλβιδοπλαστική με την παρουσία πάντα ενδαορτικής αντλίας άμα χρειαστεί. Συζητήθηκε επίσης και η πιθανότητα να χρησιμοποιήσουμε rotablator, περιστοφική αθερεκτομή δεν φαίνεται ότι είναι ο ιδανικός υποψήφιος, αφού ένα πιθανό reflow θα έχει και καταστροφικές συνέπειες δεδομένου και της κλειστής δεξιάς αρτηρίας. Αν όλα αυτά πάνε καλά, το επόμενο βήμα θα ήταν το TAVI. Παρ' όλα αυτά έγινε και η αξονική screening για TAVI, καλά περιφερικά αγεία, στο 21,4 χιλιοστά η διάμετρος του δακτυλίου. Οπότε προχωρήσαμε στην επέμβαση. Πρώτα είπαμε να κάνουμε την βαλβιδοπλαστική. Γι' αυτό το λόγο μέσα από ένα 8 French στικάρι στην αριστερή μοιραία αρτηρία το κλείσαμε ProGlide στο τέλος για πρόσβαση για τη βαλβιδοπλαστική, αλλά να υπάρχει και πρόσβαση και για balloon pump αν χρειαστεί κατά τη διάρκεια της επέμβασης. Τοποθετήθηκε ο προσωρινός βηματοδότης, όπως βλέπετε, και επιλέξαμε ένα μικρό 18 μόνο χιλιοστών μπαλόνι για την βαλβιδοπλαστική, αφού το ρίσκο, να μειώσουμε όσο είναι δυνατόν το ρίσκο για μια υπολοιπόμενη ανεπάρκεια αορτής. Δεν υπήρχε η δυνατότητα για βαλβίδα εκείνη τη στιγμή στο ράφι, όπως λέμε. Το αποτέλεσμα παρόλα αυτά ήταν καλό. 30 το peak-to-peak gradient μετά την βαλβιδοπλαστική από 45. Ικανοποιητικό το αποτέλεσμα. Οπότε, μετά την επιτυχή βαλβιδοπλαστική, στον ίδιο χρόνο, μέσα από ένα 7 French στικάρι στη δεξιά στεφανία μοιραία αρτηρία, προχωρήσαμε σε αγγιοπλαστική στελέχους και πρόσθετα κατιόντα. 2 σύρματα, όπως βλέπετε, στον πρόσθετα κατιό και στην πισωμένη. Προσπαθήσαμε να το κρατήσουμε όσο πιο απλό γίνεται. Provisional τεχνική. Προδιάταση με το Shockwave στο Prox και μέσω LED και στο στέλεχος με ένα 3x12 μπαλόνι Shockwave. 80 συνολικά όλα τα pulse deliveries δόθησαν. Και μετά έγινε περαιτέρω προδιάταση του στελέχους με 3,5 μπαλόνι. Και ακολούθως τοποθετήθηκαν 2 stent 2,75 και 3x15 και 22 αντίστοιχα στον πρόστιο κατιόντα. Και ακολούθως ένα stent 3,5 στο στέλεχος. Μεταδιατάθηκε proximal με τεχνική pot με ένα 4 non-compliant μπαλόνι, με ένα καλό τελικό αποτέλεσμα. Όπως είπαμε, είμαστε ευχαριστημένοι και το κρατήσαμε όσο πιο απλό γίνεται για ένα τέτοιο υψηλού κινδύνου ασθενή. Δεν χρειάστηκε υποστήριξη με ημότροπα ή ενδοαρτική αντλία ευτυχώς κατά τη διάρκεια της επέμβασης. Και ουσιαστικά η ασθενής πήρε εξιτήριο την επόμενη μέρα και μετά από μερικές εβδομάδες ήρθε προγραμματισμένα πλέον πολύ πιο σταθερές συνθήκες αιμοδυναμικά και έγινε ένα ανεπιπλεκτό TAVI transfemoral με μια 26 χιλιοστών Evolut Pro, όπως λέτε, ένα σχετικά καλό αποτέλεσμα. Οπότε πρόκειται για να κλείνοντας ότι τα learning points είναι σε ασθενείς με σοβαρού στένωση αορτής. Φαίνεται ότι το pre-procedural BAV μπορεί να προσφέρει μια ικανή αιμοδυναμική υποστήριξη για ασθενείς που πρόκειται να υποβληθούν σε υψηλού κινδύνου PCI και στο TAVI εν συνεχεία. Η ενδοστεφανία λιθοτριψία είναι μια καινούρια μέθοδος, πολύ εύκολη στη χρήση και πολύτιμο εργαλείο για ασβεστομένες βλάβες που σίγουρα μειώνει τον κίνδυνο του no reflow σε ασθενείς με τέτοιο προφίλ. Η provisional τεχνική σε νόσο διχασμού σε τέτοιους υψηλού κινδύνου ασθενείς, ηλικιωμένους με στένωση αορτής, νομίζω είναι ιδανική να το κρατάμε όσο πιο απλό γίνεται. Και σίγουρα τέτοιου είδους επεμβάσεις πρέπει να είναι καλά προγραμματισμένες και να έχουμε πάντα το κατάλληλο εξοπλισμό στη διάθεσή μας. Θα ευχαριστώ πολύ.
Εμείς ευχαριστούμε για την σύντομη αλλά εξαιρετική παρουσίαση αυτής της δύσκολης κλινικής περίπτωσης. Ομολογώ ότι η εντύπωσή μου ήταν ότι το BAV έχει δύσκολα αποτελέσματα, αλλά φαίνεται ότι σε αυτή την περίπτωση ήταν μια εξαιρετική επιλογή σε μια κατά τα άλλα επίσης πάρα πολύ δύσκολη αγγιοπλαστική. Κάποιο σχόλιο από τους συμπροέδρους μου, από τους panelists, παρακαλώ.
Μπορώ να κάνω ένα σύντομο σχόλιο. Η επιλογή της βαλβίδος με βάση το ότι βάλατε πριν από λίγο stent στο κύριο στέλεχος, πρόσθετα κατιόντα, οπότε υπάρχει μια πιθανότητα να χρειαστεί πάλι πρόσβαση παρά την ηλικία, θα μπορούσε να είναι διαφορετική για να έχετε καλύτερη πρόσβαση αν χρειαστεί?
Σίγουρα η Evolut δεν είναι ιδανική βαλβίδα που εύχεσαι να έχεις μπροστά σου όταν πας να κάνεις αγγιοπλαστική. Ίσως της Edwards ή κάποια βαλβίδα με μεγαλύτερα cells θα ήταν μια πιο ιδανική περίπτωση. Αλλά δυστυχώς αυτή είχαμε στη διάθεσή μας και ελπίζω μάλλον και να μην χρειαστεί παρέμβαση στο μέλλον. Αλλά ναι, η Evolut δεν είναι ιδανική βαλβίδα για πρόσβαση στα στεφανία μετά την εμφύτευσή της.
Ευχαριστούμε πολύ. Κύριε Γεωργακόπουλε.
Ναι, να προχωρήσουμε με τον κύριο Νινιό, ο οποίος θα μας παρουσιάσει την χρήση του τέταρτης γενιάς Madra Clip στην μητροειδή βαλβίδα. Κύριε Νινιέ.
Καλησπέρα και από μένα. Θα δείξω ένα περιστατικό που κάναμε σχετικά πρόσφατα, κοντεύει 3 μήνες τώρα. 87 ετών γυναίκα με σοβαρή καρδιακή ανεπάρκεια, η οποία κλιμακώθηκε το τελευταίο διάστημα. Κατέληξε να νοσηλεύεται με σχεδόν πνευμονικό είδημα, με μεγάλες δόσεις διουρητικών εγκοφλεβίως, δεν μπορούσαμε να αποκλιμακώσουμε. Το κλάσμα εξώθησης ήταν 30% με μια τελοσυστολική διάμετρο 6,8, συστολική πνευμονική πίεση στο 65, αυξημένο προ-BNP. Και εδώ βλέπετε την βαλβίδα, είναι μια κλασική λειτουργική ανεπάρκεια, μεγάλη κοιλία, διατεταμένος δακτύλιος, έλξη των γλοχίνων, σοβαρή ανεπάρκεια όπως βλέπετε εδώ, λειτουργικής αιτιολογίας. Εδώ στην κομίσουρα λήψη φαίνεται πόσο κάθετες είναι οι γλοχίνες, το P1, το P3 και το Α2 στη μέση, με κεντρικό τζετ ανεπάρκειας, σοβαρό. Και εδώ στο Multi-D φαίνεται ότι πρακτικά οι γλοχίνες δεν ακουμπούν μεταξύ τους. Μια κλασική δύσκολη περίπτωση τεράστιας ανεπάρκειας που κατά καιρούς αντιμετωπίζουμε. Εδώ στο 3D βλέπετε αορτική βαλβίδα, πρόσθετα γλοχίνα, οτίο του αριστερού κόλπου, μεσοκολπικό διάφραγμα. Το πρόβλημα είναι μεταξύ Α2P2. Υπάρχει μια έντονη έλξη προς το lateral κομμάτι και είναι ξεκάθαρο ότι υπάρχει ατελής επαφή. Είναι ευτύχημα που με τον πίδακα της ανεπάρκειας να είναι εδώ. Είναι ευτύχημα που στα χέρια μας λοιπόν έχουμε το Gen 4, το οποίο εκτός από τα δύο μεγέθη που είχαμε στην τρίτη γενιά, το μικρό και το μεγάλο, το NTR και το XTR, τώρα πλέον αυτά λέγονται NT και XT, αλλά υπάρχει και η έκδοση W, που W σημαίνει wide, ότι δηλαδή εκτός από τα 4 χιλιοστά παραδοσιακού πλάτους, έχουμε πλέον τα 6 χιλιοστά και ακριβώς θεωρήσαμε ότι αυτό είναι το ιδανικό περιστατικό για να χρησιμοποιηθεί. Εδώ βλέπετε το Transcatheter puncture, η διέλευση του καθετήρα, και εδώ είναι το XTW. Δοκιμάζουμε σε αυτό ακριβώς το σημείο το independent grasping, το οποίο είναι ένα χαρακτηριστικό που μας δίνει αυτή η νέα γενιά. Μεταξύ άλλων, βλέπετε εδώ, πέφτουν τα gripper προς τα πίσω. Βλέπουμε ότι γίνεται ανεξάρτητη πτώση του gripper προς τα πίσω και μόνο το πίσω gripper. Εδώ βλέπετε την σύλληψη των γλοχίνων, ακριβώς στο σημείο που μας ενδιαφέρει. Εξασφαλίζουμε αργά ότι κλείνουμε τη συσκευή και φυλακίζεται τόσο η οπίστη όσο και η πρόσθετη γλοχίνα. Βλέπετε εδώ, οι γλοχίνες έχουν μπει πολύ καλά μέσα στα arms. Εδώ βλέπετε ότι έχουμε συλλάβει ένα πολύ μεγάλο εύρος ιστού. Δεν είναι συνηθισμένο με το απλό το XT να συλλάβουμε τόσο. Σχεδόν έχουμε πιάσει όλο το P2 με ένα κλιπ και βλέπετε ότι έχει εξαφανιστεί αυτή η περιοχή που ήταν η ατελής επαφή μεταξύ των δύο γλοχίνων. Έχει δημιουργηθεί λοιπόν η βαλβίδα με τα δύο στόμια. Εδώ βλέπετε το άμεσο το αποτέλεσμα. Έχει σχεδόν εξαφανιστεί ανεπάρκεια με ένα XTW. Απλά επειδή η πίεση ήταν λίγο χαμηλή, την ανεβάσαμε την πίεση. Εδώ βλέπετε, κάνουμε assessment του πόσο επαρκώς έχει μπει ο γλοχινικός ιστός, ικανό μήκος των γλοχίνων μέσα στο XT. Ανεβάζοντας λίγο την πίεση, προκύπτει ότι έχουμε έναν πίδακα υπολοιματικής ανεπάρκειας σε αυτή την τεράστια βαλβίδα, βλέπετε. Οπότε επιλέγουμε να βάλουμε ένα δεύτερο κλιπ. Αυτή τη φορά πήγαμε για XT απλό, γιατί μετρήσαμε ότι το εύρος ήταν μικρό και θεωρήσαμε ότι θα ήταν υπερβολή να βάλουμε ένα δεύτερο XTW. Βλέπετε εδώ το XT, το οποίο έχει το ίδιο μήκος στους βραχίονες, αλλά είναι πιο στενό. Γίνεται είσοδος των γλοχίνων, το άμεσο αποτέλεσμα. Εδώ βλέπετε τα δύο κλιπ δίπλα-δίπλα. Και αυτό είναι το τελικό αποτέλεσμα. Έχει σχεδόν εξαφανιστεί η ανεπάρκεια. Βλέπετε και σε αυτήν εδώ τη θέση. Η πολυματική πολύ μικρή, γύρω στα 4 χιλιοστά, μεσοκολπική επικοινωνία. Η ασθενής βελτιώθηκε πολύ άμεσα, μέσα στις πρώτες 24-48 ώρες. Την τρίτη μέρα έφυγε στο σπίτι κιόλας και ήδη στους 3 μήνες έχει και θεαματική βελτίωση στις παραμέτρους της καρδιακής ανεπάρκειας. Έχουμε τοποθετήσει και έναν απεινιδωτή στο ενδιάμεσο, γιατί είχε κάποιες ρηπές από μία μένουσες κοιλιακές ταχυκαρδίες. Αλλά βλέπετε ότι πλέον έχει ελάχιστη ανάγκη από διουρητικά και έχουμε ξεκινήσει αγωγή καρδιακής ανεπάρκειας με πολύ καλή αιμοδυναμική ανταπόκριση. Ευχαριστώ για την προσοχή σας και και είμαι στη διάθεσή σας για κάποιο σχόλιο.
Να ευχαριστήσουμε τον κύριο Νινιό. Νομίζω ότι είναι προφανές και από την περίπτωση που μας δείξατε ότι η ποικιλία μεγεθών που προσφέρει τέταρτη γενεά του Mitral Clip δίνει καλύτερες λύσεις, πιο αποτελεσματικές. Κάποιο σχόλιο ή ερώτηση από το πάνελ?
Ωραία, τότε να προχωρήσουμε στο επόμενο περίπτωμα που δεν υπάρχει σχόλιο, το οποίο είναι βιντεοσκοπημένο, είναι από τον κύριο Ευτυχίου, από το Γενικό Νοσοκομείο Λευκωσίας, εδώ στην Κύπρο. Ο Χρήστος είναι εδώ μαζί μας για συζήτηση μετά. Πάμε να δούμε λοιπόν το βίντεο.
Good afternoon. The next case is a TAVI case with a difficult transfemoral access, where the use of a balloon assisted tracking technique helped us to complete the procedure. The patient was an 81-year-old male with severe symptomatic aortic valve stenosis. He was admitted in Limassol General Hospital back in February 2021, where significant LAD and circumflex disease were also noted and treated with drug-eluting stents. His medical history included diabetes mellitus, chronic renal failure, arterial hypertension, and atrial fibrillation. He had an intermediate risk for a bypass and aortic valve replacement according to his STS score. His echo showed that he had a preserved LV systolic function. He had a tricuspid aortic valve with restricted opening. His leaflets were thickened and calcified with a moderate aortic regurgitation and a low gradient severe aortic stenosis. Mild mitral regurgitation was also noted. As it was mentioned, here the patient had also significant proximal LAD disease and diffuse significant circumflex disease. Both of them were treated with drug-eluting stents in two-stage procedures before the patient was referred to us for TAVI. A CT scan was done to plan the procedure, and his measurements showed that he had an aortic valve annulus diameter of 23/30 and a mean diameter of 27. His annulus area was 600 square millimeters and his perimeter 89.2. Because he had this recent PCI to LAD and circumflex, we decided to use it based on the measurements that we had, a 29 millimeter Sapien 3 for an easier future coronary access. Unfortunately, he had some issues in his peripheral arteries. He had circumferential calcium in the right iliac artery, however, with sufficient lumen to get a 16 French Edwards sheath through. And there was also some tortuosity and an eccentric calcific narrowing of the right external iliac artery further below. The left femoral artery had a diameter of only 5 millimeter, which was less than the 6 that are needed to get 16 French E-sheath through. Therefore, we decided to use the right femoral access, and if we had any problems advancing the E-sheath through the iliac arteries, then we would use shockwave balloon lithotripsy, as we usually do in cases like these. So we start the procedure by placing a 7 French left femoral artery sheath and a Lima catheter to get to the other side and do an angiogram to guide our puncture of the right femoral artery. A Manda depth locator will use to measure the puncture depth and for using later an 80 French Manda closure device for hemostasis. And we advanced the Landerquist stiff wire up to the aorta and through the right femoral and iliac arteries to help the placement of a 16 French Edwards E-sheath. Unfortunately, the E-sheath failed to cross the calcific narrowing of the right external iliac artery. So So as it was planned, we decided to use the shockwave balloon lithotripsy method, and we kept the E-sheath only up to the femoral artery. We've given heparin IV, and 6 by 60 millimeter shockwave balloon lithotripsy balloon over a command ES guide wire was used for several dilatations. An angiogram right after the balloon angioplasty with the shockwave showed that the right femoral and iliac arteries were filled with thrombus, which was probably because the heparin didn't have enough time to act. We aspirated the thrombus with a 7 French JR4 guide catheter, and we checked the artery again, which was looking much better now. We've given another try with the E-sheath, but it was still not possible to cross. Therefore, we did further dilatations with non-compliant balloons. We've used an Admiral Extreme 6 by 80, a 7 by 80, and 8 by 40 millimeters, which unfortunately had no significant impact, and the E-sheath was still not able to cross through the same calcific segment of the right iliac artery. At that point, we decided to ask for help, and we called our vascular surgeons, who came up with the idea of putting a stent and then try again to cross through the stent with the E-sheath. We've deployed an Everflex 8 by 60 millimeter stent and post-dilated with a non-compliant balloon 8 by 40. Another attempt to pass the sheath failed. We did another post-dilatation with a larger non-compliant balloon and 9 by 20 millimeters, but the sheath was still again not able to cross through the same segment, which appeared to cause a recoiling of the stent at that very same segment. We reconsider our options, which were now abandoning the right femoral artery and trying to get the sheath through the left femoral artery. We've also considered of trying with a different valve and using a 34 millimeter Evolut R, which is sheathless and might have more possibilities of crossing. And we've also considered the option of sending the patient for a surgical aortic valve replacement. Unfortunately, we had already prepared the 29 millimeter SAPIEN 3 valve, so we decided to give it another try. So we came with the idea of using a balloon-assisted tracking technique with the inflation of a non-compliant balloon 9 by 40 millimeters and advancement of the sheath while the balloon was deflating. This actually worked, and we've managed to get the sheath first through the stent, and then we removed the balloon and got the dilator back in place and advanced the sheath just above the bifurcation of the aorta, which seemed to be enough to complete the procedure. Things were looking much better now. We've crossed the valve with a straight wire and an AL1 catheter. We exchanged it to a pigtail and placed the Landerquist in the left ventricle. We've decided to go with direct implantation of the valve without doing a predilatation so that we didn't risk having significant AR and then not being able to cross the valve through the E-sheath. We had a successful deployment of the valve in rapid pacing and with 2 mils of added volume in the balloon for adequate expansion. We had actually a very good result without any paravalvular aortic regurgitation and no LV aorta gradient. The E-sheath was carefully removed over the Landerquist stiff wire and under screening, and so that we were sure that this stent was not displaced. And the puncture site of the right femoral artery was successfully closed with the 18 French Manda closure device. In cases like this, with difficult femoral access, different techniques and modalities may be used. In our department, we usually use the shockwave balloon lithotripsy, which unfortunately, in this case, was not helpful enough. A balloon-assisted tracking technique after stenting can be a useful way to advance a large sheath through difficult peripheral arteries and help you complete your TAVI procedure. Thank you very much for your attention.
Ωραία, ευχαριστούμε πολύ τον γιατρό του Ευτυχίου που μοιράστηκε μαζί μας ένα δύσκολο περιστατικό. Ολοένα και θα συναντούμε τέτοια περιστατικά καθώς ο βαθμός δυσκολίας στον TAVI αυξάνεται. Κάποιο σχόλιο από τους πάνελιστ, από τον κύριο Σπάρια?
Ναι, Γιώργο, θα ήθελα να ρωτήσω τον Χρήστο, ίσως έχασα εκείνο το κομμάτι. Χρήστο, γιατί δεν δοκίμασες να πας απευθείας με το e-Sheath και να δεις ότι αν δεν περάσει τότε να κάνεις τη λιθοτριψία? Προσωπικά θα δοκίμαζα να πάω με ένα 14 e-Sheath πρώτα, μόνο με το διαστολέα, μετά με το θικάρι, ίσως και με το διαστολέα του 16 e-Sheath, και μόνο αν εξαντλούσα αυτή την πιθανότητα σκεφτόμουν να κάνω κάτι παρεμβατικό, γιατί κατάλαβα ότι αυτό το παρεμβατικό σε οδήγησε στην ανάγκαση να βάλεις ένα stent, το οποίο μετά σε δυσκόλεψε να περάσει από μέσα του.
Κατά ακρίβεια, το stent δεν μπήκε λόγω επιπλοκής. Δοκιμάσαμε, βάλαμε και το διαστολέα το μικρότερο, δοκιμάσαμε και άλλο θικάρι για να κάνουμε διαστολή. Δεν ήταν αποτελεσματικό. Απλά δεν έβαλα όλες τις αποτυχημένες προσπάθειες για να περάσει το θικάρι. Η δική μου έκπληξη. Συνήθως σε τέτοια περιστατικά, παρόλο που δεν ήταν circumferential το ασβέστιο, που είναι ίσως πιο αποτελεσματικό το shockwave, εδώ δεν βοήθησε. Το stent μπήκε κατόπιν εισηγήσεως των αγκιοχειρουργών, ότι με αυτόν τον τρόπο θα μπορούσε να δημιουργήσει τον ικανοποιητικό εκείνο χώρο για να μπορέσει να περάσει το θικάρι. Δεν μπήκε λόγω επιπλοκής, δεν είχε γίνει ένα σχίσιμο της αρτηρίας, ούτε είχαμε καθόλου αιμορραγία. Εκείνο που θα έλεγα ήταν ότι κακώς είχαμε προετοιμάσει την βαλβίδα χωρίς να έχουμε τοποθετήσει το sheath. Αυτό μας ανάγκασε έτσι να πάμε λίγο στα άκρα και αλλιώς θα μπορούσαμε να πάμε με μια Evolut η οποία έχει μικρότερο profile και πιστεύω θα πέρναγε από εκείνο το σημείο.
Θα χρειαζόσουν όμως 34 Evolut, που θα ήταν πάλι 16 frames.
Ναι.
Δεν θα πήγαινες πιο κάτω.
Μπορεί να μην πέρναγε ούτε η 34.
Μπορεί να μην πέρναγε αυτή, γιατί η κάψουλα της Evolut είναι κάτι πιο μακρύ και πιο σκληρό. Η αριστερή πλευρά την έχασα. Ήταν αδύνατη?
Η αριστερή πλευρά είχε 5 χιλιοστά διάμετρο κάτω στο σημείο του puncture, οπότε δεν πήγαμε από την αρχή εκεί. Θα μπορούσε να δουλέψει από την αριστερή μεριά. Ήμασταν όμως ήδη με το large sheath μέσα στη δεξιά, είπαμε να δοκιμάσουμε όλες μας τις επιλογές.
Ωραία τεχνική, θα την κρατήσουμε να τη θυμόμαστε.
Αν θυμάστε, κύριε Σπάρια, πριν από 10 χρόνια τη Sapien, μέσα στο kit υπήρχαν όλοι οι διαστολείς από 14, 16, 18. Μετά για κάποιο λόγο η εταιρεία, άστοχα κατά την άποψή μου, τα απέσυρε. Ήταν πολλές φορές που βοήθησε να βάλουμε ένα πιο μεγάλο διαστολέα, χωρίς να τραυματίζουμε ιδιαίτερα την αρτηρία, και από εκεί και πέρα να μας ανοίγει χώρο για να μπορέσουμε να βάλουμε το θικάρι. Ωραία, ευχαριστούμε πολύ τον κύριο Ευτυχίου.
Εγώ ευχαριστώ.
Να προχωρήσουμε με τον Γιάννη τον Ιακώβου, το παρόν και το μέλλον της επεμβατικής καρδιολογίας στον Άσιο. Μεγάλη εμπειρία ήδη. Γιάννη μου, ο λόγος δικός σου.
Και καλησπέρα Κώστα, ελπίζω να ακούγομαι. Συγχαρητήρια και πάλι για την πολύ καλή οργάνωση. Νομίζω κάθε session είναι καλύτερο από το προηγούμενο. και αυτό το session συνεχίζει στο ίδιο μοτίβο. Οπότε στο χρόνο του ενός περιστατικού θα αναφερθώ σε 2 σύντομα περιστατικά, τα οποία νομίζω πως έχουν το ενδιαφέρον τους. Το πρώτο είναι το challenge που έχουμε όταν κάνουμε valve-in-valve σε τριγλόχινες βαλβίδες και υπάρχουν καλώδια βηματοδότη. Ξέρουμε λοιπόν ότι πολύ συχνά η επιδιόρθωση της μητροειδούς βαλβίδας, η αντικατάσταση